We are live to the audience. Over to you, ma'am.
Good morning, namaste, and a very good welcome to season 3 of MHC. I know people are watching us globally, and we had a great session yesterday, day one of the third Metabolic Health Conference. I'm your host, Ira Sahai, a certified metabolic health coach, a D-Life member, and also its chief operating officer. Just to recap yesterday's event and the mega show that we had, guest after guest, coming and, giving us in-depth insight, into each session and each topic one by one. Day one, season 3 of MHC began with a bang, with each session bringing in-depth knowledge from the top experts and doctors in the low-carb world. Just for numbers, we would crunch it for you. MHC has 40 experts this time from countries like the USA, UK, Australia, Sweden, South Africa, India, Ireland, and many, many more. All of these experts will be talking on the low carb approach in the Indian context. The topics are varied, as you saw yesterday, from addiction to, dietary guidelines and so many more. Today, we will have a lineup of the most brilliant speakers in the low carb space talking about varied subjects and carrying the, show forward. I would like to invite Shashikant Anger and Anup Singh on the screen just to recap and have a chit chat before we formally begin with the sessions. Anup and Shashi, welcome.
Thank you, Ira.
Morning, morning, good evening, good afternoon, everyone across the world.
Yeah, what a fantastic day we had yesterday, Shashi and Anup. And would you like to say something about the speakers, the sessions that we had?
Yeah, so I think yesterday we really enjoyed. We had two sessions on seed oils. I think seed oils are very, very critical in India right now, and it's talked globally also. So and also on the addiction part, we also discuss on the lipids, and also how the alternative organization is coming to take care of diabetes, like the American Diabetes Society. And I think yesterday I really got a good feedback from many of the people who were watching, and they were really excited and they were very happy to see the sessions. And then of course we have more than 40 experts actually in this session, and I think in the three-day event, and I think we are going to enjoy all the sessions. It's going to be even more enjoyable today. We are going to have one more critical session on the seed oil part. So that's going to get it in a circle. Plus much more, especially on, we are going to talk on nutrient density. We are going to talk on amazing recovery with carnivore, and more on the carbohydrate addiction front. So we are going to have Dr. Robert Sivis with us, who is going to speak on the carb addiction model particularly. Yeah, Anup.
Yeah, yesterday was great, because if you see most of queries on Twitter or elsewhere, they keep asking whether we can have, mustard oil, peanut oil, and all these other oils. So those topics were very well covered by various experts. And for me, on addiction part, I had one interesting question for Bitten Johnson. Are fruits addictive? Now, the answer was very great. Fruits are not addictive, but the sugar in, fructose in that,
Yeah.
that is addictive.
Yeah, very
Yeah.
well put, actually. I really enjoyed the session, and actually, all the sessions, I was barely, out of my work desk. And today, also, I think we have a great lineup. And what's special is that today we will have 3 D-Life doctors also featuring in, on day two. I mean, there's Dr. Gopal Ironi, then there's, I think,
Dr.
Monil
Monin.
Patel, yeah, and also Path Samal, Dr. Path Samal. So we'll have 3 sessions there and good insights from them also. I think anything else that you would want to add about today's lineup, Shashi and Anup?
Yeah, today, as I told earlier, that no, we have Dr. And we are going to have two more on addiction today. We are going
Ah,
to have Jen Anvin on processed food addiction,
I'm really looking forward to the session.
and we are
Yeah.
going to host her. It's going to be very interesting. And then we also have Joanne Ifland, so she is also another big addiction specialist. And in the seed oil part, we are going to have Dr. Chris Kanobi. Very, very good. I mean, he's going to give a lot of insights. And people who are watching this session, and I'll request them not to miss Dr. Chris Kanobi session. And we are going to have something on the lipids again. We are going to invite cardiologist Dr. Nadir Ali. He doesn't really appear easily in many of the channels as of now. He was active once upon a time, is not too much. So we managed to get him for Metabolic Health Conference with great difficulty, and I'm sure that people are going to enjoy the conversation with him. And of course, we also have this Valerie coming in with the amazing carnivore story. And finally, we are going to have Charles Mattox, who does a lot of documentaries and films on diabetes and diabetes recovery. We are going to enjoy a session very much.
Yeah, Valerie's, in fact, a lot of people should watch Valerie's story, and I'm going to be interviewing her. Valerie's story is an amazing story of recovery from many, mental illnesses also, besides the metabolic disorders that she had, a lot of mental conditions that she had been suffering from years. And, her story of recovery on the carnivore diet, it is very big now. And I think everybody should watch it, and how, just a dietary approach or a change, once she understood that, how it made a massive difference in what she's today. So, Valerie is up today at 4:45 p.m. So I think everybody should watch that. Anup, anything you want to add to this?
On calorie model, we have Anup and Abhinav back again in this season.
Yeah.
So that would be an interesting discussion because we don't follow calorie model at all. Calorie in, calorie out is a redundant science for us. So it would be great to have their insights because they're, avid researchers and they're publishing their papers in international journals. So that would be giving us a great insight into what actually calorie model is and how we are being fooled or misguided or whatever it is, right? And then we have our friend from South Africa, Samir Dosani. We've been on his channel for, I think, 2 or 3 sessions. So
Samir is
he'll be
coming
there.
tomorrow.
Oh, he's coming tomorrow.
Yeah.
Oh,
But then the calorie model will also give insights to how the sugar industry has influenced.
yes.
Because the favorite model for sugar industry is calorie model. But that is how they can sell more sugar.
Yeah.
So that's it.
Can you get in Arun Kumar also? Arun, you want to speak something, Arun Kumar? You can speak, you can just unmute and talk.
He's not here.
Okay, Bhima is not coming.
Yeah, Shweta is taking 1 minute to log in. She's asked for the login link again.
Okay.
So meanwhile, we can keep chatting. Maybe Mandar
Yeah,
can.
so another big guest we are having is Marty Kendall, because Marty Kendall is involved in the satiety, nutrient density, and craving aspects. He has an amazing model whereby he tracks all the micronutrients which is there in the food, and thereby increasing the satiety. And he does amazing work. He is again another engineer who has done extensive work. And I think he's the only guy, he's the only person across the globe, as far as I know, who keenly focuses on the micronutrient aspect. And that gives a lot of insights into how to get satiety and how to achieve results. So he gets amazing results in not only weight loss, but also diabetes, as well as many other metabolic conditions. I think he will also partially address the how to overcome craving. And I think he's going to be interviewed by Mandar again this time. We had Marty with us in our channel long back, some 3 or 4 years back, as a podcast in D Life. But I think he's going to he has added in a lot of data points now, and his insight is going to be quite amazing as of now. So let us see how it goes.
I think his work is being, rehashed by many.
Especially his concepts about not only nutrient density. He is also one of the earliest person to talk about energy toxicity,
Yes.
among others. So we have the chief guest joining in within a minute or so now.
Yeah, she's coming live.
You can carry on chit chat till she joins.
Yeah, actually, what happens is this time we actually have 44 speakers in total. So when we say above 40, it's actually 44 speakers. So Shweta is here. So get Shweta in and we'll check out.
Please get Shweta in and log us.
Hi, I'm here.
Yeah, please spotlight Shweta and me. Hi, Shweta. Welcome. Good morning.
Very good morning, Ira. How are you doing?
I'm great, and we were just waiting for you and chit-chatting a bit. So yesterday we had a fantastic day one, of the third MHC. It's a global conference, and I was just talking to our audiences. We have this time around 44 guests, the top names in the low carb space, talking about addiction and other aspects of low carb. And smashing session absolutely yesterday, and second day's lineup starts with you. So let me start the session with Shweta. I'll start by running through a quick introduction. I am Ira Sahai, the Chief Operating Officer of D-Life Healthcare Private Limited, a proud D-Life certified metabolic health coach, and the lead host of the third Global Metabolic Health Conference, organized from India by Shashikant Iyengar and Anup Singh. D-Life is India's first and only award-winning low-carb platform founded in 2014 by Anup Singh, a silver medalist from IIT Roorkee. Anup is also the recipient of the Icons of India Award. He pioneered the low-carb movement in India in 2012 with his path-breaking protocol of 100-gram carbs per day that made not only low-carb but also type 2 diabetes remission on low carb possible for even Indian vegetarians, which is a very complex carb-based plate. So this is about D-Life and me. About Shweta. Shweta is a public policy and media professional with 25 plus years of experience across venture capital, technology, and media organizations. She's the president and CEO of the startup policy firm and Industry Alliance for India's New Age Companies. Its members include many of India's most successful startups, including Razorpay, Cred, Oyo, and many more. Shweta spent 18 years as a business journalist with leading media organizations actively covering the economic policy making landscape in India. An award-winning journalist, Shweta has traveled regularly as part of the Prime Minister's delegation to cover global economic events such as the IMF, World Bank meetings, G20 summits, and more. She has been the recipient of many national and international awards, including the British Shipning Scholarship for Journalism by the UK government, the Ramnath Goenka Award, and many more. Shweta, welcome. It's a pleasure to have you here. Yesterday, Dilip and Pankaj Pachauri ji were here and they kicked off the session. And today we have you. Very, very delighted to have you, Shweta.
Thank you, Ira.
For those who may not know, Shweta is also my mentee, and in that way, I am her coach. And very, very delighted to have a mentee like Shweta. Very sincere. And when people talk to me about not being able to follow, I give examples of people like you and Dilip, and despite being very, very hectic schedules, you have stuck more or less to the protocol. And you're doing very well. So let's begin, Shweta. It's been a couple of months since you started your low carb journey, and couple of good months. Please tell us the brief issues that you have, and how do you finally find the LCF journey? How has it gone for you? Enjoyable, sustainable? How has it changed you?
Thank you, Ira. Firstly, I think you're very gracious. You're calling me a sincere mentee, and I don't think I'm as sincere as I'd like to be. So there's room for progress there. And I think you've been hugely, hugely supportive and cooperative. So a huge thanks to you. I think we started sometime in August, if I remember correctly. And, I reached out to you because a colleague of mine, a former colleague now, Ushma, pointed me to you, and she sort of nudged me to start looking at, metabolic health and trying to get a coach, because I was struggling. Like, I've always struggled with multiple health issues since childhood, right from, I would say, and all of those, incidentally, now that we realize is a pattern of autoimmune and metabolic issues, which, as you know, while medical science is so advanced, but very often it's hard to connect the dots and try and find out if there is possibly a common cause. You tend to cure one disease, but you don't realize the underlying causes. And I think since a child, I've struggled with tons of issues, right from endometriosis, and later in life had, discovered that I'm actually celiac and gluten intolerant, and then, gave up gluten at some point. And then now struggling with thyroid, which in itself is, as we all know, can be quite debilitating in its own ways, including weight gain issues and many other problems that come with it. So realizing a spate of autoimmune diseases and a very, very demanding, career that I've had all this while, naturally health tends to take a backseat, and you don't focus on it as much as you'd like to. But I think at some stage there was a realization that you've got to fix some things, and I'm so glad that I was directed to you, and then you and I started talking. And I think for me, what was intuitive was someone like a colleague of mine who has been on a low carb journey. I don't think she just follows the same philosophy, but hasn't been part of D life, but could, like word of mouth works like magic, right? Because you're like, oh, this works, like this really works. And then, for me, what was easy was that I had been partially low carb, in the sense that if you're gluten intolerant, you're anyway not eating half the thing, so there's no wheat in your life. But then I was a rice lover because there was no wheat, right? So I think talking to you, engaging with you, and moving from there to a complete low carb lifestyle, I think has been transformative.
Yeah. And Shweta, you've done very well. I mean, you just said that, you would like, of course, there's room for progress, but, you are an example of how people can still stick to low carb, even, despite their very hectic schedules and, something like you have. So, Shweta, let's talk about, this entire metabolic health conference thing that we are organizing from India. And it's a big event. It's a global event. And as I said, a while back, 40 countries, speakers from 40 countries, 40 sessions, sorry, and from many, many countries, including UK, USA, Ireland, India, South Africa, and many more are participating. And these are the top names in the low carb space. I mean, these are not just anybody talking about addiction to, dietary guidelines to so many seed oils, a lot of sessions. So how do you see the impact of all of this, of D Life and in the Metabolic Health Conference, now when India is especially battling with an epidemic of metabolic disorders?
So, I think first, what's most important is awareness. And I would say that I'm someone who's been a very, very private person. Even though being a journalist or a public policy professional, your professional life is very public. But as a person, I'm very private, and I have a very clear demarcation between personal life and professional life, and like to keep it that way. But I think one thing I've realized, more recently, especially when you look at people having very open conversations, being very vulnerable about their struggles, being very open to talking about issues that you otherwise may think are too personal to you, is that, yes, I think a lot of us have to first spread awareness, speak up. And the fact that today I am here, and I would typically not say yes to something like this, which is talking about your personal health, talking about your issues, is because I think if we don't take this into a movement, we're not going to see many people realize that they perhaps are not aware. Like something as simple as, gluten intolerance. A lot of people do not know they're gluten intolerant. I did not know, and I have struggled all my life. I've been through multiple surgeries, so many health issues. And if only I'd found out earlier in life that I am intolerant to gluten, maybe I wouldn't have faced so many health struggles. So given the fact that half the times things either go undiagnosed, or you do not know what you're struggling with and what the solution is, and it may not always lie in medicine, it may lie in just lifestyle changes. I think that is important. And that's why I would say remarkable work being done by D Life, by you, by Anup and Shashi, in making this into a movement and in trying to at least spread awareness about it, because that's the first step. And which is why I'm here, because, as I said, normally I would not do this or do any endorsements, but because I've seen that change in the last 6 months, and I definitely feel better. I can feel that with those lifestyle changes, my body is responding. I think everybody should at least give it a try if they feel they fit into this bracket of having the metabolic health disorders that require that lifestyle change.
Yeah, Shweta, how do you summarize the entire? Because a lot of times, we hear basically people who do not want to change. I would put it like this. I mean, you have a problem, but you still do not want to change, or it's not just a diet, as we always talk about. It's a complete lifestyle change. You have to unlearn and relearn the right way to eat, and therefore, that's how you improve your metabolic markers. But a lot of times we hear people with simple changes, and they find it a bit difficult. And I was just having a conversation with Dilip and Pankaj yesterday, and both of them said the same thing. I personally follow low carb, you follow low carb. It's very, very sustainable according to me. How did you find the changes? Because you had almost everything on your diet protocol, as far as I remember, and we have talked about it. You had everything. I mean, let's not disclose the, diet protocol itself, but let me tell our viewers that Shweta enjoys a lot of things. She has access to the real life recipes, and, more or less, she's nothing is out of bounds as far as the diet protocol is concerned, except for, of course, gluten and a few other things that she may not be able to tolerate. So how sustainable is it, Shweta?
I think I would be very honest in saying it's hard. Change is hard because of two reasons. One, any lifestyle change comes with either a wake up call or a determination. Like, you can keep telling 100 people make those changes, but till that switch doesn't change within your head or you wanting to do it, it will not happen. So it requires that one moment where you're like, this is it. I've got to make some lifestyle changes. That is one. Two, I think the environment doesn't allow you. It is not conducive to it. And which is why perhaps that hand holding and having you as a coach was helpful, because I mean, I cannot even thank you enough, because we literally have a group with my cook and you on the group with you directing the cook how to even, cook a certain meal to you, even, hand holding and guiding and wanting those pictures of what one is consuming. And you need that level of discipline, which is hard. And I'm still saying I am anything but disciplined on it. But the fact that there is at least a realization and commitment that you want to make the change, and two, then your environment has to support it. It's very hard when you have, I would say a demanding lifestyle of travel, of socializing, of general cravings that will possibly make it harder to make that change. But I think it just happens with awareness. It happens a lot with word of mouth. I think it happens a lot with conviction coming from someone you trust and say, okay, it worked for you, it can work for me. So
Yeah,
it's
and I
a
remember
combination of factors.
yeah. I remember a conversation, Shweta, recently in Delhi at Dilip's, get together, where Shweta was saying, and I want our audiences to hear it. She was saying that, if whatever she's given me on the protocol, when I eat it, I'm fine. But some days when I think, I should have something quote unquote nice, and I end up eating that, I am inevitably hungry later. So that's the satiety that we are talking about, the satiety from food. So no calorie counting, Shweta, right?
No, none at all. I mean, one has tried apps, one has tried other things, but I think what works magically with your diet protocol is that you actually give a lot of nice things. So I will not say you don't give nice things, but it is very fulfilling. I think the only effort that goes into it is sticking to it and making sure that you have that availability. But in terms of feeling satiated or not feeling like you're on a diet at all, in fact, you're mostly feeling full and comfortable. I think that's what works. And the mindset change. It's all about a mindset change and making sure that it's available. Like, it's hard here at times because, even if you want to follow it, you're not on a flight food is invariably carbs. I mean, even if and it's amusing because most people won't understand. I'm constantly on my frequent flyer programs listed as gluten intolerant. So I will get, a gluten-free meal on a flight, but that gluten-free meal is not even edible. So, and then I just say, what, forget it. I'll just go with the regular meal. But then the regular meal will have carbs. So then what do you do? So now it's like moved from I don't take gluten to I don't take carbs, and it's hard at times, but the choices are there. It takes a little bit of effort, but if you put in that effort, it shows the results. And I also want to say again, like I was saying, that endorsement coming from, so when you told me about Dilip, I did call Dilip and speak with him, and I said, what, Ira has worked with you, what do you think? And then he was obviously endorsing. So I think that helps, because when people truly endorse and say that lifestyle change, and I think what's most important is that this is not just about losing weight or fitness or looking good. It's about feeling better, and you just feel better on a certain diet and with those certain lifestyle changes. That's what's most important.
Yeah, very, very pertinent insights there, Shweta, personally, as well as, about the low carb protocol itself. Finally, what is your message to, this entire conference that's happening, to the work of D-Life? Please tell us.
I think few things that we've said. Number one, let's all spread awareness, because, very few people, I think what you did for me and our initial conversations were, myth busting. I think that's very, very important to help you understand that, okay, if you're consuming too many eggs, is that unhealthy for you? Because that's a misconception we've had. In fact, that's what my former colleague Ushma and I used to laugh, and she used to say, what, eggs have the worst PR in the world, because, because there is this assumption. You and I still have a debate around consuming too much meat and the impact on cholesterol. And we keep saying, I keep telling you, I want more scientific evidence around it. So I think conversations are important. Myth busting is important. Hand holding is very important. And like I said, awareness, spreading awareness, if all of us can do that. I would still say, Ira, more work to be done by DLife and others in establishing a more scientific, believable link between what we think. Because for me now, the picture is clear, right? Autoimmune, you have multiple autoimmune when you have autoimmune. So, there is an endo, there is a celiac, there is a thyroid, and then the common link between these three is you don't have to go to a gynecologist, you don't have to go to a gastroenterologist, you don't have to go to, so each of those super specialities, maybe there is that one common link that can solve so many health disorders, is to me, I would say the most important fact that I've learned through this journey.
Yeah, Shweta, one pertinent point I would want to, point, across to you being a very, very well-known media person. Somehow, I mean, DLife has done Herculean work. It's a globally known organization, and in India, it's the founding organization of low carb movement that was started off by Anup. But somehow you always get, media always covers the other aspect of calorie counting and the usual nonsense, and the press that DLife should get, or as Pankaj Pachauri ji said, this event should have been held in the Vigyan Bhavan. It's that significant. And DLife's history has been 10 plus years of, endorsed by global low carb stalwarts. In India, I think it may take some time for people to come to know, because a lot of jingoistic so-called health coaches who work on calorie in, calorie out model, which is nonsense. So I think people like you, when they join in and amplify the work that we are doing, we hope, it reaches more and more people, and we will look up to you, for your support and for you to spread the word around also.
100%. Like I said, that I usually do not believe in endorsements or talking about personal struggles. But this time around, when you called and I said, you know what, this deserves it, because we should all spread the movement. And, a lot of people are now coming out and openly talking about issues like health struggles and sharing solutions. So if this works for you, nothing like it. The other thing I would just say is that India particularly is a very carb heavy, market. We need our, I mean, it's a joke, right? That आपने दाल रोटी नहीं खिलाई है, आपने अपना butter chicken naan नहीं खिलाया, तो आपने dinner नहीं करा है, So even if you have to serve a meal, even if you have to, there is carbs in our diet, and heavily so. So I don't think we grow up thinking you can have a low carb diet. So that mindset change is required, because for us, we need that roti, chawal is very important part of our diet.
Yeah, and just to add to that, you can have roti, you can have puri, you can have everything. The tweak of ingredients, that's all you need. And Shweta has the access to DLife recipes as well, wherein Shweta, you have cheesecake and stuff like that. So I would urge you and both the cooks, I'll talk to them to make all of these. So there is no limit. I think low carb is very liberating without the guilt. And you reverse your conditions and lose weight. I mean, that's not the target, but that happens anyways. And weight melts like butter, as I always say, on low carb, and carnivore even more. So I hope you enjoy the low carb diet, Shweta. Your journey has been fantastic, and
I hope I stick to it, Ira. That is more important.
so I'll get back, because you had asked for January sometime, January end, when you would get back in the loop. Shweta has been very busy with the launch of her own, company, and it's a big thing. If you go to LinkedIn, you will check her profile out. So we will get back in the loop after we are done with the MHC. And Shweta, thank you so much for coming and speaking to us. It's a very, very important global event, and your voice matters. Thank you so much.
Thank you, Ira, and thank you for the wonderful work that you, Shashi, and Anup are doing. Good luck to you all.
Thank you.
Thank you.
Let's have Dr. Gopal, Ironi, and Dr. Naim and Sai and Datta on the screen, and I'll shut my video.
Yeah. Hello. Hello. Am I on? Yeah.
Yes, sir, you are audible.
I don't see myself on the screen. Okay.
Yes, you're on. We
Yeah.
can see you, Dr. Gupta.
Okay. Hello, everyone. I'm Dr. Naim, D-Life member, India's first and the only award-winning low-carb platform. D-Life was founded in 2014 by Anup Singh, a silver medalist from IIT Roorkee and the recipient of Icons of India Award. Anup is the pioneer of low-carb movement in India with his path-breaking protocol of 100 grams carb per day max given by him in 2012. That made not only LCHF but even type 2 diabetes reversal possible for Indian vegetarians. In 2021, D-Life launched its diploma course, which is the only course approved under NSDC partner, the Government of India, in the segment and the only course with global biggest 144 hours CPD hours credit. Anup Singh along with Shashikant Iyengar is the co-organizer of the Metabolic Health Conference. My co-host today is Sayan Datta, who is a certified metabolic health coach. So I would like to introduce to my dear friend and colleague, Dr. Gopal Irani. Dr. Gopal Irani is a health practitioner specializing in classical homeopathy, meditation coaching, and metabolic health. As a homeopathic doctor, he tailors treatment to individual symptoms, emphasizing the body's innate healing ability. Certified as metabolic coach through D-Life, he helps his clients reverse metabolic diseases through low-carb nutrition and lifestyle changes. As a meditation coach, he guides individuals towards mental clarity, emotional balance, and spiritual growth. Dr. Gopal's holistic approach integrates ancient wisdom with modern science, addressing physical, mental, metabolic health for sustainable well-being. So, yes, Dr. Gopal, are you ready?
Yeah. Thank you so much for this introduction.
It's my pleasure.
Yeah.
So, I would like to ask you, how has the transition been being from homeopath to LCHF metabolic health coaching?
I go back to 2014 when I was almost getting frustrated with. I have been a very good homeopathic practitioner, almost a fanatic one. So I never looked beyond homeopathy anytime. But though I was very successful in the practice, but there were so many stumbling blocks, especially the lifestyle diseases people came across, like diabetes, hypertension, coronary artery disease, Alzheimer's, Parkinson's, PCODs. I didn't have a way forward. So I was wondering, what am I here? Like, am I here to only treat colds and coughs and fevers? That's not my lot. So I've been keep pursuing a lot of other modalities from 2014. And then eventually I stumbled upon few handles on Twitter. One handle was Anup's and another Shashi Iyengar's. And then I started following them. As I was following them, I was getting a nuanced understanding of this low carb 100 gram carb protocol template that Anup proposes, and I started experimenting on myself. I also suffered from gluten intolerance, and I started avoiding gluten and taking other millet rotis and all. But I found that not helping me reduce my weight. At one point before COVID, I think I touched almost 87 kg weight. I was in full-blown insulin resistance. I understood what insulin resistance is by then. And yeah, I had renal stones. I was having joints pains, and I had undergone cataract surgery, bilateral cataract surgery in COVID. So I was wondering what's happening with my health. I have never neglected my health, and I consider whatever I'm eating to be a very normal diet that anybody. I don't do much of hoteling, not much of partying, teetotaler, and yet I am suffering from all these things. And I realized I was in a metabolic disease condition with full-blown insulin resistance. And then I said, I need to step back and take a look at what I'm doing actually. So that involved a lot of learning and unlearning, mostly unlearning. And then from COVID time, I started experimenting on my patients. I have done my experimentation on myself, and then started prescribing the diet for my patients. One particular interesting case that comes to my mind is the first patient who I was struggling with treating his gout, the uric acid levels. He was having almost uric acid levels about 12.5 and all. I was able to manage his pains and swellings with my homeopathic medicines, but I was not able to substantially reduce the uric acid levels. So I proposed him that let us for 1 month, just 1 month, do this. And I shifted him on a completely carnivore diet. Mind you, a patient with high uric acid levels, for which I always said no proteins, no non-veg, no dals, no sprouts. And here I am telling him to shift on carnivore diet. That was a big shift in me, because earlier, whenever a uric acid, elevated uric acid levels had come across me, I was to be very stern and strict regarding the diet of the patient, where I totally asked him to avoid proteins. And here I'm totally putting him on carnivore diet. And you won't believe, within 15 days, the uric acid levels started dropping down, like from 12.5, it came down to 10. And then next another 15 days, it came to 9. And within 3 months, he reached a normal uric acid level of below 5.5, 5.4 like. And I was not looking at the weight loss that was happening along with, because I was more focused on the uric acid levels. And here he lost almost 15 kg weight in those 3 months.
Okay.
And everybody was surprised. And another 3 months, 6 months, he had lost 27 kgs of weight. And he was working in a bank. And people were surprised because they had seen him before COVID, and during the lockdown, they didn't see him. And after the lockdown, he comes to the office and in a totally different shape. And people were so astonished. And then they requested me to come to the bank and deliver a lecture on what this new nutrition fad, they called it then, nutrition fad that is. And I said, okay. So there was almost a crowd of 120 bank officers, all the staff, and I delivered my first lecture on low carb. And I'm telling you, I had not joined the course then still. I was just getting all the information from the tweets that I was reading. I was following Ira, Shashi, Anup, and all the D-Life members. And by then, I was quite accomplished in the way that this diet works, the way this nutrition protocol works. I had got a very fairly good understanding of what insulin resistance is by then. And after that session, I enrolled for the course. So I enrolled for the course because from that session, I almost got 20, 25 clients in the next month. Like,
Oh.
and that was a complete change in my practice. Like as a homeopath, I used to interview my client for a 1 hour consultation or 1.5 hour consultation to get to the right remedy. And here my consultation length started going up to 2.5 hours to 3 hours, because again, I have to explain about the diet, the insulin resistance part, the metabolic disease part and all. Yeah, that's how the shift happened.
Yeah. We already know this. You had already told. Yeah, that's great. And this must be very rewarding when you did this, right?
Oh, of course.
Yeah. So another thing what I would like to ask is, what is the most common metabolic disorders you see in your practice, and how much of a role diet plays in the same?
Over a period of time, like, okay, in the beginning, 2020, 21, when I was started practicing this in this thing, there was a stark, clear-cut boundary of metabolic disorders in my mind. Like, so most of the patients that used to come were for autoimmune diseases, for asthmas, for coughs and colds, for skin conditions, psoriasis, eczemas, arthritis and all. And once the patient comes to me, it sticks to me for a lifelong almost. Like, so there are families who have been with me for last 20, 22 years. Like, and then I find them going into metabolic diseases like diabetes, hypertension, coronary artery disease, and I can't help them. So mostly the patient that come across to me is diabetes, hypertension, coronary artery disease, PCODs in females. And then that boundary started getting blurred now. Now I see every time I see a patient, I see there is some element of metabolic disorder in him. Even if he is an asthmatic, even if he is a patient with arthritis, even if he is a patient with eczema or psoriasis, I do find some kind of insulin resistance or metabolic syndrome or nutrition gone wrong. So now it's almost the boundaries have coalesced, and so every patient that comes to me, whether he comes for a recurrent cough and cold, also is guided towards a proper metabolic health way of nutrition and health. Yeah.
So that is a holistic approach, I see.
Yeah.
You are taking. That's very nice. Yes, Sayan, would you like to proceed with the next question?
Sure. So thank you, doctor, for joining us and giving us, this transition that you had. One of the questions I have is that when you talk to your patients and when you talk to other fellow doctors, and the reason I'm saying is that being a certified coach, we face a lot of challenges inside the family also at times to get them convinced about this revolutionary way, because it's not common still in India, right?
Yeah.
And I'm sure you kind of understand that from your patients also. But what are the kind of discussions you have? How do you encounter that? There's misconceptions about, like you said,
Yeah, of course. There is a sea change in understanding of
moving
what.
them into a carnivore diet in a yes,
Yeah. Am I audible?
protocol kind of a thing. How do you counter those kind of yes, we can hear you.
Yeah, of course, the first difficulty is within the family, because there is a sea change in the understanding of diet and nutrition, and what a typical Indian diet of dal, roti, you need to abandon that, and the family is not ready for that transition. So it takes time for you to convince your family and then convince your near and dear ones. And of course, the same case is with the patients. So most of the times when a male patient comes to me and I explain him, I'm doing the myth busting for him. He has understood the science behind the nutrition. He has understood why he is getting this disease, why his health has suffered. When he gets a good insight into this, then the biggest question that comes to his mind is, how do I convince my family? So most of the time, I have to do a second consultation with the spouse, then with the wife of that patient. And I get on a Zoom call and I say, this is what it is. You have to just follow it for 1 month. And if you are able to follow it for 1 month without any cheat, I will assure you, I will guarantee you that you will be convinced about this diet. And if you are able to follow up this diet for another 3 months, like 90 days, people will start following you. It's not about you being convinced. People will start following you. What have you been doing? Please tell us. Just yesterday, I received a call from a female. She is kind of a eklavya. She has never come under my consultation. But I happened to visit her village and I said, this is what I eat. I don't eat the pohe and upma and kind of things. So she understood the diet in a brief this thing. And without telling to me, without me knowing, she was following that diet for almost 6 months. And then her brother-in-law comes and, your disciple has lost 10 kgs weight. I said, who's which disciple? She said she has already lost. Her son has lost another 15 kgs weight, and they are following your diet, but they have not been on my consultation. And yesterday she calls me and said, my neighboring families want to understand this diet. Shall I tell them? So that kind of it's a ripple effect that this diet has. And if you so many times I've discussed this with Dr. Naim also. When a patient comes into my consultation and understands the diet is not for only him, it is for the entire family. Sometimes it is so generic that the entire family can adapt to that diet. Of course, individual clients need more nuanced approach to the diet. There are some protocols that an individual person needs to follow according to his condition that he is in, but there is a generic way of and the whole family starts adopting that diet. And the best part is children get accustomed to that diet so early, it becomes a part of their cultural milieu of that family. And it seamlessly gets integrated in their as a family culture. I've seen this happening so many times.
Sure, that's great. And both of you are doctors here, so I think, and one of the things that we pride ourselves in D-Life is it's made for India, right?
Yeah.
And that's a pretty key, unique USP we have in D-Life today, which Anup and Shashi and Ira has brought in. How have you encountered this entire process of making this low carb concept implementable amongst your patients in a very Indian context, particularly in urban areas? Still people kind of understand it a little bit more because of exposure to various literature or various social media things. But when you move a little bit away from big cities, and I'm sure you have a lot of patients coming to you from those areas also, and we have some viewers today probably are listening to us. How do you kind of make that transition happen? Dr. Gopal, if you could just take 2 minutes to answer, and then Dr. Naim also, you could shed some light on the same.
My USP with my clients is when I take the history, we have a very detailed history taking in a homeopathic way. So by the end of the history, we have formed a chronology of the events of the medical health crisis that the patient underwent right from his birth till date. So we get a good chronology. And based on that chronology, it is very easy for me with this understanding of metabolic syndrome and all to pinpoint exactly where the metabolic disease started, at what point in life started. So my USP is I explain to the patient in his own language, in a very simple terms, how this has happened, how the diet, the eating habits that the patient has been having for all these years has led to the formation of this condition. And once the patient understands this, once the patient gets a knowledge of how he has become sick and what things are that have happened in a sequence, and he is almost able to predict, or I help him predict what next is in store for him, what medical condition is next in store for him. And once he understands that, of course, there is a little bit of fear that the patient gets into, anxiety the patient gets into, but I assure him that this is very much reversible and we can work on this very easily. And with the assurance, with the nudging that we do, I eventually bring him to an understanding where, okay, we have to shift this completely over carbohydrate dependent diet to a protein diet or a high protein, high fat diet. And slowly the diet, I take a daily routine diet chart that the patient has been following all these days. And then from that, I just remove the carbohydrate part and supplement it with the protein. The biggest challenge that comes to me is patients following a vegetarian lifestyle. And I get a lot of patients who don't even eat. I being a meditation coach, so around the ecosystem, many people are ones who don't even consume eggs. So they are totally vegetarians. And fortunately for me, at least they don't have a problem with the dairy products. And if a patient has some problem with dairy products and he is a vegetarian, I just say, I can't help you, because there is no choice that I can offer that particular person. So, but when a vegetarian comes who has no issues with dairy, then yeah, I remove the carbohydrate part and supplement with the protein. So, when I'm telling this, I say, see, when we have decided to adopt a vegetarian diet and shunned non-vegetarian diet, you have to find compensation for the nutrients that are lacking now. Without doing the compensation for the nutrients like proteins and fat and other micronutrients, how can your vegetarian diet keep you healthy? Just eating dal, roti, sabzi is not going to help you, because you will be lacking so many nutrients and micronutrients. And patient get convinced, and I tell them to encourage them to practice for 1 month. And if they see the result, then they can come back and have a more detailed protocol from me then. So many patients do agree because they have worked with me for many years and they do listen to me. But of course, there are patients, some patients who say, no, this is not, this we cannot follow. And of course, as you said, many patients that I have come from the rural and semi-urban background, money is a big issue. And they think that this diet is very expensive. But we find ways around that and say how the cost can be mitigated easily. Yeah,
So,
but
thank you so much.
largely patients accept
Yeah.
this.
Thanks so much. Dr. Naim, if you have any one last question you would like to ask Dr. Gopal.
Yeah. So I've been, yes, Dr. Gopal,
Yes.
what last message would you like to give to everyone?
Indians need to take care of their health. They're heavily carbohydrate dependent. And with the cultural propaganda that is happening all around of veganism and vegetarianism, I say, okay, I respect your beliefs. Even I am a vegetarian person, but you have to compensate for the lack of nutrients that one would have got in a non-vegetarian diet if you are following the vegetarian diet. So being over dependent on carbohydrates will make you deficient in important vital nutrients for the body. So and as we all know, India is capital for diabetes. India is capital of hypertension, coronary artery disease. It's a capital for entire metabolic health syndrome now, with large percentage of population going under its weight, and the health cost is so enormous once one gets a metabolic health disease. So it's very urgent, very important, pertinent for them to pay attention to the diet and reduce carbohydrates to 50%. That what Shashi Iyengar usually tells. If you cannot follow a low carb diet or 100-gram carbohydrate template, at least reduce carbohydrates to 50%. And I tell my patients that, and I recommend that to everybody in India.
Yeah. That's great.
That's great. So thank you so much, Dr. Gopal. Thanks, Dr. Naim, for
Thank you so
co-hosting
much.
with me. Yeah,
Thank you so much.
Shashi, do you want to add anything before we close? Shashi, Anup.
So get in Anup also.
Yeah,
Can
Anup is
take
also
me.
here.
Shashi, I think, is not here. You can take me in.
I'm here.
Oh, then come in.
Nice to see you, Anup.
Yeah, thank you.
Nice to see you.
Yeah,
Thank you,
Dr.
thank you.
Dr. Gopal, thank you very much for coming and sharing. Of course, we heard your great inspirational story in length when you spoke in the homeopathy college when we had a session on metabolic health, and very inspiring. And thanks again for sharing with everyone, because a metabolic health recovery coming with 100 grams carb template from Anup, and especially from a doctor, is going to be very inspirational for all. So thank you very much.
Yeah, thank you, Dr. Gopal. Take-home message is this diet is for family, as you rightly pointed out. And today morning, I was discussing with Dr. Sridhar. He said if this message spreads far and wide, the stress on healthcare system will be less, and it will be left to deal with only complicated cases.
Yeah. So my first target is to reach out to all my homeopathy colleagues, students in homeopathy college. There are 56 homeopathy colleges in Maharashtra. And it's my very inner longing that I reach out to these homeopathy colleagues and share my experience with D-Life and this 100-gram carb template with everybody. Yeah, thank you. Thank you so much for having me
so
on
much,
this.
everyone. Thank you.
Thank you, Dr. Naim. Thank you,
Thank
Sai.
you. Thank you, sir.
Thank you.
Please get Anup Chaudhary, Abhinav, and Ira Sahai. Hello, Anup. Good morning.
Hi, good morning.
Hello, Anup. Good morning.
Hi,
Get,
Anup.
Welcome.
Hi,
get
Ira.
all of us. Get all of us. All 5 of us. Abhinav also.
Yes, I
Abhinav,
have sent a request.
He
yeah.
has to put on his camera and unmute.
Yeah, hi Abhinav and hi Anup both.
Hi, Ira.
Welcome
Morning,
to the
Abhinav.
third Metabolic Health Conference. And while we begin, I'll probably start with the introduction. We have a couple of questions to ask both of you. So, hi, I'm Ira Sahai, a certified metabolic health coach from D-Life. Also, it's Chief Operating Officer, D-Life Healthcare Private Limited. Founded in 2014 by Anup Singh, who's an IIT Roorkee Silver Medalist and Icons of India awardee. D-Life pioneered the low carb movement in India through Anup. His groundbreaking protocol of 100 gram carbs per day max, given in 2012, made LCHF and type 2 diabetes management possible even for Indian vegetarians. In 2021, he launched the D-Life Diploma course, the only Government of India approved program with the world's largest 144 CPD hours credit. Anup and Shashikant Iyengar co-organized India's historic Metabolic Health Conference in 2023 and 2024, and now we are in 2025 into the third Metabolic Health Conferences in the conference. I'll introduce my guests for this session. Anup Bhaskarrao Chaudhary is an Indian researcher in nutrition sciences, having a couple of research papers published in international journals. Anup is also a founding director of Public Health India, PHI, an Indian health advocacy organization, and a consultant nutritionist helping a wide range of populations improve metabolic health and quality of life. Anup aims to bring India-specific low-carb data into the literature to help public health researchers, mainstream health professionals, and health organizations make informed decisions in designing and improving treatment strategies for better metabolic outcomes in the members of public. Abhinav Vithalrao Pathare is a public health researcher from India. Both of them are here with us. He received a Master in Science degree in Applied Public Health from the University of Central Lancashire, England in 2020 with merit classification. His master's thesis focused on felicitating low carb policies in the United Kingdom's national dietary guidelines and received distinction. Abhinav serves as a principal investigator in low carb related contemporary research projects. He has written multiple journal articles and editorials in various public health topics. Abhinav aims to improve public health outcomes through informed policies, strategies, interventions, and communication techniques. He advocates the whole system approach, WSA, for facilitating low carb supportive policies, which encourage the interdisciplinary and collaborative approach. Both have multiple publications and are back in MHC Season 3. Welcome, Anup and Abhinav.
Thank you very much for the invitation and the warm welcome, Ira. It's an honor and pleasure to be here with you all three, and of course with Abhinav. Thank you.
Yeah, I think
Thank you
Shashi can
very
take
much.
the first question.
Yeah. Let Abhinav wants to say something.
No, I said thank you. I was unmuted, so.
Yeah, no problem. Yeah. So, see, we invited you in MHC 1, MHC 2, when we came to know that you had published the first ever diabetes remission Indian case, Indian diabetes. It was so thrilling that we immediately made an allocation, we made a space for you so that you can pitch in and talk about the study. Now, again, in MHC 3, the moment we saw your publication on this sugar industry and as well as the SECO model, immediately we thought this gels well with the MHC 3 theme again. So immediately again we made a provision, and then we added one more session today to take you back, because you guys are doing amazing work in India in terms of publishing something which is of very, very importance. And I think the first question will be Anup
Anup's.
Singh too, because he is very itching to ask a specific question. So Anup, I hand over to you. You can ask them the question you want to ask.
Thank you. Before I ask my question, I would like to highlight that both Abhinav and Anup Chaudhary are engineers.
Okay.
It's going off and on. Anyway, just in case it was missed, both Abhinav and Anup are engineers, and that, being an engineer, I'm very happy to see engineers coming into this nutrition field. Now, my first question would be, what was the primary motivating factor, to look into this? Was there any trigger point or data set that came to mind that, that pushed you into publishing a paper on this?
Okay, so yeah, there is a trigger behind taking a decision to write this article. And that trigger point was the humongous amount of money that the sugar industry is putting in, proliferating this SECO model. So, for instance, so they always say that whatever you eat doesn't matter. You just have to count calories. It is always okay to have their products. So, for instance, in the year 2013, PepsiCo paid a humongous 396 crore rupees to BCCI for getting title rights for Indian Premier League. And Indian Premier League is one of the well-known shows in India, and with a viewership of 400 million people across television and OTT platforms. Then Coca-Cola, for example. So over the last few years, they are spending $4 billion US dollars every year. So if you convert it in Indian rupees, that becomes 35,000 crore Indian rupees. Now that's the, it's a monumentous amount of sum that they're putting in to market their product. Then for almost 41 years, McDonald was one of the top sponsors of the Olympic events. And then the list goes on and on and on. Coca-Cola, for example, is the longest partner of Olympic movement, and they are sponsoring Olympic events from 1928. There was one instance when Cadbury was rejected. The sponsorship from Cadbury was rejected in 2012 Olympic by the Olympic Committee, and it was because it was not a good fit in that particular context, because it was a sports event. But the explanation that was given by then CEO of Cadbury was that it is absolutely fine to have their products as far as an individual knows how to balance it with exercise. And then they got that opportunities. They paid some $100 million to Olympic Committee, and then they got the sponsorship. So this is how these are, entering into the field and playing with the science. Now, when I see the apex bodies, so most of them advocate this energy balance model. So the balance model has its roots in thermodynamics. And as I have the engineering background, like Anup said, so I'm having good understanding of thermodynamics, and I always saw inconsistencies in the theories that they are explaining, because the thermodynamics is a concept of physics, and we cannot apply physics on human body. Human body works on biochemistry. And when I saw this inconsistency and the inapplicability of these thermodynamics laws, I started my further investigation, and I explored carbohydrate insulin model. And there I got the solution that what exactly causes obesity. It is not just about how many amount of or how much amount of calories we are eating. It is the endocrinological effect of the calories that is making people fat or obese. So this research article is the symbolism of my effort to informing obesity science to the public. So this is how I get into it.
So how pervasive is the sugar industry's influence in obesity science and sports nutrition? I mean, other than what you told, what other things are we should know?
Correct. So this is a very pertinent question, in fact. So there are basically two ways of pervasiveness, and they are remarkably successful in doing so. So how they do it? So the first thing is that they first downplay the link between their products and obesity. By doing so, they first, delay the public health guidelines and the public health policies. Because see, there are two ways to do this. One is by weakening the public health policies aimed to go towards reduction of sugar intake or sugar consumption, and second is to delay it. So they know the answers for both of these two. So the first one, they will downplay the link between obesity and their products, and that is how they weaken the evidence that is there. And second thing that they do is they create controversies in the science. And by creating the controversies, they delay the implementation of the public health policies. Now, for example, in the year 2016, there is a very good article that was published, and it was about sugar sweetened beverages. Now, in that article, what authors did, now the extrapolation of the data and the conclusion that was drawn is for both sports nutrition as well as public health nutrition. Now, what authors did within the span of 2001 to 2016, the research papers aiming towards the link between obesity and the sugar sweetened products. So they excavated all that research and then they analyzed those research papers. And to their surprise, they found that the research papers and systematic reviews and the clinical trials that were supported by sugar sweetened beverage industry SSB. So the investigators was much more likely to find no association at all between their products and obesity and metabolic outcomes, compared to the other studies which were funded by some other things or they were self-funded. So that is how they play with the science, and they will always see a chance to exonerate their products. And that is how they either weaken it or they delay the public health outcomes or public health policies.
Yeah, just as an extension of this, Anup and Abhinav, can you highlight some of the more, I mean, you already spoke about it, but something that, people can immediately click with and, relate to some glaring examples of industry funded research, which has skewed up, scientific consensus?
Well, this is very interesting, isn't it? Like the biasing in the consensus, but it has led to it. So funding itself is biased away from the topic of importance. For example, BIRAC there is a council in India called as BIRAC. So it's a Biotechnology Industry Research Assistant Council. So BIRAC is a interface between industry and academia for the fundings for the research, the raised fundings, which is a good thing. It's a good strategy. And 74% of the studies that those have been funded by BIRAC are in light of the healthcare research. So it's again a good thing. But where is the biasing happening? It's on the topics of the research. So almost 58.7% of the studies funded by BIRAC were in light of the medical technology. Okay, because medical technology involves certain devices and techniques, and there is a way to commercialize those things. And then 24.5% research was in the therapeutics, and only 3.5% was studies were related to the public health, which we need to inform the chronic diseases. And again, there is no problem, or there is barely a problem of funds, because within the year of 2007 to 2012, in these 5 years, different institutes in India had almost 42 billion Indian rupees for doing research in healthcare. In American dollars, it was like 925 million. But again, only 4% of the fund was allocated for the non-communicable diseases like NCDs, which shares 20% burden of Indian diseases. So the skewing happens before the study starts, before the fund is allotted. They wouldn't even take interest in the research, which will not be, whose results will not be used as a commercialization. And of course, whatever research happens, like the tiny amount, and there is this skewing of scientific consensus. Wherever sugar industry is involved, they would shift the blame on the saturated fats and salts, pushing the lipid hypothesis. Whenever the food industry is involved, they would push this calories in, calories out model, and then shift the blame on the lack of physical activities. So skewing happens on both of the layers before the research starts and after the research has been completed.
Yeah, so interesting, Anup. Your question. Anup's question.
So, what are the primary, Anup, you had touched upon the perception briefly how they manipulate, but what are the primary, weapons of perception that this lobby uses when it comes to obesity and everything else?
Okay, so uh, this is again an important question to understand because there is a multiple layers of manipulation. So the first thing that the sugar industry is doing is making people comfortable. They are telling people that it is okay to be obese. And now how they will create the culture of obesity. So they are having multiple solutions for that also. So they will take some obese models on the front cover of the magazine. They will take obese people in the advertisements, and they will set up some statues having belly protruding out in front of the fashion stores selling clothes.
Plus size,
Now,
they call it.
so yeah, plus size or whatever. But you see the picture that they are putting in front of people. It is like to create a culture where people will be very much comfortable with obesity, and they will see that yes, it is fine to be obese. But the real problem that lies here is that obesity always come with some metabolic disorders, and people don't know about it. So it is really perilous to keep people in darkness and saying that obesity is fine, you are absolutely okay. That is one thing. Second important thing is the amount of money that they're spending in in propagating this narrative, which is wrong. So, for example, as advocated by Shu 2013, so he reported it. So, Coca-Cola has this famous quote that if you eat more calories than you burn off, you will gain fat or you will gain weight. And this wrong science they portray is at a common sense. And when people cannot achieve a proper weight after following this advice, they advocate the same concept as, or they advocate this as their personal responsibility. So they will never take a blame on themselves. They will always blame people. You probably is not physically active. You are leading a sedentary lifestyle. This is what they are doing. And on the top of that, there are multiple campaigns they are running. So, for example, in 2010, PepsiCo was having this Let's Move initiative. Then there is Mixify was one campaign that they run. It was specifically targeting the teens. Then there is school beverage policy announcement that they did in 2006. So there are multiple campaigns they are running, and they are ostensibly doing these things by taking health related campaigns where people see that they are promoting it for health, but they are having some different intentions and a vested interest at the cost of public health. So this is very dangerous that they are comforting the people and then they are advertising it and they are, spreading these bad science on the name of public health.
Correct.
Yeah, so they have normalized, basically they are normalizing, obesity.
Yeah,
And the
they are
unfortunate part
setting the
is if you
culture.
call some fat person fat, they retaliate by saying,
Yes.
you're fat shaming us.
Yeah,
Yeah.
and fat shaming is now considered as offense.
Yes.
So you cannot do that. So they are creating a culture around us.
How is it that these industry-funded studies still manage all this deception while fooling the public? I mean, you are given us a lot of insight. Is there something else we need to know?
Well, this is a really insightful question, and despite there is a growing body of evidence on the other side, how these things happen. Okay, in every field, there is some profession which is dominant, or whom the public trust, and sometimes blindly trust. And if the industry could buy their image somehow, it works. Indian Medical Association was founded in 1928, and the primary objectives were, of course, like promoting medical studies and public health. But over the years, so far, they have endorsed numbers and numbers and numbers of commercial products, including PepsiCo's. So in 2008, PepsiCo has received endorsement from the IMA. IMA is the apex body of medical doctors, including approximately 350,000 doctors. So they have received an endorsement from that association for the Tropicana juice and the Quaker oats. Both are the products of PepsiCo. You wouldn't find the name PepsiCo there, but some other like children brands. So when such things happen, the industry it gets easier for the industry to buy the trust of the public because they are buying the image of the people whom the public trust. So this is a very disturbing situation. By the way, I'm not getting into celebrity endorsements because they are the celebrities, but these association and health association endorsements are very dangerous. And again, like instead of promoting or endorsing a bulb which claims to kill 85% of germs, or instead of endorsing a pent which claims to kill 99% of infection causing bacteria on your walls, I am insisting and requesting them to get into the low carbohydrate science, which has a number of studies backing the effectiveness of it in the metabolic health, but they're not doing it. So it becomes easier for the industry to mislead people in a subtle way when there are no strict policies for the associations to take endorsements and exchange money or any other exchanges that they may not tell very clearly. So this is one of the ways it happens. There are many ways, but this is the way I wanted to highlight because this is the breaching of trust of the public.
It is very ridiculous. It seems something like what has happened with AHA and Crisco. So here we see somewhat in a smaller way what's happening, and it's also ridiculous that they endorse paint and bulb and everything. Yeah,
And
next.
still, you people are the only one who are getting into the mainstream low carbohydrate conferences.
Yeah, Anup and Abhinav, very, very interesting insights. I just cannot, draw parallels, something as sinister and big as this is happening. Do you think there are any parallels with the big tobacco, thing that happened in the later half of the 20th century, when they were using political manipulation, lobbying tools, misinformation in the public domain just to sell tobacco? Do you see the parallel there?
If this question is about what I think sugar industry has outshined the tactics of tobacco industry. Tobacco is, of course, is a problem, no doubt, and it also has warning labels. But no sugar product so far has a warning label that it causes diabetes. And if this question is about what current data can demonstrate, then of course there are parallels, and these resemblance of tactics and strategies are remarkable. So, for example, there are facets to it. First is funding.
Correct.
Okay, so they would fund the research whose results they can use for commercializations or to distract from the actual solution. All right. So second is publication. They are targeting publications. They want to make maximum interest into the literature, which favors them and downplay the links between sugar and the chronic diseases. This is also one of the parallels that they share, the big tobacco and big sugar. Next is separation of a good science. So John Yatkin from United Kingdom, he had always like pleading in front of the scientific consensus that it's the sugar, it's not the fat that's causing chronic diseases, but got suppressed due to the n number of forces that was skewed towards sugar industry. Next is they criticize the good research, and the thing with the science is that every research has its loopholes. So what they would do, the sugar industry or the big sugar, that hey, there are holes in this study, but there are holes. There are always holes. There were also holes in the studies that linked sugar with the with chronic diseases, and there were also holes in the studies which linked saturated fat with the chronic diseases. But instead of filling them up they would just criticize. They wouldn't constructively criticize it. Or I mean, there are evidence that can demonstrate that they'll ensure that these holes will not be filled. Another thing is public relation, as Anup said. It is now a common sense that if you eat more and expend less, you're going to be obese. So they also have that press conferences, public relation campaigns to take care of it. And the most dangerous thing is policy. They want to avoid the legislative actions, and big tobacco did this for decades and decades and decades after the first link was uh, explored between the big tobacco and lung cancer. And here they are doing the same, as Anup told, that either they would weaken the public health interventions or by downplaying the link, or they would create a controversy and delay the public health interventions that are actually needed for the reduction of the sugar consumption. And unfortunately, these things are working for them. And there are evidence to attest to this, like the internal documents of sugar associations in the history. This can demonstrate clearly what I said now in response to this question.
Yeah. Anup.
Yeah, big tobacco, camel cash is very popular.
Yeah.
If we have gone into the history of how tobacco industry was, publishing that most doctors smoke camel,
Yeah.
right? Yeah, way back, way back. Now extending to, acha, that move more, eat less. As far as diabetics are concerned, largest federally funded study had failed. And it had around 5,000 plus type 2 diabetics, 13-year by design, and they dumped the study after 12 years because there was no link between eat less and move more. So SICO model has failed repeatedly, but still, how do you think this energy balance weaponization has worked till date? And it will work in future also.
So I have a very specific resource and specific uh, thing to share on this. Am I audible? I think Anup, Ira, and Shashikant, your videos are freeze. Hello.
You're
Yes, sir, you are
audible.
audible.
Okay, okay. So yes, so this is a very important question, and they are still managing to do this and weaponizing the energy balance model. So I have a very specific resource or specific, research paper for this. So this was published in 2016, and the title of this paper is Scientific Organizations and Coca-Cola's War Against Public Health Community. So that was published in 2016. So this article, the story was actually, revealed by New York Times in 2015, August 2015 to be precise. So Coca-Cola back then entered in the market with three strategies. The first one was to advance energy balance model as the right framework to deal with obesity. That was their strategy first. Second thing, they they established Global Energy Balance Network, GEBN, it is acronymed as, and they established it by spending $1.5 million. They themselves created it. And then they showed it that it is ostensibly, independent broker. It means that there is no link between Coca-Cola and GEBN, so to speak. And they portrayed it as an independent broker with the scientists having sympathy in alignment with their goal. And the third strategy that they used was to convince policymakers, journalists, and public that it is energy balance model that perfectly defines the obesity science. So they did it by spending this much amount of money. So this is the kind of things that these industry people are doing, and this is just one example. There are many more following this, having very serious implications when we look at the public health. So they have nothing to do with public health. They are just pushing in their products and spreading bad science with these things.
So keeping all this in background, how are this misinformation, they have impacted the sports nutrition?
Well, one of the keys to do good science is to keep an alternative hypothesis in your mind while you check the preconceived idea. So, for example, this is the preconceived idea that carbohydrate is the base or the primary macronutrient for energy, and you cannot eliminate it. It is an indisputable macronutrient for the sports nutrition. This is the preconceived idea. And if there is an alternative hypothesis that you can also use fats instead and in a better way, but this is the but if there is a commercial interest, this key gets diminished. You cannot go on the alternative hypothesis and then accept it. So the correcting nature of the science is in problem when there is big commercial interest or conflict of interest. So what I'm trying to explain is the International Olympic Committee has a nutrition working group which publishes a brochure or guidelines, practical guidelines for health and performance. So both. And then there is a medical commission involved in it, International Olympic Committee's medical commission, athletes commission, which is, of course, it's very relevant. But Coca-Cola is a partner with the nutrition working group of International Olympic Committee. And when this happens, it's very hard to imagine that there is no influence on the current advice. So if you could see that practical guide published by the International Olympic Committee, it still relies, like it may acknowledge on a few instances that different macronutrients are required for different purposes inside the body, but they would simultaneously they will also talk about the energy balance theory, and still the carbohydrates are pushed as the primary nutrient for sports nutrition. So unless we don't eliminate these commercial partnerships from as prestigious nutrition working group as of International Olympic Committee, CICO and the CIM model will not get its justice because the moment they will acknowledge that different calories are metabolized in a different way and you cannot outrun its effect by simply exercising, they are not just only losing the sports nutrition, but they are losing a lot of their products which are now leading in the markets.
Yeah, Anup and Abhinav, very interesting to know these. And as a repercussion and also as an extension of this question, do you think elite athletes are being misled into over-reliance on carbohydrates due to food and in beverage industry messaging?
Yes, absolutely. So as Abhinav said that this high carbohydrate advice has penetrated into, sports nutrition advice and the guidelines. So we have so many examples that these athletes in various sports are suffering, or they are, facing a lot of metabolic challenges. They are getting obese. So for instance, marathon running is considered as one of the highest form of calorie burning exercise. But then there are examples where marathon runners are gaining weight within the span when they are into that sports. So it is a classic failure of SICO model. But then these kind of news they will never allow to come into the market or into the media. And then there are so many examples from the other sports also that I can gather. But here, the major problem that I see is the new generation of athletes because they follow these elite athletes. So they are more vulnerable to this bad science. So they are to be protected. So yes, there is a problem, and elite athletes are also, the victims of this bad science.
And being a victim of bad science, I would say Professor Knox, the ultra marathon runner,
Yeah.
doing everything right, and he turned diabetic. The moment he started talking about low carb, way of running, I think his sports gel company cancelled his contract.
Correct.
Right? That's on paper, I think. And he has mentioned it somewhere in his book or somewhere. Now, coming back to, this all this Uh, Obesity has been normalized. You cannot fat shame, right? So, and since you both are researchers doing a lot of number crunching, obesity versus metabolic, though although obesity is also part of metabolic disease, but other metabolic diseases, what is the exact, relation, correlation, if we talk in terms of numbers?
Uh, can you repeat the question? I'm not understanding it.
See, this misdirection of rising obesity, that this has been normalized, right? And this has been normalized, so people are getting into other metabolic syndrome like diabetes, hypertension. So, do you have any numbers like how this obesity, rise in obesity, and other diseases, how are they connected
Or to put it
in
in
terms of?
perspective, what he means is what is the real world impact, how it is happening.
Yes.
Real world impact. Okay. So, real world impact of this science, the energy balance model, is enormous and it is obnoxious actually, because as stated by three legendary people working in this low carbohydrate space, Dr. Asim Malhotra, Professor Knox, and Steve Finney. So they published an article in British Journal of Sports Medicine in 2015. So if carbohydrates is merely unnecessary for exercise, it would be of little concern to public health or little problem to the public health. But the growing concern is that the insulin resistant athletes are at higher risk of developing type 2 diabetes if they continue eating high carbohydrate diets for long. So now, because high carbohydrate diet actually worsens the condition called insulin resistance. Now, if we see, athletes are or vulnerable to diseases because they are the one who are following this ubiquitous advice of exercise and counting calories or taking care of nutrition. So they are doing that already as per the suggestions that they are getting from the authorities, but they are also at the risk of developing type 2 diabetes and other metabolic diseases, and we have numerous examples for this. There are cricketers who have gone through heart diseases or have died through heart diseases, and from other sports also there are a lot of examples. So if these athletes are at risk, then if we think of the normal public who are just blindly following these guidelines, what will happen to them? This is really disconcerting and very unsettling to me, that to see the picture that the future is very dark in metabolic health.
Yeah, Saurav Ganguly at young age of, I don't know what his age was, suffered from cardiac event.
Yeah, there are many more.
Yeah,
There are many.
nobody could have been more, active than a cricketer,
Yeah.
through his life, all through his life.
And Anup, also I have a tiny insight to build on what you asked about the numbers.
Yeah.
So there are numbers, there are always the numbers, and then there is an argument between the percentage and the total numbers. But the problem is that the bedrock problem here is the controversy they create around. So let us suppose obesity is extremely prevalent. Diabetes is a capital, like India is the capital of diabetes. It has been coined many of times. But the fact, and this is a fact, that correlation does not mean causation. So they will use this to again confuse to people or to criticize the research, and rightly so, because correlation does not mean necessarily the causation. So if two things are going, like sugar production in India is rising and the obesity is on rise, even if you have these numbers, these only establish the correlation. And for establishing causation, it needs randomized controlled trials. And then again, it goes to the fundings and the skewing and the biases and all. So it's really like if you don't want to agree, you just confuse people. That's what they use, the philosophy.
Yeah, correlation not equal to causation, cherry picking, I would say, to defend their product, but criticize meat at the same time.
Yeah,
Right.
correct. Both ways. It works both ways for them.
So,
Yes.
so with so many issues which you told, how do we as consumer, a lay person, or even a professional for the matter, they understand or they can identify the conflict of interest?
Well, this is very tough. I would, of course, I would start with encouraging to read the conflict of interest section in the research paper.
Read it
And
first. Read it first before
Read-
going through the papers.
yeah, disclosure first. But if it was only that simple, that they would clearly acknowledge everything there. There are instances that prestigious universities have sometimes did not disclose what they had to at the time. So it's very tough to understand that. But what I would like to highlight here, bias happens on multiple layers. So, and the most vulnerable spot is the agenda of research. So, first of all, they will influence the agenda of research, the question you ask. So, for example, you take some people, starve them, and they will lose weight, but that doesn't explain anything about why they got obese in the first place. So they would interfere with the agenda of research. They would only set the question in the way that the answer will benefit them. So it starts way early. And then there are biases in the methodology and how they conduct the research. So you have to look into that, how they selected the participants. For example, Ansel Keys' study, he cherry-picked the data for 7 countries, whereas the data was available for many countries. And then again, the biases happens in the results, how they interpret their results, and how they discuss their results. And again, the biases happens while disseminating the health communication to the people. Sometimes, as you said, that sometimes they use this correlation thing to defend them, and sometimes they use this correlation thing to for their benefit. Always, by the way. So it's very tough to understand, but whatever the institutions and the groups that are mentioned in the disclosures, read about them, because they would not always straightforward mention PepsiCo or Coca-Cola. They would mention the councils or agencies or the groups that they made, and then to mention their name in the research to avoid the direct names.
Or
Yeah,
Howard. Or
yeah.
Howard. Yes, sugar lobby, they bribed a professor at Howard, I think, to bring a bad name to fat.
Yeah.
This corruption goes back, centuries, I mean, if not centuries, decades back.
Yeah, it is like.
And
that was out in the media now.
Yeah,
like,
Anup, I would like to quickly know from you one last question we can still, squeeze through. Is there any major sports organization or a governing body that has finally started not acknowledging the role of diet over just exercise?
So yes, there are major bodies now acknowledging the role of diet. So, but the problem here is that they are acknowledging the role of diet, but alongside exercise.
Hmm.
And if we look at the diet that they are recommending to athletes or a particular sports or maybe for a better public health outcomes, this they are still revolving around the high carbohydrate, theory. So, for example, in the International Association of Athletic Federation, IAAF. So, if you read their consensus published in 2019, they are still recommending high carbohydrate based diet for athletic performance, for endurance sports, and importantly, they are still considering carbohydrate as a supreme source of energy. And the amount of carbohydrates that they are recommending is somewhere around 7 to 12 gram per kg body weight per day. So, for example, an athlete is 60 kgs of weight, and if you consider mean of that value somewhere around 10 grams, it becomes 600 grams of carbohydrates in a day. That's the plethora of carbohydrates which is going to put anyone into the risk of metabolic health. Then there is ICMR and NIN from India. Then there is ACSM, American College of Sports Medicine. These all are acknowledging the role of diet, but uh, all of them are revolving around that concept called energy balance model. And none of them are considering fat as a good source of energy. So that's the problem.
Yeah, okay. Thank you, Anup. As much as we would like to, have more of, these conversations, maybe in a D-Life podcast sometime very soon. But thank you so much, both of you, for coming and speaking on the calorie burning myth, sugar companies' influence in obesity, science, and sports. You can follow both Abhinav and Anup on Instagram and Twitter. Both of them are there, and follow their work. Thank you so much for coming over and speaking to us, both of you. Thank you, Anup, Shashi,
Thank you.
Anup Chaudhary,
Thank
Abhinav
you.
Patel.
Thank you.
Thank you.
Thank you.
Thanks a lot. Thank you very much.
Today we have learned a lot from you both, and we'll have a longer conversation later on. Thank you very much.
Thank you. Thanks a lot. Bye-bye.
Please get Tracy in and Prajakta. Hi, Tracy.
Hi, Shashi. Lovely to see you. Hi, projector.
Hi. Hello, I'm Prajakta Abhyankar, a member and a certified metabolic health coach from DLife.in, India's first and the only award-winning low-carb platform. DLife was launched in 2014 by Anup Singh, a silver medalist from IIT Roorkee and a recipient of Icons of India Award. Anup is the pioneer of the low-carb movement in India with his path-breaking 100-gram carbs per day max that made not only LCHF but even type 2 diabetes remission possible for Indian vegetarians. In 2021, DLife launched its diploma course, which is the only course approved under NSDC partner, the Government of India in this segment, and the only course with the global biggest 144 CPD hours credit. Anup Singh, along with Shashikant Iyengar, is the co-organizer of this third Metabolic Health Conference. Today is the second day of this conference, and I thank you all for joining me for this session on addiction, awareness, and action. It is my pleasure to welcome our esteemed guest, Tracy McPeath, the health and healing coach from Melbourne, Australia. Hi, Tracy.
Hello, and thank you so much for having me, asking me to be a part of this summit. It's such an honor, and I really hope I can impart a little bit of insight and information to the listeners.
The pleasure is ours. To introduce Tracy in short, she is a mom of 5, an author of 2 books, a global health and life coach, a mentor, a nutrition network lecturer, a qualified personal trainer, a public speaker, and a podcaster. Tracy has worn many hats in her career. She has worked in human resources and then she became a personal trainer. But health and life coaching is where her passion and purpose live, helping people see they have the capacity within them to live the life they want to live. She also is now teaching medical practitioners the benefits of coaching within the Nutrition Network Medical Certification Program. Tracy has also lectured within the Holistic Medicine for Addiction with Bitten Johnson, whose session we had on day 1 of this conference. She wrote her first book, You Have Today, 100 Insights That Will Change Your Life in 2021. Her second book, The Daily Insight Companion in 2023. And in June 2023, she spoke at TEDx Katumba on becoming the navigator of your own life. Tracy is an insight-based coach, which means she never shares anything she hasn't profoundly experienced or seen in her own life. Now at 51, she is the leanest, healthiest, and happiest she has ever been. Today, I'm going to try and know the secret mantra behind that. So welcome again, Tracy.
Thank you so much for having me.
So we would first like to know something about your own personal journey to start with. How did you come into the field of health and life coaching?
Well, I think like most people, I had a medical crisis, if you like. So 11 years ago, when I turned 40, I was told I was pre-diabetic and had fatty liver, and I was 18 kilos heavier than I am now. And I think, it just was my wake-up call, if you like. I was a personal trainer at the time. Just hearing that little bit of a discussion around exercise, I was very high carb. I clearly wasn't doing really the right thing by my body. But I also, carried with me a few secrets in that I had a sugar and alcohol dependency. I steer away from the word addiction so much, but it was definitely an addiction, if you want to call it that. But I also had a codependency. So, I was very, very lost. And I was very, really on the path to becoming very metabolically unwell. So that was my wake-up call. And I got into health and life coaching, first and foremost to find answers for myself. And I've continued to do that along with, really, I think, just helping others who are curious enough and really want to change their trajectory as well. I love the work I do. And, for anyone that's curious and open, because we have to be that. If we want to change anything in our life, we have to be really curious and open to doing so. And this is why I do what I do.
Good to know that. So in few of your previous podcasts, you have mentioned about LCHF, way of eating and how it has helped you overcome a few health issues. So can you tell us more about the difference LCHF made in your own life?
Absolutely. So I was very lucky when I turned 40 and had this diagnosis to have a doctor who was very early in Australia in the low carb space, kind of, started to understand nutrition and the impact on health. So he was able to guide me along. You know, that was a long time ago, 11 years ago. There wasn't a lot of information around. Even Prof. Noakes was only just starting to sort of talk about it and have his own epiphanies. So I was very lucky, but my journey kind of started with just the sugar. I took the sugar out first, and then I went low carb. And I think, like many people who have been in the space long term, I just continued exploring and, you know, sort of went keto after that. And when I turned 46, I was diagnosed with Hashimoto's. And that's when I went carnivore. I was already kind of exploring it. I had a few clients that wanted to explore it, and I went down the carnivore path then, and I've pretty much stayed there. So, you know, I'd say I'm 95% animal based. Love it, and I choose to eat that way because it makes me feel the best. And I've healed all my, you know, everyone says, oh, I don't know autoimmune like Hashimoto's could be healed. It absolutely can. I think it's important to know that, you know, just going low carb for me or just changing the diet wasn't enough to really help me heal myself in terms of alcohol and the sugar. So for about 4 years, I knew what I was doing was making me sick, but I just didn't know how to stop it. And I think that has propelled me to continually learn and investigate and just try different things in terms of what the healing path, you know, does need to be, because it's not quick. It's quite long and there's many layers to it. And I've certainly, you know, I talk about it like the many doors of healing. There are many, many doors we have to go in, and nutrition is very important, but it is only one of the doors that we need to go in.
Of course, there are various aspects of healing. So moving on to today's topic of discussion, addiction, awareness, and action, let us start with the basics. So when and why do you think food, which is actually a basic need of every human, turns into an addiction?
Yes, such a great question. I love this question, and it really, you know, I've really reflected a lot on how I want to answer this, because I don't think it is just as simple as the sugar and the carbohydrates. And I think it essentially what we have done as a human species is just totally stuffed around with our food and our food environment, which largely looks not like it looked when we were evolving as humans. It's really quite difficult to understand what even real food is. I talk about eating real food, and even, you know, today, if you walk in the supermarket, there's only a very small section of it that actually is real food. So what we've done is we have disrupted, you know, our brains, because we've, you know, back in the 1940s, and certainly in the US, and it was adopted here. And I must admit, I'm not sure if it's the same in India, but we fortified everything. So we started to fortify, you know, flour. So with all these vitamins that were energy producing. So we took something that was in and of itself just nutrient devoid, you know, powerless really in the body, and we injected it with a super fuel, which meant that our brain just could just take it and use the energy. The problem being it was still nutrient deficient. So that is a problem. So if you think about anything we eat that has grains or flour in it, and, you know, certain like grits in some parts of the world as well, like oats, it's fortified. So being a big problem, because the brain can't really recognize what's truly in this product. So it makes it, you know, I call it hyper craveable, if you like. It's something that really sets our brain to crave more. So that is the carbs, but I believe a lot of that has come because we've played with it and we've fortified it with things that are not naturally in the food. And then, you know, we've even played with it even more by, there's a term called nutritive mismatch. I don't know if your listeners have heard it, but it's a term that basically talks about how the food today isn't recognizable by the brain, to the brain. So if we think about zero sugar, right? Everyone thinks if they go zero sugar drinks, it's better for them, right? But the problem is it doesn't taste like zero sugar. So it tastes very sweet. Yeah, but the calories aren't there. So it confuses the brain. It's got this nutritive mismatch. And all of this, you know, really leads to a brain that just can't recognize what we're eating. And if our brain can't recognize what we're eating, there are problems. So, you know, all of it then comes down to the fact that it plays with our neurotransmitters in the brain. So it's not just food. But if we think about what are we exposed to first when we're born? So it is obviously food. And I don't know about you, but, you know, certainly for 3 of my 5 children, you know, they were given rice cereal and grains and fortified stuff, you know, when they were weaned off breast milk or had formula. And actually what I didn't know then, which I do know now, is that is actually priming the brain, because the brains are already starting to get confused. It's playing around with the neurotransmitters. And then now, you know, we're throwing in the next thing, which is screens. So, you know, a lot of screen times, a lot of kids are given iPads and phones and things like that. Again, it's disrupting these neurotransmitters in the brain. And I think it just goes on from there, you know, as we sort of think about kids growing up today. It's very, you know, obviously something I think a lot about, because I have 5 kids from 10 to 23. And I think we have to be really vigilant to understand that there is just so much in our environment now that can disrupt our brain. And addiction is essentially a brain illness. So we really have to look at what are those things. And it's not just food. There are many factors to it. And I see people who are coming off one addiction, they tend to go to another one because they haven't really addressed the fundamental problem with, you know, the brain illness in the first place.
Yes. So do you think there are certain type of foods, or rather any inputs, sensory inputs that we receive, which it is very easy to get addicted to than others?
Other foods, are there more addictive foods than other
Yes,
foods?
are there more addictive
Absolutely.
foods or other type of inputs that get you addicted very fast or very quickly to them?
Yes, I think so, but I think we have to see, look, it's a very individual thing. I mean, we all know people that can drink in moderation, have one drink and they're not alcoholics. We all know people that can kind of eat certain foods and just have, you know, a tiny bit and they're done. So I think that is a very individual thing. I think we have to look at our own situation and, you know what is triggering, you know, for ourselves. But I do think that as soon as we move away from real food, we're playing with fire, and we're putting a lot of risk into what's going on in our brain and our body. And essentially, I believe, whether there is an addiction or not, we all really, if we want metabolic health at a holistic level, brain, whole body, we all really need to, you know, prioritize eating real food as opposed to, the other stuff that's not food.
But in other sense, do you think that screens are more addictive than books? It is easier to get a child addicted to screens than to reading books.
Absolutely. Yeah, because what's happened is corporations have latched onto the science around the brain. They know how to manipulate the brain, and dopamine particularly, which, you know, dopamine is our reward center and our motivation center, right? So without dopamine, we would have died off as a species. We need dopamine. But what we don't need is this easy dopamine that is just flooding the brain and really unbalancing things in our brain, which leads to big highs and then big lows. And, you know, books give us an imaginative reward. And I would say reading a book is a form of earned dopamine. So we do get the reward, but we have to read the book first, as opposed to pressing a button, scrolling these reels or things that are just so instant. They give us that instant, easy hit of dopamine. But in the long run, it's not doing us any favors at all.
Yes, very true, very true. So what role do you think the environment, now in case of food environment, it might consist of social media, advertisement, grocery stores, supermarkets, do the food stacked in our own pantries play a role in developing addiction?
Absolutely. I mean, can you imagine being an alcoholic and, you know, just having alcohol everywhere? I mean, sugar and processed food is everywhere. It's on every street corner. One of the doctors I really admire in my space talks about it's like your drug dealers on every corner. It is everywhere. And they absolutely do play a role. They take no responsibility for that because they put it back on the individual. You know, hey, you don't have to buy it. And that's fine. And that is essentially true. But at the end of the day, if you're trying to heal from an addiction, it's very, very difficult when it's all in your face. And, you know, there are triggers everywhere. For example, I've had many clients that would go and fill up their car with petrol and habitually buy a chocolate bar, right, at the same time. So their awareness of that behavior and that habit is so ingrained. It's really, really difficult in the early days to go and fill up your car with petrol, because the brain instantly says, hey, there's a chocolate bar there waiting for you as well. So I think they're very much, they don't help. They make it very, very difficult. It's not impossible, but, you know, I think essentially we have to heal ourselves so well that we get to a point where, you know, none of that has an impact on us anymore. And that is possible to get to, but that does take a lot of work to get to that point.
So other than this external factor like environment, do you think there are internal causes like stress or mental trauma that contribute to addiction?
Yes, I do. But my point around that is I think that the brain is already primed for an addiction. So there is that brain, remember, it's a brain illness. So we can have stress and trauma. If we have a brain that's functioning well, that won't necessarily lead to an addiction. And I think here it's important to distinguish between emotional eating or stress eating, which a lot of people do because they've been conditioned to eat or numb their stress and their feelings. But that isn't necessarily addiction. We can have that and still have an addiction, but, you know, we can also have that and not have the addiction. So yes, going back to the stress and the trauma, absolutely it plays a part. But I think the healing has to come with the brain. We have to heal the brain while we're understanding our humanness and how we work, and understanding how things like dopamine work in the brain and how, you know, the environment impacts that. And then, you know, I think it's very hard to get help for our trauma with a brain that's not working metabolically for us. I think we need to make sure that we do that. And, you know, the trauma help doesn't, look, I don't like to say there's an order to it, because some people, you know, that may do really well with the trauma help and then, you know, work on the metabolic. But perhaps they go hand in hand. We really need to make sure we address both.
Right. So do you think there are any other factors than environment or internal factors like stress or trauma that might be contributing to developing or advancing any addiction?
Any other factors other than stress and trauma? Yes, absolutely. In the environment. So, well, I would say a big one that I've been learning a lot about over the last couple of years, which I didn't, you know, would have loved to have known this earlier in my healing myself, but is circadian rhythm. So, you know, that shows up as stress in the brain and can often affect the same centers in the brain, addictive centers in the brain. So if we have a disrupted circadian rhythm, then we are more likely to, you know, more susceptible, if you like, to these things as well. And that's, you know, again, it's environmental, because we live indoors so much more now. You know, we're under artificial lights a lot more. We're not outside. We're, you know, largely a society that sits on a computer all the time. And, you know, those things do definitely affect our circadian rhythm, because the sunlight is what times the body for all the processes that it needs to do. And hormones can be very light sensitive as well. So I think that is a big one. There are, you know, nervous system as well, really understanding and becoming aware of your triggers. So, you know, what are the things that you feel before, you know, you make your choices in life. There's kind of that day-to-day one, but then there's also a really underlying current around self-worth, you know, how you feel about life, how you feel about you. And what is the story underneath all of that that's playing out in your day-to-day choices. So many other factors that come into it. Absolutely.
So it's a complex mechanism that leads to addiction.
Yes, I believe it is. It's never one thing.
Right. So you have worked and influenced hundreds of people from diverse backgrounds to manage their addictions. In your opinion, does addiction manifest differently depending on age, sex, or their socio-cultural background as such?
I think it's one of those things that is unique across across all backgrounds, male, all genders. I just think it's something that touches all people in all walks of life. I've definitely seen that. You know, some of my clients are, you know, doctors, lawyers, and then I have people that, you know, supermarket workers. I just think it does touch, if we are human being and we live in this modern world, we are potentially exposed to addiction, whether that's personally or a sibling or a parent or a child. I think it is, it's something that I actually heard a statistic the other day that says almost 97% of adults have some form of addiction, which is quite scary when you think about it. But it kind of also really just aligns so much with the fact that our modern world is just so misaligned with the humanness of who we are. But if we can understand that, we can empower ourselves to make the changes that we need to make to really heal it, because our body has a huge healing capacity. It really does. And when we just simply have to start making changes, and already, straight away, our body gets to work to heal for us.
Yes, so I think it's right that you said 90% of us are addicted to something, even if it is not labeled as formally addiction as such. So can people get addicted to good stuff on that note, like a good routine? Some people might get addicted to exercising every day. So is it possible to get addicted to good things in terms of habits and food as well?
Yes, I think so. And I've seen it. I believe, I think, so I think people search, we're such an addictive species, and people search for the answers. I think if we can move very easily from one addiction to another, whether that's a bad addiction to a good addiction. At the end of the day, anything that is controlling us and getting in the way of us living our life, and we're doing to the detriment of ourselves and others around us, is a bad addiction. So, I've known people that have been addicted to exercise, and, even in the face of them getting an illness and getting sick, they've still continued to do it. Or, a great example, I use this often, is a client I had who was a mum, and she was learning to understand, her own state of mind and herself, and she was, addicted to exercise, and her child got ill. And she wouldn't pick him up from school because she had an exercise class to go to. So things like that, I think, are really big signs that there is a problem that you need addressing. But I think that, whether it's a good addiction or a bad addiction, the healing doors that we all need to go in, while they're very unique for everybody, they're probably the same universally, that we need to look in to understand how to heal. And I think people can even get addicted to, being healthy. I think there is a real, trying to be perfect at everything, trying to have everything right, which can't do that. We literally can't do that in the world that we live in. And I think that in and of itself can be an addiction too. And they're hard to see. They're hard to see because it's kind of, people praise that. Oh, you're off to the gym again. Good for you. You're exercising so much. That's great. Is it? Not necessarily. So again, I think we do know it. This is the awareness that I think is part of the healing process. We have to ask ourselves and look at the choices that we're making, and look at whether it's getting in the way of really living life and the responsibilities that we have in life.
So on that note, I wanted to ask you, what would be the first step to start the recovery from an addiction?
So we're assuming they're ready and they've accepted, because that's the hardest part. But, and I think that, that's the interesting part with addiction, because it's a brain illness, but the brain will convince us that we don't have a problem. So I think we live a long time, and I'm talking from personal experience here. I lived in this illusion, if you like, that I didn't have a problem for a long time. But once we accept that, we have to accept that life has to change, and we have to be the one to change it. I think there's no easy path, right? There's no magic pill. There's no magic bullet. We have to do the work. And changing any habit is always hard. It's never easy, but particularly if it's an addiction. So I think one of the biggest things that I see that gets in the way is we tend to follow our feelings. But we have to follow our values and really the path that we want to go on, because our feelings are going to trick us, particularly in the early days, because everything in our brain is designed to keep us doing the same thing over and over again. It doesn't want us to change. It doesn't matter if what we're doing is making us sick. right? It's still safer than change because change is unknown. So the brain will try and sabotage us every step of the way. And it's not you, it's just that habitual brain, you know, doing that, and those habitual thoughts and that brain junk really just saying, hey, if you change and head down another path, we might not, you don't know what's going to happen. You might fail. You might not be able to do it. It'll tell you all these different stories. But you have to see that that's just how the brain works, and you need to step into action. Action is so, so important. And even if it's starting one change. So the easiest change that someone who is ready would be to work on being outside more. And that sounds really weird and simple, but it's actually going to help your brain recognize the time of the day. It's going to start resetting a circadian rhythm. The more time you spend outside in natural light, the better you're going to sleep. So that would be an easy first step. And really, that helps regulate your nervous system. It helps bring you back to the present moment. It helps center you. All of these things help you then make better choices. So then you can look at focusing on your food and just start with one meal, you know, trying to look at each meal individually. And I say to my clients, you know, look at your plate. What on your plate is brain recognizable and what is going to confuse your brain? Because I don't say, you know, don't eat this, don't eat that. You know, an addict will want to get to a point where obviously they don't want to eat, you know, what is their kryptonite, what is their addiction, or do what is their addiction. But the minute we say to the brain, oh, you can never have that for the rest of your life, it goes, you know, and it freaks out, and we obsess about it and we think about it. So I like to work towards people saying that you want to choose what's nourishing, what's healthy, and what's helping you to feel your best. So everything's on the table, but you choose to have, you know, real food. You choose to sit outside in the morning. It's all choices that you're making to help you heal and thrive.
So the first step is to get that awareness, and maybe you or any coach can mentor them to choose the right things. But then how does that turn into action? So bridging that gap between awareness and action, can you please elaborate a bit more on that?
Absolutely. It's my favorite topic to talk about. And it is the essence of the work I do, because that's probably the hardest thing to do. You know, as I said at the beginning, I knew alcohol and processed foods were making me sick. I knew it. So we know it intellectually.
Yes.
Why couldn't I stop? Why couldn't I make a different choice? It just floored me. And how many times I have people say to me, clients that say to me, I'm intelligent, I'm smart. Why can't I do it? So this is this gap. And I think that we sit in that place for longer than we have to, just out of pure misunderstanding. So again, it's this understanding that, you know, I suppose taking it back to my story, what actually 4 years after my diagnosis really had the biggest impact on me was understanding thought. And so I started to understand that my thoughts were not necessarily to be believed, and they were really largely optional. So the thought that so for me, from 11 o'clock, I would start looking at the clock. So 5 o'clock was acceptable to drink, but any time before that, I wasn't, you know, it wasn't acceptable. So from 11 o'clock, I'd keep looking at the clock. So, okay, 11, 12, 12:30, oh, getting closer. By 5 o'clock, I could have my drink. I started to see that that was all just thought I didn't have to pay attention to. Wow. Like, really? You mean every thought that comes into my head is not true and I don't have to pay attention to it? That opened a massive door of learning and healing, and I've never left that door. I play around with that so much because that's what leads to insight. That's what leads to understanding that, you know, we absolutely can choose. We absolutely can choose. And the more aware we become of the thoughts and the feelings and all these things that are leading up to us making any choice in life, because essentially choices are our own. Nobody makes me choose something, you know, it's an internal process. So the more aware I became, you know, things like the 5 o'clock, you know, you deserve it. The kids have annoyed you all day. You're tired, you're stressed, you know, whatever it is. I put them on as Post-it notes on the fridge, and I wrote, do not believe them. That is rubbish. So that was a big door that let me, that really helped me to see that I could choose differently.
Right. Yes. And what do you think are the hurdles in this process of healing or recovery? What gets a person off the wagon often?
So
What are the different things? What are the different distractions that play a role in this process of getting out of an addiction?
Yes. So the relapses,
Yes.
the setbacks. Well, I think it's expecting that there won't be any, because there will be many. I talk openly about the fact that I relapsed and had setbacks many times on my healing path. So what's really important is what we tell ourselves when that happens. So, what happens is we do these things and then we think, oh my God, I can't do it. What's the point? I may as well go and have a month-long binge on, rather than seeing that, well, in that moment, that was the choice that I made. It doesn't undo all the healing that's happened to this point. So I think we have to accept it. It's part of the journey. And, we can't, nobody tries to change their habits or tries to heal an addiction without having multiple setbacks over essentially a long period of time. So it's expecting them, but it's also seeing them for what they are, which is an incredibly rich learning experience. And we can look at that and really learn about ourselves. How did we feel? What was the state of mind I was in before I made the choice? What can I learn from it? Obviously, I can learn how I feel afterward, because it's that reminder for me every time I did it was, I don't want to go back to that place where I felt like that every day. And I didn't even know I felt so crap every day. So it was that reminder again. And I like to sort of talk about healing it's not a linear line at all. It's really, a circle or a spiral. And many times we're going to come back to the same place where we make the same choices that we have had made time and time again. But we're not the same person, and we're looking at it through different eyes. And the process of healing requires us to look at things many times. So it's all in the way we see it. But expecting it not to happen is a big mistake.
I agree. So during this process of healing, there are many other people that play a role. So what do you think are the different roles of a coach or a support group or the family or close friends and the person himself during this process?
It's very important. You cannot heal on your own. You definitely need a support group. And it's a very uncomfortable path for many, and it's a very changing path for many. So what happens when you change the choices you make, that will bring up very different emotions and feelings in other people. So people who think they know you as the drinker, or the smoker, or the one I go out and eat rubbish food with, or whatever, if you decide not to do that anymore, that's going to bring up a lot of different feelings in them. So that can challenge us, because we are tribal by nature, and we don't like, we get very uncomfortable if we're, and it's risky, right, to be rejected or criticized, but we have to stay true to ourselves. It's part of the healing path. I think the healing path is a path that takes you from strength to strength, and you have so many opportunities to just be true to yourself, which I never was, because I didn't know who I was. So I saw all these opportunities where I had to stand in front of other people who were making a different choice to me and possibly judging me for making a choice that, I was now making, that I had to be okay with that. And that was okay. So that's really important, because that does really, it can really knock people off. So they have situations where maybe at home they do okay, but as soon as they go to somebody else's house or they go out, they find it really difficult to stick to the choices in the face of difference. But also, just having a support group of like-minded people around you, because you can't necessarily, if you've got a family that supports you, fantastic, but not everyone does. But you need support. And I think, you'll probably I lost friends, but it opened the door for the incredible huge number that came, of people that I met on my healing journey that supported me for who I was, and weren't, they weren't uncomfortable with me making a choice for me. Yeah, so it is important. But if you are a family member wanting to support someone with an addiction, ask them, how can I best support you? You know, don't assume. I think asking the question is a really good thing, but don't try and sabotage them by, if say, you know, you're used to bringing home chocolates or alcohol and they've said to you, I really want to try and stop. You've got to respect that. Don't bring that into the house, but really sit down and have a discussion. How best can I support you? I think that's going to, you know, really help the person who is trying to change.
Right. Okay. A lot of our coaches start with close family members or close friends. They start giving them tips, or people ask for an advice how to get over their addiction of eating carbs, maybe it's something else. What tips would you give to a new coach who is trying to deal with close friends or family members to help them?
So it's tricky. It's tricky when it's close friends and family members. So in the early days, I didn't, you know, the boundaries were very blurred. So I'm very clear now if I'm talking as a coach or I'm talking as a friend or a family member, because one of the things that's really important for coaches to understand is not to coach when there's no client. So yes, if people are asking you, you know, you can give them sort of general advice, but I would really not coach unless you're in a coaching situation. So I don't coach family anymore. I had some, you know, a couple of earlier incidents that didn't kind of play out how I think either of us wanted that to. I'm very happy to recommend a coach for a friend or a family member, and I'm certainly happy to pass on information. I always, you know, YouTube videos, things to watch, like something like this, something like that. But in terms of specifically coaching, to me, that is a contract, and that has to be entered into, and it's quite, I take it, it's quite serious, in that I take my job seriously, but also the client must really know, you know, what they're responsible for. As well. And I think we can, you know, if we're giving advice outside of that relationship, it just can be a bit risky. So that's how it
Better to avoid such situations.
Mm-hmm.
Do you think that addictions sometimes start with a once-off or a casual experience of or curiosity about something? And if it is so, do you think the advice that you only live once, so there is no harm in trying anything once, or do it in moderation and then you can have control in your hands? That's really a good advice for people.
So do I think a once-off can cause an addiction? Yes, I do, if the brain is primed for it. So we're looking at this gateway, right? So it's started early with the food, then it's, you know, the brain's been primed, the brain is not working optimally, and then bam, one gamble, one drink, and, you know, absolutely drugs. So yes. Not for all, it wouldn't be for everybody though, but I think for some people, yes. Now, the advice of everything in moderation, I really hate this advice, because I just think if you understand something is poisonous to you, which sugar is and processed foods are, it's just a slow poison. It just does it very, very slowly. But if you understand that, why on earth would you want to have that in moderation? This is where we have to address those underlying deep beliefs, because for a lot of people, you know, those types of food are love, they're comfort, they're, you know, part of everyone's having them. But if it was arsenic, would you want that in moderation? I just think we have to look at really, you know, this is kind of what I said, you know, that addiction is a brain illness, but it's also the brain that's going to convince you that it's not a problem. So we will look it looks at ways to get in any way it can. And if saying to you, hey, have this in moderation, you know, if you're an addict, you can't do that. You can't do that. So yeah. So again, we just have to really become self-aware and get honest. Honesty is a really big part of healing when it comes to addiction.
Thank you. What role does medical intervention like anti-addiction drugs or things like that play in recovering from addictions?
Well, I don't know about addiction drugs per se. There are addiction drugs. I certainly don't have experience with that. I think they are probably not going to address root cause. I think with everything we do, we want to be looking at root cause. And of course, we know medicine treats the symptoms. It doesn't address root cause. So we as human beings, we look for the path of least resistance. So we're always trying to find the easy way, but there's no easy way. We have to face it, we have to confront it, and we have to go through that's a sludge and the hard work if we really want to break free from the grips of it. So yeah, I would say that maybe, I think there's definitely some supplements that would help with the brain, but nothing helps more than having a brain that's well nourished, that is metabolically well, so getting the energy that it needs to run, and it knows the time, so the circadian rhythm, and it's well rested. You cannot bottle that. If the pharmaceutical company could give that as a drug, it would, as we know, but it can't, and you have to be the one to do that. And apart from the food, it's pretty much free. It doesn't cost. It just is the effort and the energy for you to do that.
I think there is a lot to learn from you, but we are falling short of time. So in the last 5 minutes, I would like to ask you a few questions before I call in Shashi. It's just a rapid round of questions, so you can just give me an answer in a sentence or so. So processed food, alcohol, or drugs, which is the most dangerous addiction according to you?
I'd say processed food, because that's what we start with first, generally. I don't think many, we don't really start with drugs or alcohol, but when we're young, we start with processed food, and it's scarily very young for a lot of kids.
Right. Environment or emotional weakness, which is a more responsible factor?
I think it's largely environment, and I think it's not, I wouldn't call it emotional weakness. I would call it a human misunderstanding. So we don't necessarily understand how we work as human beings, and it largely is environment. So if we fix the environment, we're going to find we've got the capacity to understand ourselves a lot more, and then, leading on from that, the choices that we make.
Thanks. Men or women who are more prone to addiction?
Everyone. I think there are certain addictions that are more leading for men. So gambling, I would say porn as well. We know that's an addiction, and it's a lot of men, and women probably, I think food is men and women, definitely. Maybe, online shopping, that type of thing might be more female. So I think there are certain addictions that are more gender specific, but addiction in and of itself, it's open to all human beings.
Gradual transition or going cold turkey, which is a more effective strategy in dealing with addictions?
There is no one effective strategy. It's what works for you. So I've had clients that have tried one and that hasn't worked, so they've tried the other. So I think, again, we have to really accept that there is no one size fits all. There's no one path. I didn't do cold turkey. I definitely did it gradually. But I've had clients, that have done really well cold turkey. So yeah, it's really the individual.
Thanks, Tracy. I think our time is up. I would like to invite Shashi and Anup to just say a word of thanks at the end.
Thank you so much for having me. I hope that was helpful.
Yes, Tracy, meet again. We meet again. Thank you. So Tracy is my teacher, my guru in Nutrition Network Coach Practitioner Certification. And so nice because you give a lot of valuable insights on how to manage addiction, and that is the theme for this particular conference. So I think people who have watched this, they will gain a lot of insights, and I think Project has asked the right questions also to you.
Excellent. Thank you so much for having me, and enjoy Marty.
Thank you, Tracy. Thank you.
Bye.
Bye.
Tracy's down the road from you. How cool.
Marty, nice meeting you. I'll come back in the end.
Yeah, thanks.
Hey, hi, Marty.
Hey, going? Yeah, so many good questions. I'm so excited to chat.
Great, yeah. So happy to have you here. So I'm just going to do a quick intro, and then we'll get into it. So hi, everyone. Hi everyone, I'm Mandar. I'm a member and a certified metabolic health coach from D-Life, which is India's first and the only award-winning low-carb platform. D-Life was founded by Anup Singh in 2014. Anup is a silver medalist from IIT Roorkee and the recipient of Icons of India Award. Anup is also the pioneer of low-carb movement in India with his path-breaking protocol of max 100 gram carbs per day, which he gave us in 2012. And that made not only LCHF, but even type 2 diabetes reversal possible for Indian vegetarians. In 2020, D-Life launched the diploma course created by Anup, which is the only course now approved under the NSDC partner government of India, and the only course with its globally biggest 144 CPD UK credit hours. Anup, as along with Shashi, they are the co-organizers of this Metabolic Health Conference, and I'm so happy to get to chat with Marty. So I'm going to introduce Marty as well. He's an engineer turned nutrition researcher. He approaches food through a very interesting data-driven and nutrient-first lens. While seeking ways to manage his wife's type 1 diabetes, he has developed a systematic approach that optimizes satiety, nutrient density, metabolic health, and we are going to get into that. And through his platform, Optimizing Nutrition, he has helped thousands of people reclaim their health by focusing on nourishment and eliminating cravings. And I love that when he says that nutrition is about nutrients, all the rest is noise. So thrilled to have you here, Marty. Thanks for joining us.
Yeah, thank you so much. I was saying I love all your questions and I love the Indian mindset. And yeah, you guys are a bunch of data nerd close to my heart. My daughter's boyfriend is Indian and his dad is Anup, and it's like sort of a small world, and you're all very data driven. So yeah, it's going to be a great chat.
Perfect. Yeah, as an engineer, I'm looking forward to chatting with you. So starting with your personal journey, right? So your family, I think wife and son both are type 1 diabetics, if I'm right.
Yeah,
And then,
my wife since she was 10, and my
right.
son a couple of years ago developed type 1 as well. We went, oh, okay, we know what this is.
Right.
And luckily, yeah, had a bit of experience, knew what to do with it.
Right. So when you were, discovering, food in general while managing these conditions, so
Yep.
was there sort of a eureka moment for you when you realized that the mainstream advice that you had heard wasn't quite working?
Yeah, I suppose it was initially we got married and started to think about having kids, and yeah, my wife's diabetes advice and diabetes control was not great, but all of a sudden she was motivated, and I was along for the ride to learn about what diabetes was and how to manage blood sugars, and we had a good doctor that helped us a little bit with insulin dosing and carbs, but really the advice 20 years ago wasn't that good, and it's a little bit better now maybe, but yeah, it wasn't great. But there was a definite scare of the complications of type 1 diabetes and pregnancy and the risks of that, and so that really focused my attention, and yeah, it was quite a journey of learning about it all.
So was there a specific point where you realized that what you had heard for decades, you had to sort of unlearn and do something else? If you can give us
Yeah,
an example.
there's been a whole bunch of those of like, wow, we need to, insulin dosing, and then low carb, I suppose maybe 10 years ago was revolutionary. And then discovering that it wasn't just carbs and insulin and unlimited fat and chasing ketones, but maybe it's about satiety. We're really chasing what gives us the nutrients that satisfy our cravings, and we all feel addicted to food, and why do we keep on eating? And really the food system is designed to maximize profit at the expense of our health. And yeah, it's been as I've dove into the data and new layers, I went, oh, I'm wrong again, and the data just keeps on proving me wrong, and I try to share that, all my wrongness as I've learned and unlearned
Perfect.
everything I had.
Perfect. So you are somebody who has, gone deep into the actual micronutrients, the nutrient density, and not just at the level of, the 3 macros. So could you please tell us, what are the big gaps in the general understanding, and then how we should measure or gauge that nutrient density?
Yeah, I suppose nutrient density as a concept is just, the amount of essential nutrients that are essential. Protein, which is amino acids, vitamins, minerals, and essential fatty acids per calorie. Um, and we have the dietary guidelines are a minimum to prevent diseases of deficiency and death. But if we actually, want to do more than just not die, then we need to pack in more than the minimum to satisfy our cravings, basically, is what I've found. And the quest has been to understand, how much is reasonable and satisfies our cravings. And that's what the data shows. The data shows that we'll probably dive into a little bit more, but the recommended dietary intake for all those different nutrients, for protein, for vitamins, for minerals, that minimum is really the perfect amount that hits our bliss point, that maximizes how much we eat. So if we're just aiming for the minimum, we're maximizing how much we will eat. And, it's the perfect formula for maximizing profit for food companies, really, of hitting that minimum. So to move beyond that, we need to pack in more protein, more minerals, more vitamins per calorie. And then our body goes, oh, wow, this is, it's real food. It tastes great. And I feel fantastic. And I'm going to go out and play and do something else. And I'm not going to be thinking about food and feel addicted to food and captured by food and feel like a victim to the food system. It's just so empowering once you get the nutrients to satisfy your cravings.
So it's sort of weird to think that behaviorally, if I got you right, the bliss point that you are speaking of, where I sort of get addicted to some of those foods, that and what my body really needs, they seem a bit different, is it?
Yeah, I mean, I've got some slides that I can bring
yeah,
up. You
please.
you said bring some slides up, and I'll show you
Sure.
how I think about it. If I can share screen,
Perfect.
if I can you see that now?
Oh, yeah, yeah.
Yeah. So, I mean, I don't think nature is wrong or broken. Nature doesn't really make mistakes, but if you look at what happens in nature, we go through sort of this circannual cycle, that happens every year. That in spring we've got sort of protein and fiber, and summer we've got more energy from carbohydrates, and autumn we've got fat and carbs that come together in this magical time around Thanksgiving or whatever, Christmas and Halloween, where we've got all this fat and carb together. Then we go into winter, which is sort of a low carb diet, and it all starts again. And even in you look at what happens to bears. This is the same bear, Bead-Nose, the bear who won the Fat Bear Week competition in 2018, 6 months apart. What is it about wild animals that they go, oh, I'm going to, go for the fatty salmon and the berries and put on a ton of weight so I can survive autumn and get really fat. And when you look at, this is our data from our optimizer data looking at across the year, and you can see that we eat, the black line is how much we eat. Sort of comes up and comes back down in summer, and then in Christmas we all eat a lot more, and then we go make New Year's resolutions and try to lose weight again. But the carbs and fat oscillate through the year, and then if you dive in deeper, you see the sugar, starch, monounsaturated fat, polyunsaturated fat all sort of oscillate, but they cross over in these magical times of Easter and Halloween where the seasons cross. And it's not that sugar's bad or fat's bad or alcohol's bad or whatever. It's this magic combination that hits our bliss point that makes us want to more. There's something that just says, oh, these foods are amazing. Winter must be coming, and I'm just going to keep on eating and eating and eating. But it's like the food manufacturers since the 70s have understood exactly how to hit that bliss point to maximize profits. So why wouldn't you just keep on making the foods that make the most profit? Whether they, I could start $1 billion food company with the information I've got and just, make people feel addicted to my food products by precisely hitting the bliss point to maximize intake. But I can also reverse engineer that to make people feel satisfied and satisfy their cravings with less insulin, and then that less calories, which then, insulin and all the other stuff just looks after itself, and you don't have to worry about it if you get the protein, vitamins, and minerals from your food.
Absolutely. I think, yeah, that's good that you're using that knowledge for the positive effect.
For good and not evil.
Yeah. So, and as you mentioned, many of these processed foods, they are engineered to get us hooked onto them, right?
Yep.
In fact, we have a famous advertisement in India where it's for some chips. So nobody can eat just one, right? They will keep eating.
Yeah. I bet you once you pop, you just can't stop. You just can't eat one. And it's engineered. These are food scientists who use multivariate regression analysis to know exactly how much sugar, fat, protein, salt to hit those bliss points. And I wonder if we can see that in the data and then reverse engineer it. And you can.
Perfect. So while we are on the topic of these cravings, right? So are there certain drivers that you always see common across people? And flipping that question, are there a couple of concrete steps that they can take? Okay, what should they eat more of, or what should they sort of avoid any traps? How do you look at this?
Yeah. Wait, you said you can provide slides, so I threw a whole lot together. But this is maybe the engineers amongst us will go, this all makes sense. Everybody else will go, this is crazy. But Ted Naim, who's a good mate of mine, took 800,000 days of data that I gave him and looked at this as fat versus fat, carbs, and protein. So basically what it shows is a higher protein percentage, we eat less, which is the blue. And if we move away from that fat or carbs, if we move to a lower carb, higher fat diet or a lower carb, higher fat diet, we eat less. It's this magic bliss point pimple in the middle that aligns with eating the most, like 5% protein, 40% carbs, 50% fat. And it's a really cool 3D animation that he's made.
Perfect.
You can actually spin around and go wacky and go, what's my diet look like? But basically, protein is the number one thing that if you prioritize getting more protein with less energy, that's number one. And you're probably going to get a lot of other nutrients along with that. But, people do best when they have a broader palate. Like a lot of people do really well in carnivore, but they have to keep on dialing up the protein percentage really, really high, up to 50, 60% to get really good results. But if you've got a broader palette of, dairy and seafood and plant stuff, and you can bring in all the nutrients that help with satiety and really give your body what it needs precisely. So it's not just protein, there's calcium, it's potassium and sodium and vitamin B2 and vitamin C that all sort of play a part in the algorithm to maximize satiety. So yeah, your body's just craving nutrients.
Perfect. And is this connected to, or how do you connect this to the protein leverage hypothesis?
Yeah, I mean, protein leverage, let me bring up, the answer is
you can keep your slides.
I'm trying to start a rumor that it's not just the protein leverage hypothesis, it's the nutrient leverage hypothesis. So rather than just protein, it's all the other nutrients as well. And like if you look at protein, bringing it back into 2D, which is a little bit simpler, you see that there's this 14% bliss point, 14% protein, which is a burger and chips and pizza and cheesecake and everything. We eat the most. So this is protein percentage along the bottom and energy on the top. So if you're getting a very low protein diet, you'll actually crave protein. And whether you're a pond slime or a chimpanzee or a domesticated human, you're going to crave enough protein from your diet. So you'll keep on eating to get the protein you need. But once you get above that 14%, you hit what's called sensory specific satiety. So if you imagine you just ate lean steak or lean chicken, you go, no more pork chops for me, but the cheesecake looks good. But no, I couldn't take another pork chop, thanks. That's just, I've had the protein you need. You can think of like you're filling up the protein tank, but then your body goes, maybe some energy, but you're really also craving sodium and potassium and calcium and all these other nutrients that you can imagine. There's a thing called optimal foraging theory. You can imagine a wild animal going around and saying, I'm going to get the protein and then I'm going to chew on some plants to get the potassium and magnesium, and then I'm going to have some, you know, calcium from whatever you get the calcium from. And our body is doing that all the time. And I've just tried to model that. And it's just a fascinating quest to model that. But you see that when you look at protein, this is the distribution of protein. Everybody springs back towards that 14%. You can try really hard to increase your protein percentage, but most people really struggle to stay over 50% for long. They go, oh, I need the cheesecake, I need the donuts, and swing back to the 14%. So in our programs, if say you log for a week, you find you're at 20%, we'll nudge you up to 30%. And if you sit at 30%, you're going to get a significant energy deficit. But then to bang on, you've got the same thing. It's not carbs that are bad or good. It's just that perfect amount of carbs that aligns with eating more. If you're low carb or low fat, you're going to eat about the same amount less, but it's that perfect combination of fat and carbs. And sugar has got a bliss point. You can imagine if you just all you had to eat was a bowl of sugar or a bag of sugar for a week, you'd quickly get sick of it once your glucose got so high, and you'd be give me some fat. You get sick of the sugar, and there's the fat. There's a bliss point for fat at 34%. So if you're at high fat or low fat, you're going to eat less, but it's not a big factor. Then there's calcium, and these are what high calcium foods look like, and then calcium rich foods. So what we're talking about to get you to a lower energy intake, it's prioritizing foods that contain more calcium per calorie and potassium per calorie, which are these foods here, and iron per calorie, which are these foods here, and vitamin B2 per calorie, which are these foods here. The high vitamin B2 foods will give you a lot of vitamin B2, but also with a lot of energy. So what we're trying to do is manage the concentration of these nutrients per calorie. So that's the trick, and that's where a bit of quantification and engineering comes in handy. So
Perfect.
Ask me a million questions. I just went on a complete rant. So
yeah. But I think it's very interesting to realize that it's quite multifactorial. And the only antidote to cravings is not just satiety in the sense of feeling full, but it's also getting all the right nutrients, because till then my body is going to keep asking for food, right? In a sense.
Yeah, exactly. People like think, I don't feel full on that's one of the big misunderstandings is like, I don't feel full on chicken breast, but per calorie, you're getting more satiety per calorie. Your best way to feel full is just 3 large family pizzas or 3 boxes of donuts, but how much energy are you gonna consume to get that satiety? The question that we're really trying to solve for is, how do we get satiety without over consuming energy? Because we've all got more. 99% of us have got more body fat and glucose in our blood and our liver than we need. So how do we give our body the nutrients it needs without excess energy? And just finding that balance point is where the magic happens.
Makes sense. Also, looking at the charts that you showed, and along with the suggestions of food items, we can speak of the bioavailability as well, right? So how do you factor that in, and do you have actual favorite superfoods, and then are there some which are simply marketed heavily but are not quite superfoods?
That's an interesting question. Generally, if you're getting like, bioavailability is a term that's thrown around a lot by carnivores sometimes, and say you're not going to get the iron from spinach, and that's right, but nobody's really getting the iron from spinach, and most people get plenty of iron, and there's a limit to how much iron you need, and too much iron is bad. And like vitamin K is not as bioavailable from plant-based foods, I think, and then calcium is not as bioavailable from green veggies, but if you're getting enough in absolute terms, most people don't need to worry about the bioavailability, and unless they've got a exclusively plant-based diet and the like. So yeah, I've done some analysis looking at the satiety curves and the bliss point and how that changes for different nutrients, and maybe calcium and iron and B1, B2, B3 appear to be more bioavailable, so you need to eat less to get the nutrients you need on a lower carb animal diet, animal-based diet. But generally it's not a massive concern if you're getting enough protein, if you're getting enough calcium. And like I said, most people get plenty of iron anyway, so it's not a big issue for bioavailability. So.
Got it. When you showed the energy plots, right? So one
Yep.
of the things I think you have spoken of also online is the concept of energy toxicity. So I think let me give you a few minutes to take us through what that concept is, and how do you
Yeah. I brought up this meme from TED, which I really like, and everybody talks about hyperinsulinemia and insulin bad and blood sugar bad, and insulin's the root cause of everything bad. But the reason why insulin is high is just because we've got a lot of energy stored in our body. And like I used to see, as a lot of people do, insulin as that hormone that pushes energy into our body. It's like the train conductors pushing everything onto the train. But unless someone's running around jabbing you in the bum with an insulin needle 3 times a day, that's not really how it works. Insulin is the hormone that sends a signal to your liver to say slow the release of energy from the body, like the stored energy don't flow out because we've got heaps of energy in our bloodstream. So the way to reduce insulin is just to reduce energy. It comes back to satiety. So if we found a way to eat less by giving our body the nutrients it craves, then we're automatically going to get lower insulin, lower energy, lower body fat, better body composition, especially if we're getting enough protein to maintain muscle mass. So being an engineer, I've broken it down into sort of fuel tanks in our body, and you can think of, you've got blood glucose, the liver and muscle glycogen, the fat in our blood and the fat in our body. And there's, due to oxidative priority, it basically backs up in our system. So we think diabetes is an issue of we're allergic to carbs in some way, but really the issue is that our body fat is tapped out to the max. The fat in our blood is tapped out, and then we're stuck trying to burn off the glucose in our body first because there's really little storage for it. So the body's going, I've got to burn off the glucose, I've got to burn off the glucose before you can ever start burning the body fat. So a low carb diet will reduce the blood glucose, or waiting a little bit longer, not extended fasting, but sort of intermittent fasting. So if you find a way to reduce carbs and wait a little bit longer, you'll drain the glucose in your blood, and that will drain the liver and muscle glycogen. And then as long as you're not overfilling the fat from your diet, you can then tap into the fat in the blood and the fat in your body. So it's really, it's not carbs or fat, it's sort of both, while we're getting enough nutrients to satisfy cravings. So yeah, energy toxicity is the root cause of everything bad in our modern health system. Really, diabetes, cancer, etc., obesity. Just it's the concept of having too much energy built up in our body because we've got this hyperpalatable, low satiety, nutrient poor diet that we can't stop eating because our food system is optimized for maximum profit to make us feel like we're in autumn preparing for winter, and we're that bear who just can't stop eating. I can't stop eating, I'm hyperphagic, I've just got to prepare for winter. And it's like, why am I addicted to food? It's because your environment is filled with this food that is optimized for profit to make you eat more by engineers like me.
Right. So I think it talks of how food actually is a chemical signal going into the body. It's not just about filling our bellies. So
Yeah.
one question related to that energy concept that you have is right. So when we speak of, let's say, macros like fat and protein, which are technically being used in our bodies for building stuff as well. So in simple terms, they are raw materials as well, and not simply sources of energy. So how do you look at that bifurcation of being an energy source as well as a raw material, and then carbohydrates pretty much doing only the energy part?
Yeah, I mean, we predominantly protein is the building blocks, and we can use it for energy in case of emergency if you're not getting enough glucose and protein. If you're starving or on a really high fat keto diet, your body will use the muscles for glucose, for that little bit of glucose we need. And really, carbs are fast burning energy and fat is slow burning energy that's great for storage. We can't store much carbs, but it'll give us an explosive boost. Fat is just a really dense energy source that we can store in our bodies. So I see fat and carbs as interchangeable. They're both carbon-carbon bonds, just stored in slightly different forms. And protein can be used as energy, but it's a really bad energy source just because, once you eat enough protein, your body goes, enough. I've had enough. I've hit sensory specific satiety. I just can't put down any more lean chicken breast or pork chop or whatever whatever your favorite Indian sources of protein are. And I know that they're a little bit harder to get in India, which is a bit of a challenge, but
Yeah, I think we do need to do better on the protein front. I have now a little different question. So you have delved into a lot of insulin data, of course, while dealing with type 1 diabetes right at home. So could you speak of sort of the basal, insulin secretion, as well as then what is triggered by what we eat? Of course, in people who can produce insulin, and then sort of contrast that with how do you then manage it for a type 1 diabetic?
Yeah, it's been a fascinating privilege to have two type 1 diabetics in the family and see how the closed loop insulin pump manages their body and food, and when they eat and when they don't eat. But one fundamental thing of insulin therapy is understanding basal versus bolus insulin. So basal is the insulin that you need to stop your body disintegrating. So a type 1 diabetic who can't produce insulin, their body will just leach all the energy, the stored glucose, fat, protein will just leach into their body. They'll basically melt like the snowman from Frozen or whatever. You're just melting into your own blood, and without it, you'll die. So you can think of the basal as that amount of insulin you need, which is, for people on a standard Western diet is 50-50, 50% basal, 50% bolus. For a low carb person, it might be 70 or 80% basal insulin. So the bolus insulin for food is just a minor part. So really looking at my wife's data and my son's data, and I've got another friend, Mike Fitzpatrick, who's been tracking all his data as he's gone from 400 pounds to 200 pounds and 50% body fat to 10% body fat, seeing how the amount of insulin he needs changes as a type 1 diabetic, which is just like, this is so cool. We can measure it and I can analyze it. But the biggest thing is, how fat are you? How much fat are you carrying? That's the biggest factor on how much insulin you need. So if you want to manage insulin, again, find a way to reverse energy toxicity, lower your basal insulin. When it comes to bolus insulin, carbs require insulin quickly, like a fast-acting insulin, maybe over a couple of hours. Protein requires insulin over like 8 hours, and fat is just sort of a long, slow response. And I see it as the body goes, hey, we've got heaps of storage capacity for fat. We don't need to halt the release of stored energy. We can just stack more fat on. So the fact that fat doesn't have an aggressive insulin response doesn't mean it's magic or a free food or we can eat it in unlimited amounts. We've always got enough insulin to store that fat in our diet. So that's one of the big things I had to unlearn, that, my goal to be healthy is not minimize protein and maximize fat to try and drive ketones really high to get into this magical optimal ketone zone. That's like, I did that and I got fat, and everybody else did that went hardcore keto trying to get into this magical optimal ketone zone. Yeah, it's about getting enough protein and enough nutrients, and then you eat less naturally, and your addiction turns off, and you go do something else with your life because you've had a good meal and you feel energized.
Nice. So I'll bring you back to the food related behavior. So there is one interesting term you use, which is food noise. I think that's quite new. Could you please explain that to us?
Yeah. I think I see it as a term invented by Ozempic and the GLP-1 manufacturers, and saying you're suffering from food noise and you need a drug. You ask your doctor about food noise and whether this $20,000 a year drug that goes to Denmark can help you. And really what you're doing is, we're, as I said, we're surrounded by these foods that are addicted to get designed to make us feel addicted and get our attention all the time to maximize profit. They're designed that way. They're designed to be really pretty and bright with artificial colors and artificial flavors that never quite occur in nature, and this perfect combination of sugar and refined flour and crappy vegetable oil that's super, super cheap, and with a few smatterings of B vitamins to hit that bliss point that brings you back to, overstimulates dopamine. So you're in an environment that's optimized to maximize food noise. And if you never get the right amount of nutrients that your body needs, you're always going to have that food noise. And you can turn that off now with a drug. You can take your healthy body's cravings that says, I need protein to keep my muscles, I need calcium to prevent osteopenia, sodium, potassium, etc., etc. You can now turn that off. Isn't that correct? Oh, wait up. Maybe it's not so good in the long term if we medically induce nutrient deficiencies, sending, I think it's $3 trillion a year if every American that could qualify for Ozempic went on it on Medicaid, and that goes off to Denmark, where they say exercise and eat a healthy diet, don't take this drug. It's just a crazy dystopian world. Some people need it, but they also need nutrient-dense, high-satiety foods to go along with that. And the people in our challenges in our community often say that when they're taking the GLP-1 agonist drugs, that they used to enjoy shrimp, they used to enjoy steak, they used to enjoy broccoli, but they're already experiencing so much satiety from the drug that they can't get these other foods down, so they're going for the less nutritious foods. And I don't know, I'm not thrilled. If you're on the drug, that's great, but really, really try hard to get the nutrients your body needs, because Bruce Ames talks about the nutrient triage theory, that if you're not getting enough nutrients, your body prioritizes functions of short-term survival and puts everything else on the back burner. So if you're not getting enough nutrients because you've got a drug-induced suppression of cravings, then I don't know. I'm pretty sure Ozempic isn't going to fund that study, but I'm sure the outcome wouldn't be good.
Yeah, I think that's an interesting take on, the sometimes unseen or unintended consequences of getting these drugs in. And as you rightly pointed out, we are sort of not solving the problem where it is really occurring. We're simply suppressing body's mechanisms.
Not addressing the root cause of why can't I stop eating? It's your body wants nutrients. Like, listen to it, give it what it needs, give it what it's craving.
Absolutely. So putting it in engineering terms, we want to maximize that signal to noise ratio, right? It's by actually moving away from the noise, not suppressing it.
It's all an optimization function of how do we give our body what it needs without excess energy again and again and again. That's just the whole thing. And looking at each individual's current diet, you can go, okay, you need more of this, this, and this. Let's tweak your diet with your current foods to give you more of those nutrients that you're craving. It's just super fun to do. And yeah, I love seeing it happen in real life. It's just, I love it. So
yeah, I think, we have, looking at your work, we have become fans of how you have taken a fairly data-driven approach rather than going behind any dogma. So on that note, I know one of your newer papers is out, on that data-driven fasting. So could you please tell us about that as well?
yeah, I've been doing this data-driven fasting thing, which we've just rebadged to glucose signals. But the reason we came up with it was maybe 5 years ago, a lot of people were getting into extended fasting off the back of the keto movement, thinking that if I don't eat for a week and then I refeed with high-fat keto and avoid protein and definitely avoid carbs, not eating is logical and you'll lose weight. But what happened again and again, I went through it as well. This is another dumb mistake I did, that you don't eat for 3 or 7 days and then you just can't stop eating. You're just like, I'm going for the peanut butter. I've earned that cheesecake. I've earned that box of donuts. And I just lost touch of my hunger and satiety signals. So seeing my wife's continuous glucose monitor all the time, it just makes sense that when your glucose is high, it's not a great time to eat, and you're probably going to feel quite satisfied when your glucose is high. But once your glucose gets low, it's time to eat. It's time to refuel the fuel tank to give your body what it needs. So I've got a slide here of basically what we do is that when your glucose is under what's normal for you before you eat, have a good meal, it goes up. If it goes up by more than 30 milligrams per deciliter or 1.6 millimole, you've probably overdone the carbs. If it takes a long time to come back down to normal for you, you've probably overdone the fat. And by playing that game, looking at your blood sugars, you can sort of learn, that meal had too much fat, that meal had too much carbs. This nutrient-dense, high-protein percentage meal was perfect. It got me back down under trigger. In 3 or 4 hours, I had another robust meal, and it worked really well. So, that's the process of using your pre-meal glucose to guide when and what to eat. And you feel a little bit of hunger. You don't get to the point that you're so starving you're going to demolish everything and anything and make poorer food choices. And you get in touch with your hunger and satiety signals, and you sort of retrain. Most of us don't understand what real hunger is because we're always eating. But if you get a little bit hungry, drain that glucose fuel tank just a little bit, so you're tapping into your body fat a little bit before every meal, you can achieve weight loss and optimizing your metabolic health without tracking calories. So without tracking your food, it's insane how popular it's been, and enabled me to quit my day job and run crazy online challenges.
Absolutely. I also noticed that on your graph, you had the increase in glucose levels was 30 or less, right? On the y-axis. Yeah. So could you please talk about that?
So we want to see a rise of less than 30 milligrams per deciliter, but anything less than that is sort of normal. Like I think a lot of people with continuous glucose monitors end up trying to flatline their blood glucose. They think any blip in glucose is bad, and therefore I'm avoiding all carbs and just eating fat. Or the worst thing is combining fat and carbs. There was a thing with Glucose Goddess who talked about clothing the carbs with fat. So if you add fat and carbs, you get a cheesecake or a donut, and it's the lowest satiety thing that keeps your glucose and insulin elevated for the longest and stores the most fat. So it's like, no. Let's not do that. We're prioritizing protein and nutrients and fiber when we eat, and then our glucose comes back down a whole lot quicker. So yeah, we just published, or we released the preprint of a paper that's been in the works for a couple of years. 30,000 people who have done it, and 800,000 data points, and yeah, so it's really cool to finally get that out. Publishing, in the meantime, for the last 2 years, I've probably published 200 blog posts, but we finally got a paper out.
Yeah. No, congratulations for getting that out. I know
Thank
there's
you.
a lot of work which has gone into that. So I had a fun question before, I'll request Shashi to come in a minute. But before that, do you have a favorite micronutrient that most people are missing out on, and how common is something common, that you see in people?
Favorite micronutrient? I think everybody knows about protein, and we've got a very conscious craving for sodium, but potassium and calcium are ones that you wouldn't have necessarily seen. Calcium is hard to get without dairy, and it makes sense that we need it for our bones because protein, we've got muscle, calcium, we've got a lot of bones, so it makes sense that we have a strong craving for calcium. But potassium is the crazy one that I didn't expect to be so strong, and it's sort of the yin to sodium is yang. We need potassium and sodium in balance inside and outside the cells. So that was the interesting one. It's basically a signature of fresh whole food. You can get a good amount of potassium from meat, dairy, seafood, but the high concentration is vegetables, fresh food that taste amazing because they're fresh and they contain the nutrients.
Interesting. Also, this is going to be a very different question. I know you donate blood quite frequently.
Oh, wow. You have been stalking me.
Yeah. So, and, happy to share that actually I am also a regular blood donor. So could you talk about that, and what sort of health benefits do you see, and we can maybe even tie it back to this, see, because you're getting that blood out, right? So you're losing.
I initially I had one blood test that showed high ferritin, and a mate of mine at work was into donating whole blood, so I did a few whole blood things, and then how did I come across it recently? Yeah, but there's total blood plasma replacement where you can pay a ton of money and have your plasma taken out and albumin put back in, and sort of the theory there, it works really well for people with autoimmune issues, and it's a really highfalutin, high-level research approach that you're basically getting your own stem cells to regrow all your blood cells and your plasma. So it's basically autophagy fasting for your blood and regenerating young blood. And there used to be all the crazy, the Silicon Valley crazies who'd get a blood boy, blood donor and take young blood, but then they did research where they found it was just taking out your old blood, taking out the toxins and the old plasma and letting your own body regenerate it. So you don't need to be a vampire. You don't even need to pay $10,000 to get the plasma replacement all at once. You can just go every couple of weeks to the local Red Cross and get some nice company and watch crappy TV or surf Twitter for a couple of hours, and the people are really nice, and I take the wife along and we go out for a breakfast date afterwards, and I really enjoy it, and it's something that's helping other people, and I think it's very likely helping me, and I think hopefully for my wife and my son with type 1, which is autoimmune related, I think it's probably one thing you can do for free that might really help them as well. But nobody knows about it because it's, nobody's making a ton of money out of it.
Yeah. And I think it also helps address possible iron excess, right? If you get too much.
Yeah. If you've got hemochromatosis which a lot of people with diabetes do, donating whole blood is really helpful. And I was talking to the guys there. Some people have got crazy high iron levels, ferritin levels, and they come in every week and they just throw out the blood because it's so high iron. But yeah, insulin resistance and high ferritin is highly related.
Absolutely.
Inflammation,
No,
etc.
right. So I thought I would ask you on that. But I have one more question coming to, deficiencies. Do you see any specific deficiencies in the carnivores that you have come across? And if so, how should they address that?
Yeah, it's harder to get some nutrients on carnivore. Everybody's diet's different, and to some degree, you crave the things that you need. Carnivore is great for bioavailable protein, so it works magically because you're getting bioavailable protein, and that's the number one thing you need. But then there's a whole bunch of other nutrients that are harder to get. Potassium, magnesium, calcium. Calcium is a big one. Without dairy, if you're just eating meat, you're not going to get as much calcium. So yeah, carnivore is a great way to get bioavailable protein, but I don't think it's optimal. I think dairy, seafood, and some non-starchy veggies. I don't think almonds or spinach are going to kill you instantly from oxalate poisoning, like some people believe. You've got these grown, muscular men going, if you didn't eat an almond, you're going to die of oxalate poisoning. It's like, no.
All right, thanks. Let me invite Shashi and Anu if they're there.
And we got Jen. Hey, Jen.
Hey,
Marty,
We should talk
thank
addiction
you.
sometime.
Marty, thank you very much. Thank you very much for coming in again and spreading your knowledge, especially on the nutrient
Thank you.
density, satiety, craving, and very apt for this conference. And thank you, and continue your support for whatever we're doing in this community to spread more knowledge, especially on the micronutrient part. So I keep telling my group that I know only one person globally who works on the micronutrient part, and that is Marty. So thank you once
And you
again.
did our course ages ago, which was a whole lot of fun. And your teeth are still shining like amazing. You must be getting a calcium and
Yeah.
protein.
So I'm a life member.
Yeah, it was great.
Thank you.
Thanks for the opportunity. It's been a real pleasure. Great questions.
Thanks, Marty, for a lovely conversation. Thanks.
Thank you.
Yeah, anytime. Honored.
Please get Ira in.
I'll catch you guys later and check out and let you talk to Jen. Thanks,
Jen,
guys.
welcome.
Bye.
hello. Can you hear me?
Yeah, hi Jen, I can hear you. Welcome.
Welcome.
So,
Hello.
we'll right away jump into the session with Jen. It's going to be a very, very interesting session. And just before we even introduce Dr. Jen Unwin, very happy and excited to host her. And for those who don't know, Dr. Jen has already been on the D Life podcast, and some years ago. And we also have a podcast with Dr. David Unwin at D Life. In fact, he was one of the stalwarts who reviewed the D Life forum, when Anup had started off. And D-Life also partnered with Dr. David Unwin to translate his iconic sugar infographics into 9 Indian languages. And I'm very, very proud of the fact, Jen, that he wore the Indian kurta that I had sent for him. And he even posted a picture of himself on Twitter after wearing that. And yeah. And recently, just as a conversation recently, a UK-based doctor contacted me, and she was mentioning Dr. David Unwin and how he had recommended the D-Life diploma course for her, and he routinely keeps recommending the D-Life recipes as well. We had him in the first Metabolic Health Conference, and I had the pleasure of interviewing him. So welcome.
Thank you so much.
Yeah. So I'll jump into the introduction part before we begin the questions. I am Ira Sahai, the Chief Operating Officer of D-Life Healthcare Private Limited, a D-Life certified metabolic health coach and your lead host for the Metabolic Health Conference 3. D-Life is India's first and the only award-winning low-carb platform founded by Anup Singh in 2014, a silver medalist from India's Ivy League institution, IIT Roorkee. He's the recipient of the Icons of India Award by the Outlook Group in 2022. And D-Life has had the pleasure of being reviewed by, as I call him, the doyen of low-carb, Dr. David Unwin. And just to continue on that, Anup is the pioneer of the low-carb movement in India, with a path-breaking protocol of 100-gram carbs per day max given by him in 2012 that made not only LCHF but even type 2 diabetes remission possible for Indian vegetarians, which is a very complex grain-based vegetarian plate. So a bit of introduction on our guest today. Dr. Jen Unwin is a clinical psychologist specializing in food addiction and low-carb nutrition. She helps people overcome sugar addiction and improve health through behavioral changes. Her famous book, Fork in the Road, explores food addiction psychology, and she collaborates with her husband, Dr. David Unwin, to promote low-carb approaches for metabolic health. What a pleasure to have you here, Jen. And D-Life has always had so much love for you and Dr. David Unwin. We cannot thank you enough.
Oh, it's such a pleasure to be here, and we've loved watching what you've done and how the organization have grown and the difference you're making. That's, you know, everything we ever wanted when we started was just that other people would do the same and make a difference for people. So it's been a pleasure to watch what you do, and we always recommending the website and the recipes to people. So thank you.
Thank you so much for that, Jen. And we really value your association with us and also Dr. David Unwin's. So let's start with your such significant work that you've done in the field of addiction. Jen, please start by telling us, how did you start working in food addiction? And just as an extension of this question so that we can cover more, how do you define food addiction and what are the key signs that somebody might be struggling with food addiction?
Yeah. Okay. So you've talked about the work that we've done with David. So we started maybe 13 or 14 years ago now in his general practice in the UK. I'd read a book, and some of the listeners may have come across it. It was called Escape the Diet Trap by Dr. John Briffa, who was a British GP also at the time, who was way ahead of his time and was talking about low carbohydrate diets. And it was just one miserable January day. I've struggled with my weight gain, and then, you know, doing a scheme and losing weight and then putting weight on again all my life. And I just saw this book, Escape the Diet Trap, and I thought, well, that's what I need. You know, it was just the right book at the right moment. And I read this book, and it really, as I say, it was about low carb, and it explained the science. And, you know, I'm a scientist, so I loved that. I could completely see what he was saying about carbohydrates and insulin and how that drove hunger. And he gave the diet plan, and off I went. I'm the kind of person, if I think, oh, that's a good idea, I'm going to jump straight in with both feet. So I jumped straight in with both feet. I felt terrible, awful for about a week, but he told me that I would. And that's because obviously I was, you know, moving over to burning fat for fuel. So I stuck with it. And then on about day 8, I just felt incredible. It was a real step change mentally and physically and everything. And the weight dropped off. And I kept boring David with passages out of this book about insulin and carbohydrates. And then he saw the difference it made to me. And he was a bit fed up, really. He was kind of, looking back, we discovered eventually that he was actually a type 2 diabetic. He'd gone a bit sleepy. He was a bit sort of stressy. He was kind of fed up with work. And he did it as well, and he felt so much better. And he'd always worried about the patients in the practice. Since he'd started, there's been this tenfold increase in people with diabetes, people getting sicker and sicker on more and more medications. I mean, we've all seen it happen. People our age have seen it happen in our lifetimes. The population going from sort of healthy to increasingly unhealthy and chronic conditions. So he's a bit depressed about that as a career in medicine. So we both said, well, why don't we do something in your practice? We'd never worked together before. And so off we went, and we did our first low carb group. We were a bit timid, so we did people with pre-diabetes, 18 people, but they all did remarkably. They came off medications, they reversed their pre-diabetes, and well, you know the story. It's expanded ever since. And now David's got well over 150 cases of drug-free type 2 diabetes remission that's maintained. He's just looking at the data now for another paper. And fortunately, other people have taken it up like yourselves and are sort of spreading the good word. However, we did find, and I did find, so it's kind of my personal story as ever intertwined with the science, is that yes, low carb is amazing and it works for all kinds of health conditions, but some people struggle to keep to it, even though they feel so much better, they're coming off medications, they're losing weight, it seems like a no-brainer. Some people, even with all those benefits, will struggle to keep low carb. And I was one of those. So even though I knew all the benefits, birthdays would come and I'd think, well, I'll just have a bit of cake because it's my birthday. And then I might struggle if I did that. I might struggle, and it sounds ridiculous, but if you're a food addict, you'll understand. I would then struggle for a few months to try and get back to the diet where I felt really well on it, a sort of low carb ketogenic diet. And we found that in the practice as well, that there was a proportion of people, despite it being even more life-saving than it was for me, their blood sugars would be terrible when they weren't sticking to a low carbohydrate diet. They would that would happen, and then they'd sort of go into this denial state and avoid us. And so what we tried to do in the practice was understand that, and I tried to understand it for myself personally. And again, my eureka moment really was listening to Bitten Johnson on the Diet Doctor website, and you've had her on Summit. So if people haven't heard that, they need to go back and listen to her. What an inspiration that woman is. I watched this video of her talking about sugar addiction, and suddenly all the pennies dropped. That my behavior and the patient's behavior was exactly like people's behavior around cigarettes, alcohol. It's an addiction, and that made total sense to me. It's kind of not our fault. I think what people struggle with is that they feel they should be able to deal with this thing with willpower, that because they can't, and I was in that camp, and I was a psychologist, for heaven's sakes. So, I should have been able to manage my own eating behavior. I'm an expert in behavior. Why couldn't I manage my behavior was like a shameful thing for me. But once I understood it was an addiction, I could see, well, it's not my fault, in a sense, that the problem is with the substance, and in this case certain kinds of foods, not all foods, certain kinds of foods, and if I can be abstinent from those foods, I don't have a problem with the addictive like behavior that I'll describe in a moment. So that was like the epiphany, and was sort of, why hadn't I thought of that? I've dealt with people, I've trained as a clinical psychologist. I know about food, about addiction. We all know about it. We've all have members of the family who struggle with certain kinds of addictions. Why hadn't it occurred to me before? And I think it's, that a lot of us with food addiction will do anything to keep our drug foods, our carbs. We're kind of in denial. We don't want to admit that we've got a problem, really. But once we do, that's the sort of liberating piece of information for many people. So I think it adds another piece to the low carb puzzle for a proportion of people. And there was a lovely paper, was it 2022, I think, end of 2022, showing that if you've got a food addiction problem, you're actually 7 times more likely to have type 2 diabetes, which makes total sense, because the kind of foods we overeat are sugary, carbohydrate-y foods. Those are the ones that have that addictive potential. So we're overwhelming our system with those foods, and that eventually the body struggles to keep itself in balance. So that it makes total sense that there's that. Not everybody with food addiction has diabetes, obviously, but there's that link, and there's that link with obesity and other conditions. But again, it not 100% of people. Some people are normal weight or underweight. So the second part of your question. So that was how I started thinking about it. And then, I trained with Bitten. I did her training. And then since then, I've collaborated with a a nutrition consultant who also trained with BIT in the UK, Heidi Yaver, who's an incredible powerhouse of ideas and projects. And we've been working together ever since, both on research, but also on the campaigning side, which I think we'll come back to later. So how do you recognize it? Right. So for those in the States, that they use a diagnostic manual for mental disorders called the DSM. And for those of us in Europe, I'm not sure what you guys in India go by in the medical community, but we go by a thing called the ICD, which is the International Classification of Diseases hosted by the World Health Organization. So the World Health Organization has 6 key symptoms for identifying a substance use disorder or an addiction, as we might call it. And obviously, up to now, the substance that have been recognized as addictive are things like alcohol, different kinds of drugs, nicotine, and so on. But up to now, not sugar or ultra processed food. But if we take those 6 criteria, I'm going to go through each one, and I think as I do so, people could either think, how does that apply to me, and count how many out of 6 you get, or they could maybe think about someone they know that seems to struggle with maintaining a steady sort of relationship with food. Yeah, and we'll see whether we think that these apply to food. So these are the criteria for substances of abuse like alcohol. Let's see if we think they apply to food. So the first one is, so craved is the acronym, so CRAVED, so we can remember the 6 letters. Heidi and I have come up with this, and we've developed a screening tool based on this idea of using the ICD and these 6 symptoms. So craved, so C obviously stands for cravings and compulsions, which a lot of us recognize for particular foods. But do you ever have cravings and compulsions for certain foods that are so compelling, all the C's, that you kind of can't resist? You're sort of pushed to eat those foods, even though you've said to yourself, like I used to say to myself, right, Monday, the diet's starting, no cookies today. And I'd get home from work and I'd be tired and hungry, and there would be cookies on the side because, kids and I would reach for one, despite in my head saying I'm not supposed to be doing this today. It was almost like an automatic. So do people recognize that? Cravings and compulsions that drive you to eat foods even when you shouldn't, in a sense. So see, that R stands for reaching for more, and this picks up the idea of that we all know do with alcohol, of the idea of tolerance. And tolerance really describes that effect where, say you have 1 glass of wine every evening with your dinner, and the first few times you do it, you might feel a little bit tipsy, you'd feel the effects. But after a few nights, your body and your brain adjust, and you maybe don't notice the sort of the effects of the alcohol, maybe that you're looking for to be relaxed or whatever. And so we add in another glass to get that effect. So have you noticed that with certain foods that you need more and more to get the same effect? So maybe 1 biscuit, 1 slice of cake, even as a child, maybe you just needed more and more, or wanted more and more to get the same effect. So instead of 1 slice of cake, you're eating half a cake to sort of get the feeling that you want. So that's the idea of tolerance. A stands for activities neglected, which is a very typical sort of symptom of addiction, where the whole focus of life becomes around whatever it is, in this case, certain foods. And so that you start neglecting or thinking less about family activities, hobbies, doing well at work, keeping fit, all of those sort of other things in life start to suffer because there's a lot of thinking and planning going on, either about eating the food, not eating the food, you know, where have you got the food stashed away? You know, sometimes food addicts have a secret stash of food, or they, you know, they really want their food, but they're trying to think how to get away and get it without the family, you know, giving them a hard time about it. So A is activities neglected. V is for volume, and this is the idea of, again, losing control of the amount, losing control of the volume of what you're eating. So saying to yourself, right, you know, I've got this packet of biscuits for the grandchildren, I'll just have one before they come. And then, you know, once you've had that, it's one is too many and 1,000 is never enough. So this feeling that once you've had one, the brakes are off we go. Too much volume, not one slice of pizza, but, you know, 4 slices, despite your best intentions. E stands for exclusion, and this is picking up on the idea of withdrawal. So if we try and exclude those foods from our diet, do we experience withdrawal symptoms? So we all know that can happen to people with addictions to drugs, alcohol, and nicotine. If you try and quit your drug foods, whatever it is, chocolate, do you actually get some physical and mental negatives, you know, like maybe poor sleep, like stomachache, shakiness, anxiety, depression? People often report that they really struggle with withdrawal symptoms when they try and quit sugar. And that's what I was going through. Obviously, when I did my first week of low carb, I was actually, you know, withdrawing from all these amazing foods. E and D, finally. So finally, and this is really the defining one for me for addiction, is continued use despite damage, D for damage. So do you know, for example, that eating these foods is making your type 2 diabetes worse? Is it leading you to putting on more and more weight, which is making you feel unhealthy and unhappy with yourself? Do you know that you actually feel more depressed eventually when you eat more and more of those foods, or anxious when you eat certain things? And do you carry on with that behavior anyway? So despite knowing it's harming you, or the family thinking it's harming you, which is often the case, you can't stop, or you can't control the amount. So those are the 6. So I'd invite people to kind of think, how many have I got out of 6? I definitely had 6, and have at many times in my life when I've lost control of my eating. And most of the patients that I work with have got 5 or 6 out of 6 of those symptoms, because they tend to go together. So that's how you would recognize it, and it's how practitioners might recognize it in their clinics, or they can use we've got an actual screening questionnaire based on those questions that people can sort of quickly fill in. So it's a quick 6 question, you know, does it look like I've got that problem? And I think we'd all agree that yes, those symptoms can apply to food, even if you've not experienced that yourself. I'm sure you can recognize either in your patients or maybe in some member of the family.
I was just going to come to this, Jen, and every day I see this, India being a carb heavy nation, and this is so obvious. And you know, I find the symptoms that you were describing and the tool craved, you know, I was trying to match it up with the experience that I have with my clients, and at least 3 to 4 of them exist anyway. And I've had people telling me, you know, everything's going on well, the blood markers have improved, but you know, I'm feeling very weak. So what do you do? And in spite of all that counseling and talking to them, and you would not believe, before even we planned this MHC, this one of my mentees, and I told him, you may be having a food addiction. And he outrightly denied. Of course, denial comes first, as you said. And now when you're talking about craved, I can match his you know, traits one by one. And this is exactly, he feels better when he takes honey, or he feels better, you know, when he takes some kind of sugar, you know, basically fruits in the morning. So this is such a brilliant tool, and you know, I'll remember this. And I was trying to listen and absorb as much as possible. Brilliant, Jen. Yeah.
Well, and I'll give you the website where, I mean, we're sort of developing it, but people will be able to sort of have a look and download it there, or maybe work with us if you want to share data or whatever. They can work with us on that. Yeah, I think that's the difficulty. It's that interim period where you're trying to get people out of the sugar. Yes, they're going to feel worse, because that's how addiction gets you in a way, isn't it? Eventually all you're doing is taking the substance to get rid of the withdrawal symptoms. So people who've got a real addiction to alcohol or nicotine, they're not drinking or smoking to feel amazing. They're drinking or smoking to get rid of the withdrawal symptoms. And that's how we'll probably get onto it, but that's how the brain works with addiction. And you have to break through that phase with support and come out the other end like I did, and then see, oh, okay, this is how good you can feel when you're not a slave to, like you say, you have to get up in the morning and have some sugar because you feel so weak and awful. Once we're fat burning, we get up in the morning and we feel amazing. We don't have to eat till lunchtime. So, but that requires a lot of support, a lot of education, obviously. And
would you agree that, is it any different from alcohol and other substance abuse kind of addiction, or is it just the same? Is it as bad as those?
Yeah, I would say it's exactly the same in the brain. So, if people are taking scans of the brain, you can't tell the difference between a severe food addict and someone else with some other kind of addiction. The reward centers of the brain are involved. And, addiction, as what Bitten would say, addiction is addiction is addiction. And unfortunately, those of us who have that tendency to addiction can be drawn into other it can sort of cross over into other addictions. So oftentimes when there's a genetic factor as well. So oftentimes when we interview people, they might have a father who had an alcohol problem, for example, or in my case, my mother was 100% a sugar addict. Looking back, obviously I saw that behavior, but I think also that there's a genetic component because I was like that from very, very young. So I would say it's the same. And in many ways, what we say to patients is actually it's more difficult. And a lot of people I've spoken to, like Bitten as well, who've given up other things where they had a bit of a problem, say that actually sugar is really, really hard. I think there's a number of reasons. One, we've had it since we were children. And like you say, culturally, in certain cultures, I mean, everywhere in the world now, but in certain cultures, it's been really important, and it's kind of linked with love and kind of treats and special days in the family. So there's that whole baggage that we come with. It's the only psychoactive substance that we give children. We all know we don't give children alcohol or nicotine or caffeine even. We don't tend to make kids cups of coffee in the morning to get them out of bed. But we'll give them a sugary cereal, or we'll give them a cake or a lollipop to make them feel better. So sugar's the only psychoactive substance that we give children. But not only that, the whole world has gone mad for sugar and carbohydrate and ultra processed foods. So we can't go anywhere without having it right in front of our noses. If we go to a cafe, there's cakes on the counter. Here in the UK, if you go and buy fuel, you can't pay for that fuel without there being a great big array of chocolate bars and crisps. It's every celebration, Christmas, we've just had Valentine's. It's just a festival of chocolate in the UK. Easter's coming up. The Easter eggs are already in the supermarket here in the UK. I mean, it's
the same for India, Chen. It's the same for India. All our festivals, right from birth to death, are celebrated with sugar. And I think in a way we have mainstreamed and normalized this addiction, as you call it, because, there is so much of dogma and stigma attached. If you tell somebody not to eat a particular sweet dish, so much in quantity and so frequently, you get, outcasted because it's considered normal. Yeah, it's considered normal. And what you're telling them is actually, stopping them from being happy. So we have normalized this addiction, on
Yes.
such a large scale. And
Yes.
India being a vegetarian country, the carbohydrates addiction, the sugary treats that you say, so morning to evening, we are doing this, festivals to festivals, we are doing this, birth to death, we are doing this, we are no better. But it makes it all the more complex because here you have huge amount of carbohydrates as well. And when you tell somebody that, I am scared of telling people actually that you may be an addict, you may be abusing food. I told that to one of my mentees and he denied. Of course, that would come, I know. So very, very great insights. And, I can totally relate that, relate to
Yes,
all of us. So,
definitely.
Jen, just in short, just elaborate on what kind of modern food environment exists in today's world that has led us to this place where we are in acute denial of this.
Yeah, exactly. Yes. So we did a consensus exercise last year with all the experts on food addiction we could find, clinicians, researchers, academics, to see what we could all agree. And actually, they all agreed that we should call it ultra processed food addiction because really, this isn't a problem of real whole foods as nature intended. It's a problem of the modern food environment and foods that are, we know now because that's been written about in several books and it's been exposed, foods that are engineered for addiction. That's the point. They want you to buy more and more, so they make them absolutely delicious. They've done that by, experimenting in the lab, by putting people in brain scanners so they can see which foods light up, literally which foods light up the brain, make them as addictive as possible. Like, that's kind of accepted now that that's gone on in the food industry. And I think, yes, maybe that started in America because when the writing was on the wall for nicotine and cigarettes, those big cigarette companies, Philip Morris and other companies, bought up the food companies and then applied their sort of, let's say, addiction model to food and the marketing models as well to food to make them, super enticing, super, delicious in a sense. I don't really find them so delicious now that I know all of this, but super delicious and also very, it's all colourful. The marketing's amazing. We're marketing stuff to kids, cereals marketed to kids. We start them young. So I think that's all a factor. Also, I think it's just the ubiquity and the constant access. So even when I was a child, we weren't exposed all the time to advertising, to the availability of sugary sweets. I think we were allowed one treat a week or something, which of course I, looks forward to intensely for the whole week. And I don't know if it's the same in India that we couldn't, there wasn't that, it's okay to have these foods every day. Yes, they were for celebrations and we did have some things at Christmas, but it's like these days, as you say, it's every day, every celebration. It's become more and more sugary and more ultra processed foodie. People are cooking less for themselves. People are buying less locally raised, healthy foods. The food supply, in certain parts of the UK, so people have been really struggling to buy fresh, locally grown foods or vegetables or, so I think there's a whole load of factors that have sort of come together that, as we see now, more and more people with this problem. So the latest estimates are for this sort of the level of food addiction problem that we're talking about, where it would be a clinical problem, probably 14% of the adult population, and as many children. Actually, it looks like the poor kids who've been raised in this environment, it's maybe even more. So 14% of all the adults in the UK is something like, I think it's something like 6 million adults probably have this problem, and they're the ones with the chronic health conditions, diabetes, so on and so on. So it's an absolute epidemic, disaster happening, and not everyone with diabetes. We're not saying everyone with diabetes has this problem, but the ones that really struggle to stay the course, yeah, it seems to be really a big part of the story. And then, of course, like any other addiction, what you need is a lot of help and support and patience and, explanation. It's not enough just to say, like, it's not enough to know that you shouldn't smoke, is it? To be able to quit smoking, you need support, or some people need support to do that. Same with alcohol and drugs. So I'm proposing same with food addiction. We need to get with the message that these people are, they're really struggling. They need a lot of help and support. They need to be with other people who are trying to do the same thing, so that, like you say, in your culture, they wouldn't feel so like they're the only one. They need a support group or a peer group.
Does this often require any kind of medication also, Jen?
I mean, so for the occasional person, David has used medications like the GLP-1s at the beginning. So obviously we know those medications have pros and cons, and some of the long-term cons aren't great. But if they're used as part of a package where people are then getting the support, they're then getting the education about how they should be eating. In fact, there's a paper just literally come out yesterday that David co-authored with Tro Kalayjian, where that's exactly what they did. Some people were on GLP-1s, but they were able to come off them once they had the right information. And they didn't put the weight back on, because then they were doing the right thing. So for some people that just can't get going, or the addiction's so, the cravings are so terrible, he does use that as a sort of interim, if you like, a bit like methadone for heroin. It's a way to sort of to move out of the problem and into the solution. There aren't really good treatment trials of food addiction, because this is where we get into the campaigning thing, because it's not a officially recognized addiction. Of course, there's very little research, because research isn't funded, and of course there's very few treatment programs, because the research isn't funded and the treatment isn't funded or isn't reimbursed by insurance companies in the States, etc. So a big part of our mission, myself and Heidi and other people that we work with in the team, is to get food addiction recognized officially by the WHO and by the American Psychiatric Association in America, so that those treatments can be funded and it becomes a legitimate condition for which doctors will recognize, and you'll be able to seek help and get funded help. In the UK here now, there's no help on the NHS for people with food addiction, other than perhaps David's practice, because he understands it so well now. But otherwise people would have to pay for sort of, there's folks doing online programs, but you have to pay a little bit for that. So yeah.
Yeah, Jen, we have about 10 minutes left, and I would want to ask two very important questions. One, is there a direct link between this addiction and anxiety and depression? That is number one. And two, is there any specific role that the carnivore diet as such plays in such situations? Does it help more?
Okay, so anxiety and depression, yes. So there's been a number of papers looking at the links between ultra processed type foods that we're talking about, high sugar, refined carbohydrate foods, and anxiety and depression. And there seems to be a dose response. So a bit like, the more of these foods you eat, the more likely you are to be type 2 diabetic. It's the same. Yeah, the more of these foods we eat, the more likely we are to have mental health challenges and problems. And that's partly because of the way that sugar works in the brain. I don't know if Bitten or one of your other speakers has sort of explained this, where you get a big dopamine hit from eating sugar, and that's kind of why we like it, because it sort of boosts us up, doesn't it, temporarily, because what goes up must come down. Obviously the brain doesn't really want those high levels of dopamine. It's trying to keep, like everything, trying to keep in balance. So it it knocks out a few dopamine receptors in your brain, so that the signal, even if dopamine's available, the signal is weaker. That's why we need more and more to get the same effect. But it's also why then when we're not using, when your chap wakes up in the morning, he feels really grim, because his sort of set point for dopamine is lowering over the time. So the more sugar you eat, the less available the dopamine is to you over time. And because dopamine is the neurotransmitter of motivation, the more likely you are to be feeling unmotivated and depressed, in a sense, low mood. So yeah, and the same with serotonin, which is the sort of relax hormone, a similar process whereby over time, actually your resting state is going to be more anxious and more depressed. And that's why it's the trap of then you wake up in the morning, you feel awful, you have some honey, you feel a bit better, you get on with your day. Yeah, so there's that, there's a good explanation why people with mental health problems should be eating a real natural whole food diet without these sugary refined carbohydrates in them, which leads us really neatly on to carnivore. Yeah, so lots of people on carnivore report, very quickly that their cravings for the ultra processed foods dissipate, and that's because these processes are normalizing. You're healing your brain with all the good minerals and nutrients, probably, that Marty was talking about, that you need to heal the brain and for the brain to work. It's an incredibly complex organ, and mitochondria need to be working well because your brain's very energy hungry. And if your brain's working well, you get on with life, and you stop thinking about trying to feel better by this temporary boost of a cake or some fruit or something like that. So carnivore is one way, but then there's many ways, and for some people, if they go too restrictive, they have that sort of bounce back. They can't. It's more like a sort of eating disorder way of thinking about it. If they go super restrictive, the minute they slip up, which they may do eventually, then they will tend to think, oh, hang it, that doesn't work either, and I'm kind of going to go back. And like we said, that first bite can sort of lead on to problems. So it's a very individual thing how much people should restrict, what's right for them and what they can stick to. So I think the right diet is the one that you can stick to long term and you feel good and you can cope with in sort of, like you say, modern society. So it's and obviously for a lot of your patients, they're going to want to stick to a real food vegetarian approach. And there's plenty of it's harder, but you can recover from food addiction with a slightly more liberal whole food approach. I personally feel very well on high fat carnivore, and I personally try and do that most of the time. But I think I'm pretty far down the the food addiction continuum, and it may be that for people that have had that severe problem all their lives, that is a good solution if you can stick to it. If people are less far on the continuum, they may be able to get away with a whole natural foods approach.
Yeah, Jen, and the last final question, what do you think has the role been of dietary guidelines? I asked the same question to Dr. David Unwin as well. In getting society to such a sinister stage, everywhere, sugary foods, addiction, carbohydrates, and, ultra-processed food is pushed. And, something that is supposed to work the other way around has brought us here, actually. What do you think about that?
Yes, I agree with it totally. And I don't know if you've ever had Zoe Harcum on the podcast. You may have done, but her PhD was looking into was the evidence there at the time when they brought in the low-fat guidelines in the 70s? Was the evidence there to do that? And her conclusion is absolutely not. And everything flowed from that, didn't it? Make it, recommending low fat meant that, oh, well, we had to sort of manufacture products that were low fat because, low fat dairy in its natural form is not low fat. So we had to manufacture some yogurts, and because they had to taste of something, and they had to have a certain consistency, then we added sugar to make them, taste good, and we added various kind of emulsifiers to make them feel right in the mouth. And that, amongst other things, was the beginning of the end, really. But I think I think it's turning around now. I think there's a bit of a backlash. Look at Kennedy being appointed as the health secretary in the States, and he's definitely kind of on the other side of this argument. So, and it's interesting. There was some data came out the other day to show that in the UK, margarine and sales of those kinds of products are going down, and sales of butter and eggs and whole fat milk, whole fat dairy products is going back up again. So I think in the young people, hopefully the message is getting out. We've obviously got Chris Van Tulleken over here. He's a fantastic advocate. He wrote that amazing book, Ultra Processed People. He doesn't want to be, but he's the poster boy really for the real food, argument, the real food movement over here. So yeah, I think unfortunately myself and all of you, we had to learn that actually everything we thought was true was not true to get healthy. I eat lots of salt. I eat lots of fatty meat. I've had a cardiac scan, clean as a whistle, even though my cholesterol's reasonably high. So I don't worry about, high cholesterol is actually protective for older women. There's lots of data on that as well. So I think there's lots of things we have to look at the evidence for ourselves and try and think in a different way, although it's a bit mind-blowing.
Yeah, it is mind-blowing, and the insights that you've given, Jen, they are truly priceless for all of us at D-Life, and everybody who's listening to it. I think people will identify with the fact, and they can go through the craved, tool to identify their cravings and addiction. With that note, I'll call Shashi Kantangar and Anoop also on the screen to say thanks to Jen.
Jen, thank you very much. Thank you for accepting the invite. And I think you're coming in for the second time, of course, in Metabolic Health Conference for the first time, but you had come earlier in the D-Life podcast, and your insights are very valuable, especially on the processed food addiction front, and that's where your strength lies. So we look for more such collaborations in coming times, and we maybe we will meet again once again. Thank you.
I hope so. Thank you so much.
Thank you, Jen.
Please get in Nairi, Jasmeet and Ishani. Hello, Nairi.
Hello, I can hear you well.
Hello.
Yeah, hi, Nairi.
Hi.
Hello.
Yeah, welcome to the Metabolic Health Conference, India.
Thank you, Jasmeet.
Hi, Nairi. I am Ishani, and I'm a member of DLife.in, India's first and only award-winning low-carb platform. And I, along with my co-host, Dr. Jasmeet Kaur, we welcome you for this session on low-carb and type 1 diabetes. So as a type 1 diabetes myself, I'm super excited, and I'm a big fan of your podcast. So we are very excited to welcome you.
Thank you very much. I'm excited to be here.
Yeah, so D-Life was founded in 2014 by Anoop Singh, a silver medalist from IIT Roorkee and the recipient of Icons of India Award. Anoop is the pioneer of the low-carb movement in India with his path-breaking protocol of maximum 100 gram carbs per day given by him in 2012 that made LCHF possible for Indians and especially for Indian vegetarians. In 2021, D-Life launched its diploma course, which is the only course approved under NSDC partner, the Government of India. So it's legally tenable in India. In this segment, and the only course with the global biggest 144 hours CPD SO hours credit. So Anup Singh, along with Shashikant Iyengar, are organizers of this Metabolic Health Conference. So yes, we welcome you, Nairi. And a little about you. I hope we are pronouncing your name right.
You said it beautifully. Thank you.
Yeah. So Nairi Mrs. Sian is a pioneering metabolic health expert, low carb advocate, and podcaster who has transformed the understanding of diabetes management through her personal and professional journey. As a type 1 diabetic with over 47 years of experience, she has become a leading voice in the low carbohydrate nutrition movement, challenging traditional medical approaches to metabolic health. Her work centers on demonstrating how a low carb diet can dramatically improve blood sugar control and reduce insulin dependency. Through her coaching, online platforms, and personal testimony, Nairi has helped countless individuals with diabetes and metabolic disorders reimagine their approach to nutrition and health. So, to start, Nairi, you've been living with type 1 diabetes since 1978, which is a very, very long time. And I can see that you are thriving, living with type 1 diabetes. So, how did the medical advice you initially received differs from the medical current approach, your current approach to managing diabetes?
It was a long, long, long time ago. So 47 years, 47 years ago it was. So, these days when people say low carbohydrate diet, a lot of people have that reluctance and, oh, what is this? This is fad. And, oh, it doesn't work. Oh, no, we need carbohydrates. Guess what? When I was diagnosed in 1978, my mother was given a sheet of paper by the doctor who diagnosed me because I had to stay at the hospital for a few days. That sheet of paper had a food list on it. It wasn't just for type 1 diabetics. It was for all diabetics, including type 2. So if you are diabetic, you had to follow, there was a green list, orange list, and red list. The red list was sugars, pastries, and cakes, and some of the sweet fruits. And on the orange list, we had all the legumes like lentils, chickpeas, etc., which I could eat, but not, huge quantities. And on the green list, there was all the salad, vegetables, and many other vegetables. In fact, a lot of vegetables other than the starchy potatoes, and meats and fish and dairy and cheese, all of those. So it wasn't controversial. So I don't know why suddenly now people are like, oh, it's controversial. It doesn't work. That was the diet that was recommended to all diabetics. In fact, I grew up with my extended family. My grandparents from both sides of the family were type 2 diabetics, not type 1. I'm the only type 1 in my family, but type 2 diabetics. And guess what? They were following the same diet that I was recommended to follow. So my whole extended family with my uncles, my aunties, they were married at the time. So it was a busy household, big family sort of surrounding. Everyone was eating the same foods. Everyone was eating low or lowish carbohydrate foods. There was no controversy around it. In fact, never, not even once, did I feel like I was deprived of something. We didn't have sugary drinks. We didn't have Coca-Cola at home. We didn't have cakes. Cakes were an occasional treat. From birthday to birthday, my mom would treat me to cake, and I remember every single cake for every birthday that she made. She made for me. So that's how it was. So, and I think it is because of my upbringing on a healthy, home-cooked diet that I didn't suffer, that I even now, I don't, after 47 years of type 1 diabetes, I don't have any complications. I'm in perfect health. But things did change when I came to the UK. So I grew up in the Middle East, and in my early 20s, I came to the UK to continue my studies. And as a good young person, I had to go to the local diabetes clinic to register because I needed to have prescription for insulin, etc. So that was the first time in my 20s that I read on the wall, large posters on the wall at my diabetes clinic, messages like, there is no such thing as a diabetes diet. Diabetics can eat everything and take insulin. We have powerful, effective insulins now. And that part was true because when I was growing up, we didn't have rapid acting insulin. But by the time I'd come to the UK, 25 years later, we had Novolog or Novorapid in the UK, Humalog. So we had those rapid acting insulins. And so then the advice was, we have effective insulin, eat your carbohydrates, well, eat your sugars and starches, and just cover it with insulin. I tried that. In fact, I thought, oh, we were in the Middle East, must have been some kind of backwards, right? I remember actually making an international call. This was pre-internet, right? It cost me a fortune that I could barely afford, but I called my mother to say, it's so advanced here. Medical care is so advanced. You will not believe. They're not telling me not to eat. They're telling me to eat anything I want. And that was, I think, the first time I actually probably took a few sips of Coca-Cola or Pepsi. I'd never drunk it. I'd never craved it. Because it wasn't part of my upbringing. I drank it and I didn't like it. So I decided it's not for me. But the fact that I could eat anything and cover it with insulin was completely new to me. I tried it. That's how I lived for 10 years. In fact, throughout my pregnancy also, I followed carb-based diet. And the fact that I'd also, just around that time, before coming to the UK, I decided to become a vegetarian. So I was no longer eating meat, to my mother's dismay, but I was no longer eating chicken or fish. So as a vegetarian, of course, now, and with the message that I could eat anything I wanted, now my diet was much, much higher in carbohydrates than it ever had been. I struggled with blood sugar control. I attended 2 courses over, I think, 10, 15 years, offered by the diabetes clinic to teach me how to count carbohydrates. We didn't have those apps. Now there's tons of apps. You can just you can even post a photo of your meal to an app and it works out how all the macronutrients. We didn't have those. We had to attend actual physical courses. I became a master. In fact, I volunteered as well at the hospital to teach newly diagnosed diabetics how to count their carbohydrates. Despite my mastery in carbohydrate counting, I still couldn't match my insulin to the carbs I was eating. There was something wrong. It wasn't working. But because it's put forward to us as an absolute non-negotiable science, I didn't question the method. I started questioning myself, whether I was making a mistake, whether it was 15 grams of carbohydrate instead of the 13 that I'd calculated. I kept blaming myself. For many years, I looked at myself as a failure because despite my carbohydrate counting skills, the skills of matching or trying to match my insulin to the carbohydrates, my A1C at one point actually was 12.8. That was the highest it had ever been, 12.8. I brought it down during my pregnancy, but again, it was 6.8. So,
but what was the HbA1c level you maintained before coming to UK?
So my mother says it was always below 7, so something like 6.8 or 7, and they were happy with it because we didn't have rapid insulins. I rarely ever experienced hypos. The insulin we had at the time was kind of more, I think I even initially used bovine insulin. So they were safer. They didn't cause hypos because, of course, they weren't rapid-acting insulins.
Yeah.
They were more intermediary, and I had to take 3 set doses of shots, and then I had to eat at certain times similar portions of food. And I don't remember many hypoglycemic episodes. There would be 1 or 2 because I was a very physically active child, but they were rare.
So I can get that you were lucky in a way that, you grew up with healthy food already. So you were not. So when the opposite case in India is that, the diet chart that type 1 diabetics get is usually like the American Diabetes Association chart, loaded with carbs. You just take insulin and there's just portion control, but the foods are all the same. So in that way, you were very, lucky in that way that you grew up with healthy food. So, Nairi, how has the medical community, you think, responded to alternative approaches like low carb diets and intermittent fasting for type 1 diabetes management?
So the medical community in general, if we look at sort of globally, I think there is a lot more understanding of lower carbohydrate diets now as an intervention to control blood sugars. I mean, in the realm of diabetes, for example, especially with type 2 diabetes, it's an accepted method, and if your doctor doesn't support you, they are completely ignorant. I mean, the knowledge should be updated. With type 1, we've got a long way to go. However, the recent position statement, position paper from the US-based Society of Metabolic Health Practitioners, of course, is going to make a difference. Podcasts like mine and many other type 1s who are following Bernstein, for example. My platform isn't a Bernstein platform, but of course, we are all, all type 1s who are able to control them. We're all Bernstein's children. That's how I look at us. We're Bernstein students. If it weren't for him, we wouldn't be here. We wouldn't be doing this. So in the type 1 space, we still got a long way to go. Personally, my diabetes consultant or endocrinologist, as we call, as some other countries call them, doesn't understand what I do. And he asked me a few questions in my last visit and the visit before. So how are you dosing why are you taking your 4 units of insulin? I said, well, for the protein. And he didn't argue because that was new to him. But he said, okay, so how are you working out how much protein to take? I said, well, I figured it out through trial and error because that's what it comes down to. You have to take notes. Even Dr. Bernstein recommends that. He just gives a starting point, but you have to write down what you ate, test it, how much insulin you took, at what point did you take that insulin. So now I've got it all figured out. It took me a whole year actually to figure it out. And but at least he's not dismissing my efforts. He's not questioning why I'm doing it. He's not telling me not to do it. So I'm happy. He doesn't generally interfere with what I'm doing. He just writes my prescriptions and leaves the diet to me. So I think that's big. That's big.
Yeah, that acceptance.
The major hurdle, the people face while following this low carb is all the misconceptions that the people have, like it hinders the growth and development of the child with the type 1 diabetes. So that is the only concern which we see that people, when they come to us and we suggest them this low carbohydrate approach, And they do get the flat lines like HbA1c of around 5, and sometimes even we see up to 5.5, 5.6. At least they are better, like, because before they come to us they are on 12%, 11%, and something like that. And even if they're getting these flat lines, and they are, when they have they're meeting with the conventional doctors, they ask them to add certain number of carbohydrates to each meal, even if they're getting the flat lines.
Yeah, that's sad. I think we need to. I was listening to Marty Kendall earlier on talking about the importance of protein. I think we underestimate protein. I mean, most people, look, in my culture as well, I grew up in the Middle East, and most people around me, everyone kind of understands fat, right? Because we've been told, oh, fat, 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 foods that contain fat, everyone knows that, right? People don't understand protein as much. They underestimate. So children who are reducing their carbohydrate intake need higher amounts of protein to meet their optimal growth. Again, Dr. Bernstein mentions that in the book. Children need large amounts of protein, sometimes even more than what their adult parents would be eating, to help them grow. And to be honest, I mean, the same could apply to us adults too. I focus on animal proteins as the main component of my foods. And it helps me repair my cells. It helps me maintain my muscle mass, because we know, science shows us that muscle is your longevity organ. I think someone put it that way, and it's been stuck in my head. Longevity organ, that's your muscle. And longevity doesn't necessarily mean living longer and sicker, but living a healthy life. It's important. So this is why I'm no longer a vegetarian. In fact, 5 years now. So I'm 5 years into meat eating, and that has helped me tremendously to maintain more normal blood sugars.
So, Nairi, as you grew up in the Middle East, there are the type 2 diabetes especially is really skyrocketing in Middle East. So what do you think, what are the key factors contributing to it?
I know Shashi was very looking forward to me discussing this point. So I'm glad you asked it. We're competing with India. Middle East is competing with India. It's one or the other, right on the top, and and it's a disaster. It's a disaster. Okay, the first culprit is definitely that we have incorporated Western foods, processed foods. So I'm pretty sure you will identify with that, because I have many Indian friends and they say, yes, this is how people think in India too. So you look at younger families, right? Feeding boxed cereals and that sort of junk to their children, completely oblivious of the impact of that on their children's health. But they are actually feeling like they are progressive. They're modern. They're like American, because this idea of American or Western food as being progressive and modern and, easy and convenient. And so this is how people see it. They think they're doing something good by saying goodbye to their traditional foods and incorporating or adopting a more Western junk food diet. There's one element. That's one element. But also, if you look at our traditional foods, for example, all these beautiful desserts and sweet, sugary foods that are typical of, Middle Eastern cuisine. Whereas 100 years ago, they would have made an appearance on days of festive days. For example, for the Middle East, you have multiple cultures and similar to India and religions. For example, for the Muslims, during Ramadan, they would have fasted and then feasted on all these sweet foods. But that would be it. You wouldn't see those sweet desserts because they were typical to Ramadan period. Same for the sweet breads and some of those brioches that, that people eat, the Christian people, they would have made an appearance around Easter. Now you can just walk across the road to the pastry shop and buy these sweets any day of the week you want. And so food is, in fact, unhealthy foods are easy to access. And we're physically putting less effort into making food. We have all sorts of kitchen gadgets and, we're not starting from scratch making the dough. And I made that. I did that, actually. Used to make bread at home. It's a lot of effort. The big loaf of bread, that would take like probably 4 hours. That's a lot of effort for my little hands. I used to bring my daughter in to help me knead it, etc. We're not putting as much effort. We have machines for everything these days, right? And so easy access to junk foods, easy access to food in general, and less effort making and preparing that food. So yeah, all of that equals disaster, health disaster.
So,
Yeah,
Nairi, you mentioned that you cover your protein with the bolus. But what about the fat? Do you consider the fat is enough? We don't have to cover it with the insulin dosages, because what I have seen is when we give people like the kids some extra calories, even if they're coming from the fat, we have to cover with, could be extra basal dose, or even sometimes some regular insulin as well. So what are your thoughts on this?
I always say that if you have type 1 diabetes, there are no free foods for you. You can drink water and not dose for it, but anything else will require dosing. I can't think of anything. I mean, I might just get away with half a boiled egg, for example. But that's not a meal, right? So whatever you're eating, every single macronutrient in there needs insulin. Now, how you take that insulin is going to be based on context. Are you using a pump? Do you have access to regular insulin, for example, intermediate acting insulin? Are you only using rapid insulin for your macronutrients? So it depends, but there are strategies to employ. But it is a fact. It is a fact. You need insulin for all your macronutrients. What I do personally, now I'm wearing a pump, insulin pump. So for the carbohydrates in my meal, and it would be carbohydrates from, I don't know, broccoli, and so small amounts of carbohydrates from broccoli or salad vegetables or whatever. I will take my rapid acting insulin right up front. For the protein component, I give myself microdoses depending on the protein type over a period of 4 hours, sometimes over a period of 6 hours. So after steak, for example, that's a very slow digesting food. And so the impact of the steak on your blood sugars isn't going to appear instantly. Usually with me, I mean, it varies from, just to make it more mystifying, type 1 diabetes is so individual. So I would need insulin over a period of 6 hours. I cannot take my, say, 5 units of insulin to cover it all in one shot because I'm going to crash. Remember, my pump has rapid acting insulin, Nova Rapid. So instead, I divide the 5 units up into smaller portions, 0.8 units, maybe right at the beginning, an hour later, maybe 1 unit, and 2 hours later, when I see the blood sugar rising a little bit, another two units. And that's how I cover the protein. Now, the fat, I work it into my basal insulin. So my long acting takes care of the fat. But on days that we are not eating as much fat, I have to lower my basal insulin. But it works for me because fat has that stubborn rise impact. It kind of raises your blood sugar, say from, I don't know, 80 to 200, and it just stays there. It just keeps it there for a good, 18 hours, right? And people go, oh, I'm insulin resistant. I question that because it's not necessarily insulin resistance for me. It's not that the fat made you insulin resistant. It's probably that you did not cover the fat, because fat needs insulin, maybe trickles of insulin over a period of 12 to 18 hours. If you cover that, you'll find that, well, I'm not insulin resistant. No, I'm eating the fat, but I'm covering it. And so, I'm not having the same impact. So I always question that. I may be wrong. It may actually be insulin resistance, but as any macronutrient, it needs covering. You're going to need extra insulin for it.
It's basically that extra energy has to be stored somewhere and you need that insulin for that, no?
Exactly.
Yeah.
Yeah.
And, this is a very, I think, important question for me to ask you, because this is often ignored, this side, that what are the most significant, you think, mental and emotional struggles that you've observed among type 1 diabetics over your, whole span of being one? If you have faced personal struggles or you've seen people around you.
Okay, I think we don't generally talk about the struggles. We talk about our successes, right? You look at some Facebook groups where people boast how beautifully they're managing their blood sugars, following certain protocols. They're only posting their graphs when they are beautiful. They're not really posting about their struggles. I think the more we talk about the struggles and the frustration, and the less judgmental we are of each other, I think the better our community will be. So I try to provide that platform in my private group on Facebook. I say this is a no judgment group. We're all somewhere on our health journey. It's a spectrum. We're somewhere along that line, and different interventions, different ways of taking your insulin, different insulins will work for different people. Even different ratio of macronutrients. You cannot say, if you have type 1 diabetes, this is what you should eat, this is how much insulin you need to take. It varies from person to person. Heck, it even varies in the same person from day to day, especially if you're female. But because we have a lot more hormonal fluctuations than males do, right? So frustration is what I see. And it's understandable because you're going to have to manage it on an hourly basis. You cannot. For example, now I'm watching where my blood sugars are going. They're rising a little bit because I'm anxious and
excited
adrenaline because of the adrenaline, right? So, but I'm going to leave that because right after this interview, it's going to go back right down to normal. So, but you have to be aware of where your blood sugars are. You cannot take your eyes off it. You cannot pretend you don't have type 1 diabetes one day because you're too tired of it. And I also want to say, I don't want people to kind of have a wrong interpretation of a low carbohydrate diet. Low carbohydrate diet still needs management. You still need insulin. You still need to take the right amount of insulin. You still need to manage your blood sugars. So nothing out there can give you that peace of mind so you can sit back and say, got it all cracked out. And I don't need to do much today I'm just going to put my feet up and just relax. It doesn't work. Blood sugars don't just stay in range because, you know, they want to behave on that day. It doesn't work like that. You have, it's, I call it a balancing act. To maintain normal blood sugars, you're balancing your glucose with insulin. It's a constant balancing act. So if you took too much,
and there's so many variables, no?
There are too many variables. There are too many variables, but taking all of those into account, you're still going to balance the lows with a bit of glucose and the highs with a bit of insulin. So it's constant balancing game, and you have to work on it all day long. So you understand how frustrating it can be when people go, oh, I cannot balance this. What's happening? Am I taking because of course there are other variables, so it can get frustrating. I think my attitude is, look, would you rather a disease that you cannot do anything about? When we used to complain about foods and things when we were children, I don't know if you can, if it resonates with you, my mom would say, there are too many hungry children around the world and you're complaining about this food, right? But it is, in a way, it's also the same analogy. Too many diseases that leave people completely hopeless and helpless. They want to survive, they want to live, they want to do whatever it takes to live, and there's nothing they can do. With type 1, the key is in your hands. Yes, it is hard work. Yes, it will be frustrating sometimes, but the control in a way is in your hands. It's a disease that you can manage. It's a disease that allows you to live your life, a fulfilling life. For example, I mean, there's nothing that I've wanted to do in life that I haven't done because of my type 1 diabetes. Maybe that can bring me to the fasting sort of element, because when I wanted to do fasting, I started posting in different fasting groups, looking for type 1 diabetics who were doing fasting. I thought, there must be someone out there. And I was like shunned. No, type 1 diabetics should not fast. And that's why I created a group for type 1 diabetics to give them the support if they wanted to fast. And, my aim isn't to tell everyone you should be fasting, but is it possible for a type 1 diabetic to fast? In my group, I have people undergoing cancer treatments. They want to employ the fasting protocol, but they don't know how to manage. In fact, there's just one lady who's currently going through chemotherapy, and she says, my oncologist is completely on board with fasting. He's familiar with the literature, but he's telling me, look, I don't want to take responsibility. I don't know what you're going to do with your blood sugars, because, please, can you see your endo at the same time? So she came to the group and, we're working together. She knows that there is a support network for her. So, fasting is, not everyone should fast, diabetic or not. It's not like, it's not for everyone, but there are people who will benefit from either extended 5-day fast. If you're going through cancer treatment, that might be a good strategy for you. If you have excess weight to lose, it might be, I'm not saying it will, might be a good strategy for you. But intermittent fasting is I usually call it any period, over 4 hours that you're not eating. Because we're constantly told, hey, especially if you're diabetic, you need to eat constantly. It's like, where does that come from? We're eating too much. We're actually overfed and undernourished. So instead of focusing on nutrients, we're constantly eating junk foods just because we're told we should eat. Like, no, if just eat your 3 meals a day. That's how it was when I was growing up. I had this whole kind of idea of, in fact, when I came to the UK, and people are going to be shocked about this. When I came to the UK in my 20s, and my background is in linguistics, and so I came to the UK, and with my knowledge of multiple languages, I was pursuing linguistic studies. I did not know what the word snack meant. I had to look up in the dictionary in the UK. The 2 words, in fact, the other one isn't relevant to that. The other word was bullying. Like I'd never heard of it. It just didn't exist in my culture, right? So I had to look up bullying and I had to look up the word snack because they were completely unfamiliar to me. So we didn't snack. We had 3 solid meals and we just played out in the forests, in the neighborhood all day long. So again, I'm in intermittent fasting. People hear the word fasting and they go, they're gonna be starved. It's not starving.
Especially in India, what I have heard is even doctors tell me that as a type 1 diabetic, you should not be fasting because you cannot fast. As a diabetic, you have to keep eating every 2 hours, every 4 hours, have a small snack. So, yeah, so, you are saying that it's doable. It's doable if you have the proper guidance and proper, you know what to do.
Mm-hmm.
Yeah, it's about the individualized approach in case of the type 1 diabetics.
Well, when I was told type 1 diabetics shouldn't fast, I was listening to all of Jason Funk's videos. And of course, they're not about type 1. They're all about type 2 diabetics. But I thought the same should apply to a type 1 diabetic. I went to PubMed. I started looking for literature just to see if what the dangers might be, right? And I found out 2 things. So diabetic ketoacidosis, and the other one was diabetic seizures. So starting with the seizures, of course, if you are skipping a meal, you're not going to take your insulin and sit back and think, okay, I took my insulin, but I'm not going to eat. I mean, that just sounds so silly to me and counterintuitive because I don't know any diabetics who are actually. So, and if there are, we need to teach them that they cannot take their insulin and decide I'm skipping the meal, but I've taken my breakfast insulin anyway. It just doesn't happen because now, I mean, the modern approach is actually to teach diabetics how to adjust their insulin dose based on what they're eating, right? So if you are eating nothing, you're going to adjust your insulin, your bolus or meal insulin dose to 0 because you have not eaten. So that makes sense. So as long as someone is doing that, then they should be safe. That's and put it out there. I thought, okay, if there's anyone, a single person who reads it and comes and joins my group, then at least we can compare notes. And now there are close to 1,000 people in my group. So intermittent fasting. So if you're skipping a meal, do not take your meal insulins, right? I mean, it's as simple as that. So we do not, if you're eating nutrient-dense foods, and good, decent portions of it, and you're meeting all your nutrient requirements, you don't need to eat 3 times a day. 2 meals can be sufficient. In fact, for some people, 1 meal can be sufficient as long as they are not under eating. So intermittent fasting, again, should be individualized, and it's not for everyone. Even some of my group members, I tell them, eat 3 meals. But I joined the group because of intermittent fasting. No, eat 3 meals. And you're already, even with 3 solid meals a day, you're already doing intermittent fasting of good 12 hours. So again, we have to individualize, and we have to know how to adjust our insulin doses, because that's important. So even the long-acting insulin, or if you're using a pump, your basal insulin might need reducing if you're skipping a meal or 2 meals, or if you're doing a whole day of fast. So you need to also be prepared to reduce your long-acting insulin dose. And to stay safe, you need to take your electrolytes. I mean, for type 1 diabetics, that's very, very important. I usually don't buy, in fact, I never have bought any electrolyte powders or whatever, because usually I don't like the flavors and they're very expensive. So I usually have salt and my magnesium, which I take daily, magnesium glycinate. But those two and real natural unrefined salt, which has the minerals, obviously contains some minerals, right? Natural minerals. I drink salted water when I'm fasting, and that's all I need. And as long as you have sufficient amount of insulin in your system, there is absolutely no risk of diabetic ketoacidosis. Ketoacidosis will actually happen when you lower your insulin so much that your body cannot maintain its normal function.
Right.
That's dangerous. The aim is not to, go to zero insulin. I'm sorry. That's myth. And I write about that so often in my group. Do not fear insulin. Insulin is what's keeping you alive. Even when you're fasting, you still need your insulin.
Yeah. So yeah, great advice, Nairi. And it's really inspiring to have people like you with really long-term diabetes who are thriving and setting good example for people who have just been diagnosed or their family or loved ones who are just not feeling great.
Yeah, really great insights, Nairi. I wanted to ask a few questions, but we are already near to the end.
Yeah,
So
we are already running out of time. So I would like to invite Shashikant Iyengar and Anup Singh to just come and end the session with us.
Nairi,
Hello,
hello. Thank you for coming in this conference and putting in your view, because very, very important. It's going to reach a lot of people in India. And I think your experience as a type 1 diabetic on Dr. Bernstein's protocol is very, very important, that it reaches the masses. So your two hosts, one of them is also your same community type 1 diabetic, and Jasmeet, of course, she also takes care of type 1 diabetic cases. So that's what we felt, that you three will gel together very well, and the conversation will lead to some important information coming in for others. So thank you very much.
Thank you.
And we'll see you in future events. We'll get back again. Thank you.
Thank you very much. Bye.
Please get in Dr. Parth and Priyanka.
Okay. Can you hear me?
Yes.
Yeah. Okay. Great. So hello and welcome to the Metabolic Health Conference 3.0. I'm Priyanka Matanhelia, a member and a certified metabolic health coach from DLife.in, India's first and the only award-winning low-carb platform. DLife was founded in 2014 by Anup Singh, a silver medalist from IIT Roorkee and the recipient of Icons of India Award. Anup is the pioneer of the low-carb movement in India, with his path-breaking protocol of 100-gram carbs per day max that made not only LCHF, but even type 2 diabetes reversal possible for Indian vegetarians. In 2021, DLife launched its diploma course, which is the only course in this segment approved by the NSDC partner, Government of India, and the only course with 144 hours CPT credit. Anup Singh and Shashikant Iyengar are the co-organizers of this Metabolic Health Conference. So for our session today, we will discuss the topic India as the diabetes world with Dr. Parth Samal. A brief intro to Dr. Samal. Dr. Samal is a practicing diabetologist who is also a metabolic health coach certified by DLife, author and a YouTuber based out of Jharsuguda, Orissa. It's great pleasure for me to talk to Dr. Samal, who actually both of us joined the course around the same time. And so we've participated in the community group and know a little bit about each other from before. So really looking forward to this discussion. So before we move further, I would like Dr. Samal to tell us what inspired your journey from a mainstream practicing doctor to acquire a certification in metabolic health coaching.
Okay, am I audible?
Yes.
Yeah. Thank you, Priyanka, for the sweet introduction. And I feel honored to be a part of this program. So now answering to your question, I come from a very strong medical background, right? Deeply influenced by the family legacy. Actually, my late mother was a doctor. My father is a retired physician, still giving his services whenever required. So I have grown up in an environment seeing patients, the pain and frustration a patient has to endure, listening to stories from a father about a patient's ordeal when he suffers from any kind of a life-threatening disease. So I always made it a point to take up a holistic approach in order to reduce the number of medications and of course its side effects. So through my practice, after a few years, I started observing that the medicines I'm prescribing for any kind of a lifestyle metabolic disorder, after some time, I needed to increase the dose of the medicines, the number of the medicines, right? So with this, I was also increasing the cost of the treatment. There are a lot of people. I have people from, I get patients from all walks of life. I have got patients from as a daily wage earner to night shift worker to businessman. So imagine those people who have a fixed source of income. And imagine that 1/3 of the income was going into the treatment. So that's painful, right? So whenever there is a patient who suffers from any kind of a metabolic disorder and with the complication, the cost of the treatment goes very high, right? I was determined to find a solution, to find out such a method of treatment, such a modality of treatment that will not only enhance my practice, but primarily, improve the health of the patient, improve the energy level of the patient, right? Lower the side effects from the medications, and of course, the cost of the treatment. So I did a lot of courses. I did naturotherapy, breathology, all the courses. And my search came to a turning point when I came across an ad on social media by Satyajit Das, a low-carb nutritionist, a wonderful coach, and he happens to be my mentor, my guru in the field of nutrition. I got immense knowledge, immense insights how to handle metabolic diseases from his course. Seeing my interest in nutrition, he suggested me to join D-Life. I joined D-Life, did the course, and I got an exposure to so much knowledge from the brilliant minds, from the brilliant professionals in D-Life. This led me to numerous successful stories where people have, stopped taking insulins, which they were on for past 10 years, 15 years, stopped diabetic medicines, thyroid medicines. I've seen reversal of fatty liver disease from grade 3 to grade 1. I've seen obesity, losing weight, obese people losing weight. So this was a wonderful, and this is how from a conventional doctor, I became a doctor and a metabolic health coach. So this was my journey.
Okay, very interesting. I must mention that Satyajit Das is also a D-Life member and a
D-Life
coach
member.
from
Yes.
D-Life. So yes, it's quite a quite interesting to see that not only people like us who have suffered from certain metabolic health issues, but doctors like you are also interested in taking this path and introducing your patients to low carb lifestyle. So Dr. Path, today there are an estimated over 220 million people in India who have diabetes. This amounts to about 1/4 of the world's total. So in your experience, what do you think is contributing to the rise of diabetes and other lifestyle diseases in India? And especially, if you could talk about your small town, Jharsuguda, because, even there, these cases are rising.
Yeah, absolutely. So, see, the rise of diabetes in India is multifactorial. The first one I would say is a change in the lifestyle and diet. So, if you see, since the past 3 decades, our food culture has changed, right? We have shifted from a whole food culture to a fast food culture.
Yes.
And the food environment we are living in does not match our biochemistry, right? So you'll see that the consumption of processed and ultra processed food has gone up. Processed food, no nutrition, nothing, only blank calories and preservatives that can only spike your blood sugar level, right? So the increase in the consumption of processed food in India and a place like Jharsuguda, where I stay, I've seen more patients in the past 10 decades who are suffering from autoimmune disease. The cases of allergy in children and adults has increased. Cases of diabetes and other lifestyle metabolic disorders has increased. Cases of gut problems has increased exponentially, right? Now, then the consumption of carbs, refined carbs, and sugar has increased. Consumption of unhealthy fat, that is refined oil, seed oil, has increased, which contains a lot of omega-6 fatty acids that is purely inflammatory in nature. And diabetes is a metabolic inflammatory disease. It adds on to the inflammation which already there in diabetes. The consumption of alcohol has increased. Consumption of sweetened beverages, soda, has increased in children. I see people, young children, buying, soda cans, the energy drink,
Right, yes.
So that kind of a culture has come up, and the consumption of healthy fat and protein has gone down. And I'm surprised that in India, 90% are protein deficient, and most of the people don't know that how much protein their body needs per day, right? So this is one of the things. Another reason I feel it is stress. Stress has immensely increased. And we already know the relationship between stress and metabolic disorder, stress and obesity, abdominal obesity, and the relationship between stress and addiction, right? The next I feel is sleep deprivation. Most of the patients whom I handle who are metabolically sick are sleep deprived. And I stay in a place which is an industrial belt, right? People do night shift works. So imagine a person who does night shift work on a regular basis or at least 15 days a month and having a metabolic disorder. It becomes challenging to manage that kind of a patient, right? Because whatever food, whatever diet you will prescribe, right? They cannot adhere to it because of the, erratic timings of work. And the most important thing, that circadian rhythm has gone for a toss, right? And the next reason I would say that we have stopped using our muscles. Nature has given us muscles to be used, right? And muscles being the 40 to 50% of a human body mass and stores around about 80% of sugar, whatever we eat. That's a big reservoir of fuel. We are not using it, right? So I say to my patients, see, muscles are the currency of longevity. The more the muscles you have, the longer you will live, right? So that thing has decreased, which is also, increasing the number of diabetes in India. And at my place, Jharsuguda, of course. The next I would say is genetics, of course. Yes, genetic studies has proven that South Asians, including Indians, have a higher propensity to accumulate fat around the abdomen. That makes them insulin resistant, because our ancestors, they have adapted to this technique of survival for the bad days when they were food deprived. When they were food deprived, the body has taken up this technique of survival to store fat in the abdomen, because the fat in the abdomen breaks down to fatty acids and gives energy faster, and has got a direct connection with the liver through the portal veins. So we have a term called TOFI, thin outside, fat inside. This was coined by Dr. Jimmy Bell from Imperial College of London. So this characterizes the way an average Indian male looks like, skinny outside and having a potted belly, right? So Indians are more predisposed to insulin resistance. And the next I would say is misinformation and, ignorance and
Yes.
misinformation. I see lots of videos on YouTube and podcasts on social media where people and celebrities, they talk about nutrition and health without a scientific base. I think half of the population in India, they don't know what is right and what is wrong and what is good for them and what is not.
Yes, I think that stresses the point that people need to talk to certified health coaches, like, or
Absolutely.
go to platforms like dlife.in where they can get genuine information, which is science, evidence-backed information from professionals, so that, these confusions can be cleared. And that is why
Clear.
we are having this Metabolic Health Conference. So, Dr. Path, very briefly, because, it is also reported that, I was reading that 50% of Indians who have diabetes are unaware of their condition. I think,
Right.
a lot of times people actually miss out that they are experiencing signs and symptoms of diabetes. So if you could briefly enumerate for our audience, what are the signs and symptoms people should look for when they have diabetes? To know that, okay, they might have diabetes.
Oh, okay. So basically what happens that diabetes, as we know, is a slow progressive process, right? It takes time. So initially you may not find any kind of symptom. Now, talking about signs, we see signs of insulin resistance. Like you may see dark patchy skin around the neck or on the forehead or on the cheek. We call it acanthosis nigricans. That's a sign of insulin resistance, which forms the basis of type 2 diabetes. You'll see skin tags around the necks. If any person who identifies this sign, it's high time he should connect to a very good nutritionist or a good doctor, educated doctor. Now, talking about the symptoms, the classical triad like frequent urination, increased in appetite, increase in thirst, these classical symptoms generally we don't see often, right? Most of the time, what we see is generalized weakness, fatigue, blurry vision, dizzy feeling, unexplained weight loss, frequent infections, non-healing wound, then tingling sensation, numbness, anesthesia on the feet and palms, infertility, erectile dysfunction, loss of hair in the extremities, legs and hands. So sometimes, most of the time, we see this kind of symptoms for diabetes.
So when, patients come to you with these symptoms, like you said, so what do you advise them to do? What kind of tests do you do? And how do you advise them to move forward? Because, as you said, that these symptoms are just for insulin resistance. They are not like full-blown diabetes. So at this stage, what do you advise them to do?
See, once seeing the patient, you know that he is metabolic sick or not. So before handling a case, I always go through the following tests. The first thing is the glucose panel, that is fasting blood sugar, that is 8 hours overnight fasting. Then the blood is taken to find out the sugar level. Then is the postprandial blood sugar, that is 2 hours post meal. Then you have HbA1c, glycosylated hemoglobin, which is done once in 3 months to find out the glycosylation of hemoglobin because of the sugar load. Then I recommend fasting insulin and C-peptide, which most of the doctors and nutritionists don't recommend. Now, why I do so? Because the fasting insulin, it tells you about the level of insulin resistance in the body. Right. So as I said, that insulin resistance forms the basis of type 2 diabetes. So finding out the level of insulin resistance is more important before, organizing a plan of treatment. Right. Then I do lipid panel. For some people, I do advanced lipid panel. As diabetes is a metabolic inflammatory disease, we need to see the inflammatory markers. right? The level of inflammation in the body. So ESR, HSCRP, and homocysteine levels has to be checked. Then diabetes is a disease which I think affects almost all the cells of the body, all the organs of the body. So there are some organ-specific tests like the liver function test, kidney function test, and almost all the diabetic patient or any person who is metabolically sick, I see a general trend of low vitamin D3 level and low vitamin B12 level. So these two vitamin test, I get it done. And of course, urine routine micro and an ECG if there is some comorbid conditions like high blood pressure since say more than 1 year, I do an ECG. And of course, if there are more comorbid conditions, if the patient had an attack or is suffering from angina or any kind of a heart problem like cardiomyopathy, I always send them for a complete cardiological evaluation before I can start a proper treatment.
Okay. I think this is very valuable because nowadays a lot of people, they say that they don't have diabetes, so they don't need to, go on a low carb diet, etc. And I think there's a lot of misinformation, as you pointed out earlier. So if you could also briefly explain, what are the different stages of diabetes? Because, insulin resistance is something people think it's normal. Like it is something that is normal with age, it's not something that is related to a metabolic dysfunction in the body. So if you could just briefly explain as to what is the stage and what stage insulin resistance is there and what needs to be done. And how do you basically tackle your own patients, if you could just throw light on that?
Okay, so basically we have 4 stages. The first stage is the onset of insulin resistance. This is the compensatory mechanism by the body. You won't find any symptoms at this stage, but if not taken care of, they quickly go into the next stage, that is the hyperinsulinemic stage, where the fasting insulin level goes up, right? Now, here what happens that the insulin level is high. You will find people are gaining weight. They are going into reactive hypoglycemia. Some patients I see fasting blood sugar is like below 70 or below 80, or postprandial blood sugar is below 100. So seeing such kind of a report, any doctor, nutritionist will say, okay, you need to have more food because the sugar is less. Now that's where the problem starts. We are putting that patient, by giving such an advice, we are increasing his insulin resistance, right? Because we haven't checked his fasting insulin, right? So this is the hyperinsulinemic stage. So some people may have a high blood pressure. Some people may have a high triglyceride level. And, such people, the people in this stage, I have observed they become very irritated when they feel hungry. And once fed, they feel lousy, lethargic, sleepy, right? So, okay, so this is the second stage. And in the second stage, if we don't take any step, that gradually takes us to the third step, that is the diabetes stage. Well, many authors say that that is pre-diabetes, diabetes, but frankly, in my experience, I've seen people who were pre-diabetic in just a matter of months, 3, 4, 5 months, I've seen them to become frank diabetes with the symptoms, right? So it doesn't take time transitioning from a pre-diabetic to a diabetic stage. So diabetes, you have all the symptoms. Now, what happens that at this stage, if the patient is prescribed medications that will increase the insulin level in order to control his sugar, and he is given that medication for a longer period of time, so slowly his beta cells will start getting exhausted. They will start making lesser insulin. So then comes the fourth stage, which is called the insulin dependent stage of type 2 diabetes. I have a lot of patients who are so much insulin dependent because they were treated with a drug, high dose of drug for years together. So they become insulin deficient, and I had to put them on insulin for some time. So these are the 4 stages of diabetes. And
I think I think you've explained it very well, because I think that also explains why the trained doctors also need to study metabolic diseases through a metabolic health approach, which is which we do here at D-Life. And as you know, when you were explaining pre-diabetes and diabetes, I was reminded of when I joined D-Life. Anup used to say that there is nothing called pre-diabetes. Either you have diabetes or you don't have diabetes. So I think that was a very good insight, because I think conventional doctors look at diseases in a very, very prescribed or very, jacketed manner in which they've been trained. But we need fresh thinking and fresh way of looking at these metabolic diseases so that we can tackle all the symptoms together. So that brings us to, I would like to know, what are the treatment options do you usually suggest to your patients? And how do you go about the treatment of, when they present themselves with these symptoms?
Okay, so any patient who is below 45 or 50 years of age, having an HbA1c of below 9, without any comorbid conditions, I never prescribe them any medications. I put them on a diet. I put them on a low carb diet just for 3 weeks, not more. And I tell them that, okay, let's retest your blood parameters after 3 weeks, after 21 days time. Once they do the retest, they see the improvement and they are convinced that yes, this diet is going to work for them. So you need to build the confidence whenever you're prescribing anything. Only then the diet will become sustainable. And if the patient is diabetic and has other comorbid conditions, then I will always do a thorough evaluation. I'll put them on medications if required, but with a low carb, healthy fat diet. Now, just yesterday, I had a patient, 60 years of age, with only hypertension, newly diagnosed diabetes 4 months back at our place. And I had given her a diet and told her to recheck after 21 days. But because of some reasons, circumstances, she could not turn up. And she comes to me after 3 or 4 months. Like, I didn't prescribe any medication apart from some supplements. Okay, but she took care of the diet. And then 3 or 4 months back, when she had come, the HbA1c level was around about 8.9. And after 3 months, when we retested, she was on 6.8% without any medications, only on diet, on low carb diet, right? So this is how I handle my patients.
So that's,
Yeah.
that's a great insight. Actually, I think you have planned some success stories to tell us as to how your patients have benefited from the low carb diet approach. So can you share some success stories? I'll put that.
Yeah. Please. So this is very close to me, because the first slide I want to show is that of a 31 years old lady, right? She was 84 kgs. I remember when I started her treatment, I had just joined D-Life, right? So it was just a few months, and so I was handling this case. So this lady was 84 kgs. She had come to me because she was newly diagnosed type 2 diabetes and hypertension. And she was undergoing a treatment for primary infertility because she was married for 8 years and she was unable to conceive and had PCOD. So the gynecologist said that, okay, you need to consult a good diabetologist. She came to me and we started her therapy. After 21 days, repeated the test, good improvement. And I told her, you have to continue this. I was there all through the 7-8 months when she was on low carb, did online consultation, hand holding, everything. After 7 months, she comes for a consultation and I'm unable to recognize her. From 84 kgs, she had dropped down to 63 kgs. And after 9 months on low carb, she conceived. And this year, 2025, she gave birth to a healthy baby weighing 2 kgs and 400 grams. Her HbA1c was 8.8. And now when we tested for the second time, it was 5.5. And the interesting thing is, all through her pregnancy, she didn't require any metformin or insulin, which we generally prescribe during the diabetes in a pregnancy. This is a beautiful, lovely family. This is a complete family. So this case is very close to me. Another case I want to share is of an 86-year-old lady who had a bouquet of conditions. She was type 2 diabetic. She had hypertension. Lipid panels were, totally distorted, hypothyroidism, fatty liver disease, cardiomyopathy, and of course bronchial asthma, which had shifted to COPD by now. So I started a treatment. I started a treatment, her HbA1c was 7.3% and very high insulin level, above 22 or something. And when we started her treatment, after 2 or 3 months, I stopped her insulin. After 5 to 6 months, we had stopped all her anti-diabetic medications and statins. By the end of our treatment, the HbA1c, which was 7.3, it had come down to 5.9 or something, 5.6, 5.9, yes, 5.9. And she is still without any medications. It's almost more than a year. And she celebrated her 87th birthday just a week back.
Wow.
And
that must be very satisfying. I can
absolutely.
see the picture, like she looks really happy with you. Okay. And I think
So
you have another case
another
study.
case, yes. This one is a type 2 diabetic patient. He is type 2 diabetic since 2010. He had sleep apnea problem and hypertension. When he came to me, his HbA1c level was 11.9. And I started him on low carb, rechecked after 3 weeks. Okay, he was doing well. So I told him, of course, there was regular consultation with this patient. And after 8 months, he had lost 11 kgs. His HbA1c had dropped to 5.7%. The last medicine which I had given was metformin 500 milligram, which I had stopped a couple of weeks back. So these are some of the cases which I had to handle.
Wow. That is really incredible. I think you've shown 3 different case studies of different age groups, different genders, different, lifestyle contexts. I think that will convince the audience that yes, low carb is not just for a particular section of people who are living in the metros, who have access to, very, high level, advanced level of groceries, etc. It's actually very much possible in the, Indian context, people
Absolutely.
living in small town India. So I think on that note, if you could, explain to us a little bit about how do you convince your patients to, follow the low carb diet? Like, what do you tell them, like how to design the diet and what kind of tips do you give them? What is the process?
Oh, yeah, great question. Before prescribing any kind of a diet, that goes in a lot of education, actually. I spend a lot of time with my patients. New patients mean I take around about 1 hour, 10 minutes in educating them. So the first thing they need to understand, I need to remove their ignorance. I need to clear their misinformation. So the first thing I explain them is about the macronutrients, the carbohydrate, fat, and protein. See, it's important to understand that we can live without carbs, but we cannot live without protein and fat. This is the first thing a patient should understand, right? So we have so much, we have so much become carb addicted that it is difficult for a lot of patients, because in my place, we eat a lot of carbs. A general thali looks like 50 to 70% of carbs, and with that, a lot of people taking a second serving of a rice or roti, right? So here it is very important to understand that carb is not essential as like protein. Protein, the building blocks of protein are amino acids. Now we have essential amino acids. Fats, the building blocks of fats are fatty acids. We have essential fatty acids, but we don't have an essential carbohydrate. So this is the first thing I put this information into my discussion with the patient. And talking about protein, I mean, people have lots of misinformation. Now, a lot of people think that dal is rich in protein. Now, Priyanka, if you take any kind of dal, which we use in Indian cuisine, take any kind of dal, 100 grams of any dal has approximately 20 to 25 grams of protein and 50 to 80 grams of carb. It is a carb-rich food. It is not protein-rich food.
Also, people cannot eat 100 grams of dal. I mean, it will lead to problems.
So then I talk about fat, then we have been over consuming the unhealthy fat, that is the refined oil, the seed oil, rich in omega-6 and inflammatory in nature. I shift them to a more healthier option like desi ghee, makhan, or virgin coconut oil. So a lot of education goes on into this with examples and all this till I feel the patient is not convinced with his diet. I keep on, working on that patient.
So in terms of protein, because I think protein is one of the very, there are a lot of myths, as you said, floating around, what kind of protein people should consume. So if not dal, what do you recommend to your patients? What kind of protein sources can they have?
So that basically depends upon what kind of a food they are following, what kind of a diet they are following. Are they vegetarian, non-vegetarian? I always see the cost and accessibility, whether they can get protein, they can buy the protein or not. And the next is what is the purpose? What do I want to achieve in this patient? And the parameters of the blood, all these things, on these basis, I decide how much gram of protein is required. So for vegetarian people, the best protein is the dairy protein. You have cheese, you have paneer, you have hung curd. And for non-vegetarians, yes, we have seafood, egg, fish, chicken, mutton, all this stuff. And egg being a complete protein, and anybody, you get it everywhere actually. So I always, tell people to have eggs if it comes to protein.
So when you talked about, another problem with protein, which Indians, as you talked about, cost and accessibility is an issue. And since you work in an area where, there are people from all walks of life, so how do you address this challenge when there are cost issues? I think you were telling me some stories. So
Yes. So see, I have got a patient who is type 1 diabetic. I could correct her, and they cannot afford a high class protein every day. It is understandable. And being a type 1 diabetic and a tribal, she couldn't afford insulin also. So generally, I do the test, the treatment free of cost, give her insulin free of cost. Now, what happened? We could correct the carb, but we could not correct the protein part. So I called her parents. We had an elaborate discussion about a food culture, what they used to have in veg, non-veg, and all. So the father tells that they sometimes have these snails, snail meat, and sometimes they have dry fish. Well, okay, that's good. It's rich in protein. You can have that. And believe me, when we really worked on this girl with type 1 diabetes, she was taking 64 or 65 units of insulin. Now she has dropped down to 22 to 23 units of insulin, right, through diet. So this is, I mean, like, see, whenever I want to prescribe a diet, I need to see everything. Not only the blood parameters, I need to see how comfortable it is. Do I need to make a drastic change, or I'll make it gradual, right? So a lot of factors matters when I prescribe a diet, actually.
I think this story really, tells us that, it shows us that, culturally we are, I mean, our food culture, our ancient food culture, our native food cultures are so, actually were quite low carb, as you said about snail meat and dried fish. I mean, they are getting eclipsed now with the onslaught of these
Snails are a delicacy in a lot of places.
Right. And with the onslaught of all these modern packaged food products. So I think we need to revive that, So that's a very, very interesting story. But as you said, that there are a lot of challenges when it comes to adoption of low carb.
Yes.
So if you could highlight some of the challenges that you face, like you explained one, but, what are other challenges that you face, and how do you address them when it comes to, low carb diet, adoption of low carb diet by your patients?
The first one we already discussed, that is misinformation and ignorance about diet. That needs proper education. The second I see is the fear of hypoglycemia. Imagine a patient on insulin and multiple anti-diabetic medications who has already experienced hypoglycemic episodes multiple times. He will never want to go into that episode again. So when I talk about low carbs, so they always are afraid of lowering their carbs because they might get into that kind of an episode, right? So I tell them that you need to check your blood sugar more often. It was not like till now, even a lot of people, they check their blood sugar once in 2 months or once in 3 months when they go to the doctor for consultation. So I explained them that you need to check it more frequently, and whenever it goes down, we will lower the dose of the insulin or we'll lower the dose of the medication so that you won't get into the hypoglycemic stage, right? So this needs a lot of hand-holding and education, right? The next challenge I would say is India is full of religious celebrations and festivals and celebrations all throughout the year. And our religious celebrations and festivals, they revolve around high carb diet and sweets, right?
Yes.
So it is difficult for people in this kind of a situation to adhere to the diet, right? The next thing I would say is the mental resistance, because at my place, as I said, that a normal thali looks like 15 to 70 grams of carbs. So if I tell them, okay, now you need to drastically cut your carbs by 1/4 of what you are eating, there will be a mental resistance. He cannot think of that kind of a diet. So that has to be gradual. So I need to surpass his mental resistance so that he accepts the food, right? To make it more sustainable, right? And it is important that whatever diet we prescribe, it has to be sustainable. Otherwise, there is no point. The next challenge I face is the family support. See, if you are treating any kind of a metabolic disorder case, it's not a one-man show. It's a team effort. It's a team effort between the doctor, the patient, and the family members who support him. So whenever I consult any patient, I always ask them to come with their family members. Otherwise, I don't give a consultation. I make it a point to talk to their family members so that they are also educated with the patient. Only then I know that, okay, this diet I'm prescribing will be sustainable, right? The last thing, of course, yes, cost and accessibility. I told about one, cost and accessibility. I need to see that whether they can afford what I'm prescribing it or not. Otherwise, there is no point. And one more thing I would like to add here. As I said, I live in a place where it's an industrial belt, and lot of people do night shift work, right? Now, people who are into night shift works, it is difficult for them to adhere to a diet, to follow a diet properly. And with that, it is more difficult to manage their blood sugar because they have got erratic work schedule, right? Their circadian rhythm is totally distorted. So yes, this is challenging, but sometimes I see just making just few adjustment in the diet also gives wonderful results.
Okay, so I think we are almost nearing our time. We have some 3-4 minutes left. So towards the end, what I would like to ask you is, as we know across the world, especially I was reading in the UK, they have approved low carb nutrition approach as one of the line of treatments for diabetes. So in India, how do you see the role of low carb evolving? How should it evolve to, because see, in a small town, like you said, as a doctor, it has become very challenging because it requires a lot of intensive effort to educate the patients. But, doctors in bigger cities cannot do that. So how do you see, how can we create, this sort of treatment ecosystem for patients and in the healthcare system to address this, the rising incidence of metabolic diseases?
Yeah, see, the thing is, I remember what Dr. Robert Lustig said in one of his interviews. See, if you want to fix the healthcare system, you need to fix the health first. If you want to fix the health, you need to fix the diet first. And if you want to fix the diet, you need to find out what problem is lying down in the diet, right? So doctors don't have so much time discussing all these things about nutrition because we are not prepared like that. We didn't have a completely different subject for about nutrition. So most of the doctors, they don't have time for that. And that's the, treatment lapse, I say. The nutrition part is totally, completely not taken care of. So if we can collaborate the present healthcare system with a nutritionist, a low carb nutritionist, I think we are going to do justice to the people, to justice to the treatment we are giving. So although low carb nutrition is scientifically based, low carb nutrition can regulate your sugar, can regulate your insulin, can regulate your weight, can lower your inflammatory markers, can postpone or prevent a complication from a disease. And I would say the low carb community, the DLife community, you see thousands and thousands of successful cases who have been reversed or put into remission, right? So these numbers speak a lot about what DLife nutritionists are doing for the world.
Exactly. I think you summed it up very well, that we need to create an ecosystem along with the, taking along, the mainstream healthcare professionals like doctors, trained nurses who are in the mainstream practice, and also, this new breed of metabolic health coaches who can partner with them and then create communities like, DLife, small chapters of DLife everywhere where, patients
True.
can find support.
Agreed.
And they can get knowledge, proper knowledge. So I think with this, I would like to invite Shashikant Iyengar and Anup Singh to end the session. And hi, Shashi. Yeah,
Hello, Dr. Path. Thank you. Thank you, and thank you for coming and sharing your knowledge. And I think it makes a very big impact. And especially since you're from small town, you're bound to give a lot of very practical solution for many of us who probably cannot, where they will keep the affordability in mind. And we are seeing a lot of small tips you are given, and it's going to benefit the public at large. Not only those who are seeing the live stream today, but also probably in the future, when they see the recording, they're going to benefit greatly from a practical experience. So thank you very much, and we will meet again.
Thank you, sir. Thank you, sir. Thank you so much.
Please get Valerie in and Ira. Valerie, you have to put on the camera and unmute. Welcome, Valerie.
Okay, here I am.
Hi, Valerie. You're looking so
Hi,
good.
Ira. Thank you. You do too.
Yeah, thank you. So let's jump right into the session, and I want people to hear Valerie's amazing story. I'll quickly run through the introduction and then we can begin. Hi, I'm Ira Sahai, the Chief Operating Officer of DLife Healthcare Private Limited, a very proud DLife certified metabolic health coach and the lead host of the third Metabolic Health Conference organized from India by Shashikant Iyengar and Anup Singh. DLife is India's first and the only award-winning low-carb platform, founded in 2014 by Anup Singh, a silver medalist from India's Ivy League institution, IIT Roorkee. Anup is also the recipient of the Icons of India Award, and he pioneered the low-carb movement in India with his path-breaking protocol of 100-gram carbs per day max, which is now widely used. And this was back in 2012. That made not only LCHF but also type 2 diabetes remission possible for even Indian vegetarians. So, Valerie, let me just introduce you, and probably we'll talk more about, the conditions that you had. Valerie Smith is a metabolic health coach. She used a ketogenic carnivore diet to put lifelong schizophrenia into remission in 2018. Along with it, healing many other illnesses. You will be surprised, shocked, and very, very delighted, to know what Valerie has achieved, by going carnivore. So we'll talk about this and more. She uses those same dietary strategies with her clients to guide them into health and freedom from mental and physical illnesses. She focuses on a low carbohydrate lifestyle combined with fasting and strength training as the trifecta of vibrant health. Valerie is featured in the Journal of Metabolic Health case series titled Animal-Based Ketogenic Diet puts her severe anorexia into multi-year remission. And just before we start asking Valerie her story and the questions, here's a list of illnesses and issues that Valerie had. Schizophrenia, extreme anorexia, anxiety, panic attacks, clinical depression, hypothyroidism, osteoporosis, bone pain, fractures, IBS, GERD, severe vaginal atrophy, bladder pain, spasm, overactive bladder, oxalate toxicity, adrenal fatigue, hormonal deficiencies, tinnitus, and more. Valerie, wow, what a story you have. Would you want to add something in case I missed it? I mean, I was shocked to see the list of things that, you when you gave it to me, it was a shocker for me. So tell us, Valerie, first of all, welcome. And you have an amazing, amazing story. You recovered. God bless you and all the best. But please take us to the time, maybe in January 2018, when you had all those conditions that you were battling with. What was life back then with severe depression and all of these conditions?
Thank you. Yeah, it's amazing to be here. I'm just honored to be able to speak to you and speak to everyone watching the conference. Yes, the list of what has healed is long. 6 mental illnesses and about 15 or 20 physical illnesses, depending on how detailed you want to get with symptoms. I've been ill as far back as I can remember. I don't have any memories of being physically or mentally ill. It goes all the way back to when I was 3 years old and the anxiety and the depression started. So I lived a lifetime of just not being well. And in 2018, that would have made me 48. And I was at the end again. I mean, I'd been at the end, I'd been at rock bottom many, many times over the course of all these decades. And I somehow would pick myself up and try again, find a new doctor, find a new medication, find a new psychiatrist, find a new inpatient facility. And at that point, at 48 in 2018, my life was just, it was unlivable. It was just filled with pain. Mentally, I was plagued 24 hours a day with schizophrenia. I had these screaming, dark, violent voices that screamed for me to harm others and to harm myself. And in order for me to not harm others, I turned that punishment, that harm on myself. And that was where the cutting and the hair pulling began. I was punishing myself by cutting my arms and legs to keep myself from following what the voices wanted me to do. And of course, part of that was the extreme anorexia. That was part of the self-punishment. That was the drive to starve, the body dysmorphia I experienced when I looked in the mirror. I saw someone very obese. There's just a separate mental illness component of the brain that pulls up all of these anorexia symptoms. And I had OCD and, of course, anxiety and depression. You don't go through that kind of mental anguish and not be filled with anxiety and panic attacks and just an overarching sense of doom and depression all the time. I was once again at that year 75 pounds, and I'm 5'9". I was very skeletal, to say the least, and I was in jeopardy of losing my life. My heart had shrunk half its size because I had no musculature left on my body, in my body, and mentally I was just beyond what I thought was repair. And physically, that was the end of 4 decades of malnutrition, of starvation. And physically, I was in ruins. I had been diagnosed with osteoporosis at 16. And by the time I was 48, I had such chronic bone pain all of the time. And I was then experiencing fractures. I had 5 fractures within 5 years. And I wasn't doing anything traumatic. It was just everyday life. And I would fracture a bone. Physically, I had hypothyroid and I had all kinds of gastric, GI distress issues, IBS, all kinds of female physical pain that I now know were high oxalate vegetables and combined with no fat and no animal protein many decades. That's what on these pelvic female disorders that doctors said were incurable. I was just physically and mentally just gone. And I knew I wasn't going to last another year. I began desperately trying to search for something different to try, or I was going to give up. There wasn't anything left to try.
Now, Valerie, I'm very curious to know, before you came onto the carnivore diet, what was your typical diet like?
It was the lowest calorie that I could possibly get away with. Every decade I eliminated something. In my teen years, the first things to go were protein and fat. So that was the huge macronutrients that I eliminated first, that I did the longest without. Not an egg, not a piece of chicken, nothing. And nothing with fat, no oil, no butter, nothing. So for many decades, I subsisted on fruits and vegetables and carbs. And as I progressively got worse, and in the times when I was in active starvation and not under treatment that pushed a plant-based carb diet with a lot of convenience foods to prove that I wasn't anorexic anymore, canola oil and inflammatory, processed carbs, when it was on my own, it was spinach and celery and nothing else. And on a day, maybe I would allow myself to eat a potato. And if I felt that I ate too much, the next day I wouldn't eat anything at all. It was less than 300 calories. And every day I tried to go lower. And at this point in 2018, I was down to a cup of spinach and a cup of celery. That's all I was eating every day.
Yeah, but Valerie, did you realize what you're doing, in terms of diet and the repercussion it was having on your own body? Were you conscious of that? And, what do you think propelled you to do this?
I was well aware of what was happening, but when you have mental illness, in terms of schizophrenia, when the voices are screaming at you that the food is going to poison you, or that someone is going to harm you, the need or the want to eat is gone. And then you pile onto that the anorexia, which is a whole separate issue in itself. When I looked in the mirror, I saw someone who was very obese, even though I knew that I wasn't. And the drive to starve, drive to over-exercise, the drive to just punish myself. And the goal was to not be here anymore. The actual goal was I felt like I deserved to die. And this was my slow way of suicide. I mean, I didn't ever plan to end my life, but the overdriving force behind anorexia is the self-hate, and cannot get away from it. It is not something that you can, traditional treatment, it's not something that you can turn off. And it's not something that you, when you're following what they say they want you to eat to prove that you're not anorexic anymore, and you put on a little bit of weight, it's always with ultra-processed carbs. And that just drives the brain inflammation higher. I didn't know it then. I know it now. I knew what I was doing. I knew that I didn't want to be sick anymore, but I had no idea how to pull myself out of this cycle. I expected doctors to advise me. I expected doctors to help me, to show me the way out of this. And that never came.
Pardon me, Valerie, I think I'm going to cry listening to your story. I'm already in tears and I have no words for what you've gone through. It's very emotional for me. But Valerie, just tell me before we jump on to, I'm so sorry, before we get on to the carnivore diet and the healing parts that you saw, what was, how were people around you behaving with you and how were they assessing your situation? Was nobody trying to help you out? I mean, you of course approached the doctors, but what about the family? How about the community? How were they seeing you? What were they doing for you?
I was not living in a hole. No, I was not isolated. I had advocates for me. I had family around me. As a teenager, my mom was in my corner fighting for me every single day. My grandparents were fighting for me every single day. In my 20s, my husband desperately wanted me and supported any help that I could find. If I needed to drive an hour away to see a new psychiatrist that promised that he could help me, that promised that he could find a medication that would lessen my symptoms, he was fully supportive. Go do whatever you need to do. You know, whatever we need to do to get you well. I had support. I was hospitalized 7 times in 15 years in all sorts of facilities and hospitals that were mental illness and anorexia and some for physical surgery. And they knew from looking at me and from my health what my state of health was in. And so I was actively seeking help all of these years. Nothing ever helped.
Thank you so much for sharing that horrifying, I would say, story, Valerie, and therefore we can justify the win that you found finally. You were struggling for at the till the age of 48. By 48, I think you had lost hope. You know, what was it that made you finally, given all those voices that were going inside you, how did you overcome that and to finally get onto a carnivore diet and, try to at least change your life, to begin with? How did that thought come?
Well, you know, the definition of insanity is doing the same thing over and over again and expecting a different result. And at this point, I knew that this was not working and it was never going to work. You know, every psychiatrist that I had a relationship with always started with, okay, we're going to get you better. We're going to talk about your childhood. You're going to take this combination of 3 or 4 antipsychotic meds, and you're going to feel better and you're going to get your life back. And over the course of months that I would see them, their message would change. And at the end, they would say, you're going to have to accept that this is who you are. You have intractable mental illness and there's nothing that we can do for you. And then I would, not go back to that one. I would do things on my own a little while, get work, relapse, get worse, and then try again. So this cycle just went on over and over and over again, year after year after year. And I knew that this was never going to produce a different result. So I started looking online, and I knew it had to be something with my brain because I'd been weight restored several times within there. And the lie that traditional treatment for anorexia tells you is that once you get your weight up, you won't be anorexic anymore. You'll be free from it. Well, yeah, you need to gain weight, of course, but gaining weight on their food plan, which is when it's the liquid nutrition, it's canola oil, high fructose corn syrup, and soy, which is what's put in a feeding tube, what I had when I would go inpatient. And then they transition you to a tray of food and send you home with a meal plan. And it's all muffed cakes, bagels, pancakes, always plant-based, no animal protein, no fat. And of course, I never got better. I would gain a few pounds, I would weigh more, but nothing ever changed mentally. So I quickly relapsed. Nothing had changed inside my brain. So I knew there was something wrong in my brain. And so when I started looking online about, what does our brain need to function right in terms of supplements? At that point, I was ready to take handfuls of supplements. I wasn't ready to eat food, but I wanted to find out what am I missing? Is there some way that I could be even 10% better than what I am now? And that's when I found Dr. Georgia Eid, Dr. Chris Palmer, who are both metabolic psychiatrists. And then along the way, I found Dr. Ken Berry and Dr. Sean Baker. Combining that information, that knowledge, I began to understand that the mitochondria in our body, the inflammation in our body, the metabolic brain dysfunction that happens is because we have over 100 neurotransmitters in our brain. And in order for those to produce, in order for those to function optimally, they have to have the building blocks of the amino acids that make those neurotransmitters. For instance, the neurotransmitter acetylcholine, you have to eat things with choline in it in order for your brain to make acetylcholine. Well, what's high in choline? Meat, pork, bacon, all of these animal foods that I had not consumed decades. And as I continued to learn and research and start to put these pieces of puzzle together, it seemed too simple. But at the same time, these were the same foods that I had not eaten since I was a teenager. And could this possibly, I'm like, there's no way that this could make a difference in how I feel. All these doctors, all these world-class doctors that I've seen are all saying it doesn't matter what you eat. A plant-based diet is the best thing for you, the best heart health, cholesterol lowering diet. And the only thing that's going to help your brain is to take these meds. Whatever you eat does not affect your brain. And I believe that. I believed that for many, many decades. And of course, I don't believe it now. So I was armed with knowledge, but the conundrum was, because of the anorexia, how do I implement this? How do I, I wasn't trading one plate of food for another plate of food. I wasn't eating whole meals. I was forcing myself to eat this cup of spinach, which I still felt like I didn't deserve. So I had to figure out a way to do this. And so it took me longer to heal than most people. Most people have mental health benefits way sooner than what I experienced because of the anorexia. It took me 8 weeks to be able to eat 8 ounces of meat because I had to literally one bite a day. That's all I could eat was one bite. And then I promised myself that if I could do that for a week, I would double it to 2 bites. And then on the 3rd week, I doubled it again. It took me a long time to get to a point where it was even considered a normal serving of meat. And so, when I talk to others, I tell them don't base their healing time frame. Healing does take time, but unless you're dealing with severe anorexia, where you literally cannot eat a full meal, if you are able to, you are going to heal faster. You're going to notice positive changes sooner than what I experienced. But thankfully, I didn't put myself on a time frame. It wasn't like, oh, I'm going to do this for 30 days or I'm going to do this for 90 days. I didn't have anything left to try. I didn't have left to go back to. I didn't have a life back to or a way of eating back to this was it. I was going to do this until and when it either helped me or I perished. I didn't have anything left to try. So that's what got me started doing this.
Yeah, amazing, amazing. Before I ask Valerie, the levels at which she has healed and the conditions which she has healed, Valerie, go back to the time when you were seeing and changing doctors after doctors. How do you see the normal standard treatment that the doctors were giving you, the psychiatrists? What do you see was wrong in that? Now that you've healed, you've come a long way. Going back, what is wrong with the way, they were handling a case like yours?
Traditional psychiatry failed me. Longest time, for most of my life, I always felt failure, that there was something wrong in me that wasn't doing things right, or that there had to be a flaw in me. And I now know that it wasn't me. It was the way that they were treating my illness. That's all they would do is talk therapy and dispense medications. That's all it was. And when I was inpatient, of course, that was when they would control what I was consuming, whether it be a feeding tube or of food. And that traditional protocol they have in place is that all foods fit. When you have an eating disorder, you prove that you don't have an eating disorder eating pizza and cake, and that's the only way that you can get over eating disorder is by eating these highly processed modern foods that, of course, when you're anorexic, you think of them as foods. So that's why those were the ones that they would say you have to eat. If you can eat the cake and the pie and eat it without and get over your fear, then you would be well. Of course, traditional talk therapy is good. I'm not saying that it's bad. It's a necessary component. If you have lived through childhood trauma, if you have lived through any kind of physical, sexual, emotional abuse, you do need to talk through. The problem with that is I did have issues that I needed to talk through, but I was so malnutritioned that I couldn't take new information in order to process these bad memories and lay them to rest. That takes something that they call neuroplasticity, where you have the nutrition so that you can take in new information, you can process these old memories, learn to deal with them in a different way, and come out of it on the other side, and a mental healthy attitude about those memories. And that component is not there. You spend hour after hour after hour rehashing your childhood memories, and it won't go anywhere. There's no resolution because you're so ill. Your brain is not functioning optimally because of your lack of nutrition, that you process even the talk therapy to get to a place of resolvement or healing. And then the whole other issue of the psych meds, on 3 or 4 at a time, and then they would pull out and put a new one in and adjust the dose and take one out and put another one in. Over the course of 30 years, I was on 15 different ones. Ones for the schizophrenia that were supposed to lower the volume of the voices. Several SSRIs, of course, for depression. Sedatives for anxiety and panic attacks. Some that were targeted specifically for obsessive compulsive disorder. None of them ever reduced my symptoms at all. All I experienced from them was bad side effects. And when I asked to go off of them, to have help tapering off, they would refuse. So that was something that I had to do on my own also. I had to figure a tapering schedule. The last 3 that I was on about a decade ago, and because I was functioning worse on them than I was off of them. I was a zombie. I was already losing touch with reality because of the schizophrenia, because I was going into these paranoid delusions. And the medication on top of that, I would just be in bed or on the couch, would just be sedated. I would just be a zombie of somebody who hears voices. It was just bad side effects and other side effects too, but the sedation was the worst.
Yeah, Valerie, let's come to the second part of your story, and which I want more and more people to hear. Once you came onto the carnivore diet, how did the changes start coming? What did you feel? How did you feel better? What were the first signs that you noticed that this is something that you want to or continue doing? Or is helping you?
Like I said, it took me longer to notice that I was getting better. So at about 3 months in, when I was finally able to eat about 8 ounces of meat, for the first time, I felt like my anxiety and depression was lowering. And so I just kept going. I paid attention to how I felt. My family around me was starting to notice a little bit of, I wasn't quite as anxious, and I was smiling a little bit more, not quite as much tearful, because I couldn't go a day with crying. And at the 6 month mark, 6 months in, when I was eating even more, that was I knew, even if I had not gotten any better than what I experienced at 6 months, it was going to be worth it. That was the first time since I was 8 years old that the schizophrenic voices quieted. They felt like they were in another room with the door closed. They were still there, but they muffled. They were like I had earmuffs on, or they were, in another room with the door closed. I had never, ever experienced a reduction in that. And so because that was more quiet, the drive to punish myself so lessened. So the daily episodes of cutting my arms and legs, I didn't need to do that anymore. That severe component of OCD, which is also a neurological disorder, was being healed by what I was eating and by the plants that I had removed from my diet. I mean, using carnivore as an elimination to really understand what foods make me feel like, which foods heal me and which foods negatively affect me. It's an absolutely amazing way to discover for each unique person what helps and what harms. Because there's plenty of people that can eat low carb vegetables with no problem. But I did damage to myself because of them. So I had to figure that out. So more happened another 3 months in. At 9 months, my anxiety and depression were markedly lower. I was feeling joy. What used to be gray and sadness was now in full living color. I used to look at a sunrise and a sunset. I used to look at holidays and Christmas lights and New Year's. That was sadness for me. That was all dark. And it was almost like I couldn't see color. I couldn't experience color. Everything was dark and gray and sad. And now at the 9 month mark, and then at 1 year in, 8 years ago, everything is vibrant. Everything is full of color. Everything is brand new. It's like rising from the ashes. And
like a phoenix. Valerie, you deserve to be called a phoenix. You have risen from the ashes. In fact, I was going to ask you, you mentioned that your brain healed even before you gain the weight. And, so much
Yeah.
of difference made just with the carnivore diet. And Valerie's narrating, how she had, started seeing improvements after improvements, down the months. So, Valerie, continue with this and, in short, probably so that we can put in more questions to you regarding the skepticism coming from doctors and everybody. So just take us through the journey of how you started seeing the colors and the life back again.
Yeah, it's just been absolutely amazing. And I bring up that point in most of my interviews about healing my brain, but it didn't involve weight gain yet. And the reason I bring that up is just for the anorexia component. That part about gaining weight yet is not significant for schizophrenia, for OCD, for anxiety and depression. I bring that up specifically for anorexia because that is the protocol. They say the traditional treatment is that you will be better when you are weight restored. And that is not true. And like I said before, it is critical that I gained weight. I had a BMI of 11. I was not going to last much longer. I was not going to live. But the mental illness has to be healed first. And the reason that is that there are so many components in anorexia that you'll just relapse at the drop of a hat. If your brain has not healed and you're seeing on your body and in a mirror, you're feeling these feelings about feeling not worthy of eating, or certain feelings that you have about what's going to happen to your body if you eat this food, combining that with what you see when you look in the mirror, that has to be healed, because that in a sense breaks the chain, breaks the cycle of gain a little weight, relapse, gain a little weight, relapse, because the mental illness anorexia has not been healed. So I make that distinction at that 1 year mark, and everything was gone. I had not gained any weight yet. Years 2 and 3, I effortlessly gained weight. I never experienced another relapse. The body dysmorphia was gone. I could look in the mirror and see what I looked like and be able to agree with everyone else. I have to fix this. I have to eat. I have to put weight on and get to a healthy weight and resculpt my body and redo my body composition and put on muscle. And doing it after the mental illness is healed is a way to do it effortlessly, because there's no chance of relapse. The mental illness is gone. I just was able to just pull my meals and just eat more. And as the weight came on, it was something that was welcomed. It wasn't something that I was fighting against. It was what I had done for 48 years. When a few pounds had come on, I felt disgusted with myself, and I couldn't to starve and back off, or go do 4 hours of cardio, or go on the elliptical machine, or go run in order to burn those calories off. Nothing had changed. And so that's what is amazing about this is healing, and then being able to go on and heal the physical issues and not slip back into any problems.
Amazing. Valerie, what is your typical diet now, right now? I mean, what are you eating these days? Of course, you're feeling wonderful and you're looking absolutely smashing, but please let us know, what are you eating these days to be looking so smashing?
I eat a lot. I have some guys that follow me on social media, and I eat more than that, but I have a fast metabolism. So if I eat less than what I'm eating, I lose weight, and I don't want that. I eat 2 meals a day, and I enjoy intermittent fasting. I like how I feel in a fasted state for extended period of the day. So I eat 2 large meals in a shorter kind of window in the evening, and I spend the rest of my day in a fasted state, and I have lots of energy and lots of joy. And then within 2 meals, I prioritize a lot of beef. I eat a lot of beef roast, ground beef, steak, all kinds of cuts of beef. I eat some fish. I eat eggs now. I had to heal 6 years of egg intolerance, and I can only eat eggs now. So eggs are a daily part of my diet. And I do eat some other meats in there, but it's, I eat some chicken, some pork. I'm hungry for it, but it's not a daily occurrence. So most of what I eat is beef and eggs, and it ends up being about 3 pounds, about 1.5 pounds at each meal.
Yeah, and some people may say that your recovery is just anecdotal, but what would you say to the skeptics, the doctors, or the people around you who would say that? And how do they see you now? Can they believe the transformation?
Yeah, I've gone back and done that. My family have been overjoyed to see, what has happened. The skeptics, we all know that what we eat, our diet, affects our internal organs. It's widely accepted that what you eat affects your heart, your liver, your lungs, your kidneys. Why is the brain any different? We treat the brain as if it is separate from our body, and that what we eat doesn't affect the brain. Our brain is just another organ. It is the same as when you eat sugar and it harms your liver. The same thing happens to your brain, and the same thing happens with seed oils and all of these other components that harm other internal organs. It's doing the same thing to our brain. Our brain is just another organ in our body. So it's not anecdotal. All of us, you included, who have used this diet to heal, we are anecdotes, but we are data. We are data that's being compiled into thousands and thousands of people. We're no longer anecdotes. We're the real world data that is showing what the power of nutrition can do. Going back to my doctors, that was a trip. That was they were condescending, very, very condescending, and hostile. And the ones that I went back to, finally quit going back to them, because I thought that they would be curious. I thought that they would, even if they don't agree with how I did it, wouldn't you want to know that someone is much better, that's completely healed, and maybe I can look into it. Other clients, I naively thought that maybe some of them would be curious, but I got one of 3 messages, and it's hilarious when you hear what I'm about to say. One of them would say, "You're only experiencing a placebo effect, and you're going to have a psychotic break, and you need to get back on medication. It's just a placebo effect."
Yeah.
And then I had a couple of doctors tell me that the carnivore diet is only masking your symptoms, that you need to get back where real doctors are going to help you. Like, masking my symptoms, it's been 8 years.
Yeah, and the real diet that got you here in the first place, and you had been eating that all around,
Yeah. And then the third response is the regular, portion of the big pharma doctors that just say, "Oh, carnivore is unhealthy, and all that red meat and all that fat, you're going to get heart disease, and you're going to," yeah. So I would get one of those 3 responses from it didn't matter whether it was a primary care physician, a psychiatrist, a registered dietitian. They all had one of those messages to give me, and it was not it was not productive going back.
I'm so glad you're able to laugh about it now, Valerie. I mean, even you mentioned my story, and I had gone through this, the same way. Uh, the spirit of scientific inquiry, I think, is not there. It's absent because even though they may not use the same diet or they may not even try it on their patients, but the curiosity to know what you did that got you here in the first place, that's absolutely absent, and which is very, very sad. So, Valerie, one last question. What is the message that you would want to give to so many people who are struggling with mental illnesses? Yours, of course, was very, very serious, and varying degree to which people are experiencing these symptoms. What is your message to them?
My message is, it's estimated that there are 1 billion people struggling with mental health issues. And of those, 20 million have schizophrenia. And anorexia holds the highest mortality rate of all psychiatric illnesses. So I look at that conglomeration of suffering. They deserve real help. They deserve real treatment. They deserve to be well. And I'm just amazed. I'm still amazed every day that I had lifelong schizophrenia and now I don't. and I could be angry, but I went through a period where I was angry at the lack of medical care, at the lack of how I could have been better decades ago if someone would have shown me, the way, shown me about nutrition, about healing this on my own. But I decided anger wasn't going to get me anywhere. I can be bitter or I can choose to be better. And I'm not going to be able to be a voice for anyone else and anyone if I'm not allowing myself to be filled with the overflowing joy that I have in order to draw people to me so that I can share with them that you can be healed physically, mentally, no matter how long you have been ill. I always tell people that there is no one that's beyond hope. There is no one too far gone. There isn't. I wasn't sick for a year or two. I was sick for 48 years. And if in 12 short months, a year, all of that is washed away and I have a brand new life, that year is nothing. That's a short amount of time to rise from the ashes. And sufferers deserve to have that message. And if it's not going to come from the top down, then each of us needs to reach someone.
Yeah. And Shashi and Anupa here, Valerie, to say hi to you and thank you, of course.
Valerie.
Hello, Valerie. Yeah, hello, Valerie. If you remember, we were planning a podcast. Yeah, we were planning a podcast with you, but after going through your entire history, we thought better platform would be this session. And before I hand it over to Shashi, I would like to make 3 points, 3 important points. You said, psychiatry failed you, right? Now, if you look up the data for top 3 recipients of pharma bribe, there's a site called dollarfordoctors.propublica.org. Top 3 are in top 10, 3 are psychiatrists. That is point number 1. Then, all I can say is that pill-driven protocol is pathetically insensitive to what a patient goes through. Your case has been an anecdote defined as one. You were threatened. I mean, you scared with all, you will land back into same situation again. 14 years back, when I said I am going low carb, I was told I will die of multiple organ failure. So this system is pathetically corrupt. That is all I want to say. Thank you, and thank you for coming. Many of our, teammates were listening to your story with wet eyes.
I'm absolutely honored to be here. I'm so thankful that you asked me to come. It's just been an honor to be here.
Thank you, Valerie. Thank you.
Thank you.
Please get Dr. Rob inside.
Hi there.
Dr. Cyrus.
Hello, good to be
Welcome.
here.
Welcome, welcome.
Can you hear me
Yeah,
okay?
yeah. Yeah, we can hear
Good.
you okay. We can read your T-shirt also. And I think
I've got
I
to put
will
that
first
out there.
say that welcome to the land of carbohydrates. Welcome to India.
Thank you very much. I think it's the planet of carbohydrates. If you want to get away from carbohydrates, you better book a flight on Elon Musk's flight to Mars because they're everywhere. It's ubiquitous. But first of all, thank you so much. I'm honored to be part of this incredible lineup that you guys have assembled. Thank you very much. One very, very important point that we need to make a distinction, especially because we're somewhat evangelical about where we are, and yet there's a lot of skeptics. As Anup said, he was told he was going to die if he ate carbohydrates. So one of the key things is that we exist as a species because of carbohydrates. They have sustained us through hardship. They have sustained us through troubled times when we had food scarcity. And in India, you've got this polarization of some folks who are still struggling to survive and don't have adequate food, and then others who live in an era of unprecedented abundance. The issue is not carbohydrates. Carbohydrates do not cause harm. Our relationship with carbohydrates does. And it's such a crucial thing not to demonize carbohydrates as a food source, but when carbohydrates transition across in our relationship with them, that we use them for emotion management rather than for nutritional management. That is where harm begins to happen. So we really have to quantify, and in the ketogenic space, we often demonize carbohydrates. No, 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 no. It's our relationship with them that's the problem.
Very nice, very nice. I think that was a very good prelude, and I'll take few minutes in the introduction. I think everyone deserves to know much more about you. And first, I will have a brief introduction about D-Life. So I'm Shashi, a metabolic health coach from D-Life, India's first and only award-winning low-carb platform. And of course, it was founded in 2014 by Anup Singh, who is from IIT Roorkee, and that was silver medalist and Icons of India awardee. And he also pioneered the low carb movement in India. Anup is known for his groundbreaking 100 grams of carbs per day max protocol made in 2012 to make low carb very, very easy in India, especially for type 2 diabetes management and especially for vegetarians. So in 2020, he launched D-Life Diploma course, the only NSCD partnered diploma course which is recognized and has the world's largest 144 CPD hours. So of course, everyone knows that me and Anup, we co-organized this historic conferences, Metabolic Health Conference 1, 2, and this 3. So Dr. Saivis is a bariatric surgeon. So many of you will be surprised to know that he's actually a bariatric surgeon and a dual board certified specialist in metabolic health, obesity, diabetes, and carbohydrate addiction, currently practicing in Florida, USA. With the expertise of both pediatric and adult metabolic disorders, he has pioneered the carbohydrate insulin model for obesity and diabetes, CIMOD, and has developed a clinical metabolic health program focused on TCR, therapeutic carbohydrate restriction, and behavioral model transformation, which he has just mentioned. So he holds a medical degree from the University of Cape Town, completed his surgical training in Toronto and Michigan, and earned the PhD in liver metabolism and vascular inflammation. He is a global speaker, and we all know that, and chronic disease, insulin resistance, and carbohydrate addiction, emphasizing substance abuse methodology over traditional diet. He is also founding member of SMHP, and he continues to lead in the metabolic and obesity care. He recently co-authored several chapters in ketogenic textbook, The Science of TCR. He has also earned a Center of Excellence designation from Surgical Review Corporation. So once again, Dr. Saivis, welcome to India.
Thank you very much. I appreciate that introduction. And just to quantify that introduction, yes, my background is in surgery, but there are other people whose background is in endocrinology, whose background is in ophthalmology, whose background is in cardiology. And one of the key things, no matter what specialty you're involved, from podiatry to hair replacement, if you don't understand the role of insulin resistance and the modern human diet that most people are into, number one, if you don't understand it, you should not be giving nutritional advice. And number two, it behooves you for any specialty to understand the nature of our relationship with food and a transformation in that relationship as it impacts whatever your specialty is. So while I'm a bariatric surgeon, I deal with obesity, I deal with a number of weight health issues. I've made it my point to understand why my patients get into the trouble they do and to give them appropriate advice. Not just do a Mediterranean diet or eat less Coke or do more and eat less. That nonsense, you can go onto the street and ask anybody, and they'll give you the same advice that most doctors give you about nutrition. And it's false, and it's led by false policy and a false narrative that we have been trapped into. And I'm hoping over the next 4 years, certainly here in the US, we'll have a leadership change that alters the entirety of food policy.
So you have been defining carbohydrate addiction as a substance abuse. Usually we hear this for drugs, and it's a substance abuse, emotional management problem rather than a dietary issue, and which leads to probably obesity, type 2 diabetes, cardiovascular, which are just the expression of this addiction to carbohydrate. Can you explain a little more, because people will like to know more about this?
Yeah, I think the key thing about anything that we call a drug, and really I'm going to expand it a little bit more, any behavior or any substance that gives massive upfront instant gratification, instant or endorphin relief, instant relief from emotional tension, whether that's anxiety, stress, depression, anger, fear, frustration, exhaustion, boredom, pleasure. Collectively, I call that emotional tension. And all human beings at a very, very early age, probably in utero, begin to develop strategies to activate the endorphin system that gives us relief from emotional tension so that we can function. And in the first few years of our lives, we all discover certain aspects of that. And it may be a behavior, gambling, sex, pornography, which is a process addiction. It may be a substance, and the traditional ones are the opioids, the alcohol, nicotine, crystal meth, crack cocaine. But all of them, by definition, have a massive, powerful endorphin activating role. They all can be done to excess. And when you do them in a chronic, excessive way, they have to cause harm to be defined as an addiction. The word addiction is often used by people where they don't quite understand that reality. The word addiction has to be predicated by significant harm. If there isn't harm, you may have an abusive relationship with that substance, but there's no harm. So, for example, if I get drunk one night, I may have abused alcohol. If I have a DUI, I may have abused alcohol, but I may not be an alcoholic. But if I've had 5 DUIs and I've got liver disease, I'm an alcoholic, no matter whether I believe it or not. And carbohydrates, sugar and starch, and the key thing is this, it doesn't matter. We quantify the quality and the value of food by how it enters our mouth. But remember, our mouth is outside our body. The transition happens when that substance crosses the gut barrier into the bloodstream and goes to the liver. You can drink wine, beer, and whiskey. It's alcohol that enters the system. So an apple and a donut carry the same amount of sugar and starch, and it's exactly the same. Yet we quantify one as healthy, the other as unhealthy. But that's a societal issue. However, carbohydrates, when they hit the brain in a significant rush, cause exactly the same endorphin chemical response as all of those other more classic drugs. All because we human beings haven't yet assigned or recognized that as a problem, it doesn't mean it isn't. And all you have to do as a practitioner is listen to your patients and watch that relationship. And you'll very, very quickly understand that their entire behavior, because addiction is not something we do. Addiction defines who we are. So addiction is, by definition, if someone doesn't drink alcohol, you're an alcoholic. You're a smoker. You're a crackhead. And in my case, I was a fat person. But that is, a carbohydrate addiction is one of the few addictions where we define it by the outcome. So if you've gained 5 or 10 pounds, you may have had a bad Christmas or whatever it is. But when you're more than 25, 30 kilos, 50, 60 pounds overweight, when you have type 2 diabetes, that is the quantifiable harm. To get to that point, you have to indulge in this addiction, indulge in your relationship with carbohydrates to such an extent that you are defined by the relationship. And that's addiction.
So, Dr. Rob, that was, you made a very interesting point. And, I always keep saying that whether it is an apple or a donut, as long as, you are taking in same amount of net carbs, which is going to turn into same amount of glucose. This theory of complex carbs, simplex carbs is all nonsense, because body will need same amount of insulin to produce, to process same amount of glucose. Now, coming back to question, how does this addiction model explain why people, struggle to reduce carbs, or not exactly give up, reduce carbs, and despite knowing the health risks?
So just to answer, the best way to know what you're eating does with you is to wear a CGM, okay? This tells you immediately, because if you eat carbohydrates, the apple or the donut, your blood sugar spikes. So it's a very, very useful instant feedback. The scale is a very poor instant feedback, but the CGMs, which are ubiquitously available, are an incredibly effective way to know what you're eating does to your inside your body. But to come back to the question, I think one of the issues with human beings is there are really two forms of emotion management. There's instant gratification, and there's what we call effort-based. So, for example, if I have a really rough day and I have a fight with someone, and I come home and I eat a tub of ice cream, I have instant gratification, but on the back end, there's harm. My blood sugars go up, it's affecting my heart, it's affecting my weight, my diabetes goes up. If, on the other hand, I come home and I leash up my dog and we go for a walk, that walk requires effort and time up front. I don't get the instant gratification. But as I'm walking, my emotional tension subsides. I'm able to connect with and process that issue. And by the time I come back from the walk, I'm emotionally relaxed. I've got a game plan for dealing with the issue, and I'm feeling pretty good about myself. I do not need to defend it. So the issue with carbohydrate addiction is that it occurs in people, any addiction occurs in people with a comprehensive deficiency of effort-based emotional off-ramps. So the young child has a lot of emotional tension built up. They don't have an effective way of dispelling that, of getting rid of it. They bump into a drug. And the commonest, most ubiquitously available drug, as soon as kids are weaned off the breast, if they're breastfed, is sugar and starch. We take them from a pure carnivore meal, and every child, whether you're Hindu, whether you're Christian, Jewish, doesn't matter, is raised on a 100% carbohydrate diet if they're breastfed. Just put that into your mentality, because breast milk is. But then suddenly we're giving them a bunch of carbohydrates, cereals, goldfish. We're giving them a variety of carbohydrates as soon as they come off that carnivore diet. And for some people, it's okay. They can handle that because they've got a diversity of other options. But for some people, some young children who do not have other off-ramps, they develop that relationship very quickly. And they're going to the fridge, grabbing something. Whenever the child is noisy, the mom's giving them something to eat. And it's not steak and broccoli. It's usually some sort of sugar or starch. So we entrench that behavior. And when you've got that as an opportunity, if you've got access to carbohydrates, why do you need to develop other things? Why do you need other emotional off-ramps? So the vulnerability to addictive behavior is imprinted and occurs from our parents within the first 2 to 3 years of life. And then it's a question of which drugs we bump into during our early lifetime as to which addiction we follow. A lot of kids have all this emotional tension built up. Now this is where India is beautiful as opposed to the US, because in the US, here in Florida, in middle school, these kids are discovering vaping, electronic cigarettes. India banned electronic cigarettes. I mean, it's just such a smart policy move. But 60% of children in Florida at high school vape on a regular basis. They're using marijuana and they're using nicotine as their emotional off-ramp together with a carbohydrate. So it occurs very, very early on. And addiction is a default to the lack of diversity in terms of emotion management strategies.
Now, I want to ask a very, very key question. I think it's going to be very, very relevant to India. What are the 3 core aspects that require transformation to overcome carb addiction?
Well, when you analyze, and I think this is an important concept, just as a preemptive part, you're going to have 3 people on this wonderful conference. You're going to have people who are speaking from a personal perspective. They've got a personal story. Like the last person that was on, beautiful personal story, but it's an N of 1. Then you're going to have people that are researchers, that are biohackers, that are going to talk about research. And then you're going to have a group of practicing physicians and practitioners who are in the trenches, who are observing other people. And then it's not about me, it's about what I'm observing in our patient population. And one of the problems with healthcare, it has become a generic algorithm that no matter who walks through the door, we've got an algorithm of best practices. You're going to get exactly the same treatment. What I have to do when a patient walks into my office is create an individual relationship, understand who they are and where they are, and then manage them appropriately for their needs, not the way I want them to be, but the way meet them where they are and help them to transform slowly. Having said that, there are three dominant aspects to carbohydrate addiction, and it's not food addiction. Nobody's addicted to fluids. We're addicted to alcohol, okay? And when you're dealing with alcoholism, nobody tells an alcoholic what they must drink, but everybody loves to tell fat people what they must eat. No, don't eat the carbohydrates, don't eat the, and that's why you can manage this, whether you're vegetarian or whether you're carnivore, by getting rid of the carbohydrates. So the first thing is the drug itself is carbohydrates. But when you smoke, it's not just the nicotine. There's a whole relationship, there's a whole ritual that is involved in the emotion management. Every smoker has the same type of cigarette that they smoke. They have a ritual by which they smoke. And the rituals when it comes to carbohydrates, number one, it's the drug itself, sugar and starch. And everybody has their poison. It might be more salty, it might be more sugary, might be more starchy, might be more simple. But the second one is this, a snack. A snack is always, always, always an emotional event. It is never a nutritional event, okay? You see me sipping on my coffee. This has nothing to do with hydration. This has to do with a little mind cleansing moment that gives me a little moment of reprieve so that I can focus. And the human brain needs that break every 15 to 20 minutes, particularly when it's focused. And the carb addict is having a little snack of some form of caloric load. So a snack is always an emotional event. My coffee contains nothing. It's a bridge across that need for something emotional without causing me caloric harm. It's gum instead of a cigarette. And then the third component is binge eating disorder. And our society has created and indoctrinated us with binge eating. Most of the time with our children, finish your plate. We very, very early on in a child's life, a normal healthy person, any animal, a normal healthy person has a very tight feedback system between your brain and your belly. Your brain says, okay, I need food. You start to eat, and the chemicals and the hormones in your belly go back to your brain and say, hey, you've had enough. And there are certain hormones that create satiety, one of those being GLP-1, which everybody knows is Ozempic. But when we determine preemptively how much we think we need to eat, and the brain tells the belly, eat this, this is how much you're going to get, we very rapidly override and destroy that natural feedback pathway. We've tried to experiment with ghrelin and leptin, which are some of the feedback hormones, but we've been indoctrinated by portion size to override. And most of us will eat very rapidly, and we eat what's in front of us. So part of the therapy there is to put less on your plate. Let's face it, if you don't eat enough, you don't have to grab your bow and arrow and go outside and shoot something. You can walk 5 paces to the kitchen and get more food. So if you start with a smaller amount, and it's amazing preemptively when we're dealing with addiction, how intense we need that massive amount of food. But if you put less in front of you and you eat less, it's very rare that you go back for more. So I hate this word, but we're doing caloric reduction intentionally because our belly is being triggered to go back to the brain to say you've had enough. At the same time, we've been conditioned that if you put too much in front of you, you'll override that and finish what's ever in front of you. So those are the three concepts that we really have to work with. Removal of carbohydrates, and then I really don't care about what you do eat, just like the alcoholic. There's a variety of different things that are cultural, religious, and palate, as long as you're getting adequate nutrition in. But it's not about what you are eating, it's about what you're not eating. And then working with snacks. But one final thing I'll say to you, and I know I speak a lot, but addiction is never about quitting. The worst thing you can do is quit. And the reason for that is because every addiction serves a very powerful purpose. My carbohydrates have a wonderful, very effective emotion management role in my life, but they create a lot of harm. So when you get rid of them, you are removing the harm, but you're also removing the benefit, and you're leaving a massive void in your life in terms of effective emotion management strategies. So the operative word in addiction is not quitting, it's replacement. If you think about Alcoholics Anonymous, AA does not get the alcoholic to quit drinking. That's a very lonely personal thing. And quitting carbohydrates is a very lonely, very difficult, incredibly difficult thing to do. And only we can do that. But rebuilding ourselves, reformatting ourselves from a more diverse, more effort-based emotion management system should take the rest of your life. But if you don't replace, you're either going to relapse back, and a lot of people will say, oh, it was the holidays, or oh, these stressful events happened, to justify going back. Or alternatively, you find another drug. So you go from smoking to eating carbohydrates. That's called a drug transfer. So remember that it's always about removal and replacement. And with carbohydrates, you want to remove carbohydrates and replace them with other forms of food that are culturally and religiously acceptable to you, that don't include carbohydrates. But also you want to develop an effort-based emotion management system. And I use the algorithm CHESS: creative arts, human connection, physical activity or exercise, spirituality and meditation, and healthy sleep and healthy sexuality. And that is the most robust, diverse form of healthy, effort-based emotion management systems that you can replace addiction with.
Dr. Rob, I think in hindsight, as you said, don't remove carbohydrate. It's not about addiction, but it is about limiting, I would say. So in hindsight, I think the 100 grams carbohydrate limit that we, set on our protocol, do you think it is perfectly fine?
I don't think so. And I think as an entry point, it's absolutely fine. The worst thing you can do is go from your standard high carbohydrate diet to nothing. It's a slow, steady transition. But here's the transitional thinking. And diets are predicated by control and deprivation. Control, I can only have 100 grams of carbohydrates. And the deprivation part is I'm not allowed to have this, I'm not allowed to have this. Addiction is dominated, an effective addiction transition is dominated by the word empowerment. A vegan doesn't feel deprived of steak. That's disgusting. How can you kill Bambi? They're arrogant about the fact that they don't eat that. A Muslim is not deprived of pork or bacon. There's a level of arrogant distaste for it. The Hindu is not deprived of eating cow or meat. It's just part of our cultural identity. So when you create a diet, first and foremost, addiction management will always fail when it's something that you do, because addiction defines who we are. And therefore, this has to be a transition in habits, relationships, and routines that are foundational to who we are as a human being. Of course, you want to start with changing what you're eating. But as you go through this further and further, you want to define, why did I do that in the first place? Because as long as you've got those 100 grams of carbohydrates, those act as a reward. No alcoholic drinks 2 beers a day. No heroin addict just shoots up a little bit on a Tuesday morning. I think as a starting point, absolutely, you've got to go through that transition. The first part is the ownership. Yes, I have this problem and I'm slowly going to manage it. But I think stopping at 100, getting to 100 is essential, but stopping at 100 stops you from progression. And addiction, there is no endpoint to addiction management. It's a set of milestones. And as soon as you reach a certain milestone, I'm only at 100, I'm eating all of this stuff. What's next? I've lost 100 pounds.
Let me correct myself. It is 100 grams per day max.
Right. And I think the way that I would describe that is I agree with you at 100 or 50 or whatever that set is. However, those are incidentals. So the way we work in addiction, the way I work my own program, the addiction program, is all vegetables are free. I don't care if there is some carbohydrate in carrots or peas or Brussels sprouts, because I've never met somebody who's a carb addict who rushed home to pig out on Brussels sprouts. But the potatoes, the rice, the grain products, both from a health perspective, the grain products are the most autoimmune triggering and inflammatory triggering products, not the carbohydrates, but the proteins in the grains. Most of us experience irritable bowel or a form of celiac irritation. A lot of us do. Hashimoto's, 82% of my female patients come in with Hashimoto's, primarily triggered by grain proteins. So you've got to look at where the boundaries are. But I think in addiction management, the boundaries are binary. So if you count vegetable carbohydrates, I don't have a problem with that because I've never met somebody who rushed home and pigged out on them. So we don't quantify it by necessarily the exact amount, but we quantify it by the relationship. And obviously, if you do have that problem, then you want to change the relationship with that particular food product. And you know what's also interesting, and you'll hear a lot of the carnivores come on here. I manage several thousand pure carnivores. And while human beings do very well on a carnivore diet, over time, they become so fat adapted that they are no longer triggering the release of insulin. And they become what's called insulin suppressed. And the way we correct insulin suppression is actually to reintroduce a little bit of carbohydrate. And Professor Tim Noakes just published a beautiful paper on athletes, on endurance athletes, where about every half hour, the ideal suggestion is about 10 to 15 grams of carbohydrates to support you. So we've got a lot still to learn about the role of carbohydrates in our lives, and it's not complete abstinence, but it's management of the relationship, as I said at the beginning, that is more important than the absolute number.
Now, the pertinent question for India is we are deeply high carb and grain based diet, and this is all cultural thing. So how do we think people can navigate and manage the carb addiction?
I think that is a very, very important consideration. I alluded to this a little bit ago, is that we all make choices. We make choices for our children and we make choices for ourselves based on cultural and religious aspects of our lives. And we don't even give that a forethought. A religious Muslim is just not going to, a religious Muslim, a religious Jew, just not going to eat pork. It's not that they don't eat pork. It just doesn't exist in their lives. Okay. A lot of people choose not to drink coffee. My Mormon patients don't drink coffee. They don't drink alcohol. We all make those choices to not do something. We make a choice not to smoke. So ultimately, this comes down not to culture or to religion. We have to take those into account. But it comes down to who we are as human beings and what matters to us. The one thing I can tell you, again, I've got to be cautious in India because of reincarnation, but we're all going to die. And that is one hard endpoint. It's the only endpoint that I can guarantee everybody. How we get there is our choice. And we can choose to, if we've got cardiovascular disease, if we've got diabetes, if we have obesity, we can choose to say, look, I don't like these diseases and I'm willing to give up my carbohydrates. Or you may say, you know what, I'm a religious Hindu, but you know what, I want to eat meat. I'm a religious Muslim, I want to eat pork. Those are choices that each person makes. So I cannot tell my patients don't eat carbohydrates. However, one of the problems that we have in healthcare is the difference between compliance and consent. And healthcare has become all about compliance. You're going to have a heart attack, you must take a statin. And between fear and trust, the patient is fearful they've just had a heart attack and they trust their doctor, but they don't investigate the risks, benefits, and alternatives to that drug and they take a statin. Healthcare should be about two things. It should be about consent, and consent has several stages where the person is free to make a choice and they should be given the risks, the benefits, and all the alternatives to that decision. And healthcare should always, always be about shared decision-making. So I cannot tell you you must do something as a physician. I would say, look, this is my opinion, and here's the facts, pro and con, and you decide. And the same is true with carbohydrates. Ownership of carbohydrate addiction, ownership of any addiction, is one of the most difficult things we do. The last person to know that they have that they're an alcoholic is the alcoholic themselves. So So as a physician, I use those hard things. If your A1C is above 6.5, I don't care if you agree or disagree with me. You have an addiction to carbohydrates because by the time your A1C gets that high, this is a relationship that you no longer have control over. And I know that comes down to the 100 grams is the control side. By the time you're more than 50 pounds or 25, 30 kilos overweight, this is no longer something you have control over. This is an addiction. Then you have to decide for yourself, that's the harm. I now have diabetes. How much do I care? Versus my relationship with carbohydrates. But that is a decision that each individual has to make. And what Anup is doing is more giving information to a population to say, hey, begin to work on reduction, which I love. That works at a population level. When I deal with individual patients, we have to set a higher standard if that patient chooses to have that higher standard. If they choose not to, there's very little that we can help them with. And everybody relapses. Only those perfect people on the internet are the people that never ever screw up. I screw up, everybody screws up. We have to help them to manage how do we get back on track? Because every one of my patients is an expert at failing diets. And part of the addiction methodology is it's stepwise. It's not all in a rush. It's stepwise, it's empowering, and we can slowly make new milestones. So you can be successful at milestones. You don't necessarily have to be successful at everything.
Yeah, Dr. Rob, you said 6.5, you consider it as, the break point from where you can decide whether the addiction has to go or it is perfectly fine. For your knowledge, we keep that number as 5.6 because for us,
I agree completely. Yeah.
Yeah, because for us, diabetes is much like pregnancy, a binary state, either yes or a no, right?
You know what,
Not,
Anup, you're 100% correct. However, the healthcare tradition is 6.5 defines
yeah,
diabetes.
that I understand.
Now,
That I understand.
a normal blood sugar, a normal A1C is 5.2 or lower. Why? Because at an A1C of 5.2, your average blood sugar is non-contributory to cardiovascular risk.
Yes.
But here's also a very important point that many people don't understand, and as a physician, I understand this. There is a genetic bell curve in terms of disease expression, okay? So, and this is very important in India. In my practice, some people like myself walk past a donut and we immediately gain 5 pounds, but my blood sugar is always very, very level because genetically I can produce a huge amount of insulin. So under the influence of that insulin, no matter how resistant my cells are to insulin, I can produce more insulin to keep shoving that sugar into my cells. I clear the sugar from my bloodstream and I gain weight. And in my fat cells in my liver, I turn that sugar into fat. Now, the diseases that someone like me, I call that an obesogenic genetic pattern. And I can measure insulin, fasting insulin, I can see those levels very, very high. My highest fasting insulin was 87, okay? Normal fasting insulin is about 3 to 4, below 6. So the diseases we get, people like me, and there's a subset of Indian patients, of Indian people who are obesogenic, but the minority, just that's the genetics. But the diseases we don't get cardiovascular disease, we don't get stroke disease unless we cross over. And I'll talk about that in a second, but we get Alzheimer's. We've got a much higher risk of cancer because insulin is a cancer surveillance hormone. We have autoimmune disease. We have weight-bearing joint disease, lower back, hip, knee, ankle disease because of the weight. We get polycystic ovarian syndrome in females, and we get low testosterone in males. Those are the diseases of hyperinsulinemia and obesity. On the flip side, you get people who genetically cannot produce a very high amount of insulin. So they produce a moderate amount of insulin, but pretty quickly the insulin resistance, the blockage of the receptors, is greater than the amount of insulin they can produce. So they all gain some weight. So there's a degree of weight gain, but very rapidly they cannot clear that sugar. So those same people eat the same donut and they don't gain weight, but their blood sugar rises and stays high because they now require the liver to clear it. The liver doesn't need insulin. So that's where their triglycerides go up and the liver clears it. Those are the people that are diabesogenic. And their problems primarily come, obviously it's a bell curve, but their problems primarily come from elevated sugar, which affects the blood vessels. So your cardiovascular risk is high. And it also affects the interstitial space, the space between the blood vessels and the cells themselves. What lives there? Your ligaments, your tendons, your joint capsules, and your nerves. So you're getting neuropathy. You can get ophthalmic neuropathy, you get retinopathy, you get cardiac neuropathy, you get both the plumbing, which is atherosclerosis, and you get the arrhythmias. You get peripheral neuropathy, you get intestinal neuropathy, so you get intestinal problems like gastroparesis, you get erectile dysfunction. So those are the spectrum of diseases, one predicated by hyperglycemia, high levels of sugar in the bloodstream, and one predicated by high levels of, super high levels of insulin. And what's interesting in my diabetics, the first treatment of my diabetics is actually to raise their insulin. Because while they're producing a lot of insulin, this is where I disagree with some of Jason Fung's work, the full suitcase model, is in those patients, we first have to overcome insulin resistance. So we raise insulin levels to make the cell more receptive to sugar. And then as the cell becomes used to sugar, the expression of those receptors and the phosphorylation of the receptors goes down, and they require less and less insulin over time, so we can then withdraw medication. But the first step is to clear the sugar from the blood vascular space. And a lot of physicians don't understand that, but if you work in the space, you can identify the individual patient that is diabesogenic versus the one that's obesogenic, and we have to work with them slightly differently. So the genetic predisposition is a very, very important component. And the Southeast Asian population tends to be more diabesogenic. The Southern Asian population, the Samoans, tend to be very large and more diabesogenic, more obesogenic than diabesogenic, but obviously everybody can cross over at some point.
What are the biggest roadblocks, when it comes to trying to give up this carb addiction, as you say?
The biggest, most obvious one is ownership. And it's ownership at a societal level, because we still think of carbohydrate addiction in terms of food and nutrition rather than drug and addiction. Okay. While alcohol falls in the hydration category or in the fluid category, nobody would think of alcohol as something we drink for hydration. But we think of carbohydrates as something that we still eat for nutrition. So there's a societal level that has to separate the two. And whether it's processed or natural carbohydrates, nobody or very, very few people become diabetic or obese on so-called natural carbohydrates. But once you are, the naturally occurring carbohydrates are as evil as the other. And that's an important concept. So you'll say, oh, you can eat the apples. Yeah, you can eat the apples if you don't ever eat the processed carbohydrates, but the addiction comes from the processed carbohydrates. So the first one is a policy level, but secondly, at a personal level. You get somebody coming in, they weigh 200 kilos, or somebody comes in, they have profound diabetes, we're removing their foot, and they don't understand, they cannot correlate that relationship with carbohydrates. So we have to help them to understand that personal relationship. Then the fear, the absolute fear of not having your best friend. Ask any smoker, the greatest thing is the fear. There is an enormous fear of, what am I going to do? Because all I have is sugar and starch. I got nothing else. You look in a carbohydrate addict's emotion management toolkit, it's carbs and cobwebs. And if you remove the carbohydrates, suddenly, what am I going to do? That's why we remove and replace progressively. So there's that absolute fear. And then there is a physiologic dependency. If you suddenly quit eating carbohydrates, you're producing massive amounts of insulin. Your blood sugars are going to drop. You're going to have all kinds of physiologic harm. Just like when you quit drinking alcohol, you go through the shakes, you go through withdrawal. So if you do this more progressively, once you understand it, that's fine. But the ownership part is the first thing. And then the second big issue is managing relapses. And that is where we have a binary approach, so that if you make a mistake, we have to recognize that it was a mistake. You can't go back and pay it back, but we also want to objectify the mistake. If you personalize it, oh, it was my birthday, I just had a little bit. We are so good at rationalizing. Every addict is so good at minimizing, trivializing, and rationalizing our addiction. If you objectify it, you can own it. Okay, I made this mistake. I'm not going to beat myself up, but the next time I'm in the same situation, here's how I'm going to do it differently. And it's ownership. You analyze the reason why it happened, and you make a correction for the future. And addiction management is all about change over time. It isn't change one time like a diet. It's a continuous transformation including the day you die. Every morning you wake up, what more can I do? That's what we're focused on.
Thank you, doctor. I mean, you gave a lot of insights to us on this carb addiction model, and I think we still have 3 minutes left. Dr. Joanne is here. One last question. We are very curious to know. You are a bariatric surgeon. Still, you keep recommending therapeutic carbohydrate restriction. How useful is bariatric surgery in which population, and why do you still keep promoting therapeutic carbohydrate reduction as a bariatric surgeon?
Well, I think first of all, bariatric surgery treats obesity. It doesn't treat carbohydrate addiction. Just like metformin, insulin, whatever it is, it treats the diabetes, it treats the blood sugar, it doesn't treat what caused it. So every physician out there, no matter what specialty you're in, has a therapeutic element to deal with an endpoint disease. But if you don't simultaneously treat insulin resistance, which is the gateway to all of these problems, you're not doing service to your patient. So the beauty for me, and again, I'll argue with anybody about this because I'm in clinical practice, my surgical need has diminished dramatically because of one drug, the most important drug in my lifetime that has come along for the treatment of insulin resistance, because it specifically treats insulin resistance, are the GLP-1 agonists. And whether you have kidney failure, whether you have diabetes, whether you have Alzheimer's, whether you have cardiovascular disease, whether you have obesity, whether you have diabetes, whether you have PCOS, infertility, the GLP-1s are incredibly effective drugs for the treatment of insulin resistance. But the problem is that most people are backdooring into the GLP-1s. And because they can't get hold of them, they're dosing up at home, they're using them, they're outsourcing to the GLP-1. Same thing with bariatric surgery. People that have bariatric surgery lose weight. People that go on GLP-1s lose weight. Wonderful, kumbaya. But none of them are addressing why the problem happened in the first place. And if you look at the obesity surgery, you look at diets, you look at obesity surgery, you look at the GLP-1 literature, everybody, the majority of people, 96% of patients in the STEP 4 Ozempic trial regained all or most of their weight back within 48 weeks of stopping, because they didn't change the relationship, the behavior that caused the problem. So I can do bariatric surgery on one day and get you to lose weight. But my relationship with you as a patient over a protracted period of time is not designed to get you to lose weight. It's designed to slowly, progressively help you to change why you gained that weight in the first place. So the majority of my patients are non-surgical patients. About 1% of my patients right now are surgical. The majority of my patients have had a heart attack. They have diabetes. They want to get pregnant. They have all the other aspects of this. And because I don't consider myself to be a bariatric surgeon, I don't consider myself, TCR is just something, therapeutic carbohydrate reduction, something we use. I am the beginning of a brand of a new specialty called a metabolic health practitioner. And metabolic health is about carbohydrate addiction and understanding insulin resistance. And the SMHP, which I want to promote here, it's an international organization, Society of Metabolic Health Practitioners, was created and built for people like myself who want a new specialty. Tim Noakes created sports medicine as a specialty, and I think the SMHP, so I want to minimize my bariatric surgery. It's just one of the tools I use, just like a diabetic doctor uses metformin or insulin. What we have to become is metabolic health specialists if we want to change policy, if we want to change the influence that we have over our food, and if we want to treat our patients correctly.
One quick rapid fire before we wind off. From all your talks, can I conclude that carb is for entertainment, protein and fat is for nutrition?
I love that. Yes. And don't forget the micronutrients. You're exactly correct. Carbohydrates are like a glass of wine. They're enjoyable, but they serve no nutritional purpose. And if you have a broken relationship with them, then you have to choose whether or not you're going to continue that relationship.
Thank you.
Thank you. Thank you. We'll have a bigger session with you later on someday, because you are an interesting person and we have not dug out even 20% of what you want to say and what you know. Thank you, and we'll get back to you, doctor. Thank you.
Thank you so much. I really appreciate it. Bye-bye.
Please get Joanne in and Asmita.
Hello.
Welcome, Joanne.
Hello, Dr. Joanne.
Good evening to India and good morning from Seattle.
Yeah, good morning to you.
Thank you.
Hello, I am Asmita, a certified metabolic health practitioner from Dietary, India's first and the only award-winning low-carb platform. It's my absolute pleasure to host a session with Dr. John Island on the Metabolic Health Conference 2025 organized by Anup Singh and Shashikant Iyengar. Let me just quickly run through the introduction. DLife was founded in 2014 by Anup Singh, a silver medalist from IIT Roorkee and the recipient of Icons of India Award. Anup is the pioneer of low-carb movement in India with his path-breaking protocol of 100 gram carbs per day maximum given by him in 2012. That makes not only LCHF but remission of even type 2 diabetes possible for Indian vegetarians. In 2021, DLife launched its diploma course, which is the only course approved under NSDC partner, the Government of India, in this segment, and the only course with the global biggest 144 hours of CPD hours credit. Anup Singh, along with Shashikant Iyengar, is the co-organizer of this Metabolic Health Conference. It is my distinct honor to introduce to you a trailblazer in the realm of food addiction recovery, Dr. John Island. Welcome, Dr. Island.
Thank you so much.
To tell you briefly about her work, she has transformed the landscape of how we understand and treat processed food addiction. Dr. Island holds a PhD in addictive nutrition and an MBA from the prestigious Stanford Graduate School of Business. She is the lead author and editor of the groundbreaking textbook, Processed Food Addiction, Foundations, Assessment and Recovery. Since 1996, Dr. Island has been at the forefront of research and practical interventions, helping countless individuals overcome the formidable challenge of food cravings. So today we are privileged to have you, Doctor, and to hear your invaluable insights and expertise. So please join me in welcoming Dr. John Island.
Thank you. Thank you. I am very honored to be here.
Yeah. So my first question to you would be, can you explain what food addiction is and how it is different from other forms of addiction?
Okay. All addictions happen. It's a mechanical syndrome in the brain, and it's simple to understand, very complex to recover from. But the simple fact is that we have pleasure pathways, and when those pathways become hyperactive, overactive, they put out so much neurotransmitter. They're in the midbrain, they go straight across the midbrain and control behavior. They are competing. It's a battle for control of behavior between the craving, the pleasure pathways. When they're hyperactivated, they become craving pathways. And there's a battle for control over behavior between the craving pathways in the midbrain and the rational thinking pathways in the frontal lobe. So when you have an addiction, it's because the craving pathways are putting out more neurotransmitter and controlling behavior than the frontal lobe. That's, in a capsule, that's what it is. And once you know that, you're not crazy, you don't lack willpower, you're not lazy, you're trying hard enough. But to get those craving pathways to stop putting out that overwhelming amount of neurotransmitter, that's recovery. That's a process. It's just like what Dr. Sai was saying. It's a lot of skills. It's a lot of time. It's a lot of patience. But you can do it.
Very interesting. Doctor, one of your innovative work has been with mirror neurons. So in which you explain that the neurons mirror the actions that you see people doing around you. So can you explain that pathway a little more?
Yes. So you need to change behavior a lot. You need to change a lot of behavior to accomplish, quieting those craving pathways. But because the craving pathways are so active, they pull the blood supply away from the frontal lobe. And that's where you learn new behaviors. So that's why it's not realistic to try to change all those behaviors by yourself. What you have to do, what we've discovered, and we have been awarded a patent for this method, a US patent. What you can do is you don't have to employ this weak, this frontal lobe that's been deprived of blood flow. There's another system in the brain, these mirror neurons, that is more powerful than the cravings, more powerful than the frontal lobe, and that is the system of mirror neurons. And mirror neurons do one thing. They watch or they listen to what other people are doing, and literally it's a mechanical action. They watch, they collect the information, and then they pack it into the brain cells around them. And that information then becomes thought and it controls behavior. So the strategy then for recovery is to get that person around people who are eating clean, who are eating real food, who are shielding against triggers, all those skills, and their mirror neurons will do the work. You're not actually using the learning pathways in the frontal lobe. And fortunately, Zoom can deliver. We call it mirror neuron engagement. Neurons have to be watching people who are eating real food, sleeping well, taking good care of themselves. They will do all the work. They will just pack those thoughts into the brain. And people naturally, without a fight, without a struggle, they naturally start gravitating towards healthy behaviors.
Right. That's a very interesting phenomena that you explained, Doctor. Indians are a very social and community-driven society. So most of our meals are very rich in carbohydrates, and they are linked with festivals and celebrations. So the process of mirror neurons acting and impacting their food choices becomes further more interesting. So can you please explain why deep fried snacks, processed foods, grains and sugary sweets, which are associated with festivals, so addictive?
Well, so processed for a couple of reasons. I think that there is evidence and there is an argument that processed food addiction is the toughest addiction to overcome. And a lot of it is because of what you just described. If you want to recover from alcohol, you could spend a whole day without seeing somebody drink, without being offered a drink. You can go to a meeting where nobody else is drinking and they're teaching those skills. You can't do that with processed foods. So number one, the triggering is much more intense than other addictions. But number two is it's called polysubstance abuse. And if you're an alcoholic, you buy alcohol, that's one substance. Maybe you buy some cigarettes, that's two, but you use them separately. Maybe you're also snorting some cocaine, but you buy them all separately. Processed foods, you don't get that. You're buying typically a combination of sugar flour, gluten, excessive salt, dairy, excessive fat, caffeine, and sometimes food additives. Well, the reason that's so important is because those foods individually activate all four of the major craving pathways: dopamine and serotonin and opioid and cannabinoid. So it's in the package. All four of your pleasure pathways are pumping out those neurotransmitters. And we do have evidence that these combinations, if you're using more than one substance, if you have more than one craving pathway activated, it's just harder. Another factor is that this is the only addiction ever on the planet that is targeted to small children, even babies.
Yeah.
So this started when the tobacco industry came into processed foods in the mid-1980s here in the US. Philip Morris and R.J. Reynolds bought Kraft, Nabisco, and General Foods in 3 short years. And all you have to do is ask yourself, well, why would executives that make their money from addiction, why would they be moving into processed foods? And boom, you can see exactly what happened.
Yeah. So having said that, how can an individual identify and manage their triggers for food cravings in everyday life?
Mm-hmm. Well, you can do one of two things.
Mm-hmm.
Our programs run around the world, around the clock.
Mm-hmm.
We have teams around the world because people signed up with us. We started 7 years ago,
Mm-hmm.
but also because people wake up during the night and they're craving, and they lose control during the night. But if you can flip open a screen and be among people who know you, who like you, who have these control skills, your mirror neurons will kick right in, take a deep breath, get an oxytocin release, and go back to sleep.
Right.
Okay, that's option number 1. Number 2, think carefully about the 5 people you see the most in your life.
Mm-hmm.
Those 5 people, they're going to be packing those mirror neurons more than anybody else. So think about the 5 people I see most in my life, and then get them educated about what processed foods are doing to them, persuade them, ask them, just do it with me for a week. Do this with me. I have diabetes. I want to get rid of it. I need your help. And the best thing you can do to help me is eat real food right along with me. And if you can persuade those 5 people you see the most to start eating real food with you, then that will protect your mirror neurons from copying people who are eating processed foods.
That's a very wonderful insight that you have given, particularly in Indians, where there is, I would say, a very little awareness about managing lifestyle disorders and putting it into the remission. The work that D-Life has been doing, this would be a very, what should I say, important strategy to adopt and move towards a better lifestyle. The question that comes to my mind is there has been a few drugs and which have been tried for managing food addictions, such as GLP-1, Ozempic, and Wegovy. So, what are your opinions about the impacts of these drugs in managing food cravings, food addictions, and their long-term impacts on your metabolic health in general?
Yeah. So the way I think about the GLP-1s is they give people some room. They give people a degree of control. And in that kind of, think about it as a breathing space. So, when you're craving all day long and it's all you can think of and it's become an obsession, and you finish eating one thing and all you can think of is eating the next thing, then you don't have much room to learn, to think, to change your behavior. So the GLP-1s give you a little bit of room. Not everybody. Some people take the GLP-1s and continue binging. So my message for people taking the GLP-1s is use that wiggle room, use that little degree of peace, that little degree of control, the little bit of release from cravings. Use it to build your skills. So we teach 150 skills. We have 17 categories of skills. Most of them are having to do with what we call shielding skills, where you're literally shielding those very sensitive craving pathways from being triggered into a flood of cravings and losing control. When that happens, you lose the battle. It's between the frontal lobe and the cravings pathways. If you can shield yourself from the triggers, from the cues, from the signaling, then you diminish the likelihood that you're going to be in that flood of cravings. So about half the skills that we teach are craving control, trigger control, because when a brain becomes sensitized, a lot of different things can trigger it. Emotions, stress, reminders, association. Like you run into a friend, the last thing you did with that friend was eat a lot of addictive processed foods. Just seeing that friend will trigger cravings by association. And certainly thought control, emotion control, behavior control, relationship management, communication skills, because we're being triggered in our relationships. We're being triggered by our relationships. And then there are food production skills. Here in the US, where convenience foods are so prevalent, people have forgotten how to cook. So food production skills.
Yeah.
And also, there's a whole nother set of skills I wanted to mention, which is to identify the real foods that trigger cravings or trigger some other kind of reaction. So they fall into the category of food allergies. But pain, discomfort, those are also triggers. And learning if you have any real foods. So we teach a rotation method of foods. And so it's the GLP-1s give you a little bit of space in which to start learning skills, but use that GLP-1 time to build your skills. You can't stay, I'm not an expert on GLP-1s, but I know there are doctors out there saying, just stay on this for the rest of your life.
Yeah.
But if you can't, then as Dr. Silas just said, when you come off of it, you regain the weight, the heart disease comes right back, the cravings come right back. So if you take the GLP-1s and you don't get skill building while you're taking them, everything was just waiting for you when you get off of them.
Very true. So you touched a very important point that people don't have time to cook food at home and work for making their own meals. Doctor, you have been working in this field since 1996. So could you share some insights on how the processed food industry has grown over the years all over the globe and has contributed towards food addiction and the various metabolic disorders associated with it?
Yeah, oh, great. Thank you. That's a great question. So the American tobacco industry was able to spread processed food addiction around the world really fast. 20 years. For 20 years, the obesity epidemic spread around the world. It wasn't an obesity epidemic. It was a processed food addiction epidemic. We know now. Why? Why were they able to do this? It's because they already had the distribution set up for tobacco. They already had the advertising relationships. So they were just calling up the corner stores where they were selling tobacco around the world and saying, oh, we're going to be sending you processed foods. So they did not have to develop a distribution network. And on the advertising, so remember that this is these craving floods come from a signal, a reminder, a message, and something associated with that. So advertising is a key component of the addiction business model.
Yeah.
And with the way advertising contracts work is they are discounted by volume. So they already had advertising for tobacco, and they added this very cheap advertising on top of it because it increased their volume. So the additional advertising was cheap, and they bought a lot of it. And then you had two, the addiction business model is 5 A's. They had availability, advertising right off the bat, and they had a very cheap high fructose corn syrup. And the third A is affordability. And then they designed products specifically for children. And the age of onset, the younger you are when you get these intense cravings, the harder it is to put it into remission. And then they already knew, they hired a consultant, his name was Howard Moskowitz, to increase the sugar, fat, salt content of things like tomato paste or tomato sauce. And that's the 5th A, is hidden addictive substances in the product. Like they hid extra nicotine and pyrazine in cigarettes. They hid sugar, fat, salt in these products. And oh my gosh, it just went around the world so fast. Yeah.
Very interesting. So having said that, actually we would be keen to know any of your strategies that you have tried out on real life patients in overcoming them from their food addictions. If you could share any success stories.
Yes. Oh, you have to forgive me. I mean, I know the rules of academic presentations, and you can't market. I mean, so I am going to give you the scientific concept, and you just forgive me. I mean, I'm just going to give you the science and some illustrations.
Okay.
All right.
Sounds
Okay.
good.
So, all right. If that's okay.
Yeah.
So go back to the mirror neurons. All right, let's just do a hypothetical. Suppose somebody was able to go to an immersion program. Say it was an intensive outpatient program, and they were able to go there all day and then take an audio or a video home with them. All right. This is why addictions are treated in residential settings. You get protection from cueing, from the triggering. You get protection from availability. Availability is a trigger. Availability alone will get that dopamine going. Well, then your mirror neurons go to work. And you have all those hours a day where mirror neurons are packing in, I eat real, I eat real, I eat real. So I'm going to give you a couple of examples. These are real life examples. Somebody gets into an immersion program. Let's just call it an immersion program, whatever it is. And they eat, so their pattern is they can hold on to their food plan through the day, but then in the evening, they get around their family, the family's eating dessert, and they just give up, and they eat the dessert with their family. So somebody can come into an immersion program and they follow that pattern. On Monday, the first day of the program, there's that pattern. They eat well during the day, and then they fall apart in the evening. Monday, that happens. Tuesday, that happens. But on Wednesday, this is the third day, they eat real food through the day. They come into the kitchen at night. There's the dessert staring them in the face. They're in a program which is compassionate. You know, nobody is going to blame you for lapsing. So the thought that goes through her head on that third day was, I could eat this. I won't get in trouble, but I don't want to.
That's right.
I don't want to. Those mirror neurons are there for survival. That is why they are the most powerful part of the brain.
Yes.
Humans are relatively small mammals. We will not win against a pack of hyenas or the lions. We have 7 million years of evolution behind us where we learned if we're in a group, we live. If we're out by ourselves, we die. So those mirror neurons packing in that information, they will dominate behavior. They will do anything to get you to conform to the people around you. So in those 3 days, what happened to her brain was it just got packed with, we don't need that, we don't need that, we don't need that.
Exactly.
And yeah, think about the way she thought that. She said, I could eat that, I won't get in trouble, but I don't want to.
Right.
Because now at this point, eating that is abnormal. Abnormal is one of the key words in behavior and understanding behavior. So at that point, it was abnormal. Same thing, somebody came into a program and they described the battle. Every time they went into the kitchen, every time for like their whole life, there would be the battle. Am I going to eat the bad stuff in the refrigerator, or am I going to make a healthy meal?
Yeah.
It took 5 days, but she said on Friday she went in and there was only one thought. I'm going to make a healthy meal. That's how it works.
Right. I think that was a very interesting point that you made. Particularly if a person is living in a family and only one person is trying to adopt to a healthier lifestyle and other people are happy with what they are doing currently, then it becomes more important for the person who is trying to adopt to a healthier lifestyle to train his or her mirror neurons to adopt to a particular way of life. So
yes.
My next question would be, have you tried this strategy working for an individual better than a group of people, or say a family of individuals working more quickly, more effectively, and in a sustainable manner?
Yes, this is actually where my work is headed. You had that question you just asked had 2 parts, because the second part was, what are the diseases? What are the chronic illnesses associated with processed foods?
Yes.
And we have the work of Rob Lustig. It's a chapter in his book, Metabolical, and he goes 8 ways that processed foods attack cell function. They cripple cell function. So when and all throughout the body, but when you have that basic function not working, I recently put together a presentation on how processed foods relate to 20 chronic illnesses. We have a flood of new research because people are using that definition of ultra-processed foods and doing all kinds of studies to show that it's related to all the mental illnesses. We have a book by Chris Palmer called Brain Energy, where he shows that mitochondrial dysfunction in brain cells is the basis for a broad range of mental illness. So a lot of mental illnesses are related to processed foods. All the organ-related diseases, heart disease, liver disease, gut disease, and then all the system dysfunction, diabetes and obesity and sleep disorders, for example. Those are all, I mean, here's the good news, is they are They can be put into remission.
Yes.
So that's actually the patent that we were just awarded. It's a method to put chronic illness into remission. All right, now let's go to your question about, I'm really grateful that you're asking questions about implementation. Okay, so think about where people spend the most time. They spend the most time in their workplaces and at home. So you just hit on one of the most important things, which is I say start with the education. If you want that, I made a video out of how processed foods relate to 20 chronic illnesses. There's a study about how processed foods create the disease, another study about how eliminating processed foods is the pathway to remission. And then I stuck in a third study because I have a business degree. I have that MBA. I'm very interested in business dynamics and how they influence. Well, this is kind of shocking, but the US medical, this is just US, I'm sorry, I don't have the numbers for India. The US medical industry revenues are $4.5 trillion a year.
My goodness.
90% of that is coming from these chronic diet-related illnesses.
The numbers itself speak for themselves. So
yeah, it's totally what you would expect to see. Americans are eating 73% of their food, processed foods.
I'm sure. Yeah, I'm sure the numbers won't be different much in India.
I'm so sorry. I mean, I really, as an American, I just want to just say how sorry I am that these American corporations did that.
Yes.
Yeah.
Yes, they did. So having explained these factors, how do you see the landscape of food addiction treatment evolving in the coming years?
Well, yeah.
Would be keen to have your message for Indians who are not so aware yet about food addictions and fostering on grain-based meals. There are a lot of myths about millets are good for diabetes and ragi is good and these things like that. So what would be a message for Indians?
So I am not carb averse. I have seen people go from like a struggling on a carnivore diet or an extremely low carb diet, struggling, not control of their food, cravings. They switch to a plant-based program and they're fine. And I've seen it go the other way. People are struggling on a plant-based program and they go to carnivore and they're fine. So everybody has a very individual profile of sensitivity. Why could somebody be struggling on a carnivore food plan? Because we do have fairly recent evidence that fat can be addictive. Fat activates the same pathway as marijuana.
Okay.
It's a pleasurable food. And Mother Nature rewards, if you're eating a food that's nutritious, etc., Mother Nature will reward that. Well, she rewards fat consumption with a different pathway than sugar consumption. Sugar is dopamine, fats are the cannabinoid pathway. So this is something that I hope every one of your listeners is acutely aware of, which is if you put somebody on a low carb food plan, but you haven't treated the cravings, they can easily transfer sugar flour addiction, so refined carb addiction, over to fat addiction.
Very interesting. So even if foods which are healthy, I mean the healthy fats, a person can develop addictions even for the foods identified as healthy. Am I right in saying that?
Yeah, I mean, lentils are a healthy food.
Yes.
Lentils are a healthy food. You really, unless you're a carb, you're just against all carbs. Lentils are a healthy food, but if you have carb sensitivity, you can binge on lentils. But for me, what I would say is, I would never say that there's any one food plan for beating addiction, because I've seen this experience back and forth. It can go either. You can have fat addiction and get off a carnivore food plan and do well, or you can have really deep carb sensitivity and get on carnivore and do well. So if you prescribe a low carb food plan, please, please, please check for food addiction. And it's easy. There are 11 diagnostic criteria for alcoholism. In my doctoral work, I validated those criteria for overeating for food. And they're actually on our website. I just have to be careful here. But let me just would you like me to run through the 11 signs?
Sure. We do have 5 minutes. We can definitely run through that.
Okay, great. So number 1 is called unintended use. It's where you have a plan, you're only going to use so much, you're only going to consume so much, but you consume more. You wake up, I'm going to eat clean today. By 10 o'clock, you've had a sugary snack. Okay, that's unintended use. Number 2. Now, unintended use, I'm going to cite some prevalence statistics as well for the US, and I'm sorry, I'm citing it for the US. But when you think about unintended use, think about obesity, think about overweight, think about severe obesity. Those people did not intend to become obese. So in the US, 83% of the country is overweight, obese, or severely obese. So you have, 83% of the US meets the first criteria for food addiction. Now, this is not in the DSM. This is not a diagnosis. I'm carefully calling this the signs, and you can only self-identify with these signs. Okay, number 2, failure to cut back. So you lose the weight and then you regain it. 80% of people who lose weight regain it. So there's another indication. 80% of the country has this sign number 2. Number 3 is time spent. And not just time spent going and getting it, eating it, and recovering it, but also time spent thinking about it. Number 4 is cravings. And cravings have been shown to correspond with BMI. So now you're back to that 83% of the country that's overweight, obese, or severely obese. Number 5 is failure to fulfill roles. And once somebody has become obese, we now have evidence that they also start to become immobile. They have joint pain, they're out of balance, it's hard to move around. So they can no longer fulfill roles. Number 5 is relationship problems. These foods make us very irritable, depressed. They actually shut down, they downregulate those pleasure pathways, and you become depressed and tired. Very hard to maintain relationships. Number 6, next one is activities given up. People are craving, they're tired, they go home, they don't participate in activities anymore. We have evidence that obese people tend to isolate. So there's the evidence that, again, this is one of the symptoms of this food addiction. And then you have hazardous use, like people driving and eating. And then you have use in spite of knowledge of consequences. In the US, 93% of people have a diet-related diagnosis. So again, that's very prevalent. And then you have tolerance, where people are eating more and more over time. And in the US, you see this on a whole population basis. 50 years ago, we were eating 50% approximately of our food and processed foods. Now it's 73%. And then the last one is withdrawal. You have a withdrawal symptom. So when people are eating because they're angry, or because they're tired, or because they're in pain, That's withdrawal avoidance, and that's not eating. That's drug use. All right, that's the 11.
Excellent, excellent tips, Dr. Islan. As we come to the end of this session, I would request Shashikant Iyengar and Anup Singh to join us on this session and express a vote of thanks.
Thank you.
Shashi?
Yeah,
Yeah.
we'll just get Anup Singh also in. Okay, so till it comes in, Joanne, thank you very much for accepting this invite and giving us a lot of insight on the addiction potential of food and how we can really overcome. So in keeping up with the theme, I think India is going to get benefit greatly by your sessions and all the tips.
Thank you.
And thank you very much, and we'll come back and we'll interact more in future.
Great. Thank you so much.
Thank you, Joanne, and I'm sure we'll have you back in broadcast also. Thank you.
Thank you. Thank you.
Thank you.
Dr. Nadir, welcome.
Hey, thank you, Sashi. It's an honor to be here with you.
We are so happy to have you in this conference. In fact, this is of course the third conference we are having, and I think it's time that we interacted with Dr. Nadir. So I'll just finish off the introduction briefly. So you'll also have a glimpse of what D-Life is, and we'll also give the audience the introduction of you. So I'm Shashi, certified metabolic health coach from D-Life, India's first and only award-winning low-carb platform. So D-Life, of course, was founded by Anup Singh in 2014, who is an IIT engineer and also an Icons of India awardee. So he also pioneered the low-carb movement in India with the groundbreaking 100 grams carb limit per day protocol for type 2 diabetes management, especially for Indian vegetarians. So in 2020, he also launched the diploma in low carb and metabolic health, and which is the only NSCD partnered approved program. And of course, me and Anup Singh, we both have co-organized the first conference as well as the second, and now this is the third. So today we have Dr. Nadir Ali. So he is a cardiologist. He's an interventional cardiologist from Texas, USA, known for his expertise in lipidology and metabolic health. With decades of experience, he challenges the conventional view on cholesterol and heart disease, advocating for low carb approach to improve the cardiovascular and metabolic outcome. Dr. Ali actively educates patients and medical professionals on the role of insulin resistance in heart disease, emphasizing the elevated LDL alone is not the primary driver of atherosclerosis. His research-backed insights continues to reshape modern cardiology, and he is a wealth of information, wealth of knowledge, and I think today's 45 minutes may not justify getting everything out of him, but we will do the best to get out of maximum information out of Dr. Ali. Welcome, Dr. Nadir, again.
Thank you, Sashi. Thank you, Anup. It's an honor to be with you guys. It's like I'm back home. So this is very good for me. I would enjoy.
So, Dr. Nadir, you are basically from India. From which place?
I'm from Andhra Pradesh. At least it was Andhra Pradesh when I left. Now it's Telangana. I'm from Hyderabad. I went to Gandhi Medical College. And then right after medical school, I've been in the US ever since. I've been here approximately 38 years.
Yeah. Good to know. So, Anup's background. My background is I was in pharma. So for 35 years, I was a pharma salesman. So I was meeting cardiologists, diabetologists, and promoting all products, including statins, on which we might discuss a bit today.
Sure. Now, I know about your platform for a long time because in the beginning, I interacted with you a little bit on Twitter.
Yeah.
And I have referred so many of my patients to D-Life because of any vegetarian who comes in who wants to be on a low carb program up until recently, because now I have another IIT professional here, Ravi Krishnamurthy.
Yeah.
I think he's the one who kind of hooked me to you.
Yeah.
And he is doing some seminal work for the local community for vegetarians who want to be on a low carb diet.
I think it's only thanks to him I could reach you.
Yeah, it's
Thank you.
heartening to know. It's heartening to know, so many IITians are getting into this field.
Well, they are critical thinkers. Engineers are critical thinkers, so I'm not surprised.
So
Thank
the
you.
first question, I'll ask this very, very simple, basic question, which we all know that it seems to be very oversimplified, or is it the critical cause that is LDL really the primary driver of heart disease?
Yeah, I looked at all your questions. They are some of the best questions anybody has ever posed to me. And LDL, I would like to challenge that LDL is not a driver of coronary artery disease at all. I mean, that doesn't mean that it is not associated with it. Association doesn't mean causation. And I think if you tease out all the specific details about LDL, I would label LDL as a firefighter in preventing injury, in preventing the injury-related repair mechanisms that leads to atherosclerosis, rather than being an arsonist. It's not causing the fire. It is in there to repair the damage and help heal the injury-related aspects of vascular system. So to blame LDL as a cause and to think in a simplistic term that reducing LDL will reduce atherosclerosis is very naive and essentially wrong. So I'm not prepared to accept that LDL in any condition, like for example, small dense LDL in the setting of insulin resistance, in the setting of high triglycerides and low HDL, is actually causal in atherosclerosis. It's definitely associated with it, but saying that it is causal is going too far.
Thank you.
That's kind of a little broader overview. Go ahead.
Yeah, Dr. Nadir, this ApoB is now being pushed as the superior risk marker compared to LDL-C. What does it truly represent? That is part one of the question. And should it replace LDL in risk management or assessment?
Correct. So yes, that's an excellent question. So ApoB is the protein, is the apolipoprotein that is associated with an LDL molecule, but it is also associated with VLDL. So let's tease that out further. So as you know, cholesterol is a fatty substance that does not dissolve in water, and blood is aqueous. It is water in nature. Blood is water-based. So in order to carry fat, our body has developed these ingenious molecules which are called lipoproteins. So lipoproteins have a phospholipid bilayer on the outer coat, and there is a identifying protein for LDL, which is called the apolipoprotein B. And the inside of this lipoprotein, you have cholesterol, you have triglycerides and such. So apolipoprotein is the apolipoprotein B is the specific protein that is associated not just with LDL or LDL cholesterol, but it's also associated with VLDL cholesterol. So what is VLDL cholesterol? VLDL cholesterol is something that contains a large amount of fat as triglyceride. So it's triglyceride rich, cholesterol poor lipoprotein in the blood. So when your ApoB is high, it may be high because you have high LDL, but it's probably also high, not probably, but it's also high if you have high VLDL or have high triglycerides. So that's an important concept to recognize. As you know, statins and PCSK9 inhibitors reduce the amount of ApoB, so they reduce the amount of triglycerides to a small degree. They reduce the LDL or cholesterol levels associated with LDL to a large degree, but they do it, in my opinion, the wrong way. So to give a one-liner answer, and I'll expand on that, the focus on ApoB is another little propaganda by the pharmaceutical industry to increase the use of statins and PCSK9 inhibitors. And it is essentially wrong, because if ApoB is high and your triglycerides are high, the best method to reduce the triglycerides is through the lifestyle that we all promote, which is a low-carb diet, which is physical exercise, which is fasting. The reason I'm against statins and PCSK9 inhibitors reducing the VLDL portion of triglycerides, I'm also against reducing the LDL portion of the ApoB, but the ApoB that's associated with VLDL is because it does it the wrong way. What do I mean by that? What I mean by that is that the statins and PCSK9 inhibitors, mostly PCSK9 inhibitors, increase the receptor, which is the VLDL receptor, on the liver, in the pancreas. So essentially, your liver is sucking up fat from the bloodstream and gets fatty liver. Essentially, your pancreas is sucking up fat from the bloodstream and it becomes fatty pancreas. So you get pancreatic dysfunction, you get fatty liver, you get visceral obesity. So you are essentially doing the wrong thing and looking at your blood work and saying, hey, my blood work is right and I'm getting healthy, whereas you're essentially getting unhealthy. So the right way to reduce triglycerides is very different. So I'm sorry, that was a long answer, but ApoB should never be used as a marker for improving your health, at least through statins and stuff.
So there's something which is what of late we have seen, at least in US, that essentially they're talking about more about ApoB. The other factor they're talking about is lipoprotein small a, which is often described as a sort of genetically determined risk factor. So how do we interpret it in the context of overall cardiovascular risk? Is it really a risk? And now there's a sudden rush for this because of new drugs which are coming in, which are on the anvil for lipoprotein reduction, which was essentially always ignored in the past.
Correct. Lipoprotein A is a complex molecule, and I would really advise most of the viewers who want to get an in-depth view of this to go look at my Lp(a) presentation on YouTube. And I really think that the data with lipoprotein(a) is more in favor of protection, because people with high Lp(a) have lower cancer risks, lower mortality. There is no real difference in the risks of cardiovascular disease. The way, and I don't know if I can use one slide to talk about Lp(a), or would you think that
Please use.
Okay, so I'm going to pull that up. I'm going to pull that up right here. Okay, so there is this Lp(a) presentation. So I should go to share my screen. I don't know if I have permission.
It is enabled.
Okay, it's enabled. Excellent. Okay, so I'm going to kind of just show a couple of slides out here. So what is Lp(a)? So this is an LDL molecule, and to an LDL molecule is attached a kringle. So it's called a kringle because it resembles a Danish pastry. And what this kringle is essentially a decoy for plasminogen. So in other words, when our body is forming a blood clot, the blood clot activates because the clotting mechanisms creates a blood clot. But there is a fine balance between creating blood clot and dissolving blood clot. And in order to dissolve blood clot, because if the blood clot becomes too exuberant, the body converts plasminogen to plasmin to break down the blood clot. So what Lp(a) is doing is that it's a decoy. it comes in and it looks like plasminogen. So the factors that activate plasminogen get taken up by LP little a, and you don't activate plasminogen to plasmin, so the blood clot stability remains. So in other words, the blood clot remains stable. So why is LP little a important for us? The reason it's important, and I will not go into a exquisite detail because I want to talk about other things, is that it is helpful in wound healing. So essentially, it heals the wounds. Now, statins, in this slide, you can see that when you take statins, the LP little a levels actually go up. So like Shashi pointed out, as far as statins were concerned, nobody talked about LP little a because statins do nothing to reduce LP little a. However, if you now come here and look at a study in which it evaluated what does LP little a do, and you will find that there is reduced mortality, reduced cancer risk, and I was trying to find that slide, and maybe I will not find it in time. But it, like I had said, it reduces mortality, it reduces the risks of bleeding, it reduces the risks of intracranial bleeding, it reduces cancer risks. And the reason it does that, I think, is because it's intricately involved in wound healing. Now, PCSK9 inhibitors reduce LP little a dramatically. Is that going to help us? I don't think so, because I have several women in my practice who have LP little a's, and I'm going to stop sharing the screen because I don't find the specific slide right now. I have several women in my practice who have very high LP little a levels, and they have no coronary artery disease. So I would say LP little a is the wrong marker for us to look at. And I'll make one other point. People say that LP little a levels are genetically determined, and I agree with that. But there's plenty of data that talks about LP little a levels going up in specific situations, such as a myocardial infarction, such as sepsis. In sepsis, it goes down, and as the sepsis gets better, the LP little a levels come up. So those are important aspects to recognize. And at this point, I would say that there is no firm evidence that LP little a is causal in coronary artery disease, because there is plenty of data in both directions.
So, Anu, before you go ahead on LP little a, I have two questions. It is said that LP little a causes aortic calcification.
Yeah. That is correct. I did not talk about that because I did not want to go into a diversion, but the association of LP little a with aortic valve calcifications is very strong. How causal it is in that, I don't know. So whenever somebody has aortic stenosis, I'm in the habit of measuring their LP little a levels to see whether they will have a higher risk of progression. And I think essentially what LP little a is indicating out there is that the turbulent forces, because in aortic stenosis, the valve is very small and the valve creates turbulence. And turbulence is associated with injury. And whenever there is injury, there is healing mechanisms, and that's why LP little a is there to heal the process. And whether in the process of healing it increases aortic valve calcification is well known, but is it causal? Perhaps. I'm not sure.
Thank you, Anu.
Yeah, to extend on that, expand on that basically for a better understanding. Let's say if somebody has got LPA 5.0, LDL 150. How do we interpret this? And insulin resistance 1.3.
Oh, you mean the HOMA-IR is 1.3?
Yeah.
Somebody has an LDL of 150. and then they have an LP-little levels, you know,
5.0.
like it's 70. Go ahead. So that 5.0, what does that mean in your, because there are several ways of measuring LP-little. Is that high or low? The
It is
LP-little
low. Milligram per deciliter.
Yeah.
low. Low. Okay. Yeah. So that, of course, it would be low. I don't know what that means at all, to be honest with you, because you are just marginally insulin resistant. I don't know what this person's triglycerides are, but let's say that they are low, and let's say their HDL is high. I would just say that those LP-little levels mean nothing.
Thank you. Now, the question is, LDL has always been a concern, but you have already said, there's no importance to it all by itself. But if there is metabolic context attached to it, like insulin resistance versus metabolic health and LDL, how does that, impact the overall interpretation as such?
Again, that's a fabulous question. So the question really is that, is LDL of any value to measure? And of course it is, because it gives you an idea of your metabolic health. So like, for example, somebody who is insulin resistant, they have high insulin levels, they have high HOMA-IR, they have high sugar levels, high A1C, and let's say they also have high triglycerides and low HDL. By design, these people will have a higher number of small, dense LDL particles. So they will have the overall pattern of their cholesterol, LDL cholesterol, as pattern B, and the overall size of the LDL would be smaller. So what does that mean is that you have metabolic ill health. The LDL particles are to some degree damaged, because what is the primary function of LDL? Primary function of LDL is to dampen inflammation, to be around a site where there is injury so that it has antioxidants in it. It has CoQ10, it has vitamin E. The phospholipid layer of the LDL is also an antioxidant. So what it is telling you in a metabolic ill health milieu and looking at LDL particle size is that you are creating some degree of vascular injury. Better improve your health. Better get rid of insulin resistance. Better get rid of the inflammation. Improve your LDL from small dense to large buoyant or larger LDL particles, because that's a marker of health. In my opinion, what it is not telling you is to take a statin, because that is trying to take away a firefighter, which is involved in wound healing, in vascular repair. It's telling you to improve your metabolic health. Go exercise, do fasting, become a part of D-Life India and learn how low-carb diet functions, especially if you're an Indian vegetarian. That is the context in which I view small dense particles. I don't view that context and say, hey, this person has small dense LDL and hence automatically he's in the category of people who needs a statin.
So
Yes,
does it mean that insulin resistance affects the particle size of
Absolutely.
LDL?
Absolutely. When you're insulin resistant, your triglycerides are high, your HDL is low, and because LDL is there, insulin resistance is also associated with vascular injury, with inflammation. And so your LDL is going to be small and dense and not large and fluffy.
Yeah. Anup?
Yeah, there is opinion, I would say opinion or claim that high LDL along with high ApoB is still atherogenic, even on low carb diet. How would you counter this argument?
That's such a good question. So in other words, high LDL is always atherogenic. and no questions asked. And there are several ways of answering that. I don't think anybody has a definitive answer, so I don't claim that everything that I'm saying is substantiated with science. It's substantiated with common sense and pathophysiology, but that is not proof. So high LDL, whether it's atherogenic or no, you can look at it through two ways. Number one way is to look at familial heterozygous hypercholesterolemia. So these are individuals who are born with a defect in their LDL receptor who have a lifetime of high LDL levels. So if you look at several of these cohort studies, several people, several families that have been followed, they live just as long or longer than people born with normal LDL genetics. So in other words, you should see that familial hypercholesterolemia people should have an early cardiovascular death, shorter lifespan. That is not the case. And David Diamond has several presentations that will substantiate what I'm telling you. The second aspect of this is that high LDLs are associated with lower risks of diabetes, and that has been well substantiated in this population. There is a lower risks of infection. There is lower risks of cancer deaths. So these people are living longer, perhaps because they are less susceptible to infection, less susceptible to cancer deaths, and they have a lower incidence of diabetes. So that is one evidence that high LDL may not be culprit in atherogenesis. The second evidence is coming from lean mass hyperresponders. This is David Feldman's work, and he's got the lean mass hyperresponder study, in which people who have had at least 4 years of high LDL, low triglycerides, and high HDL have had lower progression of plaque or comparable progression of plaque. If anything, a little lower progression of coronary calcium compared to individuals, matched individuals for their age, who did not have the same blood physiology. So these groups are providing evidence to us that that is not the case. Now, I could take you through numerous clinical studies in which you could say that the emperor, the statins, does not have any clothes in terms of reducing mortality in the way that you would predict by reducing LDL. But that may be another point I think you have to discuss. So I think we can explain that the association of ApoB with atherogenesis and mortality is not well substantiated. In fact, the data is in the other direction, and it's coming out now.
Do statins really reduce the morbidity and mortality? I will say in two classes. One is one who are diseased with insulin resistance, high blood sugar, and another who was metabolically healthy.
So yes, so what Shashi is saying is that, hey, use statins in people who are insulin resistant, who are metabolically unhealthy, and it may help in that group. And I'm challenging that notion, because to me, it needs to make sense. So let's try to dissect this out. So number one issue with statins is that they will affect your mitochondrial function. Mitochondria need CoQ10 for them to function properly. And statins, and everybody agrees that statins reduce CoQ10 function because there are 25 different steps in the body through which we make cholesterol, and statins stop cholesterol production at the 5th step. At about the 20th step, the cholesterol synthesis pathway diverges and makes CoQ10. So when you affect CoQ10 function, and mitochondria are there everywhere in the body. They are more numerous in the muscles, but they're also there in the brain for brain function. So you would get myopathies, perhaps over 2 to 3 decades of statin use, you would get sarcopenia. In other words, you lose muscle mass. It will affect your brain function and cognition because, as you know, there is a blood-brain barrier. And blood-brain barrier prevents any cholesterol or any CoQ10 from crossing from the blood into the brain. So in a sense, the brain protects itself by making its entirety of cholesterol, its entirety of CoQ10. And statins cross the blood-brain barrier and reduce cholesterol production in the brain. And so you would have lower CoQ10s and in your brain cells, and consequently, it can affect your cognitive function. Statins can make you a diabetic through several different mechanisms. So like, for example, when you take a statin, you increase fat absorption by the liver and the pancreas. So your pancreas becomes fatty. You can become a diabetic through that mechanisms. Another thing is that the insulin receptor is in a part of a cell membrane that is very cholesterol rich. So the orientation of the insulin receptor depends on the amount of cholesterol in your cell membrane, and statins can potentially reduce the cholesterol and can cause insulin resistance. Similarly, they can affect testosterone function. Similarly, LDL molecule is a very important in host defense and in inflammation. So when all of these things, the background of your pathophysiology is put into perspective, and from that background, you evaluate clinical trials. There may be about 1,000 clinical trials that have been done on statins to reduce cardiovascular mortality. And if amongst these thousands of trials, I pick the one trial that showed the maximum benefit and never ever been duplicated, then that would be the FOREST trial. The FOREST trial was the Scandinavian simvastatin study. And in that study, these people had secondary prevention. In other words, these people already had established heart disease, bypass surgery, stents, or heart attacks. So in that group of patients, if you treated 100 people for a year, you would reduce mortality by 0.6%. What that means is 99.4 treated for a year would not benefit. 0.6, or a little more than half a person of the 100 would benefit. So that's a very small degree of benefit. And this is something that should always be emphasized to a patient before a statin is given. Not the relative risk. What they did was they changed that to relative risk of 42% because that appears very impressive. So the robustness of data means that this data should be duplicated. It should be such that any clinical trial that you do with a 25% reduction in cholesterol should show a similar reduction in mortality. And if you reduce cholesterol even further, you should have a larger reduction in mortality. But since then, and it's also worthwhile pointing out that the FOREST trial was done completely by Merck, which means that it was done by the pharmaceutical industry. They gathered all the information. They had all the biostatisticians. They wrote the abstract. This data, this case report forms have never been publicly shared. So if you look at case report forms, you can say, hey, what is the robustness of this data? So there is conflict of interest associated with that. Now we move on and we look at other clinical trials with atorvastatin versus simvastatin. Atorvastatin is a more powerful cholesterol-reducing drug, and it will reduce cholesterol even further, up to 50%, the LDL cholesterol. So you should achieve a higher mortality reduction with atorvastatin versus simvastatin. This was not shown. If you move further and look at Crestor and the Jupiter trial, and mild knew that that was primary prevention, but cholesterol reduction was 53%. And over 1.8 years, the reduction in mortality was 0.27%. Maybe it was 0.35. So it's really very minuscule. Then you move on to the Fourier trial, which is the trial with PCSK9 inhibitors, 14,000 patients in each group. The cholesterol in the PCSK9 group was reduced by 70%. So in other words, their LDL cholesterol was 30 milligrams per deciliter. So when you reduce cholesterol that much, that especially LDL cholesterol, and if LDL cholesterol is a culprit, and if you want to validate your hypothesis that LDL is causal in heart disease, you should have a significant reduction in cardiovascular and total mortality. What happened? The mortality in the PCSK9 group with 70% reduction in LDL actually went up. So how are you substantiating the cholesterol hypothesis based on statin use or PCSK9 use is something that I find very difficult to fathom. And I don't know if you would agree with me when I talk about, of course, I'm talking to the choir, but this is not something that gets across any group of medical professionals.
Anup,
Anup,
you're
muted.
muted.
Sorry about that. Yeah, if LDL isn't the primary, driver of heart disease, then what markers should people focus on instead?
Again, absolutely great question, right? What is something that we should look at? We should look at metabolic health. And metabolic health primarily would be, consider using a CGM, see how much your blood sugar spikes when you eat a specific meal, and design your meal such that you have lower blood sugar spikes. Look at your insulin levels, see how insulin resistant you are. Look at the health of your pancreas. Are you making good insulin, or is your pancreas dead? Look at inflammation markers, CRP, GGT. Look at your liver health. Is your liver healthy? These are the things that I would look at. I would also go a little further and say, focus on seeing if you have enough muscle mass. Because if you don't have enough muscle mass, you are at risk of future injury, future risks of diabetes. Protect your muscle mass, protect your mitochondria. And the way you are going to do that is by eating right, by fasting, and by exercise. And none of this involves any drugs. All of this is lifestyle oriented. And perhaps that's the reason why major medical industry, physician industry is so prescriptive. It's so much easier to prescribe a medicine rather than talk to people about lifestyle. So we are really not focusing on the primary drivers of vascular disease, which is metabolic ill health. And that's what this platform promotes. And I applaud you for that.
Just to add to this, as a coach, so I came across to two mentees or two clients. One of them had been given angioplasty 4 times, re-angioplasty in 7 years, and his insulin resistance was very high. It was HOMA-IR was above 7. And the other one is a doctor actually. He's actually a doctor practicing in US, a general practitioner. He couldn't understand why he got stented 4 times in 5-6 years. When he came to me, I asked for blood markers, especially in resistance. He had a super high insulin value, fasting insulin, about 20. And again, his insulin resistance was M7. And when we put him on a low carb and high fat diet, paradoxically, everything came down. Insulin came down, even triglyceride came down, and we saw one of the highest HDL he has ever seen in 2 decades. So this is just to add to what you say.
Well, thank you, Shashi.
So my other question is, what is the role of inflammation in heart disease or atherosclerosis?
I think it plays the key and primary role in heart disease, and inflammation can come because you have insulin resistance. Inflammation will lead to vascular injury. Vascular injury requires repair. In the process of repair, the LDL can get into the vessel wall. It can be taken up by the macrophages because oxidized LDL cannot be taken up by the liver. It alters the LDL receptor. Now it's been taken up by a different set of receptors called LOX receptors into the macrophages. So there is plenty of evidence that inflammation, whether it is mediated through high blood pressure, whether it is mediated through poor sleep, whether it is mediated through insulin resistance, whether it's mediated through infections, will definitely lead to vascular injury over time. And that is the primary driver of our ill health, and that's what we should focus on. How can we reduce it?
Yeah, Anup.
So, yeah, I would know on inflammation part again, I'll quote some numbers. HSCRP 0.7, ESR 2.0, fasting insulin 5.5. So, any need to worry about it, or it's good enough?
Looks fantastic, right? Your CRP is very low. It's less than 1. Your fasting insulin levels are 5, but you always look at fasting insulin in the context of blood sugar. So if that means if your HOMA-IR is very low. Go ahead.
Yeah. Fasting blood sugar was 95, so HOMA-IR is 1.3.
Yeah, really not bad. I mean, just slightly above normal, but it could be that insulin release is cyclical. So fasting insulin 5 could be, depending on when you drew it, it could be 2.5 to 8 for an insulin level of 5. So yes, so I would say that this person is on the healthy spectrum.
Okay, then this person is me, 14 years after type 2 diabetes without pills.
So see, this is what is very important to understand, is that there are a group of people, I mean, especially people who have critical thinking like you. And in my experience, I have several IIT engineers who come in, they have a hemoglobin A1C like 15 or 14 or 12, and they get diagnosed and they get put on all these medications, and they don't understand why they are on medicines. They look into YouTube video, look into alternative sources of information, and they come see me from like 1,000 miles away, like from different cities. They book a ticket to come see me, and I feel so bad for that, because medical profession is failing the general public. They're failing the general public because they say that diabetes is an incurable disease. It's not. Diabetes can be cured based on how you modify your lifestyle. Now, I should say it cannot be cured in everyone who's got advanced pancreatic damage. And like Shashi mentioned, the specific physician from US who had 4 interventional procedures, he did good on a low-carb, high-fat diet. But as a group, we should always be for science and data, because not everybody who goes on a low-carb, high-fat diet will improve, because a high-fat diet in people who are severely insulin resistant, who have very high triglycerides, in many cases can cause lipotoxicity or fat toxicity and make insulin resistance worse, can make their diabetes worse. So it has always got to be tailored to the individual with follow-up of their blood work. And I have, like I get a lot of hate mail when I say that low carb, high fat diet is not appropriate for everyone, that there is this phenomenon called lipotoxicity or fat toxicity. And many people, when they have advanced insulin resistance, may need to start on a diet that is high protein, low fat, low carb, and focus on fasting and exercise, at least initially until their health improves, is something that should also be looked into.
Yeah, in fact, we do that. It doesn't, when we say low carb, high fat, doesn't mean that we give tons of fat. No, it just comes naturally with food, and we don't advocate too much added fat. And essentially, it is on the lower side, not on the higher side. But significant reduction in carbohydrate actually helps immediately, and we have seen that. And our admiration is mutual. You have been recommending people to D-Life, and even we have been recommending some people to you. In fact, 3-4 months back, I had one person coming from US with very high lipids, very high total cholesterol, very high LDL, and low triglyceride, low insulin. So she was panicky. So I told that I cannot take a decision as a clinician. You please see Dr. Nadir Ali. He's in Texas. I don't know if she got back to you, but she had super high total cholesterol and LDL. So our admiration is always mutual. And for many of my clients based in US, I always take your name and tell them to consult you in case they have any worry on the lipid front. So that is,
Thank you, Shashi.
thank you. Anup, you want to say
Personally,
anything?
Dr. Nadir, personally, Dr. Nadir, I would, I think thank you would be not doing the justice for recommending and praising D-Life. Yes, we've been doing our bit in this space, and as usual, these things are not accepted very fast, but yes, still we are moving ahead. And thank you once again for praising. And yes, before I end, I would like to invite you to the podcast that we hold any day, anytime, whenever it suits you.
I would be honored, Anup. Go ahead. Sorry.
So before we leave, I wanted to give one message to India, keeping in mind the current circumstances in India, that we are all metabolically ill, with high incidence of diabetes. What would you recommend? What is your final take?
Definitely, I would like to say that Indian diabetes is very different. Indian people become diabetic at lower weight, and they are not like Caucasian diabetics. So the Indian pancreas doesn't make a lot of insulin for whatever reason. So I would say that you focus on muscle building, you focus on fasting, you focus on a diet that is not giving you a large amount of carbs. And so that would be my recommendation.
Thank you.
Yeah,
Thank you, Dr.
Nadir. Before we end, a special invitation again. We would love to have you on our podcast whenever you are free, and time and date is your choice.
I'm going to create time for you all, because you all are so important to me. So Shashi, just send me an email and I'll agree to whatever time frame you want.
Thank you.
Thank you. Thank you, Doctor.
Pranam.
Thank you.
Pranam.
Please get Dr. Peter and Jasmeet. Peter, welcome.
Thank you. Honor to be here.
Yeah, welcome, Dr. Pete.
Very excited to be here.
Yeah, okay, let's start. So
Okay.
myself, Dr. Jasmeet, member and a certified metabolic health coach from DLife.in, which is India's first and the only award-winning low-carb platform. DLife was founded in 2014 by Anup Singh. Anup is a silver medalist from IIT Roorkee, and he is a recipient of the Icons of India Award. Anup is a pioneer of the low-carb movement in India with his path-breaking protocol of 100 gram carbs per day max that made LCHF possible for even Indian vegetarians. In 2021, DLife launched its diploma course, which is the only course approved under the NSDC partner, the Government of India in this segment, and the only course with the global biggest 144 CPDRs credit. So now, coming to my esteemed guest, so let me take a pleasure to introduce you to our audience. So Dr. Pete Delanoy, he is a PhD in biochemist and with over 28 years of teaching experience, and now has turned the keto coach. His personal health journey began when he was diagnosed with the pre-diabetes and gout. After struggling with the traditional medical advice, he turned to the ketogenic diet, which led significant improvements in his health. Dr. Pete now runs a coaching company, Ketonic Revolution, aimed at helping others reverse the chronic disease through the dietary interventions. He is highly qualified and he is also a nutrition network coach practitioner. So for this session of the Metabolic Health Conference, we are going to talk all about the uric acid and clarify many misconceptions surrounding it. So while uric acid is often viewed as a biomarker for the gout or arthritis, its metabolic effect on metabolic processes are much broader. So we are fortunate to have with us Professor Pete Delanoy, a leading expert in the implications of uric acid for the metabolic health. So please join us for the discussion. So Dr. Pete, welcome again to the Metabolic Health Conference, Season 3.
Thank you very much. I'm super honored to be here, and let's get started.
Yeah. So my first question to you, let's just to start with, I would like you to come up with your personal journey and explore what made you interested in the field of health and nutrition as a biochemist.
So 7 years ago, I'm in my 7th year. I was diagnosed as being pre-diabetic, and before that with gout. And the pre-diabetes is the thing that really scared me, because basically what my doctor was telling me was that this is just progressive, and that I would be type 2 diabetic down the road, but that, you know, that they had really good drugs for this. But I am a biochemist, and I did research before I went into teaching, and I understood at the time that prediabetes and the gout were metabolic, and as such, they should be responsive to basically what you eat. And I do want to qualify this, because we know that there are the other factors that are involved in this, exercise, muscle mass, and all of those other factors, sleep, you know, and so on down the road. But by far, I think you can argue that the biggest factor here is the aspect of metabolics. So I struggled and did what the doctors asked me to do for a while, but I saw that my fasting glucose and A1C were rising. And eventually, to make a long story short, because I know we don't have a lot of time, I found my way to the low carb environment, and the early studies that were published by Virta, and reversed my prediabetes in a very short time frame. But one of the lagging questions in this was the fact that I was hyperuricemic. So I had high uric acid. And in the process of going to the low carb lifestyle, I saw that that condition rose significantly. And then it did fall with keto adaptation, but it only falls to the hyperuricemic level. And as you already told our audience, I have a great deal of coaching experience then, which then has ensued with this. And I know that when people that are hyperuricemic to start with go on a ketogenic diet or they're carnivore, once they get to an how do I want to say this, an established metabolism. So for a someone who's on a ketogenic diet, they become keto adapted. This takes, you know, with especially older individuals, this takes months before that happens. And the carnivore diet is a little bit different, because these are in fact two different physiological states. They're related. There's a lot of overlap, and they are completely distinct from the standard American diet physiologically. But the hyperuricemia remained, and I think, as you know, there's a lot of influencers involved in this space that are asking the question, is hyperuricemia safe on a ketogenic diet and so on? And so as a scientist, I went into the literature in the early days, 7 years ago, basically, to look at what I could find in regard to the science. And as I think everyone in this space does, when you first are confronted with the low carb environment, you're like, okay, people are saying if I do this, I can reverse my disease. And they read stuff like from Gary Taubes and Nina Teicholz. But I'm talking about going a lot deeper here because for me, I had two questions at the very beginning of this. And one of those questions was, what is the biochemistry that's actually driving these diseases? And as a trained biochemist, I understood that if you make a list of all the chronic metabolic diseases that we're suffering from, obesity, diabetes, the gout situation, hyperuricemia, chronic kidney disease, yada, yada, down the road you go. There's a tendency to assign a biochemical mechanism to each and every one of those, which is when trying to understand a biological function is the first mistake that people make when they start to study the science, right? Is to invent 30 different hypotheses for 30 different illnesses. And I understood that if we're dealing with something that is metabolically, has a metabolic origin here, that there can only be a few central biochemical mechanisms that are leading to all of this. It's just the nuances with how this happens. So I started looking at gout specifically to answer this question that I was getting a barrage on my YouTube channel, and in meetings you hear this coming up. I have hyperuricemia, I suffer from gout. Is it safe for me to be on the ketogenic diet? That's where this started. And uric acid took me to basically Rick Johnson's work, and to be fair, his collaborators, because he works with a team of people, and those guys have literally published hundreds of publications. And I started looking at uric acid, and I learned right away that, number one, the fructose uric acid pathway is a central driver of all metabolic diseases. I've learned this. There's different, when you look at a bell curve of individuals, and they have, different metabolic diseases, one of the first things that you see is that there's a tremendous amount of overlap. Somebody who's obese, it's usually rare that they're not suffering from something else that's related, right? For example, gout sufferers, 74% of them also are hypertensive, right? They have either their borderline high blood pressure or they have high blood pressure. 71% suffer from some level of chronic kidney disease, which, by the way, is because of fructose uric acid biochemistry in the kidney, all right? And I learned right away that because of the polyol pathway, which is found in all human tissue where it has rigorously been looked at, and because we're low on time, I'm just going to blurt out the line for this. Fructose uric acid metabolism is as dependent on glucose as it is fructose. And we just have published a major paper in this area that I'm lead author on in the Journal of in the Biochemical Journal out of the UK. And this is going to be in whatever the next issue is. I just got the proofs for it yesterday, but that article was a direct response, basically, after I had produced a video in this area. It was a direct response to a video I saw a couple summers ago, where one of the lead scientists in the carbohydrate insulin model of obesity, he was asked during that presentation, what is the role of fructose in this, in driving obesity? And he said, well, there isn't any because fructose doesn't stimulate insulin. And I fell out of my seat. And the reason I fell out of my seat when I heard that is because I know full well that opening fructose uric acid metabolism, which I believe is going on in the chondrocyte and is a central driver of, therefore, of gout, depends as much on the glucose as it does on fructose.
So, Dr.
And
Pete, before we get into this, I think it would be better for the audience if you can talk a little bit about the polyol pathway and that fructose uric acid metabolism. And you also mentioned that glucose plays a major role in that as well, because, when it comes to the fructose, people, they just say like it doesn't, trigger the insulin stimulation. So could you please talk more about polyol pathway and how the uric acid is being produced inside the body?
Okay, so first, if we just focus on the fructose aspect of this, when someone takes in fructose, if we just talk about the liver effect, now we do have to be careful here because most of the fructose that you take in, so say somebody drinks a soda, like a Coca-Cola that has a lot of sugar in it, or they have a concentrated fruit juice, for example, which has a lot of fructose in it. Recognize that most of the fructose that's coming in there is converted to glucose by our intestine. But when the amount of fructose coming in is super highly concentrated, there's a certain fraction of that fructose that is going to reach the liver. And fructose, along with alcohol, I know this stuff is really complex, but along with alcohol is a profound activator of fructose uric acid metabolism. And what happens there when fructose enters the liver is that there is an acute decline in our energy, right? And to keep things as simple as possible, we'll just call it an acute decline in ATP. And when that happens, you see an acute rise in uric acid. And what is on an intracellular basis, all right, inside the liver. And what isn't uniformly understood is that uric acid is, in fact, a signaling molecule. So when you have that is responsive to any biochemical process that happens in any of the tissues where this occurs, to acute changes in ATP. So in the liver, you have this fructose effect. ATP declines dramatically along with phosphate, by the way. You have this acute rise in uric acid, which is a signaling molecule, which downstream drives mitochondrial dysfunction and a shift to the synthesis of fat directly in the liver and also glycogen, but stimulates directly systemic inflammation, an alteration in nitric oxide signaling, which downstream affects significantly not only blood pressure, but it significantly alters the metabolism of the cellular layer that lines our arteries, along with other effects. So the uric acid effect is very important to the metabolic effects that are driving most, if not all, metabolic diseases. And because of the mitochondrial dysfunction that happens, if you do this decade after decade after decade, this actually in the long term leads to mitochondrial insufficiency and the cancer condition. And then one aspect of this that I think probably none of the other influencers are even going to discuss, when this happens in the liver, this drives substantial peripheral effects. So the liver sends signaling along with uric acid and lactate into the peripheral circulation. So we're talking about changes in regulation, metabolic regulation at the level of muscle, adipose tissue, and perhaps very significantly in the brain.
So basically what you mean to say is like fructose, it actively reduces the ATP levels in the cells. It affects the mitochondria and then the body enters the storage mode. Is it something like body, whatsoever you are feeding, body is not able to produce active energy and it's producing the storage mode?
Yes.
Okay.
And when we come back and we ask the question, okay, so because that argument I just gave you makes it sound like, okay, so we don't have an issue with glucose then, but we do, because in the liver and all human tissues where this has been looked for rigorously, we have the enzyme aldose reductase. Now, in the liver, when you look at the historical biochemical data, I'm not talking about any of the observational stuff, no associational, none of that external sort of like literature that is not so good. When you go back and you look at specific biochemical literature that was published, peer-reviewed, high-quality work, starting with Warburg, and then Hans Krebs and Veitch, and then coming forward into the 60s through the 80s, with the literature that was published there, right up to the nutritional guidelines when they were published in the early 80s, where the kind of literature I'm talking about was then defunded over the following decades. What you see is that aldose reductase, along with the primary protein that activates the processing of glucose, both of these are glucokinase, both very similar proteins. When you look at them biochemically, their evolutionary origin came before the more complex protein and enzyme systems that we have in animal cells, right? The ones like hemoglobin that are all multi-subunited and all of that. These two proteins, glucokinase and aldose reductase, are actually activated biochemically, very strong evidence for this, under very similar incoming glucose conditions, which the activation is happening somewhere close to 90 mg per deciliter of intracellular glucose. And the reason and it's around this value, the reason that I have to hedge on this is because we don't have enough biochemical studies, in vitro studies, and in vivo studies that have been done on this. It hasn't been pushed on hard enough. But here's the thing. We know that aldose reductase, which is the first rate-limiting enzyme responsible for opening the polyol pathway, which is a two-step pathway that produces fructose directly in the liver from glucose.
Okay.
And once we activate aldose reductase, 30% of the glucose that's in the liver is now being pushed directly into making endogenous fructose. And endogenous fructose, at the point where you're making that, the fructose uric acid pathway is blown wide open.
So basically, if a person is a type 2 diabetic, okay,
Yeah.
and he is consuming a lot of fructose, so all that fructose will be then turned into the glucose of the polyol pathway, because you mentioned those enzymes get activated after a certain level of the blood glucose.
Yes.
So if a person is already insulin resistance, so that can elevate the uric acid levels?
Okay, so hold on, because the insulin resistance issue is what I call a macroscopic control that is in fact involved in all this. But where does the insulin resistance come from? Well, when you activate glucose, and so I'm going to call it by what I think is more correct. When you activate glucose, fructose, uric acid metabolism, the type 2 diabetic, so in all of this, let me just back up 1 minute. You have two things going on here. Activating aldose reductase, right? So that you're feeding glucose directly into fructose uric acid metabolism. But when you do this, and when you have incoming fructose along with the elevated glucose, you also increase the expression of a number of different enzymes. One of those crucial to this is aldose reductase. So not only are you activating it, but you're making more of it. So basically, you're just you're just kicking the soccer ball of glucose harder into the formation of endogenous fructose, which literally like a funnel is falling into this pathway. You have accelerated glycolysis, you have the elevation of lactate, you have all those things. And then what I said was, and this is super important, you have a tremendous amount of liver signaling that's going downstream. You have the direction of hyperinsulinemia into the peripheral tissues. You have insulin resistant signaling that also is being pushed downstream, which is driving, I think everyone, like if you guys are talking to Bickman, everyone agrees that hyperinsulinemia that's getting pushed into the peripheral tissues is driving insulin resistance. So there's a direct connection of, in regard to very strong associational evidence here that when you activate these pathways in the liver, you're driving hyperinsulinemia and insulin resistance downstream. So all of that is part of this.
So is it a bidirectional relation? So the high uric acid in itself can cause the insulin resistance that you mentioned. And once you are insulin resistance, you activate that polyol pathway. So it's like bidirectional. So it's a vicious cycle that person gets into.
Okay, so you raise now the issue of hyperinsulinemia. So I think that hyperinsulinemia and gout is a window into the soul of chronic metabolic disease. The only difference between, in my view, the only difference between somebody who's hyperinsulinemic or who has chronically high uric acid. So if you look at a type 2 diabetic and you ask the question, do they have high uric acid or not? Well, a lot of them don't. The distinction is now something that you have to take into consideration between a diabetic that has high uric acid and a diabetic that does not, because the distinction has to do with what's happening to the uric acid in the kidney. And for people that are hyperuricemic, high uric acid chronically, they have an excretion defect, which is genetically inherent in our population. So when I say our, I mean people like me that are hyperuricemic and also a gout sufferer, right? But the non-gout sufferers, they still have the excretion defect. Now, in studying those guys, what can we learn about these biochemical pathways that I believe that these central mechanisms that are leading to this whole constellation options, if you will, of a chronic metabolic disease that someone is going to end up with? Well, there have been a ton of both in vitro, in vivo, and mouse studies, for example, animal studies, and I think even some human clinical studies that show unequivocally that when uric acid is running high, it can diffuse into the tissue of interest, and it can elicit the same intracellular effects as if it was produced in that organ. We know this for sure with kidneys. You can diffuse uric acid into a kidney, and you're going to get out all of the pathological conditions that eventually lead to chronic kidney disease. And when you look critically, for example, at the gout data, you see the same phenomenon. We know that you can diffuse uric acid into a chondrocyte, the biologically important cell that is responsible for maintaining the health of our joints. And you see the same intracellular oxidative stress and so on, as if the uric acid was produced intracellularly. And also, this is important to mention, we know when you look at the chondrocyte and you go back into the high quality biochemical data that has been published in the past, that uric acid is in fact produced in the chondrocytes of gouty subjects, and there's even modern data on this. There's a group in New Zealand. The senior researcher there is Anthony Kettle, and I want to mention these other guys who are involved in this: Rufus Turner, Lisa Stamp, and Flavia Miotti, the Miotti papers. They have shown also with very good specific biochemical research that uric acid is in fact produced by chondrocytes. So every tissue where you can identify significant production of uric acid when you change the phosphorylation potential. So when you let ATP fall involved in these kinds of biochemical processes, when you diffuse uric acid in, you can have over the long term the same kind of pathological effects that you see when it's being produced directly in the tissue. So hyperuricemic people, of which we've got approximately 43 million in the US, and India has a bigger population. So I would imagine that your hyperuricemic population there is going to even be bigger than ours. And then we have a little bit over 4% of that who are also gout sufferers. So I imagine that you have this going on in India too in regard to lifestyle.
So, Dr. Pete, you mentioned like uric acid is being produced inside the chondrocytes. So it's an intracellular uric acid production. But when we see like so many people here, like they have gout, but their serum uric acid level is normal. So is it something like the intracellular uric acid is causing that gout?
So let me try to do this in one sentence that's going to sum this up. We know from the research that came from the 60s, the 70s, and the 80s, and then very recently from the Kettle studies, that the intracellular uric acid is involved in this because you have this elevation of systemic inflammation that happens in the chondrocyte. We know from the Kettle work and this previous research that uric acid is diffused out into the extracellular matrix of the synovium. And the Kettle data is very interesting because it suggests that the uric acid that is extracellular, which is pushed because it's rising to a higher concentration intracellularly, it comes out into the synovium, and out there it's involved in an oxidation reduction network with at least 3 other factors: ascorbate, a protein like or is myeloperoxidase, and a urate radical. And when the concentration of uric acid in that redox circuit rises to a high enough concentration, then you can get the formation of seed crystals. And the track into a gout flare requires 2 steps, because once those seed crystals form, if they get modulated quick enough, in other words, converted back into soluble uric acid, then you cannot advance to the second step, which involves, this flood of neutrophils and macrophages and then get the flare. So the crux, or the most important aspect of gout, is what's happening in step 1. And if the seed crystals rise to some threshold which is unknown, then the processing of those crystals kinetically will not happen at a high enough rate. And you advance to this next step where the macrophages are overwhelmed, they start to break apart literally, and you get this cascade with the neutrophils into the actual flare, which is super hot. You know, there's a higher temperature and a pain threshold, which most gout sufferers are going to say is a 10 on the scale of 1 to 10.
So, Dr. Pete, my next question is like, how important is the early diagnosis of the elevated levels of the uric acid? As you mentioned that it can lead to the various degenerative diseases. But when you say like the high uric acid level, what levels of the uric acid you consider high?
So that is a really good question. And well, you asked more than one, but here's the thing, right? We don't really know what normal uric acid is in a human. We know if you look back at early historical data in the early 1900s, the average uric acid in our population, both men and women, was around 4 mg per deciliter, around 4 mg per deciliter. And now that average is around 6 mg per deciliter. In our space, you're going to have, there's a lot of hand waving in the low carb community because we know uric acid rises, right? Or both on carnivore and in a low carb environment. And these guys will argue, okay, well, when you reach keto adaptation, the uric acid comes back down to 6 mg per deciliter. That's the average in our population, so everything's okay. But the truth of the matter is, because uric acid historically anymore is not measured, it might not have ever been done, measured when in our children and then young adults and so on coming forward, we don't know when the hyperuricemia, is it there from the beginning? Is this a genetic thing that in part of the population, this is the way it is? We don't really have an answer to that. And quite frankly, when I raised the issue about the fact that in the early 1900s, the average was around 4 mg per deciliter, and now it's 6, that usually causes whoever I'm talking to go silent. And honestly, when you look at the data that's out there, which is almost completely associational and whatnot, it's multifactorial. You can't say, for example, it's because we're eating more protein now, because honestly, eating meat hasn't changed that much. I suspect it's a matter of the rise of sugar consumption, processed food, along with the rise of alcohol, and while meat. Okay, so be really careful about putting blame on meat, because eating protein is only a small contributing factor to elevated uric acid. The majority of the effect is a sugar effect and an alcohol effect, right? If you take in a high quantity of sugar with both elevated glucose and or elevated fructose and have alcoholic drinks while you're doing this, so if you're looking at a plate of food that's hyperglycemic, lots of potatoes and rice and a sugary dessert, maybe you're having an alcoholic drink like a daiquiri would fall into this category that also has sugar in it and so on, you are going to be overproducing uric acid in your liver, whether you want to or not, along with lactate effect that it's pushed into the peripheral circulation and all of the things that we were talking about, the downstream signaling in regard to insulin and lactate signaling, actually, because uric acid and lactate, along with beta hydroxybutyrate and acetate, all of these small molecules, evolutionarily speaking, were involved in the control of our metabolic pathways a long time, millions of years before you had the macroscopic controls like cortisol, insulin, and all of these, this next layer of regulation.
So, Dr. Pete, my follow-up question for this, like you mentioned, the uric acid production, it depends on the consumption of your fructose, alcohol, and hyperglycemia. But what about the salt? Like when the high carb diet, the standard American diet, is in combination with the salt, is there any relation that it can activate the polyol pathway?
Yes. So the activation of the polyol pathways is affected, right? You have an increase in expression of that enzyme under conditions of hyperglycemia, under conditions of alcohol, under conditions of sugar. And when I say that, I mean it generally. So however you're getting it in there, table sugar with glucose, fructose, and so on, and the elevation of salt, right? And hypoxia. This is why the sleep apnea problem is tied into driving chronic metabolic diseases and gout, because hypoxia activates and increases the expression of aldose reductase, which then increases our sensitivity to incoming glucose in the liver. And this is why, and I know where you're going with this. So one thing, I know that we're running out of time here. So very quickly, when you shift to a low carb diet or carnivore, because we're bringing the insulin expression down, you see a change in relationship with incoming salt at the level of kidney. So we have to really be careful here, because we're talking about different physiological states. So somebody on the standard American diet, in general, right? And part of this comment is coming from 7 years of coaching really sick people. But basically, they are just eating a plate that's hyperglycemic with a lot of sugar coming in and alcohol, usually for the adults. A lot of times, they're also eating a high quantity of processed food. And processed food, what does it have in it? Normally, it's going to be hyperglycemic. There's going to be sugar in there. And they have altered the salt and also other things that we haven't even talked about here, like glutamate and compounds related to glutamate, along with certain types of fats. And I didn't even get to the part about glutamate and the fats, because they also are contributing to opening in a very big way this central metabolic pathway that's driving downstream chronic metabolic disease. Now, when we switch to a low carb environment and or carnivore, everyone knows you've got to modulate the salt. And that's because when you pull the insulin off, now we're pushing during the keto adaptation phase, we're pushing salt out into the urine. And to avoid the keto flu, I'm just going to call it that, you've got to make sure to be getting the right amount of salt. You have to be taking in more of it. But eventually, in the case, this is looking downstream, right? At guys like me, perhaps you, I'm not sure where you are in the journey, right? But I've been doing this for 7 years. And I've been eating this way religiously. And I don't mean willy-nilly. I mean, I took my biomarkers this morning before I talked with you, because I'm still trying to, coming back into the science, understand what's going on here. And because of my work in looking at the actual science that was published by Warburg, by Hans Krebs and Veitch, I know that the standard American person eating the standard American diet and compared to the ketogenic person, by comparison to a carnivore person, that these are all defined physiological states. And our processing of energy is dependent on the ions that are related to how our cellular systems are able to process ATP, to keep the ATP levels, the proportionalities of our energy correct and in a zone where our tissues can function. And the fluctuation of ATP compared to its other to its other related molecules is dependent on the sodium, the potassium, the magnesium, the calcium, and other ions that I can't, like bicarbonate that I can't think of right now. And I know I'm going into the weeds with this, but this is so super important to us, because these physiological states are driven by these mechanisms. And even though low carb and carnivore overlap significantly, right, we have similarities, much more similar than the standard American diet. Your relationship with salt will change the longer you're in a low carb environment, right? This idea that keto adaptation happens and then you're done is not correct. The longer you're in this environment, the more our physiological state in regard to how we respond to incoming nutrients is going to become more formatted in a way, to think of a term with that. All right, and I better pause there.
Yeah, so Dr. Pete, really, so I'm so excited about this topic now after listening to your session. So one more thing I would like to ask. I know that you are a very active researcher and you are studying actively more on the uric acid. I think if you have certain latest studies or interventions about the uric acid that you would like to talk.
Okay, so people ask me all the time that are hyperuricemic, what do I do? I'm on this low carb and I'm seeing these extreme values. Okay, so step number one, before you think of any other interventions, it's to get stable with your metabolism. And what do I mean by that? You need to get keto adapted, number one. If you've gone onto a ketogenic diet, you need to get keto adapted. And in this space, a lot of the investigators or whatnot are going to say this is around 3 months. But for old people like me, I'm 66 years old. I know from experience and working with a lot of clients that keto adaptation in older people can be significantly longer. I would say you're probably looking at a year, maybe even. So you need to get stable in the lifestyle and let your uric acid come to a level which is normal for you. And if you are hyperuricemic at that point, then you have a decision to make. And the big thing is that understand that we really, when it boils down to it, push comes to shove, we don't know if hyperuricemia is safe or not. I'll take anyone that wants to argue about that to task. We really don't know. The only thing that we've got are observational and associational studies, and a lot of them point to that you're at a higher cardiovascular risk for some type of an event. So here's what I tell everyone who asks me this question. At that point then, that you're still hyperuricemic, either on the carnivore diet or on a ketogenic diet, and I mean ketogenic now, so 50 grams of total carbs or less per day, then you've got a personal decision to make. Do I go into urate lowering or not? And if you decide you're going to do it, I think the best way, and there's a lot of supplemental things you can do and whatnot, but I believe you should just go for the throat and consider allopurinol. But you need to titrate onto that. Going to your medical provider and saying, okay, I'm hyperuricemic, I want to go on allopurinol, that doctor might say to you, okay, we're going to put you on 600 mgs of allopurinol per day or something like that. And that is not the way to do it. What you want to do is start low and titrate yourself up over several months. And what do you want to settle at for a concentration of uric acid? I believe you go with the concentration of uric acid that people were expressing in the early 1900s, because that was before the advent of all of this sugar and alcohol evenly across our population, which is about between 4 and 5 mg per deciliter. That's the target. Now, you also, it turns out, can attack the excretion phenomenon at the level of the kidney, and you do that with glycine. right? And there's been really good, high quality studies done that have shown in a dosage dependent manner that if you increase the amount of glycine in your diet, that will directly cause uric acid lowering, because it increases the excretion of uric acid at the level of the kidney. And I've experimented directly with all of this methodology, and you can use both the glycine and the allopurinol together. And so what I recommend, if you're going to attack the hyperuricemia, that you very carefully titrate up the allopurinol over a matter of months. Your target is around 4 to 5 mg per deciliter of uric acid, and you couple that with glycine and find where your equilibrium best works. And then I guess people are probably asking the question right
Dr.
now.
Pete, I'm really sorry to stop you, but because we are already running out of time, so it's
okay.
So yeah,
You can measure your uric acid with a meter. All right, that's it.
So okay, so so before we close the session, I would like to call Shashiji and Anup Singh.
I'm sorry, say that again.
Yeah. Peter, thank you. I just came to thank you for coming in this conference. And I always had your mind that you are an authority on uric acid and gout. Since I saw multiple presentations, especially Nutrition Network, I always had you in mind, and I was just waiting for a particular event. So thank you very much, and we will meet again. Probably we'll invite you in a podcast where we can have extensive discussion, and Jasmeet will host you again. Anup.
Awesome. I
Yeah,
would
thank
love
you.
to do that. Thank you.
Thank you, Dr. Peter. And before I sign off, I think I will have to listen to this episode at least 10 times to get hold of everything. It was such a brilliant one that you can take it as I would say not less than 10 times, because every minute you have been talking science and every minute you've been talking data. Thank you. Thank you very much. And we'll have
Thank
you
you so
on
much, Dr. Pete.
yeah, we'll
Thanks
have
for
you on a
having me.
podcast. Yeah, we'll have you on a podcast for sure.
Yeah.
Awesome. I'd love to do that anytime.
Thank you.
Thanks you
So-
guys for having me. All right, bye.
Bye. Please get Dr. Chris in and Sandesh. Dr. Chris, hello.
Hi, Sandesh.
Hello, Dr. Chris.
Thanks for having me on.
Thanks for your time and very good morning.
Good morning. Good evening to you in India.
Yeah, thank you so much. All right, we get started right here. Hello, guys. I am Sandesh Bhatt, a certified low-carb nutrition and metabolic health coach from DLife.in, India's first and the only award-winning low-carb platform. DLife was founded in 2014 by Anup Singh, a silver medalist from IIT Roorkee, India, and the recipient of Icons of India Award. Anup is the pioneer of the low-carb movement in India with his path-breaking protocol of 100 grams per day, making low-carb, high-fat diets possible for Indians. In 2021, DLife launched its diploma course, which is the only course in its segment that is approved under NSTC, Government of India, and the only closed course with the 144 hours CPD credit. Anup, along with Shashikant Iyengar, are the organizers of this Metabolic Health Conference. Friends, it's my privilege and honor to have Dr. Chris Kenobi here with us today. I have followed Dr. Chris for a really long time and probably watched most of his presentations, if not all of them. Dr. Chris Kenobi, MD, is a physician, public health advocate, researcher, ophthalmologist, and associate clinical professor emeritus, formerly of the University of Texas Southwestern Medical Center in Dallas, Texas. Dr. Kenobi is known primarily for his research, publications, and presentations connecting westernized diets causally to numerous chronic diseases, including heart disease, hypertension, stroke, cancers, type 2 diabetes, and his area, age-related macular degeneration. Dr. Kenobi's research has focused greatly on the dangers of vegetable oils in India. We call them edible oils, and their unequal contributions to chronic disease. In the field of ophthalmology, Dr. Kanobi is known for his revolutionary hypothesis and supportive research regarding the potentially blinding eye disease, age-related macular degeneration. Dr. Kanobi's hypothesis holds that AMD is driven by processed, nutrient-deficient, and toxic foods, of which vegetable seed oils are the most pernicious and deleterious. Dr. Kanobi is the author of 2 books in the field of nutrition, The Ancestral Diet Revolution and The Ancestral Diet Strategy to Prevent and Treat Macular Degeneration. In the spirit of being as pictorial as possible, I'd love to share a quick screenshot of Doctor's work that I captured from his website. All right, Dr. Chris, the floor is yours, and we are so humbled to hear from you.
Thank you, Sandesh. Let me go ahead and share my screen. Looks like you'll have to give me permission.
All right.
Okay. Let's see. Here we go. Just one moment.
You're all set.
All set. Good. So thank you so very much for this honor of being able to present here at the 3rd Metabolic Conference of India. Today, ladies and gentlemen, I want to discuss this question. Are the industrial seed oils the major drivers of overweight, obesity, diabetes, and virtually all chronic disease? So the question is, are we currently enduring a seed oil apocalypse? Now, you may think this sounds awfully dramatic, but it is not. Let me give you some perspective. In the United States, throughout all of American history, 1.3 million American military battle deaths have occurred. 1.3 million. Think about that for just a moment. That's a lot of people, but today, 1.65 million Americans die every year just from cardiovascular disease, cancer, and diabetes, just those 3. In fact, 1.7 million people, more than 1.7 million people die of chronic disease in the US every single year today. We have the most gargantuan, probably the most sophisticated hospitals and hospital systems in the world. And yet we've come to think that this is normal, right? I believe this is, people look at this and think this is normal, right? The United States spends more on healthcare than any other country in the world. And we have the worst health outcomes among high-income countries, the worst health outcomes. Interestingly, from this paper, I quote, the US has both the highest obesity rate in the developed world and the highest consumption of seed oils per person than any other nation. Where did they get that data? They got it from me. We published a paper in 2017, and this followed that. So my charge to you today is that vegetable oils, primarily the industrial seed oils, are chronic metabolic biological poisons. And today I want to try to show you how and why. So let me begin with the thinking in the United States. So allopathic medicine believes this, basically. This is a paper from Dariush Matsafarian at Tufts University in Boston, Massachusetts. Here's the title, Prospective Obesity, an Unexplained Epidemic. And in this paper, Matsafarian publishes this graph. Now, I've labeled it to make it easier to review, but you can see that in 1999, right over here, obesity in the United States was 30.5%. That grew to 42.5% by 2018. But look at the total energy available and consumed at the top and bottom here. So total energy available began to drop after 2005 and 6. This is total energy or food consumed, essentially. This is total energy actually consumed. And after 2003 and 4, it statistically significantly dropped. So we cannot explain obesity with calories any longer. All right. Let me give you a little bit of history in the United States that you may not be aware of. So coronary heart disease was virtually unknown in the 19th century. 8 scientific papers for the entire century. In fact, it was 1912, James Herrick published the first known documented case of myocardial infarction, heart attack. 1930s, coronary heart disease became the leading cause of death, but think about it, it wasn't even known in 1910. Today, about 1 in 3 Americans, 32%, die of coronary heart disease. How about cancer? So cancer took the lives of 1 in 188 Americans back in 1811. That increased to 1 in 17 deaths due to cancer in 1900. It's almost 1 in 3 again today. It's 31.2%, I believe, is the number. That's a 62-fold increase in cancer deaths in 200 years. How about type 2 diabetes, or just diabetes in general? The prevalence of diabetes in the United States in 1890 was 0.0028%. That's about 1 in 36,000 people. That increased 132-fold by 1935 to 0.37%. Then it tripled by 1960 to 0.91%, tripled again by 1991 to 2.97%, more than doubled by 2010 to 6.95%, and that more than doubled again by 2023 to 15.8%. This is a 5,643-fold increase in diabetes in 133 years. Now, if the number had doubled, that would be statistically significant. It's gone up 5,643-fold. Let's look at Alzheimer's and dementia. So the first known case documented 1908 by Alois Alzheimer, physician in Germany. There were 4 cases, I believe it was, in 1910, 150 cases in 1948. Today, 2023, 55 million cases of Alzheimer's and dementia around the world, and 10 million new cases per year. That's 1 new case every 3 seconds. How about obesity? So obesity in the United States was 1.2% in men age 18 to 80 in the last several decades of the 19th century, about 1860 to 1900. From there, obesity increased 11-fold to 13% by 1960, to 23% by 1988, 30.5% by 1999. Clear over here, 2018, 42.5% of Americans are obese, and another 31.2%, I believe it is, overweight. That makes 74% of Americans are either overweight or obese. All right. Well, what's driving this? This graph right here, if you just looked at the dark part without all these pop-ups here, that would be what would come up on a PowerPoint. But you can see this is what happened with vegetable oils in the United States. We were at 0 over here on the left side of the graph in 1865. We were at 1 gram a day in 1900, 19 grams a day by 1960, 80 grams per person per day by 2010. 80 grams is 720 calories. That's 32% of US caloric intake. All right, now think of this. In 1900, 99% of our added fats in the diet came from animal fat. But by 2005, 86% of added fats came from vegetable oils. So the vegetable oils almost completely supplanted and replaced animal fat, right? Okay. Well, is it sugar? Well, take a look at this. Here's sugar versus obesity. And I hope you'll see quite quickly that there is not a very strong correlation here. There's quite a disconnect. Sugar has risen tremendously. In fact, it rose from between 1822 and 1999, where sugar consumption peaked. Consumption increased 17-fold. But almost all of that increase had occurred by here, which is this peak right here is 1922. All right, so since then, sugar's only increased, around 10-20% in the following decades. All right, and so think about that by 1922. So why obesity in 1930 was about 3 or 4%, but sugar consumption was 499 calories. Now, that's 1930. But over here in 2016, sugar consumption is 526 calories. It's 27 calories higher than it was in 1930. And yet obesity climbed from about 3 or 4% to 42.5%. So I hope you see a big disconnect there. Now, people will say, well, what kind of sugar are you talking about? Every form of added sugar there is. This is the FAO definition, the Food and Agriculture Organization of the United Nations, and the USDA has the exact same definition. And it goes like this. Added sugars include sugars added during the processing of foods such as sucrose and dextrose, foods packaged as sweeteners such as table sugar, sugars from syrups, which includes corn syrup, high fructose corn syrup, and maple syrup, and honey, and sugars from concentrated fruit or vegetable juices. So it's every form of added sugar you can think of. This does not include fruit sugar. That's not really measurable or not very well. All right. So take a look at this. Now I've narrowed down that graph on sugar versus obesity just to this 65-year period between 1922 and 1987. So in 1922, we were consuming 473 calories worth of sugar. 1987, 497 calories. It's up 24 calories, which is 5%. So it's basically flat. Anyone can see this is flat for 65 years. But obesity climbed from 2.95% to 18.6%. So now I want to bring in vegetable oils, right? So here's vegetable oils, 78 calories in 1922, 550 calories in 1987. So during this time frame, 65 years between 1922 and 1987, sugar increased 5%, vegetable oils increased 605%, and obesity increased 532%, which is 6.32-fold. So for sugar theorists who are pointing the finger at sugar, how do they answer this? Sugar is not changing, and obesity has gone up 6.3-fold over a 65-year period of time in the United States. So let's bring the vegetable oils in here. Now look at this incredibly tight correlation between the vegetable oils and obesity. So back here in 1900, when obesity was 1.2%, what were we consuming in vegetable oils? 1 gram a day, approximately. In 1961, here, obesity is 13.4%. We were consuming 19 grams of vegetable oils per day. Here, where obesity is in 2018 is 42.5%, we're consuming about 80 grams per person per day. So I hope you'll see now, and there's so much more evidence behind this, but I have to go quickly, but obesity shows a striking correlation with vegetable oils, far less correlation, even negative, as we'll get to. You can see sugar going down since 1999, and so a much poorer correlation to sugar. So this is just between, now we're kind of going back to the same date I began with, 1999 to 2018, where obesity increased from 30.5% to 42.5%. And so here's the obesity in the red. But look at the sugar trend. It's down, right? Sugar has been going down since about 1999. So now let's look at diabetes versus sugar and vegetable oils in the United States. So first, again, notice here's the diabetes prevalence. Remember, we started at 0.0028% in 1890, and that increased 132-fold by 1935 to here we are, 0.37%. Look how high the sugar is. It's 22.5% of calories, 440 calories that year, 1935. All right. Then diabetes increases from 0.37% to 13% by 2016. All right. And yet the sugar only went up 86 calories to 526 calories by 2016. Right. Okay. So, but look at this strong correlation between the vegetable oils, which were around 15 grams a day in 1935, but 80 when diabetes was 0.37%. But when vegetable oils are 80 grams a day, we're at 13%, right? So an enormous increase. So let's break this down again with diabetes. So here we look at that same graph, sugar between 1922 and 1987 versus diabetes. So during this period, diabetes increased from 0.09% in 1922 to 2.6% in 1987. So while sugar was flat, right? Sugar increased 5%, diabetes increased 2,800%. What's going on here? Well, let me just show you this another way. In 1935, sugar consumption was 22.5% of our calories, when diabetes was 0.37%. In 2016, sugar consumption was 24% of our calories, 1.5% more calories from sugar in 2016 versus 1935, yet our diabetes is 13%, diabetes up 35-fold, right? While the sugar changes very little. If we bring the vegetable oil in here, you can see that same period, 1922 to 1987, sugar's flat, vegetable oils increase 605%, diabetes increases 2,800%. How is anyone going to blame sugar for diabetes or for obesity with this evidence alone? All right. After 1991, you can see diabetes increased from 2.97% to 13% by 2016, but while the sugar is on the decline. Now you'll notice in some of these graphs, the data looks a little bit different. And the reason that is because I'm using two sets of data, both the FAO and the USDA data, because they have slight differences. But I want to show you that no matter what data we pull from that's accurate, the end result is the same. Now, let's jump ahead so let's look at vegetable oils versus saturated fat and heart disease. Look at this in the United States. This is 1900 over here on the left. This is 2020 over here on the right. Here's the heart disease deaths in the red. And we published this in 2017, by the way. Here's the saturated fat. You can see it barely changes through the whole century. It goes up about 5 grams a day. But look at the vegetable oils. Look how they parallel the heart disease deaths, right? And now we replotted this data because some people like to see, you can change the axes. It doesn't change the data. But let me change the axes and bring what looks like the heart disease deaths lower, just so we can see this comparison partly with, look at the saturated fat versus the vegetable oils. So right here in the 1970s, the vegetable oils surpassed saturated fat consumption and have gone way above saturated fat consumption. But the heart disease deaths have gone down essentially since about the 1960s. Why is this? Because in the 1960s, smoking went way down. So I don't have that to show you here, but that's what's going on. So I'm not saying vegetables are the only driver of coronary heart disease. Smoking is a significant consideration. But the vegetables are very high in omega-6 fat. And I want to show you that we modeled the diet of Americans, 1865. We're consuming about 1.1% of calories as omega-6 linoleic acid in 1865. And I won't give you the other numbers, but by 2008, we're at 11.8% of our calories as omega-6 linoleic acid. Where's all this coming from? It is coming from the seed oils. So we took a lot of this data that I just showed you on the United States, and we presented it to statistics professor Eugene Antipov, PhD. He's a professor he's currently in the United Arab Emirates in Dubai. And so he ran the analyses to assess this effect of sugar and/or vegetable oils. Just these two factors. So it's a two-factor linear regression model. Here's what he said. There is no significant effect of sugar consumption on the prevalence of obesity and diabetes at all. And he went on to say, at the same time, vegetable oil consumption's positive effect is significant at any imaginable significance level commonly used in scientific literature, P less than 0.0001. So if you account for vegetable oils, sugar has no measurable effect on obesity or diabetes. We constantly see this, though, headlines like this. 6 ways added sugar is fattening, right? And I'm here to tell you that I believe the sugar theory of obesity and diabetes is abolished if industrial seed oil consumption is accounted for. And there's theories about fructose as the unifying factor. I don't believe this. I'm going to say the answer to this as a driver of obesity and diabetes, the answer is no, because if sugar is not the cause, fructose cannot be the cause. Fructose is half of sugar, basically, right? This is the cause. This is a Cargill industrial seed oil refinery. They look like petroleum refineries, right? And guess what? I think this one, as I recall, is taken, this picture taken in India. I think this is in Andhra Pradesh, if I recall, but this is a Cargill vegetable oil refinery. And in the United States, think about it. They're producing 1/4 to 1/3 of our food supply is coming out of these factories. And I'd say, I think one of the most important thing we can do is eat natural food. Does this look like a natural food? So again, get back to this graph? Well, the reason I want to bring this back in is 80 grams a day. If we're consuming 1/4 to 1/3 of our calories, this is why we need, quote, refineries gigantic like this to produce all this food. And I use the term loosely. All right. So I want to show you back to this omega-6. In 1865, when we were consuming 1% or 1.1% of our diet as omega-6 linoleic acid, the primary omega-6 fatty acid in any fat, the LA linoleic acid was 1/90th of our calories. 1/90th. In 2008, that had grown to 1/8 of our calories. Again, from 1% or 1.1% to 11.8%. The dose makes the poison, ladies and gentlemen, and this is a poison at this level. All right. You might ask, well, isn't it the carbohydrates? Well, here's the carbohydrate consumption in the United States from 1909 to 2010. You can see it dropped way down until about the 1970s and then climbed back up until 1997, then dropped again. So we have no correlation here at all between carbohydrates and obesity in the United States. Absolutely. It just makes, the only time we had any correlation was for a 20-year period from about 1977 until 1997. What about the total calories? Well, you can see here, total calories declined between 1909 and 1976, while obesity rose 11-fold. And then obesity continued to rise, but it continued to rise after 2004 when the calories were on the decline. And it's still the same, right? As I showed you in the beginning, the calories have gone down a little bit since 2003 and 4 in the United States, while we've had the greatest increase in obesity. So these men and women that look like this, they are innocent victims of our food supply. This is not their fault. And they're eating what they've been told to eat, basically. Maybe not the processed food, but they're being told to eat vegetable oils, right? And I will submit to you that I have discovered 4 what I call pillars of hazard driven by vegetable oils. So the vegetable oils high in omega-6 fat accumulates in our body fat, sets up an environment that is pro-oxidative, pro-inflammatory, toxic through advanced lipid oxidation end products, and nutrient deficient. There's no vitamins A, D, or K2 in any kind of vegetable oil, even the good oils, coconut oil, red palm kernel oil, olive oil. Those do not contain vitamins A, D, or K2. All of this leads to metabolic disease and physical degeneration. That's all the time I really have to go into the mechanisms right now. Now, I want to show you the case of Japan. This is very compelling evidence. And this next slide is a very complicated slide. I apologize in advance. But over here, right in this area on the left, all these numbers, these are right around 1960, about 1958 to 1961. And over here on the right, you see the same data around 2009, okay? All right, look at the total calories in Japan, declined from 2,837 down to 1,850 calories. Their calories dropped about 1/3. Carbohydrates were at 84% in 1960. Dropped to 56% by around 2009. Sugar began at 196 calories in 1961, peaked at 384 calories in 1989, then dropped down to 282 calories, a very significant drop, about 1/3, or at least 1/4, by 2010. Okay. I want to drop down here to the fat. So the fat consumption increased from 5% to 27% during this period. And the saturated fat is the lowest in the developed world at 7%. But let's look at the vegetable oils. 81 calories per person per day in 1961 351 calories per person per day by 2010. That's a 4.5-fold increase. Now, remember, too, the sugar is all forms of added sugar, right? Okay, so I won't go through that again. So what happened to the Japanese? Here's the male obesity, 16% in 1977, right? Increase, it doubles to 31.2% by 2009. Again, obesity in men doubles while the calories, the carbohydrates, and the sugar are all on the decline, right? Obesity doubles. Okay. How about diabetes? Diabetes was 0.02% in 1954 in Japan. It increased to 6.9% by 2009 or 2007, I believe it was. Excuse me. Again, that's an increase of 345-fold in diabetes, while the calories, the carbohydrates, and the sugar declined. Next up is breast cancer incidence. 21.7 per 100,000 in 1975, I believe it is. Increased to 101.4 per 100,000 people incidence by 1997, I think it is, or 1999. All right, so during this period, breast cancer increases 5-fold between 1975 and 1999, while the calories and the carbohydrates and sugar all go down. But again, what are all of these going up in relation to? Vegetable oils. Look at that. Look at these precise correlations between each of these and vegetable oils. All right. Next, let's look at age-related macular degeneration, AMD, the leading cause of irreversible vision loss and blindness in people over the age of 50 worldwide. So AMD was 0.2% in 1970, in the late 1970s, increased to 16.37% by 2013. That is an 82-fold increase in macular degeneration between the 1970s and 2013. While again, total calories, carbohydrates, and sugar go down. But again, in perfect parallel to this increase in vegetable oils. So, but here's the omega-6, folks. Omega-6 consumption was 1% in Japan in 1961. By 2009, it increased to 7.8%, a 7.8-fold. So back here, when their calories were high, their carbohydrates were high, and their sugar was relatively low, but they were lean and healthy, right? But here, when their vegetable oils had increased 4.5-fold, they're riddled with overweight, obesity, diabetes, metabolic syndrome, cancer, and macular degeneration. Next, let's look at China. So take a look at this. So in China, overweight and obesity combined increased from 15.3% in 1991 to 42% in 2015. All right, it tripled. Cancer increased from 495 per 100,000 in 1990 to 1,587 per 100,000 in 2017. So China has the 8th lowest sugar consumption in the world. All right, it's only 2.5% of calories, and it's flat since the 1980s, right? Okay, but look at the vegetable oil. It increased from 30 calories to 204 calories per person per day. So while overweight and obesity triple and cancers triple, vegetable oils increase 7-fold. So now I want to show you, I think we're running short on time. So I want to jump to France. I had one more country I was going to cover, but I'm going to jump to France because I could show you country after country after country where this all follows through. All right. Obesity and diabetes and all this chronic disease follows vegetable oils. I could show you again over and over and over. But a colleague of mine sent me this article. How is France dodging the global obesity trend? He said, you should look into this. And that article, they published all of these countries where obesity is rising since 1990, right? And let me name them: Egypt, US, Saudi Arabia, Mexico, Argentina, South Africa, Australia, Brazil, United Kingdom, Russia, Morocco, Germany, Italy, Sweden. I'm going to leave out that one. China, India, and Japan. All obesity going up. But there's one where the obesity is going down, France. So he said, boy, we got to find out what's going on in France. Well, guess what? Look at this. After 2008, this paper shows pre-diabetes, known diabetes, and unknown diabetes in France all going down after 2008. That's 45 to 54-year-olds. And this is 55 to 64-year-olds. Look at this. Pre-diabetes, not so much, but look at the huge drop in known diabetes. So overall, diabetes since 2008 is going down in France. What happened with their food? Well, here's obesity versus vegetable oils in the blue. And look at this. Beginning in 2008, the vegetable oils dropped dramatically, while the sugar is virtually flat. So again, we've got vegetable oils going down substantially at the exact same time that obesity and diabetes went down. Is it carbohydrates? Well, I'm working on the data after 2000, but this is a published data, not by us. In the last 200 years, carbohydrate in France has been going down. All right, it's going down. So what about the counterfactuals? This is one of them. France is one of them. In other words, what if you take away the vegetable oils? So what about these populations that have never had vegetable oils? Well, let me just show you very quickly. This is the Maasai tribe of Kenya and Tanzania. All of them look like this. I mean, all of them. My colleague, Suzanne Alexander, has been there with them, lived with them, and they all look like this. But yet their diet is milk, meat, and blood, 3,000 calories a day, 66% animal fat, but it is only 1.7% omega-6. They have no heart disease at all. And obviously, they're lean and fit and healthy. This is a different population, the inhabitants of Tokelau. So the Tokelauans' diet is extremely different. It's coconut, fish, starchy tubers, and fruit. It's 53%. 50% of their diet is saturated fat, but only 2% of it is total PUFA. That's omega-6 and omega-3 together. In 1982, in men aged 40 to 69 years of age, they had no known cardiovascular disease. They also had no obesity or diabetes. This is all published scientific evidence. Let's look at a very different population, the inhabitants of Tukasinta, Papua New Guinea. So these people, the Papua New Guineans, their sweet potatoes account for more than 90% of their diet. They occasionally feast on pork and chicken. Look at the extraordinary macronutrient ratios, 94.6% carb, 3% fat, 2.4% protein. This is the highest carb, lowest fat diet in the world. Yet Professor Sinnott and White, after studying them for 4 years, wrote this in their papers. Population was lean, physically fit, and in good nutritional state, absence of obesity and hypertension, no diabetes or gout, ischemic heart disease was rare if not absent, and no macular degeneration. None. All right, so what are the take-home messages for Indians of India? My message, which will differ from many, is return to your traditional diet. I know for a fact Indians are extremely healthy traditionally, like all of the world. So I would say return to your traditional high carbohydrate diet if you like that. Staples were rice, dals, which are legumes, lentils, beans, wheat, barley. Barley was huge. Millet, chickpeas, which are garbanzo beans, fruits, vegetables, root vegetables, honey, sugarcane. Yes, sugar. Indians typically had a sweet, as I understand it from the literature, had a sweet following most meals, and finally milk. So I would say number 2 point is avoid all vegetable oils. Return to using ghee or butter for cooking. Indians have typically used ghee in their best cooking. I'll give you some data. Vegetable oil consumption in India elevated from 97 calories per person per day in 1961 to 215 calories per day in 2007. That's more than doubling of your vegetable oil consumption, which increased in parallel with obesity and diabetes. So historically, sesame, mustard, safflower, and a few other oils were used throughout the ages. That's over more than 3,000 years. But the consumption was very, very small. I mean, very small, probably 40, 50, 60 calories a day. All right. Number 3 point, traditional animal foods. It's almost all forms of meat, beef, sheep, goat, pork, venison, fowl, and fish, all consumed in India. I would say number 4, simple, avoid processed foods, prepare your own food. So Again, these vegetable oils, the highly polyunsaturated seed oils, soybean, corn, canola, cottonseed, rapeseed, grapeseed, sunflower, safflower, rice bran, those are the worst of the worst. Peanut, sesame oils, mustard oil have a better track record in Asia, unquestionably. All right. But our mantra is seed oil free is the key to being disease free. So I represent Ancestral Health Foundation here in the United States, nonprofit entity, and I can be reached through this website or through my own website, chriskenobi.com. So Sandesh, I want to thank you, Dr. Sashi Iyengar. I want to thank you and all the organizers of the Third Metabolic Conference of India. It's been an honor and a pleasure, and I'll be happy to answer questions.
Thank you, Dr. Kanobi. This was insightful. I always say that data never lies, numbers never lie. So I think there's a lot of things for us to learn here. So thank you so much for sharing a lot. I'll probably have only one question, Dr. Kanobi, and this is talked a lot in India. So one of the things that is pretty much back in vogue is with regards to vegetable seed oils is bull-driven or cold-pressed versus the branded industrial seed oils, basically, done at very low temperatures using a bull that is roving around, right? Is it about the temperature that makes the oil toxic, or is the linoleic acid in itself that makes it toxic?
It's both. It's both. So there's no question that the cold-pressed oils, whether they be sesame, peanut, olive oil as examples, those oils are going to be healthier because they will have less of the advanced lipid oxidation end products. However, they are high in omega-6. And as I showed, even in India, the consumption was only 97 calories a day back in 1961. That's pretty low. That's where Americans were in the 19 teens. I mean, that's because we were the greatest consumers of vegetable oil back then and the greatest consumers today. But I would submit to you that again, you could consume these non-processed, non-heated oils, but I wouldn't recommend it. I don't recommend consuming any of those oils. I would suggest that the healthiest oils would be the ones that are extremely high in saturated fat, would be coconut oil and palm kernel oil. But there's no question that, some seed oils have been consumed throughout the ages for thousands of years, but in very, very tiny quantities. That's what's really important. And they're not processed like they are today. That, they don't have to go through the processing like soybean and canola where they're crushed, heated, pressed, treated with, chemically alkalinized, chemically bleached, chemically deodorized, and then heated in that deodorization step like 5 times to over 250 degrees Celsius. So
great. I think that was great. I think you myth busted quite a bit here. I'll invite Shashi to come in here and say a few words. So,
Dr. Chris, thank you very much for accepting the invite and coming in this conference. And I think your viewpoint makes a lot of difference to India. And this is the third session we are having on seed oil in this conference. And I think the way you explained is really, really very clear. And I'm sure the message is driven hard. Now, I want to give you one credit. I saw your podcast long back in Ancestral Health on AMD and seed oil. And one of my relatives was suffering from AMD, which was progressing. And thanks to your podcast, we put her on a ketogenic diet, got her off all seed oils. The progression of AMD stopped on tracks, and with a slight possible reversal and improvement in the vision also we have seen. So I think you have made an impact from US to India long back. I think this was before the lockdown, probably 2019 or so. So once again, thank you very much for all your information and life-saving information. Thank you. And
thank you, Dr. Sashi. Yeah, we have hundreds of people reporting back to us that their progression of AMD has stopped after going to an ancestral diet and getting rid of seed oils from their diet. It just halted in its tracks.
Thank you. Thank you. We'll see you again
Thank
in
you.
future, in coming time.
Thank you, Dr. Kanobi. Have a nice
Thank
day.
you, Sandesh. It's been an honor and pleasure, gentlemen. Thank you.
Please get Dr. Monil in and Dr. Neha. Welcome, Dr. Monil.
Hello, good evening.
Hello, Dr. Monil. Thank you for
Hi.
joining us.
Hi, Mr. Sandesh. Hi. Good evening.
All right, we'll just get started here. Welcome to everyone joining us today. Welcome to the India's third Metabolic Health Conference. I'm a member of DLife.in, India's first and the only award-winning low-carb platform. DLife was founded by Anup Singh in 2014, a silver medalist from IIT Roorkee, and the recipient of Icons of India Award. Anup is the pioneer of the low-carb movement in India with this path-breaking protocol of 100 grams carbs per day max, given by him in 2012. That made not only LCHF, low-carb healthy fat, but even type 2 diabetes remission possible for Indian vegetarians. In 2021, DLife launched its diploma course, which is the only course approved under NSTC partner, the Government of India in this segment, and the only course with the global biggest 144 hours CPD hours credit. Anup, along with Shashikant Iyengar, are the co-organizers of this Metabolic Health Conference. I'm Sandesh Bhatt. I will be the host for this discussion, and with me is Dr. Neha Sadhwani, the co-host for our discussion. Dr. Neha, would you like to introduce yourself? Dr. Neha, you're on mute. You'll have to unmute.
I'm sorry. Hi, thank you,
All set.
Sandesh. I'm Dr. Neha Sadhwani, a practicing dentist. I have been a beneficiary of low carb lifestyle and DLife.in. Using low carb, I have been able to overcome my own weight challenges and lost about 15 kgs. I also want to call out to all the listeners that I have no financial affiliation with DLife.in, and my presence here is purely out of my own passion and giving a bit back to the community. It is my pleasure and honor to invite Dr. Monil Patel here with us today. Dr. Monil is a consultant anesthetist working in high-stakes environment of emergency medicine. He has a unique first-hand understanding of critical impact that chronic diseases have on individuals. He is also a senior resident at emergency medicine at Sardar Vallabhbhai Patel Hospital. Dr. Monil is also DLife member and certified metabolic health practitioner. His background in anesthesiology and emergency response complements his passion for metabolic health coaching, as he is driven to help others achieve lasting health through nutrition, fitness, and lifestyle modification. By promoting these preventive measures, he aims to reduce the frequency and severity of these preventable emergencies. Hi, Dr. Monil.
Hello, good evening, everyone. So as Dr. Neha introduced me, I am a doctor working in emergency medicine department. So I see firsthand how insulin resistance play a critical role that is often overlooked in our acute medical crisis, whether it's diabetic ketoacidosis, gestational diabetes, the cardiovascular emergencies. We tend to overlook this term. But the opportunity to bring this discussion to a global stage is very invaluable, and it speaks volumes about DLife's commitment to evidence-based patient-centered care. And DLife.in is more than just a community; it's a movement that empowers doctors, healthcare professionals, and individuals to challenge these outdated paradigms and embrace metabolic health as the foundation of the disease prevention and management.
So I'd like to ask you this thing. Would you like to explain us the role of insulin resistance in acute and emergency department?
Yes. So, like I said, it's an honor to be here today to discuss this topic that is very often overlooked in our acute care. Most of us recognize high blood pressure, that is hypertension and uncontrolled diabetes, as a major risk factor for strokes, heart disease, and sepsis. So, but what's often overlooked is the insulin resistance part. So basically, I will discuss that. It's been discussed already, but what is insulin resistance? Insulin resistance occurs when our cells in our muscles, fat, and liver don't respond well to insulin and can't easily take up the glucose from your blood. As a result, our pancreas makes more insulin to help glucose enter the cell. As long as your pancreas can make enough insulin to overcome your cells' weak response to insulin, your blood glucose levels will stay in the healthy range. But what happens in insulin resistance? Let's understand the mechanism. Under normal circumstances, insulin facilitates the uptake of glucose into the cell, providing energy and maintains the blood glucose level. But in insulin resistance, this process is impaired, leading to elevated blood glucose level. The pancreas compensates it by producing more insulin, resulting in hyperinsulinemia. And if this is not controlled, the risk of having type 2 diabetes increases, and eventually you get it. So while dealing with high blood pressure and diabetes in emergency room, it is, I would say, a silent disruptor, because let's start with these both diseases. We often tend to see patients which have high blood pressure that is above 180 systolic and 120 diastolic, and full-blown diabetes that is HbA1c more than 8. They are significantly at higher risk of having heart attack, strokes, and organ failure. Now, how this insulin resistance makes this thing worse? Because when patient is having hypertensive crisis and stroke, what mechanism that provokes this is insulin resistance damages these vessels and making them stiff, and they are eventually becomes unresponsive to the medicines that we give to prevent these conditions, though this will lead to poor blood pressure regulation, clot formation, and higher stroke risk. In heart attack and cardiac arrest, insulin resistance and inflammation and the oxidative stress, this will result into heart attack, and it will eventually lead to poor recovery. So for this was the mechanism and etiological part, but now I'll discuss is the difficult blood pressure control. What happens in insulin resistance is we start off some of the medication to lower their blood pressure in ER, that is the emergency room. But the standard blood pressure medication are like AC inhibitors and beta blockers. They will won't work effectively in this insulin resistance patient. So eventually what happens is these hypertensive and diabetic patients in ER, we are not just treating their numbers. We are fighting against a metabolic disorder that is actively damaging their blood vessels and cardiovascular system per se.
All right. I think you have covered how it complicates the treatment, but I'd like to understand how nutritional deficiencies like vitamin D, vitamin B12 plays an important role when it comes to treatment outcomes. Also, how insulin resistance is related to immune responses as per your experience.
So it's my own personal experience about the vitamin A deficiency. It is a truly an epidemic kind of a situation in India, because people are eventually nowadays living in indoors and they are doing corporate jobs. They are not seeing the sun so often, and they are likely to be deficient in vitamin D. Among all of my colleagues, I have been, because I was found severely deficient in vitamin D, so I have advised all of my colleagues and my family members about that I advised them investigation, and they are eventually found out to be vitamin D deficient. So according to me, vitamin deficiency is a very hidden risk factor. It's actually a hidden risk factor in your all your metabolic health, because what it does is if you are found deficient, or if you are deficient in vitamin D, it eventually lead to weakened immunity, and there are if you are in ER emergency room with severely deficient vitamin D levels, your chances of getting the infections because of your weakened immunity, like sepsis, pneumonia, and other post-operative infection, the chances of getting that is it will be increased, and it will also lead to increased inflammation, which will eventually fuel the cytokine storms which we have seen in COVID-19 and kind of a patient. So for takeaway for the vitamin D part is it's very crucial in maintaining your immunity and your overall metabolic health. And I would like to discuss the significant role of also vitamin B12. It is also very important to consider, because majority of Indian population are vegetarian, and they tend to lack in vitamin B12 level in their bodies. So vitamin B12 is also very much important in terms of maintaining your metabolic health, because it leads the deficiency of vitamin B12 will lead to eventually lead to neurological impairment, and this deficiency can mimic stroke and causes delirium. And if worsens your neuropathies. So patients of vitamin B12 deficiency have higher cardiovascular risks because of B12 deficiency increases the level of homocysteine, and it raises the chances of patients of getting blood clots, strokes, and heart attacks. And in addition to that, it will lead to anemia and oxygen transport failure. So poor B12 deficiency delays your post-op recovery. Post-op recoveries are, that is, you cannot recover after your OTs, whether it is emergency OTs or elective OTs. There are slight delay in your recovery, and it increases the fatigue also. So many diabetics and elderly ER patients, they are likely to be deficient in B12 and D3. So this vitamin deficiency should be taken care of in very crucial manner. Yeah. And about immunity, actually, what this vitamin deficiency will lead to is, they will, as I said, it leads to immune dysfunction. But this deficiency, how does it affect our defense mechanism? There are neutrophils. They damages the neutrophils because they are the body's first line defense of mechanism. So they become sluggish. So they becoming sluggish will make the infection like pneumonia and sepsis harder to fight off. And macrophage and T cell also don't function properly, leading to higher ICU mortality and septic patients. And the chronic low-grade inflammation make the body overreact to the already existing infection, and it will increase the cytokine storms that we have seen in sepsis and COVID-19 patients. So for us in emergency room, this means that insulin-resistant patients they don't just have any infections. They have infections that are harder to control, they are longer to treat, and they are deadlier than in non-insulin resistance patients.
Okay, doctor, in your experience with regards to anesthetic and surgical managements of patients suffering from metabolic syndrome, how does it impact the surgical outcomes, prognosis, and quality of life post-operatively?
See, Dr. Neha, what happens in our operation theater is, we often see so many patients in so many age groups, but the majority of patients that we found are the comorbidities part that we talk is basically hypertension and diabetes. These are the only comorbidities that I have majority have came across, that people, any patient that walks inside the OT in preoperative evaluation, I find that at least 70 to 80% have blood pressure and diabetes in, they are on meds basically. So what my perspective is, whenever you are entering by any chance, if there is an elective surgery or an emergency surgery, I hope you don't suffer any kind of emergency surgeries, to all who are listening. But in case if you are facing any, if you need to enter the operation theater, I would if I was at your, if I am at your place, I would like my self to be metabolically very healthy, because inside OT what happens is, surgery, to go under surgery is a very stressful thing for your body as well. It's not just the you are stressed out at mind, but your whole body gets so much of stress throughout the surgery. But the metabolic syndrome and its anesthetic challenges are very different. Metabolic syndrome is basically a cluster of central obesity, hypertension, dyslipidemia, and hyperglycemia. So all of this creates challenge in anesthesia and preoperative care. So it will basically, this patient have increased cardiovascular risk. They have high risks of getting myocardial infarction, strokes, and arrhythmias during the surgery. This is because of the endothelial dysfunction and insulin resistance that reduces the vascular activity and making the intraoperative, the blood pressure monitoring and those management difficult for us. And the respiratory challenges. Basically, metabolic syndrome patients are having obesity, and their metabolic dysfunction will contribute to the obstructive sleep apnea and the restrictive lung diseases that will reduces the capacity of lung to breathe properly. Those patients, they have central obesity, they will be eventually having lesser of the lungs function in comparison to the normal BMI person. So this factor will increases the risk of airway management. For us, an anesthetist, airway management is very crucial, and it will lead to difficulty. And during and performing or inducing the patient and during giving them anesthesia, it will lead to hypoxemia. and the postoperative lung complications like pneumonia and respiratory failure. And the one more important part is wound healing and infection risk. So hyperglycemia and microvascular dysfunction will impair the collagen synthesis and immune responses. So this will lead to delayed wound healing and higher rates of surgical site infection, and it will eventually can be converted to sepsis. So wound healing and infection risk also is there, and the impact on surgical outcome and their prognosis. This patient will likely to be having higher mortality and morbidity because metabolic syndrome increases the postoperative cardiovascular event and infection. So they are tend to stay in hospital more. So their hospital stay is more prolonged the compared to the normal person. So like example, if I would say that in total knee arthroplasty, if you are going under total knee arthroplasty, studies have shown that metabolic syndrome patients have poor functional outcomes, and they have increased joint inflammation and the slower recovery compared to the non-metabolic metabolic syndrome patients. So optimizing the perioperative management that we do inside the OT is very important in metabolic syndrome. So preoperative optimization is like before the surgery, we ask history about the patient's medication and everything is managed beforehand. Though intra-op we are managing it, but beforehand, also before the surgery, we are going to, manage everything uh, in detail. Everything should be in control. Though we are doing it with the medications, but it need to be under the normal range. So the second part is the tailored anesthetic approach that I will I am like it's very long thing, but I will try to summarize it as good as possible. The regional anesthesia technique that we give is the anesthetizing the part that is required only. If the part of matlab if the operation is performing on this area only, so we'll block this area only, right? That kind of a operative anesthetic approach should be required. So careful intraoperative glucose control and this kind of other things should be look out for, and the multidisciplinary collaboration. So all team from the starting from the endocrinologist, cardiologist, nephrologist, and nutritionist help to prevent this perioperative metabolic optimization. Yes. So to conclude it, metabolic syndrome presents a real challenge in perioperative medicine. It increases the surgical risk and complicates the anesthesia, and it prolongs the recovery. But with early identification, meticulous perioperative planning, and a team-based approach, we can significantly improve the surgical outcomes and long-term patient health. As anesthesiologist and perioperative physician, I have a critical role to play in this process because managing metabolic X syndrome isn't just about diabetes prevention. It is about saving lives in the operating.
Thank you, Dr. Monil, for explaining that bit. I'd like to ask Sandesh if he has certain questions for you.
Right. I have a question on liver health / liver injury, Dr. Monil. Can you speak to us a little bit about the complications, liver injuries like extreme NAFLD, fibrosis, NASH brings in acute emergency care? How does it make your life difficult?
So see, this NAFLD part is very much of a acute emergency kind of a situation because whenever your liver is damaged up to an extent, see the starting of fatty liver grade 1 to 3 is a normal situation. You can walk around and having a fatty liver, but when it progresses to the fibrosis and eventually full-blown cirrhosis and liver failure, it will create so many complications. I will enumerate that one by one. First off, one of them is ascites. That is, the liver fibrosis will lead to portal hypertension. Portal hypertension is your vessels inside the liver will constrict and it will lead to the portal hypertension. And eventually those fluid that is flowing around inside the liver will, due to the fibrosis, it will eventually accumulated in your abdominal area and that will lead to the ascites. So clinically, this patient will present with abdominal distension and discomfort, and in emergency setting, significant ascites will raise and compromise the respiratory function, and they may necessitate to paracentesis to alleviate this respiratory breathing symptoms. The second one is hepatic encephalopathy. the impaired liver function associated with fibrosis will lead to accumulation of neurotoxins, notably ammonia, that is eventually to be excreted by the liver. But it will accumulate since our liver is in failure. It will accumulate and will culminate in the hepatic metabolic encephalopathy. So basically, patient have a spectrum of symptom starting from subtle cognitive changes to profound coma. These are the spectrum of the symptoms that patient may suffer, and the prompt recognition and management of these symptoms are very essential to prevent the irreversible neurological damage. So we need to act upon it very early in the stage of this developing these symptoms. And the third one is variceal hemorrhage. So the back pressure changes that I talked and will that results into the ascites, same will happen with the variceal hemorrhage, that the lower part of the esophagus, the blood vessel they are supplying the lower part of esophagus will eventually dilate due to back pressure changes, and they have there is development of varices, particularly in the lower part of esophagus and stomach. So these varices are very prone to rupture. They have very weakened, thinned out wall because of the pressure changes, and they are taking time bomb. They can rupture anytime. So they are very prone to rupture and leading to massive gastrointestinal bleeding. So it is a kind of a die-hard emergency, and we need to intervene immediately to stop that. So we do banding. So gastroenterologists basically perform those banding, and we are there to give anesthesia to patients. And it's a very critical situation when you are anesthetizing this kind of patient, because any time those time bomb can rupture and the enormous amount of blood will eventually come down to through your stomach, esophagus to your respiratory tract, and once it goes inside the respiratory tract, your lungs are totally damaged. So it's a very critical situation, and I would say that it's better to prevent this situation before it's too late. I would just say this one line, that it's better to prevent it, because inside the operating room and seeing this patient in emergency care, it's very, very, very disheartening to see those patients suffer. And I hope whoever is listening to these lectures and all the metabolic health conferences topics, they need to get that thing in mind, that there is no good way to manage your body, and it's just not good at the other side of the hospital door. It's very messy. You will just be found in loop of every other diseases that will come freely with diabetes and hypertension and other metabolic X situation. And the other thing which you will be having with liver injury is coagulopathy. Your blood that there is supposed to clot once you get a cut won't cut, and eventually you will bleed to death if there is some mishap in your circulatory system. So yes, it's very, very, very critical.
Thank you, Dr. Monil. I actually had no idea about what happens, in the critical room and the role that metabolic health plays. Right? As a coach, it just adds more humility in my role, I guess, as a coach.
Exactly.
I do have one follow-up question on the B12 part that you mentioned. We know that as a country, India is severely vitamin B12 deficient.
Yes.
Any thoughts on how you go about when someone suddenly lands up in the emergency medicine room with a very low B12? What things you have to do? Because as a nutritionist, what I know is you cannot rise it too fast unless it is an IV. So what do you do in a practical situation like that? Because you said B12 is so important.
Mr. Sandesh, B12, basically, we haven't came across that deficiency that people are not presenting to the ER because of the vitamin B12 deficiency part. They will present to the ER with some other symptoms, which we cannot, target it out to the B12 deficiency, because like this specific thing is because of B12 deficiency. But let's say that the deficiency is a neurological, that will lead to neurological impairment, and that deficiency can mimic, I would say, can mimic stroke and causes delirium. And sometimes what happens is they'll have extreme neuropathy, like they have sudden shooting pain of the backside of their leg, and they'll present with it. You cannot just point it out that's because of this, because there are differentials. Like, it's a traditional medical practice that will follow the differential diagnosis of this. So eventually, when we send investigations, and eventually, after investigation comes, then we find out that this patient is actually having the symptoms because of B12 deficiency. So acutely, they do not present in B12 deficiency, though I have found one patient of vitamin D deficient severely presenting in ER. Yes, that's all I have in experience of mine pertaining to vitamin deficiencies. Yes.
Thank you, Dr. Monil. This was very insightful for sharing some of the unique experiences you had. You shared with us some practical issues you have faced in the emergency care when dealing with
Yes.
patients and having insulin resistance. Any final word you have before I call Shashi and Anup back here?
See, the final word I would say is maintain and prevent your health as much as possible. As much as possible. Hello?
Go ahead, doctor.
Yes. I would say maintain your metabolic health so beautifully that you should not land to emergency room so often, and maintain your level of diabetes and hypertension. Matlab, you should be aware of your metabolic health, so that you should not get diabetic hypertension unless you are type 1 diabetic. That's because you get it from your even earlier years. But the type 2 diabetic and certain other metabolic X comorbidities, you should be aware of them, and you should not get it. Otherwise, on the other side of the operation theater or the hospital gates, there is very a critical scenario that will eventually will make you accustomed to those drugs, and it's very difficult to maintain as you grow older, to cope up with those medications.
Yeah,
It's very
thank you. That was very insightful. Thank you so much for your time, Shashi.
Thank you.
Anup, over to you.
Yeah,
Dr. Monil,
congratulations.
yeah.
Shashi,
Anup,
yeah, start. Yeah, start.
Okay, Dr. Monil, thank you very much for sharing your insight, and I think it's very critical because you work in an emergency setup, and
Yes.
whatever you say, we also in coaches in our own practice, we also see very severe deficiencies of D and B12. Practically everyone who comes to us are deficient B12 and D unless
Yes.
they keep supplementing.
Unless, yes. I have that thing in my mind, that who is having vitamin D more than 50? Matlab, he is superhuman. According to me, without supplement, if he's maintaining more than 50, then he's a superhuman. In
No, they
Indian.
have to be deficient. So I
Yes.
think your job becomes even more critical because you can prevent the future
Yes.
complications as you identify this,
Yes,
and
yes.
possibly also explore the option in future of measuring insulin resistance in those who are admitted if it is easy and is permissible. Otherwise,
Easily.
okay.
Exactly. I have this, you have told me, but I have talked with my professor who is a departmental HOD. But in our setup, it's likely not possible because it's a semi-government setup. So getting an insulin measurement would be a very difficult. So yes, getting lipid profile, we will get it in 1 or 2 days of span. We cannot get it like that. So it's very difficult right now. But I hope that this goes well.
Thank you. Anup.
Thank you, Mr.
Yeah, congratulations, Dr. Monil, on few counts.
Thank
Count
you.
number one, in 30 minutes, I think you covered about 60 minutes of content, right?
Thank you so much.
And and we're very proud, to see a mainstream doctor and a D-Life certified low carb nutrition and metabolic health coach making his
Thank
debut
you.
in an international conference. So all I can
All
say
credit
is
to you.
go ahead and conquer the world. Good
Thank
luck.
you. Thank you so much, Mr.
Thank
Anup.
you.
Means a lot. Thank you. Thank you.
Please get Mr. Charles in. Good evening. Good morning.
Hey everyone, can everyone see me or?
Yeah. We can see you, Charles. Welcome
How
to
are
India.
you? How are you?
All
Fine,
good.
fine.
Good morning.
Good
So nice.
morning.
So nice to have you in this session after we have been interacting a few times in Twitter X.
I love what you guys are doing, and it's an honor to be a part of it. It's so refreshing to see this movement, you know?
So I'll just finish the introduction first. And Charles, just to give you a perspective of who we are and what we do. So first of
Yeah.
all, I'm Shashi, a certified metabolic health coach from DLife In, which is India's first and only award-winning low carb platform, founded in 2014 by Anup Singh. Anup Singh is here. He's from IIT, a premier engineering institute from India, and he's a silver medalist and also Icons of India awardee. So Anup also pioneered the low carb movement in India. Anup's groundbreaking concept of 100 grams carb limit per day protocol for low carb diet has helped the management of diabetes, obesity, and various metabolic disorder. And it is more suitable for Indian vegetarians, which are primarily high carb. So also in 2020, he did some groundbreaking work in this instance that he launched a certification course, which is the only approved government of India approved course, and which is having a very large 144 CPD hours. So Anup and me, we both organized this Metabolic Health Conference, India's low carb conference. We did the first one in 2023, 2024 the second, and now this is the third one in 2025. So so for the audience, I'll give a brief introduction about Charles. So he has a very impressive profile. So Charles Mattox is an award-winning actor, director, producer, television host, and a leading health advocate whose priority for health first and saving life does not get his way of excelling in all the areas of the business. A Blue Circle champion for the International Diabetes Association and published author for American Diabetes Association, created and directed and executed, produced several seasons of Reversed, the highly acclaimed documentary film on diabetes, produced Trial by Fire, which is about Mother Rare Earth complex regional pain syndrome, and more than 8 documentaries and series have been released till now, and a lot of new series which is also coming in and which we'll discuss. He has become the premier media expert on health and wellness. Charles entertains, educates, inspires, heals millions ahead of the curve creativity and dedication to excellence in television hosting, content creation, and dynamic advocacy. So what we are going to discuss is diabetes and the power of storytelling, raising the awareness through film. So that is Charles' strength. So Charles, welcome to India. Welcome to DLife In Metabolic Health Conference.
Thank you for having me. And I have been to Mumbai, and we did some shooting in Mumbai with some local doctors, and it was amazing. We that was part of one of my documentaries, and I had a beautiful time.
When was it?
This was at least probably about 8 years ago.
8 years ago. Okay.
Yeah, I got to get back though. I got to get back.
So Charles, you have created multiple documentaries highlighting the diabetes epidemic and its reversal. What inspired you to take this step?
I was inspired by my own diagnosis. It was probably about 12 years ago, and I thought I was healthy. I was going to the gym. I was working out almost every day. And actually at that time, I was making cookbooks that were so-called healthy cookbooks. And I went to the doctor one day, and I was having some symptoms, some frequent urination, and I didn't think anything of it. The last thing I could have ever thought in my life that this was diabetes. And he came back out just from a finger test, and he said, do you have anyone who is diabetic in your family? I said, diabetic? And he said, yeah, I could put you on medication for it. And I thought this wasn't even my doctor. It was a local doctor on a Saturday, a clinic. And I thought, how did I get here? And how does he just want to put me on medication right away without really finding out what the underlying cause was. That I mean, there were a host of things that could just be thought of before just putting me on medication. Not there's anything wrong with being on medication, but I had seen my doctor regularly and taking plenty of tests and didn't ever think, didn't get any indications I had diabetes. So I left and went home, and I started to kind of reinvent how to fix myself. And that's really what started on this journey of being an advocate. I then started to direct this beautiful documentary called The Diabetic Youth. It's taken me around the world. I wanted to kind of chronicle my life with diabetes, but then also understand what it was like for others who are dealing with diabetes. And that kind of led one door to another as I started to look at the health industry and the food industry and just all the things that contributed to poor metabolic health and diabetes and obesity and really that's how I got my start. I started reaching out to a bunch of pharmaceutical companies. They believed in what we were doing, and one thing led to another, and we started to create these amazing programs that, as you say, tell stories. So what I wanted to do was have someone be able to sit in the comfort of their own home and watch someone and say, that is me. Wow. But be educated on the television shows that we've created. Be educated by the nutritionists, the diabetes educators, all the experts that are in the diabetes and cardiovascular world in one home, just enjoying each other too as well.
Anup, unmute.
Sorry. Yeah, Charles, your work basically blends, storytelling with science. Now,
Yeah.
in this journey, what has been the most, emotional or eye-opening instances that you have witnessed? More than one would also be fine.
I would say some of the most eye-opening. There are a few of them. One of them I could think of is there was one of the shows that we did. Our first series that we did was in Jamaica, and Lisa, who was a guest, and she brought her husband with her, and Lisa came there ready to make changes. And in storytelling, it's really about allowing those who are living with these conditions to see themselves, to understand the seriousness of this. Because if they don't, they may not take it as serious as they should. So Lisa came there to Jamaica with her husband. Her husband came there, diabetic, amputee, in bad shape, smoking cigarettes as he's getting ready to come to the house. It was so bad one day from his amputation that his leg was so rancid that literally it smelled up the whole room. This is all from diabetes and diabetes complications. Long story short, Lisa went home and she made the changes. She's probably lost about 50, 60 pounds. Sadly, her husband didn't make any changes, and about 3 months later passed away from diabetes complications. I would say some of my time in Jamaica, as we see, countries who may not have the resources and have to deal with, poor conditions. There's a lot of diabetes wounds, as far as wound care, not having the people there to treat the wounds. Sometimes people are going, maybe once a month while they're supposed to be going once a week to get the wound redressed because of distance and things like that. And even some of my time in India, where, you see people who are, there's a high rate of diabetes in India. And, there are people doing some good work there, but there's just, the lack of being able to educate. So I think that's one of the reasons why I really love what we do, is because, and one of the things I would love to do, which I was thinking about for years, is doing a series in India. Because if we did a series in India where we featured the Indian population and Indian experts, how amazing would that be for people to be able to watch from wherever they wanted to watch and be educated in one fall swoop, while they can be, at their homes, at their offices, whatever it might be, online. So yeah, so I've seen some things that really make you wake up, and while it's diabetes is the culprit, I think that there's a few things that play in that, and I think food addiction is actually one of those as well. And we have to look at that. We're actually working on a series right now on food addiction, because when we look at all these GLP-1s that are now on the market and they're making billions of dollars, they're not addressing the root cause, which is a lot of time poor eating habits and food addiction. And that's why they're continuing to lose some weight, gain weight back, get right back on the GLP-1s, lose some weight, get right back on the GLP-1s and gain the weight back. And we know that, unfortunately, these may have some serious consequences in the future with these GLP-1s. So I've seen some things that really have made you say, wow, but it's I think if more people saw them, maybe they would have that same fire to stay healthy, because it's very important. Being sick is no fun, and it's important to do simple things that we can do to change that metabolic health.
So till now, based on your filmmaking and experience, what do you think are the biggest misconceptions and myths in the management of diabetes, which keeps them in the vicious cycle of being diabetic for life?
Well, I think, number one is that I think we've been conditioned that we just accept medication. We just get on medication and that's the cure. And we don't have to make any changes once we just get on medication. And so people are on, metformin, they're on, other medications, and they don't change their diet. I met a German guy the other day who has a restaurant, and he's severely diabetic, a ton of complications, has used Ozempic, it didn't work right, and is eating horribly, drinking Coca-Cola and eating poorly. So I think that people think that once you get on medication, that is the fix. And we know it's not. But diabetes is progressive. It goes after and destroys every organ in the body. So I think that poor education when it comes to, let's say, doctors who aren't trained in nutrition, they can't really give nutritional advice, right? If you just can't say, hey, change your diet, come back and see me in 3 months, or eat more salad. So I think that doctors actually need to be a little bit more trained in nutrition. And I think, to be honest, programs like what we create, if they were, let's say, endorsed or sponsored by the government, which is a small amount, you guys could be doing what you do just in the same way you've created this amazing platform, but doing a television series that could actually reach millions of people, where we could actually really educate people. I think we need to do that. But as far as misconceptions, is that that you definitely need to control your weight management. I think people don't even consider that at times when they have diabetes, and it's very easy to tell someone to do those things. And when you see them make those changes regarding weight, they end up in such a better place. So yeah.
Anup, you're muted.
Yeah, before I get to question, it's heartening to know that you are planning to do some series in India.
Yeah.
And whenever you start it, I can promise you there would be no shortage of storytellers in this space, because we have, many of us have lived through this life for decades.
Yeah.
1 decade,
Yeah.
close to 1 decade, you have 3, and 8 years, 9 years. I mean, that's what I wanted to, pass on the message. Now, the question is, you must have collaborated with a lot of experts while working in this space, right?
Yeah.
So what is the most revolutionary approach that you came across to manage diabetes?
Yeah, we have done television shows on both ketogenic, and also on carnivore. I've worked with everyone from Jason Fung, who is a guru in the space of intermittent fasting, where we, utilize intermittent fasting and ketogenic and also carnivore, because obviously, having a low carb or at times no carb, and not even vegetables. There's been a lot of studies on these things that have shown tremendous benefits to both. And I think at the end of the day, it's as far as revolutionary or anything of that, it's really about you also have to have a form of vanity. And what I mean by that is I look in the mirror every day. And while we may talk about diabetes on so many levels, I look in the mirror every day and I say, I want to look like I was when I was 18 years old. And whether it's me gaining weight or having excess weight, and then looking at myself and saying, I've got to make a change. I want to look good for myself. And it's not just about being overweight per se, but we know that a lot of diabetes is found in the gut. But it's about even addressing the fact that we want to be here for our loved ones, right? I got kids I want to live for. I got a beautiful family that I want to live for. I don't want to die early from complications of diabetes. So I think once we kind of put those simple things into someone and make them understand their why, then we can, and that's what a lot of our shows have done. We kind of make them understand their why, because we all know what we should and shouldn't be eating. When we pick up that fast food, we know we shouldn't be doing it. But if we make them understand their why and let them know how important they are, whether big or small, and that they are loved and that they mean something, that they have something to contribute to society, I think maybe then people will say, you know what, I've got to eat what's right. I've got everything that goes into my mouth should be accounted for. So while there might be revolutionary things, I think at the end of the day, let's strip it down to, hey, you know what? Eat right. Let's do the right thing, because we want to be here for our family, for our loved ones, for our children, for our wives, for our husbands. And if it's based on what we put in our mouth, we got to make better choices.
And for your information, Anup here, so he's on he has completed 14 years pill-free diabetes.
Wow.
And me more than 9 years, almost 9.5 years.
That's why I said, you will not find shortage of storytellers the moment you step into India.
And now what I want to know is, you have created so many documentaries, films. Have you ever faced any resistance, any pushback from either medical organizations or doctors or any front for the matter?
Yeah, of course. I mean, our first series was done, I forget how many years ago, but it was called Reversed. And it wasn't about reversing diabetes. It was about reversing the mental, physical, emotional state of us as people so that we would make better choices. And I remember, and so back then, which was, let's just say 7 years ago or 8 years ago, they didn't want to talk about reversing diabetes. That was taboo. So I got a ton of pushback on the name Reverse, and I would even tell people who would interview me. I remember one big reporter from some big diabetes magazine, and I said, "Listen, it's not about reversing diabetes. Please don't put that in there." And I said, "It's about reversing the mental state, the emotional state, and then allowing the person to make changes." And of course, what did they do? Put it in there as I'm trying to reverse type 2 diabetes. When we shot the film in Jamaica, for whatever reason, the sponsor, which was a diabetic foot ulcer company too as well, Shire, a big biopharmaceutical company, had the idea to send some big Fierce Pharma, the big online publication. I forget the name of it. It was a big publication. He sent them there, and they literally must have been just on an attack job. And they spent like 2 days just watching this film and pretty much destroyed us, for no reason, and I don't know if they had it out for mankind, which makes Afrezza the inhaled insulin. So yeah, it was definitely pushed back. But then also, I think that when I came into it, I was so excited because I thought, wow, we're gonna make a show called Reverse. It's gonna help people with their diabetes and other comorbidities. And I thought, man, I'm gonna reach out to this company or that pharma company or this company, and they're gonna love it. And then only to realize that that makes no sense. Us talking about reversing diabetes or helping, control blood sugar without, medication or blood pressure without medication. So, when I was all, starry-eyed thinking that, this was going to be a beautiful thing that I can just create all these amazing shows and be supported by these companies, I realized that's not the case. They're not looking to cure people from diabetes. And now they don't even have to advertise, right? And they don't, right? Because it's like if you have the only gas station within 100 miles, you don't have to advertise. They're gonna come to you regardless. And Big Pharma knows, and I work with them, but Big Pharma knows they don't have to put any real effort into getting the word out or helping people because every year there are going to be millions of people diagnosed anyhow. So definitely got some pushback, but we just kept going. And now the word reversed is the thing to talk about. You have big companies that have, created, have thousands of members or that are part of their business that help reverse type 2 diabetes.
So, carrying forward, India has the highest number of diabetics. In fact, is the diabetes capital of the world right now.
Yeah.
But yet, everything is on pill-driven approach, and that is because high carb, low fat diet has been
Yeah.
called the balanced and good for everyone diet. So, what lessons from your work can an Indian take, to reverse his or her condition? And I'm saying
Yeah.
reverse. Yeah, please. I'm saying reverse without any fear because when I say I have reversed my diabetes, I
Yeah.
say until or unless somebody tells me where is the science of eating
Yeah.
60% carbohydrate, I will call it
Yeah.
reversed. Right.
Of course, I love that. I call it the same thing without any fear. But I would say that, if we could do a series on in India, I think that it could save millions of lives. And these are a few simple tweaks. This is not having to even at times get rid of everything that you love. You don't have to start eating, cardboard or wood, as someone living with diabetes and other comorbidities, is that with some simple changes, whether it's increasing, some exercise, whether it's, focusing on losing weight naturally, whether it's drinking, water instead of soda, which we know that, whether it's in the Caribbean or Asia, that soda is, Coca-Cola plays a big risk factor in these things, whether it's cutting back on the rice. I mean, I'm from the Caribbean, and we this is a staple. It's rice and potatoes and carbs and things like that kind of put us in this bad place and have us as, especially in Jamaica and where I'm from, they have the highest rate in the Caribbean of amputations, and it's based on our diet. So being able to make simple changes, whether you're in India or in the Caribbean, to our diet, eating smaller portions, practicing intermittent fasting. I fast for very long hours a day. At times, I eat one meal a day, and it's really pretty much protein based, and I'm fantastic and fine with that. So you'll see, your energy start to increase. You'll see your activity start to increase. You won't feel bloated. I remember recently, I was trying to race my little 14-year-old daughter because she was in track. And I remember thinking, because I used to be the fastest kid when I was in high school, and this little 14-year-old is beating me in a race, and I'm like, hold on, I got to lose some weight here. I got to get it together. I'm not saying I'm ever going to be as fast as she is right now, or as when I was in high school, but I want to feel good like that. And a lot of us, at times, because of this extra weight that we're carrying, And because of these conditions, we don't feel good. You're not feeling the way you should. That's why I say vanity is a part of this too as well, because you got to be a little bit vain and say, you know what? No, I want to feel good. I want to look good. And there's nothing wrong with that, you know?
See, India is basically a very high grain based diet.
Yeah.
Our 60, 70, 80% plate is filled with grain. And it's the cultural thing which has been going around for quite some time. Of course, now we have replaced all the healthy fats with all vegetable oil. And then a lot of sugary stuff, processed food have
Yeah.
also come in. So
Yeah.
do you think, in your experience, if you have worked in various countries, various culture, do you think a cultural shift is possible? Because in India, again, it is a low protein diet. And
Yes.
for reversal of diabetes, we need to lower carb and increase protein. Our
Yeah.
per capita meat consumption is very, very less, negligible. Even consumption of egg is negligible, not even one egg per capita.
Yeah.
So do you think such a cultural change is possible? If so, how?
I really do. You know, and I hate to keep talking about the show, but you know, there have been how many countless, whether it's in India or United States, they're always trying to think of ways to reach people with diabetes, and it's splintered, so it's not cohesive. Right. So, you know, in America, they may say if they're trying to reach the black population with diabetes, they say, oh, yeah, we're going to maybe want to reach the barbershops where you get your hair cut, or we can reach the churches, but, you know, it's this company spending, you know, a lot of money to do some little small activation that nobody will see in that little town or city that won't really, you know, cross into other places. I think if you're going to reach people cohesively and get a message out there, once again, I go back to the television show, a show that could reach millions of people. And then now you don't have to do this little event here where you have 200 people or 50 people or 100 people here or 20 people there. You can create something that can be engaging and entertaining, but also informational. So I think that you have to get the messaging together first and let it be a united front, or else we're going to be talking about this for the next 100 years until they may come up with some the magic pill that just helps with everything per se. But it, and instead of spending money here, there, near on all of these things, it could be something that once again creates an energy for people to be able to watch something and watch. Because can you imagine with all the dynamic people in India, whether it's the experts or the potential guests, how dynamic and engaging this show could be as you see them living together for a few days or a week in a house and learning and being educated, but also understanding the issues that they're going through, the ups, the downs. You see them laugh, you see them cry, you see them learn together. Now that's something somebody wants to see. And then you could have a CTA, which is a call to action. What's the next step? Well, we have these clinics, we have these people who are here to help you, these diabetes educators who are here to help you along your course. And here are some healthy tips as far as eating. So instead of eating this, eat that, and you could still have the great taste. I mean, you know, I'm from the Caribbean. I love me some chicken curry, some curry chicken, some curry goat. You know, we know that you know in India they love curries too. Well, you could have curry, and you could have your curry chicken, but maybe instead of the rice, you substitute it with some salad. Substitute it with some cucumbers, some whatever it might be. It's just simple things.
Yeah,
So
one of
there
the
can be a shift.
yeah, Charles, one of the issues, is low income group. Their
Yeah,
access to primary, premium healthcare, I would say, is very limited. They cannot.
yeah.
So how do we, address that segment of population and help them to reverse diabetes?
Well, we know that it's expensive to be sick, right?
Yeah.
So while they may not have access to maybe even the best foods, they may not have access to healthcare the way they should. I think that that's exactly who we're targeting by saying that, you know what, at times McDonald's costs more money than going out and buying yourself something decent to cook, right? So when we're talking about these things, it's really about, once again, practicing of the intermittent fasting and eating it less portions, so you don't have to eat as much or feel that you need to eat as much. And then, you're going to cook, get yourself some quality food, whether it's eggs or something of that nature that's more protein based. And I think allowing them to be more educated allows them to not have to deal with healthcare as much, because they are going to be healthier. So I think that there's definitely something in this for them too as well, that they can truly benefit from, because if they're the ones who are suffering and not being able to get their diabetic wounds dressed once a week, but once every month or once every 2 months, if they're dealing with other cardiovascular issues that come from diabetes, that eating a healthier having a healthier way of life is actually showing them that we care, because we want to make sure that they don't have to deal with these conditions that cost a lot of money to deal with and that are just burdensome to life and to their life extension and to their families. So I think that's actually the way we're doing it is actually more in line with showing that we actually care about the people.
Do you have any upcoming projects, especially on diabetes, or it may not be diabetes, it could be any other illness
Yeah.
or illness?
Yeah, we're working on a series right now on menopause. So this is going to be the first ever series that we're going to shoot, where we bring 5 women together who are dealing with menopause, and we're going to bring some amazing, well-known experts together to kind of just live together for a few days and have them share and open up and cry and laugh and learn. Then we have a food addiction series that we're working on too as well, because I myself suffer from a food addiction. And, just realized it, not too long ago, where my eating habits and very unhealthy eating options. And even though I'm all about health, I found myself, doing some things where I felt like a conflicted, like a hypocrite. So, when you fight that and you're able to win through that, everything changes. So we're working on a food addiction series. And then we also are working on a series called Reverse the Church, where we're going to go into a well-known church to help change the health of a whole congregation. So it's like going into, the temple, and if there's 1,000 people in that temple, that you're able to go into that temple and help change the health of everyone who is in that place. And so we wanted to kind of show what it could be like on a bigger scale, instead of just 1 or 2 people or 5 or 15 people, but show on a bigger scale how we can change the health of masses amounts of people through faith-based initiatives.
Thank you. And what is your message to India?
Say it again.
Your message to India.
I had such an amazing time the first time. The doctors were open their arms to me. They took me. There was one hospital, I think I went to, a clinic that I went to, or hospital that, wanted to do some work with us and get behind us. I actually had someone reach out to me too the other day. He's in India. It's a big company. He's a big time head of this company in India, and wanted to work with me. And I told him, hey, you know what? I'd love for them to be a part of this, and so we can do something in India. And I would say that, it's a proud and beautiful people. I had such an amazing time there the first time. We filmed some powerful scenes there that are in the documentary. I would love to come back and help create a series that we could create for the people of India, that could help, be a portal for change and education and inspiration. So I would love to continue these conversations and hopefully one day make this a reality.
Thank you, Charles. Your story is such an inspiration that your own suffering, you have changed that into you have healed yourself, and your storytelling and amazing films are healing the world. So not only in your place, but across the globe. And thank you very much. And whenever you want any other help in India, so we have amazing story. We have amazing people with us who can always help. Thank you, Anup.
Thank you, Charles. It was nice interacting, and hope to see you soon in India.
Thank you so much. Have a great one.
Thank you. Good night.
Bye-bye. Bye-bye.
Good day. Ira. Ira, are you there?
I think she must be.
Okay, fine. So anyway, we have come to the close of the day, and I think we had a very exciting and good session, and we look forward for the sessions tomorrow. Tomorrow it's going to start at, I think it's just going to start at 8:20. So I request all the participants who are here, all the audience, to please join us tomorrow for an exciting session starting from 8:20 a.m. Thank you.
Thank you. Thank you. Bye-bye. Good night.
Yeah, thank you so much, everyone. So from here, I'm